request Dr. Monogenic, Dr. B.N. Panda and Dr. K.P. Tripathi to please chair the session. We have three speakers, Dr. Amit Gupta, Dr. Muklesh Gupta and Dr. Shankar Sen.
Hall. And the name of the hall goes with the great physician from the soil of India, Dr. B.C. Roy, and to keep up the tradition of the old stalwarts of this land, the focus is on clinical side. Not the patient comes out of gigantic gadgets with some fancy diagnosis where you try to find out where it starts and where it finishes. And there were three speakers. Dr. Amit Gupta will be talking on critical care illness.
Yes, sir. Sir, thank you, sir.
Deeper than the Pacific.
Can we have the slides? Full presentation में डाल दें. अंकित इस व्यू को हटा दे, खाली ये कर दे.
सर ये ऐसी है, ये नेक्स्ट स्लाइड
चाहिए नहीं ना?
नहीं, ये नेक्स्ट स्लाइड है, चलेगा ये.
So thank you, respected chairpersons, and I am thankful to Dr. Anuj Maheshwari sir and Dr. Anil Mirwani for giving me this opportunity. When I was given this topic, that charting unknown waters in the hospital ward, and to be very precise, I was supposed to talk on critical illness. So this is a very, very interesting topic, and it is more of clinical, as you are told that I am speaking in B.C. Roy Hall, who is, you can say, one of the most revered person in the field of medicine. So it is more clinical, less of any data and anything like that. We all have taken hospital wards, and I think one of the most frightening thing which we have is that we have just taken the round. We are sipping a cup of tea, and all of a sudden you get a call from the sister or your junior doctor that, sir, so and so patient which you have seen today morning, he has collapsed. So something has gone wrong with the patient, and all of a sudden the patient ends up in a situation where you don't want to be. Because in the morning you were chit-chatting with the patient, you were explaining the family that everything is going right, everything is fine, but after 2-3 hours you find that the patient is in a very, very critical situation. So this is like charting unknown waters. We don't know what is going to happen with the patient, and we have done our best, but can we do something? Can we identify these things early in our patients? So this is very, very important. So what is the importance in patient care? When we admit a patient to under us in any of the hospital unit, the patient trusts us, and the patient believes that he is in safe hands, and whatever is going to happen with him, he will be taken care of. When a patient is admitted in the ICU, we all know that we take consent, we explain each and everything in detail, we explain the possibility of any mortality, morbidity associated with the condition, but it doesn't happen so in the ward. So ward is a more area where patient feels comfortable, doctor is also more comfortable, and if something goes wrong in the ward, we know that we may be subjected to the violence, we may be subjected to inquiries, we may be subjected to many things which we don't want to be. So we want to prevent the complications, and we want to improve the outcomes in the hospital ward, and we want to minimize the shifting of the patients to the ICU if it is not required. So can we recognize the signs of deterioration? So what are the key indicators? So any changes in the vital sign, any altered level of consciousness, any abnormal laboratory results, and increased pain or discomfort. So if we find that the patient is having some sort of discomfort, vitals are fluctuating, patient sensorium has gone down, or some laboratory results which are abnormal, they are there. So it is a red flag sign, and we need to look at very carefully. Importance of monitoring technique is very, very important. Regular vital sign assessment, continuous remote monitoring, and patient's observation and communication. Also, communication with the healthcare team is again equally important. So prompt response to clinical deterioration can be prevented if we have timely intervention. We are able to identify the problem timely. There are some emergency protocols which are set up in the hospital ward, and we are thinking of a team-based care, collaborative care, where each person involved in the care of the patient is part of the team. So what can be the points where we can think of providing high quality care? So to improve patient outcome, to enhance patient experiences, and it is about building trust with the patient. Just to give you an idea that we don't have such kind of systems, I think, in our hospitals and hospital setups, but in Western world, this is very, very common. And for example, this is an example from the UK where that there is a national early warning score. And this is a technology-enabled score where the data is fed in the system. And if anything goes wrong, if there are any deviation from the normal data, then there is a red flag. So immediately the team will be able to identify that this patient is having some problem. For example, some patient is having a normal pulse rate, and all of a sudden the pulse, there is an extreme tachycardia or there is extreme bradycardia, and the data is entered into the system will raise a red flag that yes, this patient is on priority, and this patient can be one of the patients where you can measure the things. And this simply involves 4 to 5 things like respiratory rate, oxygen saturation, systolic blood pressure, pulse rate, level of consciousness or new onset confusion, and temperature. So these are very, very common vitals which are taken in any hospital ward, and this score is based only on that. Based on this score, different kind of triaging can be done. Low risk, where the score is 1 to 4. Low to medium risk, where a score of 3 in any single parameter is there. And the medium risk and the high risk. So I am not going into details of this score, but what I want to convey is that these early warning sign systems are there. And by using them with the help of the technology, there are some alarm systems which are already in place in majority of the Western hospitals, but they do not exist in our hospitals. So let me come to the factor, can we correct something? So most of the common factor which goes wrong is the communication factor. And the communication factors can be divided into multiple parts. So first, most common thing which goes wrong is the verbal communication. So you have said something and your staff has understood something else. You have told the staff very clearly that you monitor blood pressure every 30 minutes, but the staff doesn't take it seriously. The blood pressure is not monitored and only the entry is entered in the chart. So most significant problem area, this is the most significant problem area which has been identified in many studies. Staff may not adequately inform each other about patient's care. So whenever the shift is changing, the previous shift worker, they may be having more information about the patient, and that information is not transferred to the next shift during the next shift. So this is particularly problematic during shift handovers and patient transfers. So when the patient is transferred from one ward to the other or one unit to the other, proper transfer order should be there, everything should be mentioned in detail. Otherwise, the lack of communication can lead to some mishappenings, and we may be simply facing the bad things. Outlying patient is a patient who you have admitted under your unit, but since in your ward there is no availability of bed and you have occupied somebody else's bed on the request of, suppose we are all internal medicine people, we find that there is a bed empty in the orthopedic ward. So simply for the sake of admission, we have requested our orthopedic counterparts that please admit this patient in your ward, and they have obliged us. But remember that their staff is not tuned to the medical care which the patient is going to receive in your ward. So standard of care may be totally different in a surgical ward or a orthopedic ward, and it may be totally different in a medicine ward. Important thing is, another important thing is the communication between medical and the nursing staff. So nursing may not always communicate very clearly enough and may struggle to convey the urgency of situation. It is a very, very common problem. Whenever we encounter such a situation, we will say, why didn't you inform us? So this is a biggest barrier. Somebody was there probably because of their lack of awareness, lack of knowledge, or lack of, or their ability to interpret the situation. They could, and even if they interpreted, they couldn't communicate to you. So this is again there is a communication. So there should be a proper communication. There should be a cordial communication between the medical staff as well as the treating physicians. Also, there is a reluctance to call the doctors. Sometimes we also are responsible. Whenever our staff calls us, we don't speak to them properly. We are angry on them. Why are you calling me again and again? Why this is happening? So you don't know why your patient is calling. So this puts a kind of barrier in your staff, and your staff may be afraid of communicating to you. So they will try to avoid many formal communication to you when it was actually required. So this can lead to a lot of mishappenings in the ward. What are the challenges for the doctors? From the doctor's perspective, you look, they face difficulties when making decisions about the urgency of a patient's need based solely on a phone call. So if you just get a phone call, you don't have any clue that what has gone wrong. So you are not in a position to make any decision in such a case. So it is again very, very important that if you are well informed about that patient, then probably you can take some right decisions. So lack of clinical context and familiarity with the patient care make the decision-making process challenging. So this is again a big barrier. Then there are errors with the written communication. Sometimes there is an incomplete and inadequate documentation. So observation and fluid charts may not always be completed correctly. I think we have observed many a times that you have seen the chart is empty all the night, but in the morning when you see, everything is written there. So sometimes somebody has not even taken the observations, like simple observations like blood pressure, pulse, and they have only documented it. So there is this can also be a reason that your patient has gone deteriorated. Also, there is a missing or discrepant documentation, something which is not matching with the patient's profile. So these things can sometimes inadvertently happen. Ineffective paper charts. We know that whenever you are taking a rounds, nurses are putting their notes separately, doctors are putting their notes separately, and there is a big ICU sheet which is totally separate. So there is no connection between what one is recording. So it is important that everyone documents on the same chart, and whatever is happening, it is visible to each and every person of the team. So this is again very, very important. So separate medical and nursing documentation makes it difficult to interpret or predict any alarm which is already there and which may be ignored. Working condition, we know that most of the time the hospitals, they may be having a problem with the staff. Staff may have gone to leave, they may have gone for tea breaks, or they are having the sick leave, so you are working with the less staff. Time constraints is again a very, very important factor, because difficult to allocate sufficient time for patient care. Sometimes you have so many patients in the ward and you are rushing through the rounds. So during that rush, you may simply sometimes miss even the some of the signs which may be easily picked up if you are able to devote some time. So lack of time can also be one of the factor. And weekends and nights are especially challenging, because during these times, most of the senior staff is on leave. And your unit, your hospital is mostly dependent on the junior staff. So junior staff may not be having that much training at that point of time. They may not have acquired that much expertise which a senior person will have. So these weekends and nights are especially very, very problematic. And a patient who was doing very well during the weekdays, you will find that you will wonder that what happened to this patient when you return after a couple of days of leave or after a weekend. So it is important to have experts available round the clock. Nighttime observations is something very important, that routine observations. I want to emphasize one point here. We talk about few vitals. So how many of the doctors, they themselves record the blood pressure? I don't think anybody of us goes to the ward and record the blood pressure. Your staff may not be recording it properly. Respiratory rate is one of the very critical parameter, which is an important observation. But respiratory rate is hardly recorded. You will find a standard 16 per minute, 12 per minute. So you will find every patient is breathing at 12 per minute. So these are the observations, these are simple observations which have to be recorded meticulously. Staff composition is again very, very important. That is why there is a structure of junior resident, senior resident, assistant professor, associate professor. So there is a mixed team, so that everyone brings a level of different expertise and different kind of experience, and this team actually works well. So staff composition is again very, very important. And sometimes patient turnover is very high. Your patient is lying in the emergency department, the patient is not adequately evaluated, and patient has been rushed to the ward because they want to clear the emergency bed. So when you are admitting the patient to the ward, you should be very confident that the patient actually is a ward patient. It is not a critical care patient. So rushing at the emergency unit can again lead to a patient entering your ward who was actually sick, who required admission in a critical care unit, but because of the improper assessment, patient ended up in the ward. So also because of the fast turnover, sometimes you are under the pressure that you want to discharge patients very quickly because there is a high turnover. So you may end up discharging a patient who has not actually recovered till now. So these are the challenges which we need to understand whenever a patient is there. Then sometimes environmental factors. I don't know about, we all know about the private hospitals as well as we know the government hospitals. So the wards in a government setup can be just like a fish market because there are multiple attendants, multiple staff, multiple doctors. We don't know what is happening there. So it can be sometimes very, very chaotic and can lead to noisy atmosphere which can actually compromise the communication as well. Then there are monitoring challenges. So monitoring, sometimes the patient is admitted in a side room, patient is in some other unit, so they are not under the direct vision of the staff. So the staff is not able to see anything which is happening to them. So this is again a problem. And the impact on working culture is again important, that how the working conditions they are provided at a place. So if the working conditions are very good, the staff will be working more efficiently, the doctors will also be working more efficiently. Another important thing is that the task factors. So what are the tasks? So one of the most important tasks is to record the blood pressure, vitals, but they are considered as low priority. So doctors as well as the nursing staff sees this work as something which is not theirs. So they don't do it happily. So no doctors goes to the ward and takes blood pressure themselves. Nobody goes and check blood sugar themselves. We don't have that much time because there are so many patients. But this can be because of the low priority perception. And then variability in observation frequency. In SDU unit, observations are seen as integral to patient care, while some other units you have written more frequent observations, but more frequent observations simply doesn't happen. There are issues with the early warning scoring system also. The score which I have shown earlier in my slides, it also comes with limitation because sometimes there may be too many false alarms. So every time if you go and see a patient, and this can also be a pressing effect from the patient also. Sometimes attendant of a patient may be very, very demanding. They will come to you again and again for each and everything. And you will simply say that, no, nothing is wrong. But he may actually be coming to you with some major problem. So this is a time where you will think that if I would have heard that patient at that time, probably I would have saved this patient. So these are the things which are happen. So what is important is that sometimes lack of knowledge and training, lack of calculative skills like numerical skills, for example, calculation of the wrong doses whenever you are giving something in infusion or you are giving some life-saving drugs. Responsibility delegation is again who is responsible for the ultimate patient care. Lack of awareness about all these aspects, and experience matters. So it is not that everything you can acquire in a day. It is with experience, the physicians, they become more and more wise, and over a period of time, they acquire this gut feeling also. So a senior physician may simply come and say, this patient is sick, shift him to the ward. And a junior physician may not be able to understand why the doctor is saying this. So this comes with the experience, and I don't think any book can describe that experience. This is something which a physician acquires over a period of time, and this is something which is very, very personal. Patient factors. You have said communicated something to the patient, but the patient doesn't understand your language. So the communication has gone wrong. You have asked the sister to take the temperature every hour, but the patient attendant told that, no, don't disturb the patient is sleeping. Don't take the blood pressure, don't take the temperature, everything is fine. Though you have observed, because you are told that BP to be recorded every hourly, urine output is to be recorded every hourly, but the attendant doesn't want that the patient to be disturbed. So this can lead to lack of observation. High patient expectations can again be demanding, and apparent health and non-clinical signs. Non-clinical signs are something which are not mentioned in the vital. So this is something I think which an experienced physician may be able to pick up during the round. For example, a patient may simply say, I am not feeling unwell. So this is not a clinical sign. This is just a symptom. But why somebody is not feeling unwell, I think it is very, very important to understand and pay some attention to that description also. So this is about the non-clinical signs. So lack of teamwork is again, this is very, very important. So we should all work in a team. So senior is saying something, junior is doing something, and nursing staff is doing something else. So this will not help the patient at all. This will lead to the more complicated outcomes, more adverse outcome for the patients. And also hierarchy and communication. We know that I had discussed in a previous slide also, hierarchy and communication is very, very important in medical field. We respect all our seniors, and sometimes because of that hierarchy, the communication dies down. So if you need to report something to very high authority, you will think twice whether what my HOD will think, what my associate professor will think, whether he will feel that I am talking something silly, he will feel that I don't know about this. So I think when we are practicing medicine, we should ignore each and everything like this, and we should be very clear in our communication so that our patients can benefit from that. Also, sometimes the hospital may not be supportive. You are doing everything right, but hospital is not supporting your decisions. They are pressing you for multiple things. Unclear roles and responsibilities. We know that sometimes even non-medical persons now they are managing hospitals, so they will not understand your medical needs. They will simply understand that this is the bed, this is why this bed is vacant, and why this. So it is important to have enough and good knowledge of the hospital system, how the hospital system works, and sometimes this, if it is not clear, it can be a problem for the patient as well. So lack of guidelines, low morale, no culture. Sometimes equipments may be equipments may not be available. Sometimes you are over relying on any kind of technology. So for example, you put a patient on early warning sign score, and you are simply believing that, and you are not ignoring your clinical skills. So this is again not going to work. And if you have admitted a patient who may require some kind of equipment and resources, and you have not explained to the patient, then again this can be a factor which will not lead to a good outcome. I will not go into the details of individual factors and other things. So these can be, doctors, we do long shifts, so you may be tired, you may not be able to see the patient properly, you may not be in right sense of your mind to take the right decision. So I think the long duties, 48 hours, 3 days in a, we have all done that, 2 days, 3 days at stretch, working all day, all night. So sometimes that can be very, very challenging, and this can be a harm to the patient. We can do more harm to the patient rather than doing any kind of benefit to the patient. Also, some nursing staff can develop coping strategies to manage their workload, and including avoiding scoring patients to save time. So sometimes there are so many patients, a nurse has to do so much of the work, they have to do each and everything. And so if they devote more time on one patient, definitely somebody else's time will be less. So it is important to have the adequate ratio, adequate staffing in the hospital. Using findings to improve practice. So what can be done? So address staffing and workload issues. So if there are any staffing issue and workload issues, it has to be addressed properly. Emphasize on regular training and education. So it is important to conduct workshops. It is important to communicate regularly with your staff, so that they understand what you want to convey and how they should gel with you as a team. Strengthen leadership. So a true leader is the one who leads from the front. So don't shy away from taking responsibility. So if somebody is admitted under us, if something goes wrong, don't shout on your staff. Don't tell them that you have done this, you have done that, you have done. So we need to take the responsibility, and taking responsibility means developing a culture where your staff is comfortable with you and is able to communicate more effectively with you. So this covers the another important point, that is the enhanced communication and clarify role and responsibilities. So it is important to define clear-cut roles in the team, that who will look after this, who will look after this, and if this goes wrong, who will be informed. So there should not be any confusion. You should always be open to any kind of communication to you whenever we have patients admitted under us. So it is important to have adequate equipments if we are admitting somebody under us, because it becomes our responsibility. Value each and every observation. Simple parameters like pulse rate, systolic blood pressure, diastolic blood pressure, temperature, fluctuation in the respiratory rate can give you a very, very important information that this patient may be having an impending trouble, which you can sense early. Improve policies and procedures. So it is a constant process. It may not happen in a day, but with each and every day, we need to develop some kind of policies and procedures so that every time we shall not be repeating the same mistakes. Consider the healthcare environment. So address environmental factors such as noise, interruptions that can affect staff's ability to detect deterioration. Also promote a culture of responsibility where each and every person of the team feels responsible. So this is how I think we can navigate through a troubled water in the ward, and we can identify patients who may actually end up with a critical illness in the ward, who are actually not admitted with a critical illness. So early identification and management of the clinical deterioration is paramount in delivering high quality patient care, and through recognizing signs, timely response and collaborative efforts, we can make a significant impact on patients' lives. Thank you.
Thank you, Dr. Gupta, for taking a wonderful topic. Today, many of us, our colleagues, when you go to ICU, look at the charts, not the patients. But the vital signs that can illustrate by touching a patient, it's much more than the gadgets can tell us. Secondly, many studies I have seen both students, nurses, even faculties. The first one told by you is respiration, nothing new, nothing great. It's there in textbook of medicine. But that is not looked at. Respiration not counted by most of us. So, holidays, I am always scared when the holiday comes. The previous day, many people will deteriorate. Or that night, people will deteriorate. On Sunday by evening, if by chance you go, you think so many things have gone wrong. So there are very, very vital aspects of critical care medicine has been touched upon, dealt with, and the practical aspect. Again, going back to clinical, yes, questions please.
About the early deterioration of clinical symptoms. Now, with the help of ACP, and we have got even partners from Japan and Korea also, can we not think of some devices which are portable, which are applied to the patient, and they can be detected with the help of AI, and they will give early warning signal. Like what you said, respiratory rate is one thing which is not calculated by. People just look at and just give approximate respiratory rate. Similar thing which we have found in dengue patients, if your pulse pressure goes on reducing, that is a red flag sign. There are so many clinical things. We have to have a marriage between the clinical things and the technological aspects of it, and that will help a small place physician very significantly. Because in dengue, Maharashtra now, dengue is running like anything. I have got 15 to 20 patients running out. It is not possible to track their vital signs. So do something with the help of, because in ACP you must have seen, there are around 15 to 20 stalls of only digital monitoring. Why don't we bring them here? Because it is the number which is important. If we buy more, then the cost will be less. This is actually a very good way of sensitizing people about technology.
I think, sir, we can think about that. Sir, I would just like to share one example that how things can go wrong in a ward. One day I was taking the round. There were 20 patients, 20 patients in the ward. One patient started to have chills. Then second patient started to have chills. And all of a sudden, 10 to 15 people in the ward, they are shivering. So as a consultant, you are taking the round, you don't know what has happened to them. So immediately you ask the nursing staff and you find that the nursing staff has given some antibiotic in ringer lactate. So in the ringer lactate, because it is not supposed to be compatible, all the patients are developing shivering. So if you don't happen to be at that time in the ward, there was a lot of panic which was happening. So sometimes going deep into what is happening and understanding your staff and educating the staff at that multiple times is very, very important. Yes,
Thank you,
Dr. Arvind.
Chairperson, for the opportunity. Dr. Amit, a wonderful talk. But just a comment, I differ in one of your, duty hours. There are good quality studies now, if you see, in medicine residents, in critical care, that if you have short duty hours compared to long duty hours, so the outcome of patients were not that optimal once you minimized your duty hours as one do in other profession. So definitely it's a debatable issue because you have to take care of our residents' health also. But somehow the outcome are in favor that long duty hours in critical wards favors patient outcome. At the same time, the rider is that we are for residents, their health is also important. But what is important is the studies doesn't show that. Sorry, I forgot to my name is Arvind from AIMS Delhi. Thank you very much.
Thank you, Arvind, for the nice comment. You may be right in some sense, maybe 24 hours we are all supposed to do. But when you stretch 2 days, 3 days, you don't have any backup, you don't know how to take care of yourself. I don't know whether the study will show it or not, but this is a general perception. This is not going to improve. This is definitely going to blunt our faculties to take any kind of clinical decision.
Thank you, Dr. Amit, for the
Thank you, sir.
wonderful talk. Now we'll go for the next talk. That is the gateway to the clinical medicine. Having a nice this thing that unmasking of the faces. Many these days we diagnose from the face, and Dr. Mukhyaprana Prabhu, he will be speaking on this. Next one, right. So nails tell the tales when it is unpolished. So a lot of information do come from nails on examination of nails, and Dr. Mukesh Gupta will be speaking on that.
So, a very good morning to everyone. And what I am supposed to talk today is nails tell tales when unpolished. And let me confess, when I got this subject from Dr. Virmani, on the first instance, I thought of requesting of changing this topic for me. But then I pondered for a while and I thought that there must be a reason that why he has asked such a basic topic to be discussed at such a prestigious forum in front of lot many senior physicians and clinicians. So once I prepared the presentation, I was of the opinion that yes, despite we are living in the era of artificial intelligence, the clinical things cannot be omitted. They are still very relevant and very important. Let us see whether I am able to create that sort of opinion after my presentation in you, and maybe I prove my worth for the topic suggested by Dr. Virmani. So my flow will occur through very basic things about nail, and then I'll take you through what happens in various sort of conditions. So nail, as we know, that it is a plate of keratin that covers the dorsal aspect of digital phalanx, and changes in nail color, texture, appearance point towards underlying disease, and this is what I like to talk. Basic structure of the nail, it consists of the matrix or the nail plate. There is a free edge. In the proximal part there is cuticle, and there is a moon-shaped area which is known as lunula. And around nail there are very interesting facts. The first is it grows at a pace of nearly 0.1 millimeter per day, and it becomes clinically important at times. Then dominant thumbnail tends to grow faster. There are conditions where it will grow slow, like aging. It can grow fast, like in pregnancy and hyperthyroidism. Another very important aspect is that you can have a clue to the handedness by seeing the lunula or that lunar area. The larger area of lunula in your thumb points towards your dominant handedness. And second thing is the wider angle of the nail also points towards the handedness. So very interesting facts around nail. And if I talk of ancient science, Ayurveda, that is, we know that it's much older than our modern science. And that has also talked about the appearance of nail and maybe getting some clue about what is happening in the body. The lunula in Ayurveda represents Agni, or the fire in the body. And then it talks of whether the person is having deranged sort of Agni or Visham Agni, slowness of that Agni, or that is Mand Agni, or Tishn Agni, whether it is in the hyper state. So if suppose the lunula is low or it is absent, it points towards poor digestion, poor metabolism in the background. Likewise, if suppose the lunula is on the larger side, it talks of Pitta, that is the increased sort of fire or Agni in the body, and that points towards other illnesses like hyperacidity, inflammation, malabsorption of the nutrients, so on and so forth. That means nail as such, observing them, Ayurveda talks of these Vat, Pitta or Kapha as dosh and points towards some sort of assessment about the nutritional health or the metabolic health or the digestive health of that individual. So this is in brief about the doshas which are talked about in Ayurveda. Coming to the examination part. So once we are talking of nails, we have to have a systemic examination pattern. So we'll first look at the nail plate, then look at the lunula, then going on to the nail bed, then under the nail, that is the hyponychium, and the processes around the nail and the skin, and then we'll compare it with other limb or the foot or the other hand. So this is how we will go in for the examination part. And now I'll give you, and I'll seek your attention to look on this picture carefully, and I'll be taking this as a pre-quiz for the presentation, and I'll come back to these three cases once again after the presentation. And probably the answers, they will be met. So keep the answers with you. On the left are the conditions, and on the right is the figure or the picture. So just focus on the nail, looking into those parameters, and keep the answer with you. I'll come back to these cases at the end of the presentation. On the left, the conditions remain the same, but the nails have changed. Once again, look carefully onto the nails. Remember them, what is happening to the nail, the plate, the distal half, the proximal half, the lunula, the color, all these things. Remember them, try to focus onto the diseases on the left, and we'll come back to it again. Case 3, another same conditions, but the nails are different. And once again, this will be interesting. Let us talk about the nail plate now. So first and the foremost thing what we see is the nail plate, and we see various sort of patterns. The blue lines, they are the transverse depression in the nail, and it is indicative of a systemic illness. And therefore, once you see that ridge, and then gradually it grows with time. So the distance from the cuticle to that ridge points towards the duration of the illness, whatsoever has happened in the past. If suppose you happen to have two lines, the distance between the two will give you an assessment of the time gap between the two illnesses. So if suppose it is 6 millimeters, here approximately talks of two illnesses, systemic illnesses, nearly 2 months apart. It happens because of the arresting of the growth of the matrix. It happens because of various viral illnesses, hand, foot and mouth disease, measles, diarrhea, Kawasaki syndrome, peripheral ischemia, and any other serious systemic illness can lead to arresting of the growth of the nail matrix, leading to these production of bulines. If suppose we have more serious bulines, it is known as onychomedicis. So it points toward more serious sort of illness. And here what happens, that distal to the bulines, the nail tends to separate. It tends to break. So this is what is known as onychomedicis, and it basically denotes same pattern, same mechanism, but more serious in nature. The longitudinal ridging, that longitudinal lines right from the cuticle till the end, and many of us will be having it, including me. And this happens with aging also, but otherwise in conditions like gout, peripheral vascular disease, viral infections. Coming to another is clubbing, which we all know about. And here it is the Shamrock's window, which is caused because of the obtuse angle, which is known as the Lovibond's angle, formed at the base of the cuticle, and these two Lovibond angle will form the Shamrock's window. So the obliteration of this Shamrock's window is known as clubbing. I will not go into the details because you all are aware about the causes of clubbing. Primarily happens in 5 to 10%. Most of them, they are 90% in the acquired sort of causes of clubbing. It may be pulmonary, cyanotic heart disease, GI causes, hyperthyroidism, and it may be unilateral in the in sort of AV fistulas. But a point to note here is that COPD doesn't cause clubbing. Koilonychia is the spoon-shaped nail that occurs mainly in the iron deficiency anemia, but in other conditions also we can see hemochromatosis, Raynaud's phenomena, porphyria, scleroderma, thyrotoxicosis, diabetes, syphilis, Plummer-Vinson syndrome, and it occurs because of oxygen deprivation that causes the matrix to go plantar grade. The other cause for this koilonychia is low cysteine content, which also is accompanying severe anemia. Coming to pitting, a couple of pitting here and there is a normal phenomena, but if suppose it is happening more than 6 on a nail in a linear pattern, that is basically significant pitting, and it happens in connective tissue disorders, collagen vascular disorders, Reiter syndrome, rheumatoid arthritis, SLE, psoriasis, and other skin conditions. So this is what is pitting. Coming to onycholysis, that is the separation of the nail plate from the nail bed at the distal aspect of the digit. And it is associated, if it is happening in a typical pattern, it is happening more in the 4th finger, and then following is the 5th finger and the remaining fingers. This pattern of onycholysis is seen in hyperthyroidism. So that can be a clue to what is happening in the background of the patient. But that onycholysis generalized can happen in amyloidosis, multiple myeloma, Raynaud's disease, diabetes, porphyria cutaneous tarda, syphilis, histiocytosis X, Hansen's disease, hypothyroidism, pregnancy, and other conditions. Nail beading. Now this is wax-like dripping onto the nail, and that happens in endocrine disorders like diabetes, thyroid, and Addison's disease. There can be a central nail ridge, which can be predictive of an iron deficiency, folic acid deficiency, protein deficiency, or there can be a central nail canal right in the center, which can give an appearance of Heller's fir tree deformity, and this is, there you see that the cuticle is mainly normal, and this is also seen in association with severe arterial disease, severe malnutrition, repetitive trauma. Splinter hemorrhages we all know about. These are linear hemorrhages in the distal part of the nail, seen in Sabe, APL syndrome, sarcoidosis, SLE, rheumatoid arthritis, thromboangiitis obliterans, scurvy, severe anemia, patient on dialysis, pityriasis rubra, biliaris, and these are very characteristic seen in, and I have given this in one of the cases. Coming to another important part, and that is beaked nail. Now that happens because of resorption of the distal phalanx, which can happen in hyperparathyroidism or in renal failure, which may be associated with pseudo-hyperparathyroidism, in skin disorders like psoriasis, maybe in a disorder like progressive systemic sclerosis. Nail thickening is a common finding which can occur in various disorders because of the slowing of the nail growth. So there is accumulation of matrix. It appears rough, thick in onychomycosis, chronic eczema, peripheral vascular disease, yellow nail syndrome, psoriasis. Now coming to the color of the nail. It can be focal color change or it can be a generalized color change. So we are focusing on to the lunula. Once the lunula is absent, it focuses towards anemia or malnutrition, maldigestion, as it is also talked about in Ayurveda. If we talk of red discoloration of the lunula, it is seen in cardiovascular disease, collagen vascular disease, hematological malignancies, and if it is a pyramidal shape, prominent lunula, it may be because of the excessive manicure or trauma. There can be important brown lines, which are longitudinal lines, which happen because of increased melanin production by the nail matrix melanocytes. It can be indicator of Addison's disease. Nevus at nail base, then you will be seeing that nevus. Breast cancer, or it can be melanoma. Once again, you will be seeing the periangular pigmentation there, and trauma. So these are the conditions. So Addison's become important here. Then coming to the Mees and the Merkes lines. The Mies lines appear as transverse white lines which move with the nail growth. It happens in heavy metal toxicity, chemotherapy, septicemia, aortic dissection. The Murky's lines, basically they are non-moving lines, non-migrating lines. They are parallel white irregular lines. They are caused by edema to the nail plate. It happens in hypoalbuminemia, less than 2.2 grams per deciliter, and they tend to disappear once you correct the hypoalbuminemia. So these are indicators, and we can have a differential also. If we talk of the renal involvement, then you will see a brown sort of tinge at the end, and that is predictive of the renal involvement. Terry's nail or the 50-50 nail, half-half nail, the half of the nail is of different color, the proximal one lighter, the distal one the darker. They are seen in liver cirrhosis, renal disease, peripheral vascular disease, Raynaud's phenomena, SLE and other connective tissue disorders. And once again, if you happen to see the terminal brown sort of line, it is indicative of renal disease, and if that line is not there, it is indicative of liver disease. Generalized discoloration seen in various conditions. It can be yellow nails, which can be in chronic pulmonary infection, lymphedema, bronchiectasis, but other conditions like diabetes, hypothyroidism, Raynaud's disease, rheumatoid arthritis. In these conditions, you can have yellow discoloration of the nail. White nails in conditions like anemia, renal failure, cirrhosis, diabetes, chemotherapy, and hereditary, which is rare, of course. Pink or red nails in polycythemia, SLE, carbon monoxide poisoning, where it tends to be cherry red, angioma, and malnutrition. Melanonychia, this is not traumatic nail. It is the color of the matrix is something like this. It is seen in conditions where you have small cell lung carcinoma producing ACTH or MSH, Addison's disease, HIV. Other nail colors are also possible. These are rare to see, but then orange color, blue color, black color, gray color nails can also be seen in these conditions. Processes around the nails. We can see periungual telangiectasia, dilated capillary loops, and atrophy of the cuticle in SLE, dermatomyositis, or scleroderma. We can have certain lesions around the nail like mucus cyst, fibroma, or malignant melanoma, or masses like pyogenic granuloma, which is commonly seen in patients with the pyronychia, warts, fibroma, and malignant melanoma. Now I'll take you through, because I've explained the things which can be seen on nail, I'll take you through other way around. Let us talk about disease conditions like diabetes. What do we see? Because of diabetic angiopathy, diabetic peripheral neuropathy, or immunopathy, we can see periungual erythema, telangiectasia, yellow nails, onychogryphosis, ram horn nails, which are depicted there in the image, vesicles and bulla on the toes, or onychomycosis. These are the conditions which can be seen in diabetes. Nail signs in thyroid disorders. If we talk of hyperthyroidism, I've already explained the differential sort of onycholysis which can be seen, or in hypothyroidism, it can be slow growth, haplonychia, that is thin nails, longitudinal sulcus, brittle nail, and chronic mucocutaneous candidiasis. Nail signs in hypo and hyperparathyroidism. In hyperparathyroidism, I've already explained the beak nail because of the absorption of the terminal phalanx. Hypoparathyroidism can lead to brittle and thin and fragile nails affecting the distal half of the nail and finger clubbing. In renal diseases, we can have these sort of appearances. Once again, they are pointers to nail patella syndrome, hereditary osteoonychodysplasia, Hood syndrome, or it can be seen in half-half nail like Terry nail, which I have explained in azotemia. In nephrotic syndrome, we can have Merkey's bands and splinter hemorrhages if the patient is having multiple dialysis. In GI disorders, we can have this Bejet's syndrome, which is basically the paraneoplastic syndrome with keratosis of the palms and acral skin, featuring nail plate thickening, subungual hyperkeratosis, longitudinal ridging, discoloration, and nail plate loss. So these are things which we often see in our clinical practice, and they can point towards some background illness. In respiratory disease, a person who is a smoker, we can see two-color nails. If the person quits smoking, otherwise there are brown nails, but if the person quits smoking, then the natural, normal nail grows, and you can see that sort of pattern happening in a person who is a smoker. In psychiatric illness, we can see a person biting nails, so it's a bidet nail, or hang nails, which can be seen like isolated small tags appearing from lateral to the cuticle. We can have those small nails-like structures having present there. Then nail signs in hematological diseases, I already mentioned about the pallor and the koilonychia. Talking of connective tissue disorders, I have already mentioned lot of abnormalities there that can be pterygium, inversum unguis, the periangual hemorrhages and ulcerations in the sclerodoma, erythema of the distal nail folds, hyperkeratotic thickening and roughening of the cuticles in dermatomyositis. Connective tissue disorder can lead to these sort of telangiectasias, hemorrhages. Coming back to my case number 1. So what can be the possibility now with whatsoever I have discussed? These are yellow nails. The lunula is present. It is appearing to be rough. The probability in most likely case is diabetes. Another thing, it is the terry nail. The distal part is going, it is basically going off the base. The lunula is absent, so it is focusing towards a liver disorder. Here we see the splinter hemorrhages very clearly. So out of these conditions, probability is SLE. So dear friends, I know that nails can certainly be not a pathognomonic as far as the examination is concerned, but certainly the clues, they can lead to detection and confirmation of various other systemic illnesses. As clinicians, as diagnosticians, we are obliged to make use of this information in our clinical practice. And I leave you with more images which are very clear. Like once again, you can see terry half and half nail here with a brown distal band there. So it is pointing towards, and the second, the little finger is beaked. So it is pointing towards renal failure and hyperparathyroidism. Here is another patient with thyrotoxicosis having that half and half nail and the onycholysis which is happening here. This is what, and the lunula is suggesting towards the thyrotoxicosis. The brown longitudinal line focusing towards presence of Addison's disease. So dear friends, nails certainly important, and once unpolished, certainly they are clue to lot of clinical things and they tell lot of tales. Thank you so much for your patient listening.
Thank you, sir. Thank you for the brilliant deliberation. And we know that clinical medicine could be so nice, can diagnose so many diseases on examination of nails. We can take quickly one question if we want to keep in time. Can we take one question or one comment on examination of nails regarding various systemic illnesses? Okay? Okay, sir. Thank you.
Thank you so much. Thank you so much.
Now we'll go to the next session.
Can I call upon Dr. Shankha Gupta, deliberate on skin, answer very important element of the examination of any patient is the examination of skin. They overclothed patients, covered all over, you have to find a skin to look at it.
Yes.
So please guide us.
Good morning, respected chairpersons. I thank the organizing committee of Dr. Anuj Maheshwari sir, the governor of ACP, the organizing scientific chair, Dr. Anil Virmani sir, and the main person behind the show at Bhubaneswar, Dr. Jayant Panda sir and team for this opportunity. My topic will be on skin, the warning signals. That means the systemic diseases which we can learn from skin. So I will be focusing on mainly some pictures, and I will be not going through my slides because it will be more cumbersome, because there are multiple areas which I need to show the photographs so that we can keep it in our mind what are the skin manifestations. So dermatological complaints are a common reason for presentation to a general practitioner. Complaint may be a manifestation of a more serious underlying systemic disease. Disorders of every organ system may cause skin symptoms and signs, and some symptoms may be due to the treatment of these conditions. Most common is pruritus, a common complaint of dermatological disease. In the absence of a rash, requires investigation and exclusion of an underlying systemic disorder. Many patients will develop excoriations and with time may develop prurigo nodules. So it is important to distinguish these from an underlying primary skin disease such as scabies or eczema. There are various disorders like anemia, myeloproliferative disorders, uremia, cholestasis, hyper or hypothyroidism, which can cause pruritus. Now there is vitiligo. Vitiligo is very commonly encountered. It can be a part of polyglandular syndrome type 1, and most common associations are Hashimoto's thyroiditis, Graves' disease, rheumatoid arthritis, psoriasis, type 1 diabetes, adult onset mainly, pernicious anemia, SLE, and Addison's disease. Though this is psoriasis. And psoriasis, the medical associations are arthritis, inflammatory bowel disease, obesity, cardiovascular disease, hypertension, and dyslipidemia. Xerosis is commonly found. Now, SLE is one of the most important skin findings we get when we are treating our patients. It involves the malar erythema, photosensitivity, and certain other involvements of the arthritis, nephropathy. Subject, and we know the skin manifestations are very important. Regarding systemic sclerosis, scleroderma is a group of autoimmune disorders which includes morphia, systemic sclerosis crest, and underlying mechanisms are quite complex. The other symptoms might be GI symptoms, shortness of breath due to ILD or pulmonary hypertension, cardiac and renal involvement might be there. Then the CREST syndrome, that is calcinosis, Raynaud's phenomenon, esophageal involvement, sclerodactyly, and telangiectasia. Out of these, the cutaneous calcinosis, the sclerodactyly, and telangiectasia of CREST syndrome are seen in this picture. They are anti-centromere antibodies are positive. It has better prognosis than systemic sclerosis. Now, erythema nodosum is another important clinical finding, such as tender erythematous nodules over extensions of legs. And most importantly, it's found more in women, but the causes might be infectious diseases, drug-induced, inflammatory, sarcoidosis, even malignancy, and sometimes idiopathic and in pregnancy also. Pyoderma gangrenosum, the associations are inflammatory bowel disease, rheumatoid arthritis, ankylosing spondylitis, and certain hematological malignancies. These are very important, which starts as a papule or a nodule and rapidly ulcerates with undermined borders and violet bluish ridge. Now, venous insufficiency is something which causes skin discoloration, and the hemosiderin deposits cause this color, and certain patients come with these features of chronic venous insufficiency. Most important among the rheumatological features are vasculitis, which involves palpebral purpura, papules, vesicles, macules, necrotic ulcers, and edema. It can be due to infectious causes or inflammatory causes like inflammatory bowel disease and other autoimmune diseases, and certain drugs like penicillin, NSAIDs can cause this vasculitis. So there is a huge list, but the vasculitis screen is very important because from that we have to need to identify the underlying disease. Now, HSP, the Honexon purpura, granulomatous and polyangiitis, Chokes-Strauss, cryoglobulinemia, and polyarteritis nodosa are some of the notorious forms which cause vasculitis. Another important rheumatological disease, this is dermatomyositis, which involves heliotropic rash, poikiloderma, Gottron's papules, calcinosis cutis, Gottron's signs, all can be found in this chronic inflammatory dermatomyopathy, which is dermatomyositis. Now, the most common findings in our clinical practice are related to the hormones, and hormones are essential in regulating the physiological processes, and through excess or deficiencies of hormones results in changes in cutaneous function and morphology, and skin manifestations may reflect an underlying endocrine disorders, and that I will discuss regarding hypothyroid disease and also diabetes mellitus. Skin manifestations of both hyperthyroidism and hypothyroidism are there, usually in hyperthyroidism, the warm skin, blush, palmar erythema, hyperhidrosis, onycholysis, pretibial myxedema, thyroid acropathy. I'll show some pictures. And also skin manifestations of hypothyroidism are dry skin, cold blotchy skin, carotenemia, myxedema, macroglossia, and rough and brittle hair. So skin manifestations are quite important when we come across these patients. Generalized myxedema is a result of the deposition of PAS-positive dermal acid mucopolysaccharides in the skin, and usually it's non-pitting. There are cases of congenital hypothyroidism also, which of skin is cold, xerotic, and pale, and edema is there. The non-pitting edema is characteristics. Similarly, the yellow nail syndrome or plumbered nails can be found in due to onycholysis of thyrotoxicosis. Graves' dermopathy is very important, and this particular form called pretibial myxedema is a misnomer, as this form is non-pitting in edema and is not restricted to the pretibial region only. It can appear anywhere in the skin, including forearms, shoulders, arms, and also on areas of traumas and scar. Scleromyxedema is another severe form which is found in thyrotoxicosis. Thyroid acropathy, it involves a triad of digital clubbing, soft tissue swelling of the hands and feet, and periosteal reaction in the long bones. And it is a rare condition in approximately 1% of patients with Graves' disease. Cutaneous conditions which are associated with hyperthyroidism also involves dermatitis herpetiformis, herpes genitalis, pemphigus vulgaris, Sweet syndrome, vitiligo. Now, pretibial myxedema, as I mentioned, of Graves' disease is skin is shiny and orange peel in appearance. Along with that, there will be eye signs of exophthalmos, goiter, nails changes, hair diffuse thinning, and tremors of thyrotoxicosis. Now, another important manifestations which we see is in diabetes mellitus. The key points is the diabetic dermopathy, that is the shin spots, is considered to be the most common dermatological manifestation of diabetes. And 79.2% of people with diabetes presents with skin manifestations. Skin manifestations serves as a port of entry for secondary infection. Candidal infection is quite common. And there is another thing called diabetic scleroderma, which may present as limited joint mobility of hands. The classifications are various. It can involve the vascular, the metabolic, the necrobiotic, the bullous, infectious, neuropathic, treatment-related, and certain miscellaneous manifestations of diabetes. Most commonly, we come across acanthosis nigricans, and this is very common because those with darkened skin color, the patients usually have it. It is found in insulin resistance. Other endocrine syndromes like PCOS, like acromegaly, Cushing's disease, hypothyroidism, and CA of stomach can present with acanthosis nigricans, and obesity and diabetes are the most important cause. They, very importantly, in the back of the neck, axilla, elbows, the palms, the inframammary creases, umbilicus, or in groin. It's not that it is always on the back of the neck. It can be found in other areas also. It's usually symmetrical, velvety, with hyperpigmented plaques. Hyperinsulinemia is very important because it stimulates the insulin-like growth factor, and that leads to these particular findings with hyperkeratosis and all. So if we can pick up early, we can think of a patient who is in pre-diabetic stage can pass into diabetic stage, and these young adults, if we can pick them early, we can recognize and we can treat them, or at least we can ensure that they start lifestyle modifications so they don't go on to develop these type of problems. Similarly, this another findings called acrocordons, and these are benign soft pedunculated growths that vary in size and can occur singularly or in groups. It is more prevalent in those with increased age, weight, and diabetes mellitus, and in women. Diabetic dermopathy is the most common thing, and certain studies have shown that it's quite large in number, affecting 30% of patients with type 1 and 39% of patients with type 2. Eruptive xanthomas are also very important. They are present on the buttocks, elbows, and knees as sudden onset drops of yellow papules with an erythematous base. For diabetic dermopathy, which I said is the most common manifestation, the shin spots, that is multiple oval round macules over the shins, thighs and forearms, the hyperpigmentation and atrophy both are present. It is twice common in older men. And at least there should be more than 4 lesions, and marker of microvascular disease, high correlation with diabetic retinopathy. So it usually doesn't need any treatment. Another thing is rubeosis faciae, that is diabeticorum, that is rosy redness of the face. It is evident in newly diagnosed diabetics with poor glycemic control, which returns to normal after the glycemic control improves. Erysipelas-like erythema is another thing which is seen in elderly diabetics, majority of more than 70 years of age with a longer duration of diabetes. It might involve underlying bone destruction also, and compensatory increase in peripheral microcirculation, and the spontaneous resolution occurs over weeks but may recur. Pigmented purpura is due to RBC extravasation from superficial plexus, and this is quite common. Similarly, periangual telangiectasia can be seen in 49% of diabetics, as presented by my previous speaker. Regarding the nails, I will be skipping those slides. Eruptive xanthomas occur in less than 1% of 0.1% of diabetic patients. These are crops of small yellow papules with an erythematous halo. It may be pruritic and tender, and it resolves with the treatment of glucose and also hyperlipidemia. Yellow skin and nails may be prevalent in 40% in type 2 diabetes, mostly in elderly, caused by hyperkeratinemia and protein glycosylation end products. This is quite important. See these hands, and this signifies diabetic scleroderma. It is due to non-enzymatic glycosylation of collagen. Fingers and the dorsum of hands with limited joint mobility. It can be seen in this picture, and it can be subclinical also, and it improves with tight glycemic control. Another important thing is necrobiosis lipoidica. It occurs in 0.3 to 0.7% of diabetics, more common in females, Caucasians, and mainly type 1, and mean age of onset is 34 years. See these pictures, what are these? These are disseminated granuloma annulari. There is no clear establishment between the relation, but symmetrically distributed on the arms, neck, and upper half of the trunk, less often on the legs. It runs a protracted course. These are papules and annular lesions with raised skin-colored erythematous border with a flat center. Now, bullous diabeticoram is more common in type 1 and in males, usually confined to feet, occasionally hands, spontaneous, not related to trauma or infection, it heals. Bacterial infections are quite common and they need antibiotics. Most commonly, the most dreaded one is malignant otitis externa, cellulitis, osteomyelitis, meningitis, cranial nerve palsies, and it causes mortality also. Candida and dermatophytosis are most common fungal infections we come across. And in certain cases of rhinocerebral mucormycosis, black crust or pus in turbinate, nasal septum, palate, and orbit is quite involved. It can cause cerebral involvement with high mortality. Now the neuropathic foot, that is due to anhidrosis, hyperhidrosis can also occur, but the neuropathic ulcers are circular, punched out ulcer in the middle of a callosity over metatarsal heads. Now certain insulin reactions are also very important. When we give insulin to the patient, when we prescribe, there can be lipoatrophy, which can occur after starting the treatment, and lipohypertrophy resembling lipoma, which can be prevented by rotating the injection sites. So the dermatologic manifestations of diabetes are quite weird and multiple mechanisms are involved, and there are certain miscellaneous causes also. Now bullosis diabeticoram is another thing which you can see in this picture. The bullous can appear and the lesions are quite important, and the treatment is focused on prevention of infection, and if the bulla become large, and so they can be aspirated. Xerosis is quite common, which is another name for dry skin, and we have to educate our patients for skin hygiene. And scleroderma diabeticoram I have already mentioned, and the granuloma annulare are the things which I mentioned in my last few slides. There is another thing is called acquired perforating dermatosis. This is another thing where perforating dermatosis refers to a broad group of chronic skin disorders categorized loss of dermal connective tissue, and majority perforating disorders, reactive perforating collagenesis are quite important. And acquired perforating dermatosis is seen in both type 1 and type 2. The lesions of acquired perforating dermatosis are commonly seen on the trunks and extremities and tend to be pruritic. And in most cases, renal disease is a complication of diabetic neuropathy, and the diabetic complication linked to renal disease leads to this. Onychodystrophy is quite important, and poorly fitting shoes may cause repeated trauma and worsening of the injured site in patients with diabetes, and it is a result of poor peripheral circulation. Periangular telangiectasia is another thing which might be present in around 49% of patients with diabetes. There are common cutaneous fungal infections like candidal vulvovaginitis, perianal candidiasis, thrush, which are very common, even intertrigo, paronychia, and onychomycosis, and they should be treated when diagnosed adequately. Bacterial infection is very important. The diabetic foot ulcers are mainly later infected by bacteria. We have to take care of staphylococcal folliculitis and skin abscesses, and the dreaded ones are when Pseudomonas gets involved. Dermatic dermatopathy initially presents with rounded, dull, red papules that progressively evolve over 1 to 2 weeks into well circumscribed atrophic brown macules with a fine scale. Diabetic foot is one of the most important thing which you come across, and it encompasses not only the neuropathic but also the vasculopathic thing, and it is slightly more prevalent in type 1 diabetes compared to type 2 diabetes. And the scleroderma-like skin changes are quite common. As I showed in one of my pictures, on physical examination, finding known as prayer sign, that is inability to press the palmar surfaces of each hand together, may be present. So the non-specific dermatologic signs and symptoms are also present in diabetes. Now, ichthyosiform changes of shins, which having fish scale appearance on the anterior shin, is also found. Xerosis is quite common. It is present in as many as 40% of patients with diabetes. And to avoid the complications of fissures and secondary infection, xerosis should be managed with emollients. Huntley's papules are also known as finger pebbles, present with clusters of non-erythematous asymptomatic small papules on the dorsal surface of the hand. It affects the metacarpal MCP joints and the periangular areas. Keratosis pilaris is another thing which is present and it on the posterior surfaces of the upper arms are often affected, and involvement of the thighs, face, buttocks can be seen. Pigmented purpuric dermatosis is another thing which occurs in the late stage of diabetes with nephropathy and retinopathy as a result of microangiopathic changes to the capillaries and sequential erythrocyte deposition. Granuloma annulari is the localized granuloma annulari represents as a ring of small, smooth, flesh-colored or erythematous papules stretching the skin, enables the papules to be seen more readily. Sorry, I'm speaking. Now, necrotizing fasciitis is one of the very important forms, and that is very important because in sometimes these cases needs extensive surgical debridement and broad spectrum antibiotics. Now, my last part of my talk will be on the renal diseases, and that includes some nail things also, but I will not be discussing the nail ones. That very importantly, the end-stage renal disease can lead to pruritus, uremic frost, acquired perforating disorder, and nephrogenic systemic fibrosis.
Can you sum up?
Sir, it's showing time. Yeah. 2 minutes left, sir. Cutaneous manifestations of uremia involve xerosis, uremic pruritus. Incidence is 50 to 90%. Pigmentary changes like pallor, anemia, yellow hue, brown black hyperpigmentation on sun-exposed areas are also found. Now, hypercalcemia, hyperphosphatemia, all the complications of chronic renal failure can cause this. This is another important thing, 2 or 3 slides left, that calcific uremic arteriolopathy, that is calciphylaxis. It is metastatic skin calcification, papular or nodulous cutaneous lesions around the large joints or flexural sites. It is due to which abnormal elevated level of PTH, which may trigger the deposition of crystalline calcium pyrophosphate in the dermis and subcutaneous fat or in the arterial walls. And also it involves the acute thrombosis of the calcified vessels, and it is associated with high mortality, particularly when the skin of the trunk is involved. Acquired perforating dermatosis is another thing which the pruritus is a major symptom, and it has a strong association with end-stage renal disease. Bullous disease of dialysis is something, the syndrome of cutaneous fragility and blistering. It resembles porphyria. Plasma porphyrin levels are normal or is only minimally elevated. Uremic frost is very important when the blood urea nitrogen is more than 250 milligram per deciliter. Usually this occurs. It consists of a white or yellowish coating of urea crystals on the beard area and other parts of face, neck, and on the trunk. Amyloid deposition is also very important, and we come across cases like these. The nail changes I am skipping because my previous speaker has also already dealt with it. Now, for the cutaneous manifestation in patients on dialysis, the diffuse hyperpigmentation is most important, and some skin infections also ultimately are put into it. Now, my last slide will be on this particular picture, which is one of the dreaded complications or dreaded diagnosis for us physicians, that the epidermal necrolysis or Stevens-Johnson syndrome. It is a rare mucocutaneous necrotizing condition diagnosed in 1 to 6 cases. Because we have to diagnose it early and treat it, we need to admit the patient, and the first exposure to the inciting drug within 8 weeks of the first dose also this can happen. So Stevens-Johnson syndrome is one of the dreaded complications. Now the outcomes is we have to recognize the dermatological manifestations associated with common systemic diseases, how to assess the patient, we have to consider the differential diagnosis, investigate them properly, know when a biopsy is appropriate, and formulate and implement a management plan for acute period of care. I thank you for your patient hearing, and I said I completed on time 8 seconds before. Okay. Yes, sir. Thank you, sir. Sir, thank you, sir. I tried my best because time constraints I kept in mind. Thank you, sir.
Sango, as usual, fantastic talk.
Thank you, sir.
You have covered such a vast topic in such a lucid manner. Only one perspective I'd like to know that often we come across septic patients with skin manifestation. Would you elaborate acute febrile neutrophilic dermatosis that we sometimes found in the febrile patients.
Yeah, in our ICUs, we commonly come across patients of septicemic patients. There are definitely rashes are quite common. Now, in this period of dengue, when you are admitting our patients in the ICU, it might be dengue. When till the results come in, we don't know whether the patient is in septicemia. Rashes are quite similar, but dengue rashes are quite smaller compared to the rashes we find in septic patients. They usually start as a reddish discoloration and very quickly fade into a darkish color. And even in septicemia, you rightly pointed out that we come across skin manifestations, which can be a sign to send the procalcitonin and blood cultures immediately.
Thank you.
Thank you, sir.
Thank you.
So is Dr. Mukhapranya Prabhu available? Is he here for his deliberation? If he is not there, now this is the end of the first session. Thank you very much.
Thank you, chairpersons and the speakers. Kindly go to the side stage for felicitation. And I would request Dr. Sanjay Arora, sir, to kindly felicitate the speakers and the chairpersons. So now moving on to the second session of the today, it is about charting unknown waters in the ward. So for this, chairing this session, we have Dr. Manoranjan Behra and Dr. Nibedita Pani. Dr. Muklesh Gupta, kindly come for the felicitation. Yeah, he's already. So I'll request chairpersons to kindly invite the first speaker.
On critical care illness management.
Thank you, chairpersons. At the outset, I would like to thank the organizers of IAM ACP 2023 for inviting me to share this prestigious platform with such distinguished gathering. My topic will be on hyperkalemia. I think we all have experienced hyperkalemia in our patients in the wards, and we have managed them very, very judiciously, and we have got very good outcomes as well. This talk will be somewhat a revision of what we've been doing for so many days. Of things that I'll be going to talk would be known to you, but just as a revision, let's talk about hyperkalemia. Hyperkalemia is an abnormal physiological state resulting from high extracellular concentration of potassium. Potassium, as you remember, is an ion which is present inside the cell. In our body, it's somewhere around 3,000 milliequivalents of potassium is there, and 98% of it is inside the cell. So very little amount is actually in the circulation. And this combination of high amount of intracellular potassium and low amount of extracellular potassium is responsible for maintaining the stabilizing effect on the cell membrane. So when this ratio is disturbed because of some reason or the other, the membrane stabilization effect is lost. The membrane gets irritable. You can have arrhythmias in the cardiac myocytes. You can have problems in the nerves. You may even have paralysis, flaccid paralysis of the muscles because of this. When we come on to the definition of hyperkalemia, there's no internationally agreed upon definition. The American Heart Association, the Canadian Cardiovascular Society for Heart Failure, for the European Resuscitation Control, the National Kidney Foundation, all of them have slightly different definition for hyperkalemia. But more or less, all of us agree that if the potassium goes beyond 5.5, definitely we must sit back and think what could be the reason behind this hyperkalemia. The consensus definition comes from the KDIGO guidelines, which not only looks at the definition of hyperkalemia, but also the severity of hyperkalemia. Remember, the severity of hyperkalemia depends not only on the numerical value of potassium, but also on the ECG changes. So if you have a potassium of 5 to 5.9, you might call it a mild hyperkalemia, but if you have ECG changes along with that, then you'll have to label it as moderate. So the overall picture will depend upon not just the potassium level, but also on the ECG changes. What causes this hyperkalemia? Like any other situation, true hyperkalemia may be caused by increased potassium intake. You put a lot of potassium into the circulation, or there could be a transcellular movement. The potassium may move out from the cell where it is present in large amount, and there would be a surge of potassium into the circulation. And thirdly, this potassium that has come in the circulation is not able to be excreted out. All these three conditions can lead to an elevated potassium. But remember, the most common cause of hyperkalemia is a pseudo-hyperkalemia, and we should be aware of that. It's not reflective of the true serum potassium levels. And why does this happen? This is basically an artifact. When you've taken out a blood sample in an improper way, we produce a lot of hemolysis of the RBCs. And this can cause the potassium to leak out from the cells into the serum. And that can cause an elevated potassium. So whenever you have a very high potassium, think about pseudo-hyperkalemia. Along with that, especially if there is no obvious reason, a patient is perfectly all right, just coming for diabetes with normal renal functions, and suddenly you find the potassium of 7. You must sit back and think once again whether could it be a hyperkalemia because of excessive hemolysis during the sampling. So intracellular potassium can be measured in the serum because of the hemolysis, and especially when you are using a syringe instead of a vacuum device. Using a tourniquet and excessive fist pumping during the blood drawing can also increase the risk. Specimen, if they have been taken out from a person with very large amount of cell count, can also cause an elevated potassium. Patients with leukocytosis, thrombocytosis can have a falsely elevated potassium. Again, if the sample has been kept for a very long time, there may be excessive hemolysis and you may have an elevated potassium. Now, this is the usual pattern these days that we are not testing for these sodium and potassium immediately after taking out the sample. Sample is being collected at some center, collected for and kept there for hours together, and then finally transferred to the testing laboratory. Now, this sort of a thing should not happen. Always ask your patient to get a potassium done in a lab which is really doing the test, not a collecting center. Somehow that can mitigate the false readings. Increased potassium intake is usually a very uncommon cause. Just by eating a lot of potassium, we cannot increase our serum potassium unless the renal functions are deranged. Some of the foods that, of course, we must remember can cause elevated potassium is rich potassium content like dried fruits, vegetables like spinach, potatoes, tomatoes, broccoli, beets, carrots. Kiwi, a very frequently being used food, and most of the patients will say that they love to eat kiwis even they don't like the taste. I don't know why. The red meats are also very rich in potassium. Intravenous intake of potassium can also take place in your patients in the wards where you are giving them potassium-rich fluids. And then, of course, medications. You should always remember of medications which can contain a lot of potassium. Then a very important cause is extracellular shift of potassium. If there's a cellular injury, any crush injury, where the muscles have been crushed, trauma, sepsis, severe burn, all of them can cause a lot of tissues to be damaged, and a lot of potassium can really enter into the circulation, creating a really dangerous situation. Insulin deficiency and diabetic ketoacidosis should always be there at the back of the mind. Severe insulin deficiency can also cause hyperkalemia. Now, in diabetic ketoacidosis, even though there's a lot of potassium depletion because of excessive diuresis, but there could be a shift of potassium from the intracellular to the extracellular. So you may have a normal potassium or elevated potassium despite an overall deficiency of potassium. So you have to be careful about that, and supplementing potassium should be taken with a lot of pinch of salt actually. Tumor lysis syndrome, another situation where you have malignancy, lot of tissue breakdown is there, especially after chemotherapy, that can lead to hyperkalemia. Hyperkalemic periodic paralysis is also one of the situation. That is a rare situation, a genetic condition where you can have paralysis because of elevated potassium. Metabolic acidosis, I think, is something that we must remember. At the kidney level, the potassium is excreted along with the hydrogen ions. So whenever there's loss of potassium, the hydrogen ions are also lost. When the potassium is being retained, the hydrogen ions are also being retained. So remember, hypokalemic alkalosis and hyperkalemic acidosis. These things really go together, until of course there could be certain other situation, but for all practical purposes, potassium and hydrogen go together. Reduced excretion. We all know that in kidney situation, when the kidney is not able to excrete out potassium, you can have hyperkalemia. But important thing to remember is that even in pre-renal situation, where because of some reason or the other, there is poor perfusion of the kidneys, even though kidneys are functioning normally, you can still have hyperkalemia. So if there's a volume depleted situation where there has been severe burn, or there have been massive blood loss, or hypotension, severe hypotension leading to tissue ischemia or poor perfusion in the kidneys, all of them can also lead to elevated potassium in the circulation. Tubular dysfunction because of aldosterone deficiency or because of resistance to aldosterone can also cause hyperkalemia. Drugs are a very important cause, and one should always remember, whenever you get a patient with hyperkalemia, look at his drug prescription. Those which can cause increased potassium intake, like potassium chloride solutions, urinary alkalizers, should always be taken into account. Those drugs which can cause increased intracellular potassium, like diazoxide, minoxidil, the calcineurin inhibitor that is being used in patients with kidney transplant, post-kidney transplant, succinylcholine, and some volatile anesthetics can also cause release of the intracellular potassium into circulation. And of course, decreased excretion, we all know about the RAS system and the blockers of the RAS system, but important drug to remember is beta blockers. Beta blockers can also cause hyperkalemia. So if you have a patient with hyperkalemia, look at his prescription. If he has beta blockers, try to remove it. Remember, ECG is not a sensitive method for detecting hyperkalemia and should not be relied on to rule it out. However, it is highly specific. So if you get the ECG signs, you can be rest assured that it is hyperkalemia. But if it is normal ECG, you cannot be sure. If the potassium level is going up slowly, then there might not be ECG changes despite a high potassium. The mean sensitivity is just 20% and mean specificity is 97%. Hyperkalemia is a great imitator and can cause a variety of ECG changes. In critically ill patient, ECG is the most readily available diagnostic tool. Remember the ECG consequences that we talk about. First, the tall peak T waves, and then the P going down and the PR interval increasing. All these changes are not actually happening in sequence. And they do not occur in stepwise fashion. And their evolution may be unpredictable. So don't think this is just the elevated T, tall T peak waves. So it would be a slow progressing, and you still have got time. The next very moment you can have sinus waves in your ECG pattern. There could be a sudden jump from the early sign to the last sign. So this is something that one must remember. One cannot be complacent in that situation, that this is an early sign, probably the patient has time to take action. The ECG changes, I think everyone is aware of that. The peak T waves, the narrow, pointy, prominent T waves. Then the Brady's arrhythmias are very common. Sinus bradycardia, high-grade AV block, slow junctional and ventricular escape rhythms. The sine wave pattern is a profound widening of the QRS complex in peak T waves, which mimics a sine wave. And then the ventricular tachycardia mimics can always be there. So if you look at these important T wave changes, the peak T waves happening, followed by a wide PR interval, the P wave gets suppressed, the QRS starts getting widened, the the T wave also gets widened, and slowly there's loss of the P wave, the T wave and the QRS complex become a sinusoidal wave. And this could be the very dangerous situation. And one must remember that a normal ECG should not necessarily be regarded as reassuring if elevated potassium concentration has been definitely observed. Such patient may still experience sudden hyperkalemic cardiac arrest. Coming on to the management of hyperkalemia, I think we all have managed it. Just a simple revision. The urgency of managing hyperkalemia should be dependent on how rapidly the condition develops. If it's a chronic hyperkalemia, these patients will have very few ECG changes, very few ECG signs, and probably these patients will also not land up with any major complication. But on the other hand, an acutely developing hyperkalemia is a dangerous situation, and you never know how fast it's going to change from the simple peak T waves into a sinusoidal configuration. So any patient with neuromuscular weakness, paralysis, or ECG changes with even a mildly elevated potassium, 5.5 or something, needs management, because these patients are at risk for ongoing hyperkalemia, and any patient with more than 6.5 should of course be managed intensively. The exogenous source of potassium should be immediately removed. Reversible cause should be identified and should be managed. Remember, any changes associated with hyperkalemia in the ECG warrants emergency treatment. You cannot be complacent. Presence of bradycardia, QRS widening, junctional rhythm are associated with increased likelihood of short-term adverse effect. So if you're getting ECG changes, even if you don't have the potassium levels with you, start treatment. It may be reasonable to give IV calcium while awaiting a potassium report. You don't have to wait for the potassium report. As I said, these signs are more or less pathognomic of a hyperkalemic situation. And as you know, ECG changes in hyperkalemia requires urgent, emergent treatment. What we need to do is give IV calcium gluconate, which has got a stabilizing effect on the myocardium. And within 1 to 3 minutes time, it really takes care of the destabilized myocardium. What we need to do is give 3 grams of IV calcium gluconate over 10 minutes. This is what's to be done. Any ECG changes requires this treatment. Potassium more than 6.5, even without ECG changes, it requires treatment. Redosing may be needed if required. Calcium chloride can be given, but the problem with calcium chloride is it has got 3 times more calcium, but is highly irritating, so you cannot give it through a peripheral site. If you have a central site, of course you can give calcium chloride, because extravasation can cause a lot of tissue necrosis. And then calcium gluconate is therefore the drug of choice, is the initial drug in patients with evidence of cardiac toxicity. Remember, calcium should never be given in a bicarbonate containing fluids, as it can cause precipitation of calcium carbonate. Calcium was classically contraindicated in the setting of hyperkalemia and digoxin toxicity, but nowadays we are assured that you can give calcium even in patients with hyperkalemia and digoxin toxicity. About the IV insulin, that is the prime treatment. This is what's going to bring down the potassium level in the blood. Insulin binds to the insulin receptor on the skeletal muscle and pushes the potassium back into the cell. So this would be, the potassium shift lasts for several hours, but may be needed to redose periodically if there is a delay for definitive treatment in form of a diuresis or dialysis. So indication is again, serum potassium more than 6.5 or patients less than 6.5 but ECG changes. The problem is that when you give IV insulin, there could be chances of hypoglycemia. So always give around 50 grams of glucose whenever you initiate the treatment with IV insulin. Dextrose administration may be avoided. You can give simple insulin if the glucose levels are high, more than 250. Between 180 and 250, you can give half the dose of glucose. Keep on monitoring the glucose level if the patient is on an IV insulin infusion, and take presumptive action in case you feel that the patient is landing up with hypoglycemia. Sympathomimetic drugs, they can also cause a shifting of the potassium from the intracellular into the, from the extracellular into the intracellular milieu. Albuterol or salbutamol can be given, but remember the dose of the salbutamol by inhalation is very high. Normally we give 100 micrograms per what you call in bronchial asthma, but here you'd be required 1200 micrograms. So nearly 10 to 12 puffs of salbutamol may be needed in a spacer to give the potassium lowering effect. IV epinephrine can also give the same effect, but it can be dangerous, especially in a situation with cardiac toxicity. You can have a lot of arrhythmias. But in case you have bradycardia along with hyperkalemia, this could be a good choice. It can correct the hyperkalemia as well as the bradycardia. Bicarbonates have proven to be ineffective, especially the hypertonic, but the isotonic bicarbonates can be given in patients with metabolic acidosis. It decreases the potassium in 3 ways: by dilution, by shifting the potassium into muscle cells, and prompted renal potassium excretion by producing a state of alkalosis. Then, of course, GI potassium elimination that we usually do. The GI potassium binding agents are slow in action. So in an acute emergent situation, these are not the drugs of choice. So don't give potassium binders in that situation. Of course, once the primary emergency situation is over, then for controlling the potassium later on, you can use these drugs. Calcium polystyrene sulfonate, which is known as K-bind, is available to all of us, or patiromer has been proven to lower the potassium acutely, but then again, be very careful, don't rely too much on them. Another one is sodium zirconium cyclosilicate, an oral potassium binder, which is safe and somewhat effective. Whether this is clinically beneficial depends on the context. Then coming on to potassium excreting diuretics. Loop or thiazide diuretics may help to enhance the potassium excretion. They may be used in non-oliguric volume overloaded patients. So patients who are volume overloaded and they are still passing urine, they are non-oliguric. These are the patients where thiazide diuretics or even the loop diuretics can be tried. In hypervolumic patients, of course, you can give 40 milligrams of intravenous furosemide every 12 hours, or depending on the situation. If the patient is euvolumic or hypovolumic, that is, there's less amount of fluid inside the body, then you can give this diuretic along with the fluids. And thereby you can avoid further dehydration or hypovolemia. Hemodialysis should be performed in patients with end-stage renal disease or severe renal impairment. When everything fails, this is what has to be done. The prognosis is excellent for patients with mild transient hyperkalemia if the inciting cause is addressed and treated. Sudden onset extreme hyperkalemia can cause cardiac arrhythmias that can be lethal in up to 2/3 of cases if not rapidly treated. Hyperkalemia is an independent risk factor for death in a hospitalized patient. Summarizing my talk, hyperkalemia is an abnormal physiological state resulting from high extracellular concentration of potassium. The most common cause is, of course, a pseudo-hyperkalemia, which needs to be ruled out in all patients where you do not find any definitive cause. The urgency with which hyperkalemia needs to be managed depends on how rapidly the condition develops. For example, there's a condition of hyporenin hypoaldosteronism, which is a chronic condition. We have chronic hyperkalemic situation. These patients are perfectly all right. They have no physical problems, and they do not land up with usual cardiac arrhythmias or paralysis. These patients do not require a very emergent or urgent treatment. So if it is a slow-growing, slowly evolving hyperkalemia, one can be a bit complacent. Presence of any ECG changes associated with hyperkalemia warrants emergency treatment. So the moment you find the patient is hyperkalemic, get an ECG done. Any change in the ECG, even a mild change, because it cannot be relied upon that this patient might not land up with a more serious changes within next few minutes. The prognosis is excellent for patients with mild transient hyperkalemia if the inciting cause is addressed and treated. Sudden onset extreme hyperkalemia can be lethal. This is very important to remember in up to 2/3 of cases if not rapidly treated. So we all have to be careful identifying hyperkalemia, differentiating it from pseudo-hyperkalemia, looking at the ECG, identifying the emergent or the urgent situation that the patient is in, and then treating it accordingly. Thank you for your patient listening.
Thank you, sir, for your very nice description on hyperkalemia. And to summarize, I think hyperkalemia, the most common cause. And we have to see whether it's pseudo-hyperkalemia or true hyperkalemia. If it is true hyperkalemia, if there is ECG changes, you have to be very aggressive. And you have to rule out any causes, dietary causes or drugs. You have to eliminate those things and have to address the primary disease which is causing hyperkalemia and to immediately treat the hyperkalemia. Only one question is allowed, only one question from the audience. If any question at all, one question. If there is no question, thank you, sir.
Thank you. Thank you so much, sir.
Thank you, sir, for your excellent deliberation. Next speaker is Dr. Supratik Bhattacharya, and his topic is hyponatremia. Sir, please welcome to the dais.
The poster competition has started in front of the lift. Those who have posters for presentation, kindly come in front of the lift. Thank you.
Greetings, everyone, and thank you, Dr. Anuj Maheshwari. Thank you, Anil Vipani, sir, for this kind of opportunity and the choice of topic, which I think is very important, understanding how to deal with the day-to-day situation where we deal with this electrolyte disturbances. So I'll be talking about hyponatremia with SIAD in context, and why blood sodium level changes are very important. The reason is the changes in the sodium levels can produce serious neurological symptoms and even death. And low sodium levels can be the most common electrolyte disorder in hospitalized patients. So let's talk about a scenario. This is something which is an acute scenario where a person lands up in an ICU setup. So typically you might get a scenario where a female ends up in the ICU with mild hypertension, admitted, comatose, and a CT scan was done. There was no abnormalities that was found, and the plasma sodium comes out to be around 112 millimoles per liter. So we'll be talking about the water and sodium balance, and we know that when it comes to the extracellular environment, sodium remains one of the very important components. Now, if you talk about the osmolarity set point, there are two things that are very important in terms of maintaining the plasma osmolarity set point. One is the sodium balance, the other one is the water balance. The plasma osmolarity set point is 275 to 295 milliosmoles per liter, and the mechanisms are triggered even if there is a 1% change in either of these. So how sodium level is kept normal? We have multiple mechanisms. One is the thirst mechanism, one is the renal excretion, and also AVP secretion that we are going to talk about subsequently. So how sodium levels are kept normal? Changes in any of the key elements that control the water balance can lead to hyponatremia. So we'll now talk about the different types of hyponatremia, incidences, and presentation of hypervolemic and euvolemic hyponatremia. So the definition and incidence of hyponatremia are: incidence depends on the definition, of course. If the sodium levels are less than 135, the incidence is 15 to 25% of the hospitalized patients. Whereas if it's less than 130, that's something of a rare incidence, between 1 to 4% of the hospitalized patients. Now, if you classify hyponatremia, it can be classified as a dilutional hyponatremia or depletional hyponatremia. Among the dilutional hyponatremia, you have the hypervolemic hyponatremia and euvolemic hyponatremia. And in the depletional hyponatremia category, you have hypovolemic hyponatremia. I'll show you a very nice figure which will help you remember, but just remember one thing, that tolvaptan that we use in a condition like SIAD, for example, is absolutely contraindicated in hypovolemic hyponatremia. I'm not sure if this is visible to you, but you can see in here, this depicts the three conditions that we just talked about in a more illustrious way, where you have the first scenario, which is clearly hypervolemic, and then you have broadly euvolemic conditions under which you have diuretics, it could be SIAD, and also hypothyroidism. And then finally, at the bottom, what you see is those who are clearly hypovolemic in nature. Now, talking about the dilutional hyponatremia, you have the hypervolemic hyponatremia. The conditions are heart failure, cirrhosis of liver, nephrotic syndrome, etc. Then you have the euvolemic hyponatremia like SIAD, and that can be caused by multiple things like drugs, malignancies, pulmonary diseases. We'll have an entire list set out to you. And the adrenal insufficiency and hypothyroid. So this remains the primary differentials when we are talking about SIAD. So majority of the cases of hyponatremia in and outpatients are dilutional hyponatremia. So incidence of hyponatremia in different situations. In the community care setting, it's about 7.2%, and acute care hospital settings, it's about 28%. So hyponatremia and probability of hospital mortality. So you see this is a U-shaped curve. So mortality is the least when the sodium levels are between 138 and 142. Lesser the sodium levels, higher is the mortality. And again, if the sodium levels go high, also the curve starts rising. So majority of the morbidity associated with hyponatremia is due to brain damage. And hyponatremia can produce a wide range of disturbances involving almost all body systems, but the most relevant ones are those which are involved with lethal involvement of the CNS. Now, this is the evaluation of gait in mild chronic hyponatremia patients before and after treatment. So on the left-hand side, you can see the gait in those who are chronic hyponatremic, and post-treatment, you can see the gait has become much more straighter as compared to untreated patients. The one thing that we are concerned in elderly individuals are, of course, the frequency of falls that come with chronic hyponatremia. And of course, this is one of the primary concerns. And 21% of the patients were admitted with a fall compared to 5% of the controls. How do we risk stratify hyponatremia? How rapidly does hyponatremia develop? So more acutely the hyponatremia develops, worse is the prognosis. So very rapid means within 24 to 48 hours would mean that it's acute hyponatremia. More slowly, over more than 48 hours, would mean chronic hyponatremia. How severe is the hyponatremia? Mild chronic are those who are asymptomatic or symptoms may be moderate. So brain gets sufficient time to adapt via adaptive osmosis and changes that we'll show you in the subsequent slides. And acute severe are those where cerebral damage and death occurs immediately and there is less chances of adaptation. So understanding the duration and severity of hyponatremia is important because it will determine therapeutic decisions. So clinical presentations of hyponatremia, as we said, if they present acutely, you can have cerebral edema, irreversible neurological damage can occur, coma and death. So this is something of an acute scenario which we should be very aggressively considering and managing well. Whereas the chronic ones are usually asymptomatic. Non-specific symptoms occur when sodium levels fall below 120. The patients can come with headache, lethargy, nausea. Symptoms when sodium levels fall even further, then they can come with hemiplegia, limb weakness, dysarthria, hallucinations and disorientations, tremors and depressed reflexes, acute psychosis, and seizures. Symptom incidences, as you can see in here, altered sensorium remains the most common symptom, followed by seizures, nausea, vomiting, gait disturbances, dysarthric speech, and then coma. So these are the cerebral changes in hyponatremia. What you see in here is the normal brain, and if there is immediate effect of hypertonic, so water gain, and then rapid adaptation and a more slow adaptation that happens. So if you correct the hyponatremia very, very aggressively, that would lead on to osmotic demyelination. So this needs to be prevented, and you need to correct hyponatremia very, very slowly as to prevent these damages so that the brain goes back to the normal state. So cerebral complications of hyponatremia, neurological symptomatology decide further line of management and treatment. Herniation may develop disastrous consequences if you're correcting hyponatremia very, very quickly. So there can be transtentorial herniation or tonsillar herniation. Assessment of volume status, again, this is very necessary in deciding what should be the management. So we classify as hypervolemic, hypovolemic, or euvolemic. Then assessment of hyponatremia type based on the body weight, skin tarja, axillary and mucosal moistness, positional variation of blood pressure, and hemodynamic responses to volume changes. Now, management of hyponatremia. If it's a chronic condition which occurs slowly and the patient comes to you with headache, irritability, nausea and vomiting, confusion, delirium, falls, etc., then the correction is usually by hypertonic saline and tolvaptans. And if it's acute situation, which is more of an emergency, it has to be corrected by hypertonic saline because otherwise it would lead to stupor, comatose state, convulsions, etc. Now let's review the clinical conditions causing hyponatremia. So one of the conditions that we are going to talk about today is SIAD, or syndrome of inappropriate ADH secretion, where AVP secretion is not suppressed appropriately when plasma osmolarity falls below the osmotic threshold. So this is the brief outline of the causes of SIAD. It could be ectopic ADH production from malignancy like small cell cancer, inappropriate pituitary ADH secretion from malignancies like lung cancer, lymphoma, prostate cancer, pancreatic cancer, then inflammatory lung diseases, neurological disease like meningitis, head injury, subdural hematoma, tumors post-surgery, antidepressants, tricyclics, SSRIs, etc. So a whole list of medications that can cause SIAD. Then post-operative, and others are nausea, pain, and porphyria. So broadly, you can classify them as malignant diseases, pulmonary disorders, transient causes, CNS disorders, and drugs. So I'll hold on for a second if you want to take a click. And then you have a more elaborate list. So if you go to any of the textbooks, you'll see a more elaborate list charting out all the causes of SIAD, but those were the basic ones or the headings where you can subclassify SIAD. Now, how do you diagnose? There's high urinary osmolarity, more than 100 milliosmoles per kg, and inappropriately low serum osmolarity, less than 275. There's elevated urinary sodium excretion of more than 40 milliequivalents per liter, and despite normal sodium and water intake. There will be clinical euvolemia. So no signs of ECF volume depletion is there, no signs of excessive ECF volume. And what are the primary differentials? We need to rule out any hepatic, renal, or cardiac abnormalities. We need to rule out any thyroid abnormalities. We need to rule out any adrenal insufficiency and no recent diuretic use. Now, hyponatremia and pneumonia. So mechanism of SIAD is by resetting the AVP osmostat here. The choice of initial IV fluid influences the hyponatremia risk. So isotonic saline is 3.9%, hypotonic 14.5%, and no IV fluids 13.5%. Incidence of hyponatremia in pneumonia patients admissions, adults is around 27.9% and pediatric is 27%. And hyponatremia should be cued to high disease severity. Now, coming to the pituitary functions, we'll just go back into basic physiology and anatomy. And we know that you have the anterior pituitary and posterior pituitary. And AVP is released from the posterior pituitary. It's a nonapeptide arranged as a 6 amino acid and disulfide ring plus a 3 amino acid tail. It's synthesized in the hypothalamus and carried down the axons, and it remains stored in the posterior pituitary where from it is released. And AVP secretion controls the osmoreceptors. So any changes in the plasma sodium is detected by the hypothalamic osmoreceptors via the pituitary gland, which releases AVP. And then also AVP secretion can be controlled by the baroreceptors as well. So any reduction in the blood pressure by 10 to 20% also releases AVP. And this happens via the vagus acting on the hypothalamus. So AVP receptors, it works through V1A receptors, which are present on the vascular smooth muscle cells causing vasoconstriction. V1B receptors, which are present in the anterior pituitary and controls the ACTH secretion. And V2 receptors, which are present on the collecting ducts and is involved in water reabsorption. So you can see in here how the AVP works. It acts via the V2 receptors, via the CAMP. It increases the aquaporin expression on the collecting duct, via which the water is reabsorbed back into the tubules. So AVP promotes more water absorption by the CT cells, less urine output, and more concentrated urine. So summary of the AVP actions are, if the sodium levels are high, increased AVP release leading on to decrease in the urine formation and osmolarity being restored. If the sodium levels are low, then there is decrease in the AVP release, increased solute-free urine formulation, and osmolarity is again restored. Now what happens in SIAD is there is inappropriate response. So changes in the plasma sodium detected by the hypothalamic osmoreceptors like pituitary release AVP. However, the osmoreceptors have a set point, as we had already mentioned. AVP secretion stops when the plasma osmolarity falls below a certain level, leading to excretion of very dilute urine. So there is an inappropriate response in this regard. So in SIAD, AVP is secreted continuously in spite of low plasma osmolarity. Now, review of hyponatremia management. So these are the management guide. So volume status, neurological symptoms and signs, current medications likely to cause hyponatremia, concurrent illnesses suggest hyponatremia. So we need to determine what is the type. Is it hypovolemic, euvolemic, or hypervolemic? What is the duration, acute or chronic? And the tests that are generally needs to be done are the glucose levels, sodium levels, BUN, creatinine, plasma osmolarity, urine osmolarity, and the urine sodium levels. What is the management guideline? So first thing that you consider, is hyponatremia present, or is the serum sodium level less than 135? And random glucose, is it less than 200 or not? And serum creatinine. Whether hyperglycemia and renal disease contribute to hyponatremia needs to be considered. Second thing that you consider is what is the plasma osmolarity. Normal osmolarity is between 285 and 295. Less than 280 is excess water present, and if more than 300, that means dehydration. What is the urine osmolarity? Normal is 50 to 1400 milliosmoles per kg. If less than 100, then excess water intake, and more than 100, impaired ability to dilute urine. And finally, what is the urine sodium? So between 20 and 40. So these are the considerations that you need to make. Sometimes we do a water deprivation test in order to find out whether this is SIAD as well. But generally, if you look at the management protocol, this is how we go about. This is a simple flow chart. So you start with the hyponatremia and you look at the serum osmolarity. If it's more than 280, look hypertonic hyponatremia. And you need to rule out hyperglycemic hyponatremic infusions, rule out isotonic infusions and pseudo hyponatremia from severe dyslipidemia. And then if it's normal, Isotonic hyponatremia, and if it's less than 280, then consider BUN, creatine, uric acid, urine osmolarity, etc. So I won't go through the entire list. If you want, I can send the slide over to you, but this remains the basic management. I think we already have discussed the prototype. I'm just running out of my time, so I won't go into the details, but I'm happy to share this slide with you. Just wanted to highlight that beware of factitious hyponatremia, although highly unlikely in this particular case, but pseudo-hyponatremia occurs when there's context of gross hyperlipidemia and should be excluded before embarking on a more detailed investigation. So this is the SALT-1 and SALT-2 study that has been done with tolvaptan, which had shown that there was a significant increase in the serum sodium level compared to the placebo. And thus, it has gotten its approval to be used in hypervolemic or euvolemic hyponatremia, where the sodium level is less than 125, or less marked hyponatremia, that is symptomatic and resisted correction with fluid restrictions, including patients with heart failure, cirrhosis, and CIAD. Dosing is 15 milligrams once daily, regardless and there's no particular timing. And the dosage increased to 30 milligrams once daily after 24 hours to a maximum of 60 milligrams once daily, and should be started in the hospital settings to allow close monitoring of serum sodium levels. So with this, I conclude. I know it's an elaborate topic and it's difficult to complete in 20 minutes, but I'm happy to answer any questions if you have on a one-to-one basis. So thank you.
Thank you. Dr. Supratik Bhattacharya is an excellent elaboration. Sir, in addition to one point, I'll tell, when the patient comes into the ICU, only the problem is very difficult because if you go for a rapid correction, that we landed in trouble. And if the patient is in the ventilators or something like that, if we put the patient on the opioids, generally put in the fentanyl or whatever. So in that situation, what is your advice? What should we do? Because opioid itself will also decrease the sodium level also.
Correct. So I think we need to be very vigilant, and whether opioids, you're saying, right? So I think we need to be very vigilant regarding this and carefully manage the hyponatremia. And as we said, rapid correction is what we are trying to avoid in this scenario. So go slow. Did I get your question? If you just repeat once more time.
No, because when the patient comes with a ventilator or whatever, the fentanyl or opioid, the patient sodium level comes down. So if the patient is already hyponatremia is there, we are going to correct it. How will, like you said, one, the rapid monitoring, and we will be very much vigilant we have to do. Any other method we can do it, sir?
You can look at the pupils. I think if general examinations are very important. So anyone with opioid will have constricted pupils. So there's no replacement of good general physical examination and history taking. So I think that needs to be the basis before we try and manage the patient, though.
So we face the problem actually in the ICU.
Yes.
Any one questions is allowed, sir?
Comment here. Excellent talk, Subhadi. You really justified your subject. I've just, the reason I kept this topic was, today, with the rampant use of thiazide diuretics, especially in hypertension in elderly, we see a lot of cases of hyponatremia coming to us. So one has to be very cautious in elderly patients while prescribing full dosages of thiazide diuretics. That is one very important cause that we are seeing in routine day-to-day practice, and often missed because we don't think of doing an electrolyte level at that time.
Absolutely. I think dyselectrolytemia in elderly patient is something that we deal with on a regular basis, and we need to be very vigilant and try and not over-treat conditions, so go slow. Yeah, right. Thank you.
Sir, now the session is over.
We have a third talk, Dr. Puneet Saxena, please.
Sorry, sir.
स्लाइड कैसे चलेगा इससे यहाँ से चलेगा. So good morning everybody. So my talk was scheduled yesterday, but because of some flight problems it has been shifted today, and I thank Dr. Virmani, team ACP, Dr. Anuj Maheshwari, Dr. Narsingh Verma, and the entire organizing team and the chairpersons. And Dr. Virmani, he keeps on giving good tasks to the speakers. And in the same series, he has given me a topic which is not related with therapeutics, but carries immense importance as far as management of patients is concerned. So this is the topic, management of patients in post-acute care settings. The photo is obviously, you can see the picture. This picture is from US, it is not in India because we don't have these kind of facilities in India. And in last 2 decades, because of the burgeoning burden of the chronic diseases, we have lots and lots of patients who falls into this category and needs attention as far as the management of this problem is concerned. So managing these patients in the post-acute care, I cannot discuss the individualized management of all the problems which have to be followed in the post-acute care, but this will be a general presentation that how they can be managed and what we need. So the definition, if you see, is that this post-acute care involves specialized healthcare services provided to individuals after an acute illness or hospitalization, focusing on rehabilitation, recovery, and the transitional support. What has been happening in India, you see that the patients, either they come as planned admissions to the hospital or as the acute admissions to the hospital, and when they are discharged, probably not enough care or enough support or enough management is available to these patients, and there is we need the importance. So there is an importance in the continuum of the care. That this continuum is what is very important, because these patients needs to be managed on long term, and recognizing the importance of post-acute care is pivotal in ensuring a seamless and comprehensive healthcare journey for the patients for their optimized recovery and well-being. So these are the services which will regain patient the general well-being and the strength and recovery from their diseases. Sorry, this has gone there. So after inpatient hospitalization, patients having minor or major traumatic injuries, care for chronic diseases, and recovery from life-threatening illnesses, for that matter, even the infections, they will require them. These are the common medical conditions which I was talking, that why the burden of the diseases have gone up. The cardiovascular diseases, the pulmonary disorders, the neurological disorders, the orthopedic conditions, the surgical, complicated surgical conditions, and trauma and accidents. So what are the benefits of post-acute care? They promote continued recovery. The close monitoring for the complications can change the entire prognosis of the patient and their families. Physical, occupational, speech therapy is required for complete recovery. Rehabilitation services is required. Wound care is required. Medication and pain management is required, and it can be optimized if somebody is paying attention. It reduces the likelihood of hospital admission. And obviously cost in our part of the world is very important, because the insurances are not robust. So cost saving is very, very important, and overall you reduce the health burden of the society. So these are the types of post-acute care settings. So you can deliver the services on the outpatient basis, the home health concept. Home health has been picking up in the metro cities and tier B cities also, where there are providers who will provide everything at the home. So this thing, and we have been seeing that the investigation part especially, so blood sample is being collected, and it's the part of home health only. In last 2 or 3 decades, there are so many centralized laboratories who will collect any damn sample from anywhere, and they will provide the report within 24 hours or 48 hours. So social services and the supports, behavioral health, this is the neglected part, the behavioral and the psychiatric health or the mental health, you can see. Different kind of therapies, especially the rehabilitation, the physical exercise and the lifestyle advices, and palliative and hospices care. Palliative care is picking up, and NMC has made it mandatory to establish the departments of palliative care in most of the medical colleges across India, so as to give the concept of palliation, because we have large burden of the cancer patients and the chronic patients who will require palliation. So
these are the post-acute care settings. You have long-term care facilities, LTCF, or you can say LTCH hospitals, you can say. Then you have inpatient rehabilitation services. Then you have skilled nursing facilities. Then you have the home hospices, and then finally the home health. So these are the 5 post-acute care settings which are not established. I think most of you will agree that we don't have a very good network, or rather developed infrastructure which can provide these kind of post-acute care settings. And if you see the rehabilitation facilities, they are very, very weak. Patients will manage on their own at whatever level, primarily at their homes or the clinics or the hospitals which they rush to. The long-term care centers, they are absolutely missing in India. Just imagine a patient of Alzheimer's who nobody to take care, and he's going to live for another 10 years, 20 years. Where does he go? There's nobody to look after them. Even if they are moneyed people, there is nobody to look after them. So we think we need these long-term care facilities, and finally the home health care, because it is the most economic model of providing the post-acute care management to the patients. Now, this is how the transition of care should proceed, where the short-term acute care in the hospital should be followed by long-term acute care, either in hospital or you can say facility, and then inpatient rehabilitation facility and the skilled nurse facility. And finally, if the patient thinks that he can be put out of the hospital, then the community-based post-acute care, which can be managed at home, which can be delivered as in the form of assisted living, where no nursing care is required, but it's only the activities of daily living, or maybe supervision is required, where you can use the semi-skilled personnel also, not even the nurse. And finally, the nursing home. The nursing home concept, in India, nursing home means a hospital, but nursing homes are meant for basically providing nursing care to the patients. So the long-term care facility, where you can provide the eating, the bathing, the dressing, the transferring the patient, the toileting, walking. And just imagine somebody who is quadriplegic after an accident, road traffic accident, is mentally alert, but he needs all these kind of care for himself. And these are the facilities where these can be managed. We don't have the space, we don't have the infrastructure, we don't have the concept, I can say. We don't have the concept also. Skilled nursing therapy required in many situations where we require nursing staff, maybe hip fracture, maybe stroke. But these patients, stroke patients, will require care maybe for 2 months, 3 months, they recover very slowly. Pneumonia patients. We've seen in COVID what has happened. People have recovered for 2 months, 3 months, 4 months gradually. And with those who had good access to the health care and the post-acute care, they survived also. Heart failure, such a huge burden. They need frequent hospitalizations and skilled nursing facilities. So what these nursing facilities will provide: the custodial care, the wound care, the nutrition therapy, which is a neglected part, the cardiac care, the post-stroke recovery, the pulmonary rehab, the physical therapy, the speech therapy, and the occupational therapy. And this is the gist. Given in this diagram, you can say that how the post-acute care is moving. So at the level of the hospital, followed by the dark blue part of the pie, that is the skilled nursing. And on the right hand side, you will find that what are the post-acute care locations or the settings of the hospitals, and the skilled nursing locations of the hospitals and the setups. We move on to inpatient rehabilitation therapy, and this is required in long term. Many medical colleges, even where I'm working at Jaipur at SMS Medical College. We have a very robust, which was famous, the RRC department, which was famous for Jaipur Foot. And it's a huge indoor department where the prolonged inpatient rehabilitation therapy is being provided. So that kind of support is required. Critical care. Patients who are discharged from hospital, they may go sick again. Their sickness may prolong. So even that also forms the part of post-acute care sometimes, that you will require critical care facilities or the facilities which have an escalation, where you can, if the patient goes sick, you can escalate them to the critical care facility. Post-operative care. The surgeons are not here, but yes, post-operative care is very, very important, and we lose large number of patients just because of the post-operative complications rather than the problem or the surgery itself. And this is a rough diagram how the hospital settings, they should have a step-down unit, and you will see the first chart where how the inpatient flow should be managed, where the separate standalone units in the form of ICU, the step-down unit, and finally to the ward and to the discharge, and maybe then using any of this long-term care facility or the skilled nursing facility that they can be provided, or rehab facility can be provided. I'll skip this. So these are the modalities which needs to be managed in the post-acute care. Medication management, medication reconciliation. We will find most of the time patients, they are not taking medicines regularly. They are taking wrong medicines, wrong doses, wrong names. So medication administration itself is a problem. Adverse drug reaction itself is a problem. Polypharmacy, because of the aging population, the so many chronic illnesses, so polypharmacy is such a problem. Nobody pays attention to drug interactions or dosage adjustment to the drugs. And many a times people will carry so many prescriptions from the different specialists, and they will be taking even some 4 or 5 vitamins at a time, or maybe analgesics at a time. So this polypharmacy is a big problem, especially in the geriatric problem. Infection control is the second, and the immune system of these patients would be weak in the post-acute setting. So you need to add if you are dealing with long-term care facility, which we don't have, then outbreaks of we keep on hearing news from Western world that there has been outbreak of an infection in a long-term care facility and these kind of things. Because the patients, they are they're weak, and there is a spread of infections. So preventing antibiotic resistance is also very important, and maintaining quality of care, because if infections are brought down, then the quality of life, the cost, the health, everything is improved. Fall prevention of these patients is very, very important. And as just my previous speaker was saying, that hyponatremia is also one of the problem and is responsible for falls in the geriatric population. So fall prevention, you can use the counseling, the environmental modification in the form of the support, like the non-slip floorings, the handrails, and all these advices, the assistive advices, they are required, and patient education is required. Pressure ulcer prevention, you can assess the risk by various scales which are there, and all the maneuvers like repositioning and support surfaces and skin care are required. Nutritional management is very, very important. Taking care of malnutrition, the specific nutrients which are required for a specific disease of the patient, enteral nutrition and the parental nutrition, maintenance of the stoma in case of the GI surgeries is important, and involvement of dietitian. Rehab services, we have already discussed. Respiratory management is very important, because out of ICUs, those who have been weaned off from the ventilation, pulmonary rehab is very, very important. And step-down mechanical ventilation in form of BiPAPs or CPAPs is also important. Oxygen therapy and airway clearance techniques and chest physiotherapy is very, very important. Cognitive rehabilitation, often the missed part, but assessment is the first step. And we all are busy. We don't do assessment on a scale. Rather, it's a subjective assessment, but then you need to assess it and you need to take care of it. And these are the steps, basically. Discharge planning of the patient who has been admitted with acute illness in itself is the first step for post-acute care management, that how, when, how, and on what medication and with what advice the patient has to be discharged. Then the case management in coordination with the family and the healthcare team. Then the transition of the care, the utilization review, that the utilization of the resources, seeing the pocket of the patient, and the optimized healthcare which has been presented, and obviously the quality assurance has to be there. So these are the best practices for interdisciplinary collaboration and coordination of post-acute care, where you need a right team, composition of the team for the patient, the physician, the nurse, the physiotherapist, the interdisciplinary rounds, and the electronic health records. They are very important, because if somebody is to be taken in the long term, you need the health record of the patient. And finally, we can use technology nowadays in post-acute care management, where telemedicine, the patient monitoring devices like wearable devices, where somebody is suffering from recurrent PSVT or VT, and if he is wearing an eye watch and he can transmit his ECG, probably that is the use of the device in the augmented reality for patients for recovery. And this is my last slide, that addressing social determinants of health is also important in post-acute care. So that involves food security, the transportation, and the adequate housing for the diseased and the ill patients is required. And to conclude, post-acute care management will continue to evolve as healthcare systems face new challenges and opportunities, and this is very, very much required. And I am thankful that he has kept this topic as a discussion to throw light on this kind of subject, which is not even discussed at any of the platforms. And innovation and interdisciplinary collaboration will be essential in improving patient outcomes and reducing healthcare cost, and addressing social determinants of health will be increasingly important in providing patient-centered care and improving overall health of the patient. Thank you very much for your listening. And I don't have too much of experience on the post-acute care because none of these facilities, some of them they exist, but they are, I will still say they are in the primitive stage and they have to evolve. But yes, we all should have a concerted effort to develop these kind of facilities in our part of the world also. Thank you. Sir,
Started medical health attendant course from rural areas who have the education of basically 10, 12, or graduates. And we are training in Seva. And they are training. Even I am in who are there.
Yeah, yeah, this kind of things are required, sir, and they help a lot. But you have knowledge of these things, you are resourceful. But people at large in India, they are neglected because of absence of these kind of facilities in now.
Thank you, sir, for your nice deliberation. And to addition that, I'll tell you this hospice care, which for the palliative care, they're doing the excellent work, sir, because all the patient care is being taken at home. And second thing, I'll just add to your topic, sir. Sir, nowadays this E method, E ICU and E post care methods, they are being done. So my question, how are you coordinate the things?
I cannot get your question.
Suppose we are having the EICU sort of thing, or the post of care, we are going to handle the patients.
So that is what I said, that use of technology, evolving technology is very, very important. And I think E means you are saying about the emergency ICU or because.
No, EICU, the patient is now transported to the home management or acute care.
So that's what I'm saying, because EICU is used for emergency ICU also and for the electronic.
Yes.
So the EICU, if you use technology, you don't need the patient to be admitted to the hospital also. So if you correlate it with the skilled nursing facility, and if you use gadgets and tools, you can manage the patient at home also. So I think, and we have seen in COVID and the post-COVID area that how ICUs were created at homes and they were being managed by remote. So we all did that. So use of technology, that is a very welcome thing which
Sir,
we do.
India, which corner is basically they are doing all these thing works in the palliative cares?
What?
In the palliative care, India, which sectors are doing the better? Which area of the India?
Which areas are doing better? So as of now, basically it is looked as for the patients who are having the post-cancer patients, basically they are being taken up, because at our center also we have a large number of patients who are getting morphine and other drugs for palliative care and other things. But majority of these patients are those patients who are suffering from cancer or from they are post-traumatic patients. These are the two categories which are having, because for rest of the patient, the concept of palliation is not robust.
Thank you, sir. The session is end now.
Yes, sir, please. Yes. Thank you very much, sir. Thank you.
Thank you, chairpersons and learned speakers. Now I would request the speakers and the chairpersons to kindly go to the side stage for felicitations. And I would request Dr. Prahlad Chawla to kindly felicitate the chairpersons and the speakers. Meanwhile, I'll request Dr. Preeti to kindly go for the next session.
Good morning, everyone. I am delighted to invite Dr. Manoj Srivastava and Dr. R.K. Srivastava as chairpersons for our next session on Osler's lesson, Prevention is Always Better. Over to our worthy chairperson, sir.
Coming on to the next session, prevention is better always. And for that, we are inviting Dr. Ananda Bagchi. Will speak on the topic, can we prevent sudden cardiac death? Dr. Ananda Bagchi.
So I would also like to invite Dr. A.K. Arya as chairperson for the session. Thank you.
This one. Respected chairpersons, good morning everybody, esteemed colleagues. At the very outset, I thank Dr. Virmani for inviting me to talk on this topic, and is definitely little bit innovative as the heading of the session goes, prevention. So in my next 20 minutes, I'll see how we can prevent sudden cardiac death. Definitely is a dreaded problem. This is my contents. So despite the revolutionary advancements in the past 3 decades in the management of ventricular tachyarrhythmias with device-based therapy, SCD remains an enormous public health burden. Why it is burden? Because survivors of SCD are generally at a high risk for recurrent events, and its management needs a multidisciplinary approach, a good post-resuscitative care, and a well-organized preventive strategy. As per definition, sudden cardiac death is an unexpected death due to cardiovascular causes occurring with a very short period of time in a person with known or unknown cardiac disease, occurring within 1 hour of the onset of symptom in assisted cases, and with 24 hours subject being last seen when not witnessed. Approximately half of all the cardiac deaths can be classified as sudden cardiac death. And another etiological definition is there. SCD occurs when a triggering factor serves as a catalyst in an anatomic or electrophysiological substrate, either genetically determined or acquired, resulting in the final common pathway of ventricular fibrillation or ventricular tachycardia, leading to ventricular fibrillation with hemodynamic collapse and cessation of cardiac mechanical activity. There are other few things which are to be known: sudden cardiac arrest, sudden cessation of normal cardiac activity with hemodynamic collapse, which can be reversed with CPR or defibrillation. Sudden unexplained death, unexplained sudden death occurring in an individual older than 1 year. And SADS, sudden arrhythmic death syndrome, is also there. Now, regarding prevalence, in global annual incidence of SCD would be in the range of 4 to 5 million cases per year. But in our country, we have got very little data. You see, here MI in 87% cases of SCD, and compared to patients without MI, those with infarcts has a higher incidence of diabetes, patients who are older and had more frequent CAD. Now coming to the causes, there's a big list of causes of SCD. I just give a few. It may be due to coronary artery disease, maybe coronary vasospasm, anomalous coronary arteries, other structural heart diseases like hypertrophic cardiomyopathy, dilated cardiomyopathy, ischemic cardiomyopathy, storage diseases or infiltrative diseases like sarcoid amyloid, myocarditis, arrhythmogenic right ventricular dysplasia or cardiomyopathy, and valvular diseases like aortic stenosis. And most important is electrophysiological, long QT, short QT, Brugada syndrome, polymorphic VT, ventricular pre-excitation, and idiopathic ventricular fibrillation. Electrolyte abnormalities, you have just heard from Dr. Srivastav that acute hyperkalemia can lead to SCD, hypomagnesemia, and there are some non-cardiac causes like massive ICH, pulmonary embolus, and status epilepticus. But out of all these causes, 5 causes must be remembered. Number 1 is post-MI with low ejection fraction, acquired or inherited long QT syndrome resulting in torsades, Brugada syndrome, catecholaminergic polymorphic VT, and idiopathic VF. And depending upon the age SCD, the causes may be there. In young age, mainly the electrical abnormalities are more, hypertrophic cardiomyopathy is more, myocarditis is more. But during the 4th decade, half of the SCD cases are related to coronary artery disease, especially ACS, and also heart failure with low ejection fraction. And in older population, chronic structural diseases predominate. This is the same slide almost. Now, SCD has got a diurnal variation. It may have a diurnal circadian pattern with peaks in the early morning, as you all know, and a nadi during sleep. Similar findings were also seen in the Framingham heart cohort. Furthermore, mutation in some genes like SCN5A gene occurs, leading to some electrical abnormalities like Brugada syndrome. There is a big list of genes, I'll come to that. These are the risk factors. Now, who are the high risk group? CHD is responsible for more than 75% cases. In 10 to 15% cases, ICMR and coronary heart disease is responsible, and 5 to 10% cases, electrical abnormalities are the main cause. Now, coming to the presenting symptoms, as you all know, it includes palpitation with sweating, sudden collapse, no pulse, no breathing, and loss of consciousness. And there may be some preceding symptoms as well, like pre-syncope or syncope, dizziness, palpitation, chest pain, shortness of breath, generalized lethargy, malaise, etc., vague upper abdominal pain. And studies reveal that prior to SCD, chest pain is a main problem in persons more than 30 years of age. And in less than 30 years, the syncope or pre-syncope is the main symptoms. And we must take the family history, because there are some families where the cardiac diseases run, like hypertrophic cardiomyopathy, channelopathies, Marfan's, etc. They run in families, and premature death in families often common, and epilepsy or syncope history must be taken. Coming to the diagnosis, this is the blueprint of the diagnosis. First, take care of the risk factors, then the clinically and laboratory tests like ECG, echocardiogram, coronary angiogram, etc. And biomarkers, there may be genetic biomarkers, protein biomarkers, and plasma biomarkers. Now, ECG markers, the microvolt T-wave alternates, T-wave duration difference between the alternate beats of the microvolt level is increased. T peak to T end interval is also increased. QRS fragmentation is also patient, and QRS duration obviously increased. And these are the genes I was mentioning too. There are a number of genes, and mutation of these genes lead to some electrical abnormalities and channelopathies. First, I have already mentioned about SCN5A gene, the mutation of which leads to Brugada syndrome. So, for lack of time, I don't want to go to the whole list of genes. And these are some protein biomarkers. There may be inflammatory markers, neurohormonal markers, oxidative stress markers, hemodynamic markers like BNP, NT-BNP, etc. And there are some plasma biomarkers which are present during the early stages of CAD or manifest CAD, even the vulnerable plaque. These biomarkers have been taken into account for the diagnosis. Coming to the management, this is the plan of the management. First is medication, treatment of the underlying cardiac disease and comorbidities, ICDs, catheter ablation, acute management, and revascularization. Beta blockers, as you all know, gives the highest amount of mortality in cases of mortality benefit in cases of CAD, and also to reduce SCD and ventricular arrhythmias. They are also the first line of therapy in channelopathies. IV amiodarone is a very, very useful drug. However, it failed to provide strong mortality benefit over a longer period of time because it has got certain adverse effects. Heart failure patients, you all are aware that the treatment, they are very, very vulnerable for SCD, especially heart failure with low ejection fraction patients or HFrEF patients. The drugs are beta blockers, SGLT2 inhibitors, ARNI, MRA. They are all recommended for SCD prevention. And for MI patients, all the drugs like beta blockers, ACIRB, dual antiplatelet therapy, statins, and early revascularization. Now, coming to the most important thing is implantable cardiovascular defibrillator. ICD is the mainstay for SCD prevention. And for primary prevention, ICD therapy is routinely used in cases of electrical disturbances or electrical arrhythmias, and also hypertrophic cardiomyopathy. And for secondary prevention, it targets patients who recovered from SCD. These are some indications for ICD, SEC HRS guidelines. When LVEF is less than 35, NYHA class 2 or 3 symptoms, or less than 30 with class 1 symptoms, patient with LVEF less than 40% inducible sustained VT, patients with ISD, unexplained syncope and inducible sustained VT. Now, catheter ablation. While ICD can terminate ventricular arrhythmia, but it cannot prevent ventricular arrhythmia from recurring when catheter ablation can accomplish. It is particularly valuable for patients with scar tissue related VT or VF. The procedure is more effective in patients without structural abnormalities than patients with structural heart disease. And according to AHA, the acute management of ventricular arrhythmia it may be defibrillation should be performed as quickly as possible, but in out of hospital cardiac arrest, we must appreciate that 60% of SCD cases occur outside the hospital. So in out of hospital cases, CPR should be performed immediately until the defibrillator is available. If the patient remains arrhythmic after 3 shocks, then amiodarone IV should be given. And regarding revascularization, all patients with sustained ventricular arrhythmia and survivors of SCD should be evaluated for ischemic heart disease. This is very, very important and should be revascularized without delay. Although revascularization improves survival, there is no difference between either CABG or PTCA. And what is the Indian perspective? Real-time management of SCD events are largely impacted by non-medical confounders. The time from symptom onset and presentation at hospital is typically longer among our patients. The mortality data of MI showed that 60%, what I was mentioning, 60% of deaths that occurred out of hospital were SCD. Hence, hospital-based treatment of MI, including high-tech primary angioplasty, would prevent only a small proportion of cases. Now, can we prevent SCD? Yes. SCD prevention remains very difficult for patients without pre-existing disease and warning signs. If there is no warning sign, no disease, how can you prevent? Because most episodes occur at home and outside hospital. And the complex interaction between anatomic and functional substrates differs widely based on the underlying cardiac cause. Our incomplete understanding of the pathophysiology of SCD make precise and individualized preventive approach an enormous challenge. So definitely it is a big challenge. Now coming to primary prevention, this targets mainly patients who are at high risk for SCD but have not sustained any life-threatening arrhythmias. And randomized clinical trials have investigated the use of ICDs in the primary and as well as secondary prevention, while antiarrhythmic drug therapy continues to be used as an adjunctive therapy for ventricular arrhythmias in secondary prevention. Now, secondary prevention is aimed at preventing SCD in those who have survived the life-threatening ventricular arrhythmia and selected high-risk groups. Now, I'll quote 1 or 2 trials. Conventional versus amiodarone drug evaluation therapy cascade trial. It has shown that between the two, definitely the IV amiodarone is superior to other antiarrhythmic drugs like procainamide or quinidine. And ICD therapy for secondary prevention, I'll quote 3 trials like AVAID trials, antiarrhythmic versus ICD, CASH trials, cardiac arrest study Hamburg, and CIDS or Canadian implantable defibrillator study, out of which AVAID study is the largest. 1106 number of patients have been taken. They have demonstrated the efficacy of ICD therapy in reducing sudden cardiac death and total mortality as compared to antiarrhythmic drug therapy. And a meta-analysis of these 3 trials have demonstrated a robust 50% relative risk reduction for arrhythmic death and a 28% relative risk reduction for all-cause mortality with ICD therapy. Though ICD is a very good tool for prevention, but it should not be implanted for secondary prevention if SCD occurs in the setting of acute MI. Complete coronary revascularization is the treatment of choice here in patients whom ischemia has been implicated as the immediate cause of VF or polymorphic VT. Beta blockers improve the outcome and reduce the incidence of VF in the setting of acute MI. I have already mentioned that beta blocker has got the highest mortality benefit. So friends, I have come to the end of my talk. Sudden cardiac death remains a public health issue of concern, and immediate focus should be on timely management of ACS and MI patients, compliance with medication, as well as secondary, as well as on primary and secondary prevention. There is decline in post-MI mortality and SCD achieved in developed countries in last few decades. There is emphasis on routine use of ICD for both primary and secondary prevention. So ICD definitely a very important tool for the prevention. Till today, real-time management of SCD remains a challenge in our country. So thank you very much. Thank you for your patient hearing. Thank you, Chairperson.
Thank you, Dr. Bakshi, for a very elaborate take on sudden cardiac death. The House is now open for discussion.
Dr. Bakshi, I just had a query.
Yes.
In your clinical experience, how often did you see this SCD post-COVID? Has the incidence increased or was it same? And if it has increased, what is the reason? Particularly in reference to post-COVID.
I don't have much experience in seeing SCD cases post-COVID. So these post-COVID cases are to be dealt with with a very individualized approach, and SCD is the mainstay for the treatment in these cases. If the patient is younger age group, then the arrhythmic deaths may be very common, so SCD should be implanted early. Yes, yes. Yeah, commonest cause. And hypertrophic cardiomyopathy is also very common in younger age group. Yes. Yes. No, I have no knowledge about any article, but what I feel that this COVID virus subclinically damages cardiac disease leading to myocarditis. This myocarditis suddenly gets flared up and causes death due to arrhythmia. This is my take.
Thank you, sir. Thank you so much. I'm sure Dr. Bakshi deserves a loud round of applause for an excellent talk on a very burning and topic these days. We have lost so many young celebrities due to sudden cardiac death. Okay, moving ahead, may I request our next speaker, Dr. Gururaj Satur, please, sir, and sir would be speaking on medical fitness for high intensity activity. Sir, he has to go.
Just put the, can you just manage the green pointer? Doesn't go there, that's okay. But slight change of it doesn't go. Okay, don't your okay. The first slide. the outset, thanks to Dr. Anuj, Dr. Narsingh Verma, Dr. Veermani, and Dr. Jayant. It's indeed a tremendous opportunity to speak on medical fitness for high intensity activity. With 64% of young individuals in India, highest in the world, we really need to take care of younger generation rather than patients with diabetes and hypertension, who are equally important. And younger couch potatoes are increasing, especially in India, and we are already prone for cardiovascular disease. Lifestyle, everything seems pretty easy, but simple doesn't necessarily mean it is easy. Despite knowing all this, 112% increased risk when you don't exercise of diabetes, 147% increased risk with heart attack, stroke, 90% increased risk with death from CV events, and almost 50% from any cause. Despite knowing this, you could see there is hardly any line for lifestyle change, whereas the queue is endless for drugs. This is an excellent study which showed as you move from the red area where you sit for a very long time, long sitting is almost equal to smoking, come towards the greener to moderate to vigorous intensity activity. The more vigorous the activity, lesser the all-cause mortality. It is not just moderate to vigorous intensity, and one of the important things to watch on this slide, please give an attention on this slide, the exercise intensity and duration are very important. If you can see the top interrupted line, that's a vigorous intensity, and the lower one with longish line is a moderate intensity. Suppose you have to take, say, for example, around 20 minutes of vigorous intensity activity, that would almost reduce around 35% of all-cause mortality, while the moderate activity, the lower blue line, you could hardly reduce 15%, indicating longer and more intense the activity, more the lesser in cardiovascular mortality. Whenever we think of exercise, we think of three things: the duration, the intensity, and the frequency. As I already said, the couch potatoes, physical inactivity by this ICMR India study showed very clearly that physical activity, both rural and urban, both male and female, is very common. This is a busy slide, but extremely important. This is the nucleus of my talk, this slide. So I'd like you to concentrate a bit. The top column shows that you may have angina, you have symptomatic coronary artery disease, you may have syncope, you may have dyspnea, paroxysmal dyspnea. If all these things are there, and then you come to the lowermost column, medical clearance recommended. I also added echo, which was not there, but I think echo is commonly used now. That should be done. Now, what about people who are not having coronary artery disease, but if you go to the no column, you can see there, does the patient have established ASCVD, diabetes, CKD? Yes. If he is already into moderate intensity activity, say around 30 minutes, 3 days a week, and you can, if he is not doing, better go into exercise stress testing, echo, before you send him for the higher intensity activity. What about a guy who doesn't have diabetes, who doesn't have any ASCVD? There, if it is yes, medical clearance not necessary because he's already into moderate intensity. And it's very important that these people who are already into moderate intensity, you can go ahead and just say without any stress test that they could go in for vigorous intensity. So it's very important to realize this slide. Now, what is the difference between moderate and vigorous intensity? Look at the METs. It's around less than 6 METs for moderate, while more than 6 METs. And walking around 4 mph here is a faster walking there. And the rating of perceived exertion, very important, RPE, I'll just explain it a bit later, is 5 to 6 here and 7 to 8 in the vigorous. and the heart rate ratio around 50%, 80% the heart rate max around 76 and goes up to 93 in vigorous intensity activity. There are many vigorous intensities, especially, for example, playing squash, playing tennis, swimming laps, the faster swimming, and bicycling 10 miles per hour. Vigorous dancing is taking place even in two-tier town like Hubli, where I practice. Doing moderate intensity can talk a sentence without much break, while a guy who is on a vigorous intensity can say only a few words without stopping to catch a breath. For example, a moderate intensity, I am going to office after walking. I am going, that is vigorous intensity. You are able to complete a sentence when you are in moderate, you don't complete when you are in intense. Of course, WHO 2022 said you need 75 to 150 minutes of vigorous intensity exercise. Although for normally they say around 75, which is around 30 minutes 3 times a week that you need to do. This is came up. This is the prescription by the American Sports Medicine. 15 minutes or 10 minutes. I tried to make it simple, and I call it 15 by 2 rule or a 10 by 3 rule. What is 15 by 2 rule? Go 15 minutes twice a day. Maybe before breakfast around your house, around 15 minutes maybe around your working blocks, or in the night around your own home before dinner. You make it either 10 minutes 3. I prefer that you would rather make 15 minutes twice a day. Any exercise is better than no exercise. People wanted me to speak on sex exercise. I definitely worthwhile, lot of demand on more than around 25 platforms when I spoke this. Undoubtedly, sex is an excellent exercise, but if the X is not with a regular partner, the heart rate can double and BP can shoot up beyond 200 systolic and sudden cardiac death can occur. So one has to be very careful when there is a sex exercise. Now you say, I mean, there is a moderate intensity, vigorous intensity. You may ask me, I don't want to exercise. Is there anything else, sir? Of course there is. I keep on saying exercise. Everybody says exercise. You say, I don't want to do. There is an alternative. The next best alternative is hospitalization, because you will have one or more non-communicable disease. You get admitted with either stroke or with diabetic complications. So exercise is the only one to keep you alive. You may not worry much about diet, but exercise is very important. Muscle strengthening is equally important. Muscle strengthening, you can do dumbbells, and for lower limbs, you can do half sitting, or you can do pull-ups. You can do many times like squatting, for example. And you can do some of these exercises on the floor. A quick exercise for all of you. Some are used to this. Dr. Veermani and our chairperson knows this. All of you, please stand up quick. Those with who are practicing. Stand up. Try half sit. Don't keep. Hamstring. But there is one muscle that teaches you. We'll come to that bit later on. Now, excellent slide. Now, I would like you to just go through this slide again. This is another mitochondria of the nucleus slide, rather. On the heart, on the blood vessel, and in the blood, you have a lot of changes going on. You can have increased fatty acid oxidation, reduced glucose utilization, and resting heart rate reduces, and cardiac output increases, contraction, relaxation, velocity increases. Following an MI, the left ventricular wall compliance or remodeling also is better. What about blood vessels? The plaque formation decreases, aortic valve calcification decreases, and there is a shear. Oops. Yeah, and you can see here resting blood pressure also comes down, and certain changes in the plasma. Raised HDL, reduced small dens, LDL, reduced VLDL, reduced TG. Insulin sensitivity increases, even if you lose 5% weight, insulin sensitivity increase almost by around 25%. So that is very important to realize. And what about the lipids? I just said small dense LDL reduces, HDL-C could rise, but to raise HDL by exercise, you need 150 minutes of vigorous intensity, not just by going around your blocks at night 15 minutes. Number one. Number two, it is very important that you wear shoes. We are very particular in our clinic. No shoes, no exercise of any kind. So that's very important for you. And you can see here, improvements were related to the amount of activity and not to the intensity of exercise. This is again very important to see there. You can reduce 4 millimeter of reduction. Although 4 millimeter reduction in blood pressure is too small to see, but each 1 millimeter reduction of blood pressure reduces all-cause mortality by 13%. So just don't say that exercise reduces only 4 to 5 milligram of blood pressure. Very important, lots of benefits of exercise. I don't need to go into the details. All of you know this. Body composition, arthritis, stress. What impresses me most is the self-esteem. A guy who is into activity, how does he walk? How do you walk to impress people? There are only 3 ways of walking. You should know this secret. Tuck your stomach in when you are walking. Keep your shoulders back when you are walking. And never ever bend like this. This is a very coward walk. The shoulders should go back. How do you make the shoulders go back? You should do the shoulder exercises. So your own stance of walking is extremely important. And people would rather stop you in the airport and say, do you exercise regularly? You can easily make out a guy who exercises and who doesn't. Who doesn't exercise goes so these are all very important things to follow. And of course, the worst is sarcopenia. Beyond the age of 35 years, you lose 1% muscle mass. Beyond the age of 60 years, you lose 2% muscle mass. That's how the elderly people keep on falling. So you see here, wonderful slide, 8% muscle loss due to aging in 10 years, whereas hardly in 10 days, you lose 5% of muscle mass when you are admitted to the hospital. That's the reason why cricketers, sports people, when they recover, they are really trained extensively by the trainees. These trainees are paid around 5 lakhs per month because the post-injury training is extremely important because of this, 5% muscle loss. And you just can't afford this amount of muscle loss. And motivation for exercise. Look, these are not motivated. Can you see that? These guys are going on an escalator. How does a motivated guy go? He would bloody run on the steps. So these are not motivated. Your body language speaks one hell of a lot. You are made out by what your body language is, even by the unknown, unsuspecting person. See this motivation. This guy can't push the elephant in, can he? But elephant knows just a support helps it. So you need to keep talking to your patients and need to talk to yourself. How many of you do exercise? Raise your hands quick. Raise your hands. Good, quite impressed. Okay. How many of you do abdominals? Quick. I think more should do. I can make out. More flatter the abdomen, more abdominals do you do. If there is time, we'll talk about abdominals a bit later. This is one of the recent slides. Any exercise activity like running, lifting, does release some cytokines. When they release from muscles, they are called myokines. Different organs like liver, they are called organokines. Through cytokines, through mRNAs, through the blood, through the deposition in the extracellular vesicles, they try to stimulate the organs. For example, the cytokines stimulate the heart, increase the blood pressure, increase the heart rate, which over time, the blood pressure standardizes and comes down because of adaptability. And there are many more new additions. IBEC 2022, cognition is increased, delays your Alzheimer's, delays your dementia. You saw from our state, Devegowda at 92, speaking absolutely clear in the parliament for the women's bill. So at 92, look at his clarity. Of course, politicians' way of living longer, which many of you treating politicians would know, they have tremendous willpower to live. Now, these are all excellent chemicals: dopamine, oxytocin, serotonin, endorphin. One of the great authors said, endorphin release on exercise is equivalent to 7 capsules of LSD. Can you just imagine the kick? So it's very important that you are into exercise. Now, how do you know that exercise occurs? Sweating? Not really. Because if you are by the side of the sea, you sweat one hell of a lot, even if you exercise 15 minutes. If you are in, for example, Netherlands, even if you walk 45 minutes, you don't sweat. Therefore, to know how much you have exercised, we have something called perceived exertion scale. And the best scale is to be here in between 13 and 16. So this scale is very important to follow. And you can see that here. If you are in the orange, it means you are having hard of breathing, not gasping for air. But as you go to the red, your intensity of activity has really increased. Excellently proved by perspective articles. You can see there the RPE of 13 to 15, as you saw here, is very important. Diet is very important if you want sort of vigorous intensity, because diet has to have lots of protein. Very important to realize. And of course, alcohol is nice. It will be served tonight. Alcohol, according to Lancet, is allowed after the age of 65 years and not below the age of 65 years. But we continue to consume. Probably moderation could be the answer. Of course, tobacco, no goodie at all in any form, the tobacco. Some contraindications for high intensity exercise: recent MI, uncomplicated symptomatic heart failure, acute systematic infections, and there are some ungrateful muscles. Rotator cuff. I had a partial tear of my left shoulder rotator cuff around 6 months ago while trying to do exercise. Then transverse abdominalis, VMO, vastus medialis, which is very important to hold your patella. The exercise that you just did, it strengthens all your hamstring muscles. And you have to be very careful, because VMO doesn't really listen to you. That's called ungrateful muscle. And finally, are you serious about high intensity exercise? If you are, watch this video. And if you don't get scared of this video, go ahead with your exercise. So are you him? You want not to be him? Thank you very much.
Thank you, sir. Very interesting and very motivating. And you also made us do exercise, and we all could stand up to your expectations. We can take 1 or 2 questions, please. I'm sure there must be a lot, but we can, because of the paucity of time. Any query to sir regarding exercise? Okay.
If all are starting exercise, I don't think there should be any query.
Thank you so much, sir. Thank you so much.
Thank you, sir.
Thank you, Dr. Satul. And coming on to the last session and last talk of the session, it's going to be a very interesting talk and on a very different subject. And it is about the transgenders. And we have an eminent speaker, Dr. Sunil Gupta, who's going to talk about routine screening and prevention of diseases in transgenders. Dr. Sunil Gupta, please.
Thank you very much, Chairperson. Can someone help me to put the slide set mine on the screen? It's always a pleasure and honor to be here with Anuj and the team of ACP India chapter. Thank you very much for this invitation. My topic today is quite an untraditional topic, possibly as I'm speaking on this particular topic for the first time in my life. Yes. And my talk today is screening of the diseases in transgenders. I have thank you Anuj and the team. I have a disclosure here that there's no conflict of interest. More so, I have around 62,000 plus people registered with me in my clinic last 30 years. But the number of transgenders, if I have seen, I say, will not be more than 50 or 60 in last 30 years, as diabetes or possibly there must be some other reason of not coming to the tertiary care centers, these individuals. I'll cover this talk on introduction, transgenders, men and women infections, non-HIV diseases, and the carry-home message. If you just go through the history, almost someone has claimed that its Ramayana was almost 7,000 years BC and Mahabharata is 5,000 years BC. So in Ramayana it has been mentioned, Purush napunsak nari va jeev charachar khoi, sarva bhav bach kapat jati, mohi param priya hoi. So nar, nari as well as those who are Purush napunsak nari, everyone is close to me. And when Ramchandra ji went for Vanavas for 14 years, while going from the city, he said, "Ab aap sabhi log nar aur nari apne apne ghar jaiye." So when he came back after 14 years, he saw a group of people who had a lot of beard and were just sitting at the bank of the river. And he asked, "Who are these people?" Small group of people. He said, "These are the people." They said, "We are the people, we were neither nar and nari, but you said, you asked everyone to go home, but these people are still waiting for him for 14 years. So, and that is why then Ramachandra ji, they give a Ashirvad to these people that they can be, can I use this pointer here? Yeah. That they will confer blessings on the auspicious occasions like marriage, childbirth, or inauguration function. So that Ashirvad or blessing has gone to transgenders then almost 7,000 years ago. And I feel everyone knows the history of Shikhandi, who's one of the key person in the Mahabharata, when Bhishma was not getting killed by anyone else. That time Pandavas have used Shikhandi as, because of the Vardhan Bhishma had that he will not be killed by anyone. But then Shikhandi, Shikhandi, if you just go through the history, who is originally a girl. Shikhandi was raised as a male by King Draupada, and later, prior to her marriage, she exchanged the gender with Yaksha and took the name Shikhandi. Shikhandi henceforth renamed as man until his death at the battle in Mahabharata. So transgender people have played an important role in ancient Indian culture over millenniums. They portrayed in a famous Hindu religious scriptures, Ramayana, Mahabharata. They have given imperative role in the royal courtyards of Mughal emperors. In 2014, India's Supreme Court has made a landmark ruling by declaring that transgenders people must have an access to the equal opportunity in the society. Unfortunately or fortunately or coincidentally, India has the highest number of transgenders in the world, legally recognized as a third gender, protected by progressive legislation. Changing trans-friendly legal environment has helped the gender dysphoric individuals in the society at large to come out of closet and demand medical help. The environment has changed what we have seen 33 decades or 4 decades ago. But unfortunately, healthcare professional ecosystem may not be necessarily every time welcoming them. These transgender persons go for the inappropriate procedures by untrained and unqualified individuals. And many of the time they do not seek the medical help because of the prevailing doubt about the benefit of modern medicine. So from the ancient times of Ardhanarishwar to today's transgenders. Now let us understand few of the categories and the terminologies in this subject. Transgenders are the person whose gender identity differ from their sex assigned at the time of birth. Someone is assigned as female, getting converted to or being then recognized as male is transgenders. Independent of the decision to use, whether they use hormone therapy or the gas or gender affirming surgery, they will be called as transgenders. Now you'll have transgenders men and transgenders women, or transgenders men is person who were assigned female at the time of birth, but have then adopted or opted for the male gender identity. And the women is person who assigned male at the time of birth and have then have converted or have now identified as female gender. Cisgender is every one of us describes person whose gender identity aligned with their sex assigned at the time of birth. So they are always being considered, compared as a control with cisgenders. Transgenders, the gender diverse, is a person who may identify and present themselves as both or alternatively male or female. They are neither as male or nor as female, and they will be non-binary, and they are being classified as gender diverse. Dysphoria, gender dysphoria is basically a kind of depression amongst these, and psychologically they are sometimes depressed. Now, GARD therapy or the gender affirming hormone therapy, the use of medical therapy, it could be estrogen, anti-androgens, testosterone, gonadotrophic hormone releasing hormone, antagonist or agonist to reduce the gender dysphoria. There can be gas, that is gender affirming surgeries, which is being used. There's the surgical part of the gender affirming management, affirming the management. Procedures may include facial surgeries, gonadectomy, hysterectomy, mastectomy, penile implants, penectomy, vaginoplasty, metoidoplasty, and many more, some cosmetic surgeries. They are being adopted to be looked as the gender which has been assigned. Transgenders, as I already told you. Now let me talk about something about this GAT. The gender affirming hormone therapy aimed to align the characteristic of an individual with their gender identity. Someone born or declared as female, not trying to come as men, then that has to be matched with this hormone therapy or the surgery. The mainstay of this treatment or lifelong treatment is the transgender male is testosterone, typically delivered as intramuscular testosterone hormone, either in the undecanoate or the ester formulation. The transgender female, they receive oral or the transdermal estrogen preparations, maybe estradiol valeriate or the hemihydrate, often in conjunction with either a gonadotropin releasing hormone to have a better look or better outlook. Use disorders, mental health problems, violence and victimization is common in this group, and this can be seen, the mental health is seemed to be highest. Now, compared to the general population, transgender people, they experience higher rate of these health concerns. Now, let us talk about the screening. What are the screening which we need to do? Now, there are some important messages for transgenders, because most of us don't treat these groups regularly. The current available evidence does not show that the hormone therapy increases the oncologic risk in the transgender individuals. However, the available evidence is limited, and we need to have more research. It also has been shown that these hormones eliminate the potential for the malignancy of the patient of the natal sex group, and transgender individuals should undergo cancer screening in all the organs. There are different guidelines. We'll try to go through the guidelines. Now, screening for infectious diseases. As I told you, HIV is highest, but it is again surprisingly the transgender women 0 to 49, almost 50%, and transgender men is 0 to only 8%. When it comes to syphilis, gonorrhea, and chlamydia, almost 1.4 to 50, 2 to 19, 2.7 to 25%. In female versus the men, it is much less, almost less than 10%. So female transgenders are more prone to have infections versus male transgenders. And at which age? Around 25 to 34, it's almost 47%. 13 to 24 is 37%. So almost 80% of the HIV infection is seen before 35 years of age in these individuals. Screening for chlamydia, gonorrhea, it has to be done on a regular basis. Sometimes you have to go for even rectal examination and see for it. It has been said if you are less than 25 years of age, there should be annual screening. If there's more than 25 years of age, then you should have a risk-based screening. Gonorrhea, almost the same line. You have to see oral as well as the rectal area also for the gonorrhea. For syphilis and HIV, we have to see at least once in a year, and those who are at high risk should be taken more aggressively. HPV and cervical cancers should be seen as that of the cisgenders. Now, the mortality trend over last 5 decades in the adults transgender people receiving hormone therapy. I'll not be able to go through this congested slide, but this is important. The higher rate of reproductive cancers are not observed in the transgender individuals, but those who are on the hormonal therapy, this is seen more into female genders. Cardiovascular and renal diseases in transgenders. Those who are on hormonal therapy may have adverse effect on lipid, blood pressure, and body weight. 24 months of the testosterone therapy in transgender men reported mean increase in triglyceride, LDL cholesterol, and lowering of HDL cholesterol. And triglyceride again has increased by almost 32. This is a European data where the blood pressure again found to be more in the transgender men, and in women it was actually reduced. So there are contradictory data available. Now, weight gain is important, and diabetes risk certainly increases, but the exact percentage is not very, very clear. The prevalence was higher in transgender men on those who are on hormone therapy versus control women. But the transgender women on hormone therapy are at high risk of having type 2 diabetes prevalence compared to both control men as well as women. What about the kidney risk and kidney failure risk? If you see the...
Dr. Gupta, can you please conclude?
Okay, so I'll be very fast now. So for kidney, in summary, author says acute kidney injury and chronic kidney injury in transgender individuals receiving a GARD actually seem to be less, those versus not receiving GARD. And this is, I'll skip this slide. Coronary artery disease, not very common, but female they are more prone to have. The screening has to be done like you do in non-transgenders or cisgenders. There are various guidelines. I'll be directly going to the conclusion because of the paucity of time. And breast cancer, prostate cancer, cervical cancer, they all to be screened. And for osteoporosis, again, they are supposed to be screened. So for conclusion, there is an increasing visibility of the transgender person in the society. Healthcare professionals are frequently initiating and monitoring medical necessary GARD therapy to reduce the gender dysphoria and improve quality of life. Specialized clinics is not required, nor do we have the adults need for this. However, it is vital to have more data to come out with further recommendations. There is a team which works. Before I forget, let me invite all of you for the National Obesity India meeting, Arokhan at Nagpur on 2nd and 3rd December. And thank you once again and wish you all a happy Ganesh festival, happy forthcoming Eid, Gandhi Jayanti, Navratra, Dashera, Deepotsav, World Diabetes Day, Merry Christmas and Happy New Year well in advance 2024. Before you celebrate any occasion, please look into this slide. Stop cutting the cake and start cutting the fruit to celebrate any occasion in your life. Thank you very much for patience listening.
Thank you, Dr. Gupta, for a wonderful talk. I just wanted to know whether these genetic syndromes like Turner syndrome and the Klinefelter, are they also transgenders or you put them in a different category?
Sir, honestly, I have not gone through in so much of depth of this particular topic. Rather, I told you I have gone through all this, so I'm not much aware of the genetic syndrome of this kind. But there is.
They under? You don't call them transgenders? Okay. Any question from the audience?
क्वेश्चन करा लीजिए फिर उसके बाद
Questions from the audience?
Please give him mic. Sir, repeat.
Yeah, actually, I shall definitely echo the same feeling here. Dr. Sunil Gupta is well-known diabetologist working on the gestational diabetes primarily, but I am really very happy that he has agreed to speak about the transgenders. And I am really very much proud and happy that our ACP meeting for the first time included the topic on the transgenders, because as you said very rightly, there are a lot of transgender population in India. People don't disclose themselves. People are not ready to identify themselves. And also we are very much resistant for their problem. We are not really going into their problems, not really want to solve their problem. And I'm really grateful, Dr. Sunil Gupta, that he has agreed for speaking on such a difficult. Just one big round of applause for him.
Yeah.
And from the ACP, I would like to specially felicitate him for this wonderful gesture, what he has taken, and what wonderful job what he has done. Please bring.
Thank you, sir. I think this is the first time that in any conference, whether it is state or national conference, this topic is included. I'm not aware earlier was it included in any conference. So we are very proud of it. Thank you. Sir, I can say that only Dr. Virmani sir could have thought of such a topic, thinking out of box.
Travel karna.
Thank you, sir. And at the end, loud round of applause for all the three speakers. Thank you.
So we come to the end of this session. I would like to request Dr. Vermani to facilitate our speakers and chairpersons for the session. Facilitation for the speaker and the chairperson at the side of the hall. It gives me immense pleasure to invite our chairpersons, Dr. Prahlad Chawla and Dr. A.K. Azad, for Honorable Governor's Address. Over to chairpersons.
Good afternoon, friends. Now we have the governor's address, and everybody knows our governor, Dr. Anuj Maheshwari. He is very well known to all the audience. He has so many things in his credit, and is one of the best governor I have seen in this ACP conferences so far. Over to Dr. Anuj.
All are clip. So I think at the ACP forum, at least I don't need any special introduction. So without wasting much time, I am coming on the topic. Thank you. So I shall be talking on a very unique thing what many a times is missing in our conferences, which is very much required also. How should clinicians evaluate clinical trials?
Sir, just a minute. Before that, we have to felicitate you, sir.
ये बाद में भी कर सकते हैं. So keeping this role on my own as a token of affection of Dr. Jain Panda and Dr. Virmani, I will speak in the keeping this with me. So let's come over the topic. How should clinician evaluate the clinical trials? हाँ तो यही नहीं आगे बढ़ता. Okay, that's right. So first of all, congratulations to Dr. Jain Panda and team, Bhubaneswar, Dr. Anil Virmani, who has made this conference unique by their best efforts. So now I should come on the topic. Why do we really need to keep this topic? Because keeping up with the latest advances in diagnosis and treatment becomes a challenge. Now we are having a plethora of data, plethora of studies, and plethora of clinical trials. Question is that how to find which is correct, which is useful, and which is not useful. Many a times in various CME lectures, in sponsored sessions, in pharmaceutical advertising, we get multiple kind of the thing. Whenever a pharmaceutical company comes to you and opens its folders, you have an idea that all good things are with them only. When another company comes, then that gives the same impression what you had with the previous molecule. Now this is a dilemma for a doctor, dilemma for a prescriber, how to go with these advices and what should be followed and what should not be followed. Application of these results which are coming out of the clinical trial to the individual patient that physicians see is quite difficult. The volume of the clinical research and data can be downright overwhelming. Obviously, not everything published or presented is of the equal quality. Everything which is yellow is not the gold. Everything which is shining is not the gold. So we should be very much careful about that. How can a busy clinician determine what is relevant and valid? Now the question arises, what should be the evaluation parameter? How should we go with those trials and studies which are being kept before us? There are certain evaluation parameters like patient population, designing of the study, data analysis, study outcomes, results, and others. Most critical consideration when evaluating the strength of the clinical evidence should be the selection of the study. Which study we are going to select? Gold standard, always randomized double mask controlled clinical trial,
but many of the time the results of the randomized double mask clinical trials are not really fitting with our day-to-day practice. So that's why another terminology has been generated in recent past, that is the real world evidence. And real world evidences are those what we experience in our day-to-day practice, in our clinics, and incrementally the things are becoming less validity, but they may have many of the times more nearer to the truth what we see in our day-to-day practice. Very low end of the clinical evidentiary spectrum are case series and case reports, and meta-analysis has the highest level of the evidences. Now, if we compare these different designs of the study, like randomized control trial, cohort, case control, cross-sectional, case report, and case series. As I already said, that case report and case series are the least value of documentation, in which we can say they are based on the individual experiences with the patient, and highest amount of the credibility remains always with the randomized control trial, which is the gold standard for the evaluation of the therapy that and its effect, which can determine casually and minimizes the bias and confounding. Cohort studies are the observational studies which can help in identifying the risk factors of the disease, more generalizable than randomized control trial. So from here, usually the real world evidences start taking place. Case control studies are observational studies in the diseases which are done in the retrospective manner compared with the controls for the exposure status. They are having the lesser cost. Time concern is always there, so many of the times they may not be as accurate as the prospective studies are there, but they are found to be more realistic when we are looking a patient or group of the patient in retrospectively. And I must tell you, ACP India chapter has done 3-4 studies on the retrospective manner. The very famous study which we had done on the COVID-19 and its effect on new diabetes and neo-diabetes has been the retrospective, because during COVID time we were not having any tool to do the study. So once the COVID has been over, then we asked our members to submit your data and retrospectively we analyze. Similarly, the subclinical hypothyroidism, similarly the study a few anemia in the physician's clinic, they were the prospective study which can come into the cohort studies category. Cross-sectional studies are the observational which assess the prevalence of the disease and exposure during one period of the time. Case report and case series already I have discussed. So come over to the another criteria of the evaluation or another parameter, that is the patient population. To determine whether the subject is the study or representative of the patient a clinician sees in other practice or not. That is the most important thing. Many of the time we see the studies done in those kinds of the patient which are usually not being seen in our clinic. So these kinds of the studies are naturally not the true reflection for our clinical practice. They may not be guiding our clinical practice. So always when you are going to some study and going to some clinical trial, ask the question, were the study subjects sicker or did they have more complicated disease? Did they fall more prior medication or did they have longer disease duration? For example, I am not going to take the name of the trial. For example, 10 years before there were the 2 trials came. One trial has included all the patients of the diabetes which were ranging HbA1c from 7 to 11. And another trial very cleverly included the patient between 7 to 8 HbA1c. So obviously the patient, those who have been included 7 to 8 HbA1c, they were comparatively healthier in the condition as compared to the previous one. One drug is tested in the one trial which has included 7 to 11. Obviously the people, those who were 10, 11, they were more sicker, they might have been more non-responder. So obviously the drug may not be found that much effective and probably it might have found that more cardiovascular adverse outcomes could occur there. Another drug which has been tested between these 7 and 8, less cardiovascular outcome, and they said that CVOT trial has done and we have we are coming out of the flying colors. So these are the things which must be understood whenever we are getting the results and analyzing the studies. Your study subjects often have a longer duration of the disease, more complications, more active disease, and more previous medication failure. Recruitment methods also influence the makeup of the study population and can lead to different response rates. In publication of the clinical trial, the first table in the paper usually summarizes the characteristics of the study sample. So whenever we are doing this, we should examine the table to determine age, race, gender, typical disease severity, disease duration, modification history. Clinician can only apply the result of a study to patient care if all of these factors appear to be similar at the baseline. Many of the times we don't ever see the results are really being analyzed, comparing it with the baseline or not. Consolidated standards of the reporting trials may be having a flow of subjects from recruitment through the end of the study. Special attention should be paid to the number of patients in each arm who dropped out of the study. Very rarely we talk about the dropped out population from various studies. Subjects drop out of the study for many reasons, but two of the reasons are most important. One is the lack of the benefit and another is the side effect. If dropped out occurred without any reason, then you should also be very much alert then why did these reasons has not been documented. If somebody has not come back, then we should at least know why it's not coming. Maybe drug not effective. If some study has seen the more than 40%, 30%, 40% dropout, then you should be very much cautious whether the drug is really going to be effective or not. The clinician can compare the percentage of the subjects in each arm of the study who drop out due to lack of benefit. Consider if dropout rate due to lack of benefit is lower in the treatment arm than in the placebo arm. This finding not only validates that statistical significance of the study result, but also indicates that patient consider this difference to be clinically significant. And reasons for the leaving the study may not be specified in some studies, and readers have to make to do comparing the exit rate of each arm. Now come over to the third parameter, that is the study design. Comparator group should always be taken into the consideration. In disease states with established therapy, the comparator should be a standard of care therapy. Functional disease states should incorporate a placebo group and or a comparator that has proven to be effective to ensure that the placebo effect is measured. And allocation of the subjects to the treatment arm is again very much important to be taken care. The design of the clinical research will often determine the degree of bias present in the study. The most common types of the bias in clinical investigation relate to the subject selection, outcome measurement, and confounding factors. Next comes the data analysis. So whenever we talk about the statistics, this clinician becomes very much puzzled of that. The eyes of the most clinician begins to become glazed. The way the data are analyzed in a clinical trial can dramatically alter the trial outcome, and this should always be kept in mind. All game is of the analysis. The same analysis can prove something very much effective, and different way of the analysis of the same data can prove not effective. Yesterday, we have seen the study which READ-IR study which has been presented by Dr. Makkar, and very good analysis we could analyze there. Although vitamin D deficiency is not causing any relationship with the insulin resistance, but the people, those who were having the deficient in the vitamin D, once they have been supplemented, and if they were having the high HOMA-IR, they have been found to be reducing their HOMA-IR. So this was the very important observation what we could get. But this again needs a very specific and very intelligent analysis until unless we don't get this. Two types of the errors are committed when designing the clinical research, which is one is the systemic error, which is due to bias in the studies design, like selection of the patient, selection of the outcome measures, as well as confounding factors may not be dropped. Second is the random error, which results from variations in either biology or measurement and is evaluated by examining the study's outcomes with statistics. Does the study include an intention to treat analysis? What is the intention to treat analysis? An analysis that includes all randomized subjects in the trial. As per protocol analysis, early reports of the trial which analysis data of the only subjects who received their assigned intervention and not the early dropouts. So despite the importance of the performing in intention to treat analysis, fewer than 50% of the papers in some well-regarded journal identify their analysis as an ITT analysis. Is this a test of the superiority, equivalence and non-inferiority? Multiple times this has been explained. So I am not going into the deeper, how will you know about the superiority, how will you know about the equivalence and how will you go about the non-inferiority. Superiority trials compare two therapies with the intent of proving that one is superior to another. Equivalence or non-inferiority trials are those in cases where a new therapy is more convenient or cheaper. An equivalence or non-inferiority study can be appropriate comparing with the previous one. From the standpoint of the study design, the sample size needed to determine non-inferiority or equivalence is higher. Typically, the design of an equivalence study requires that the 95% confidence interval. This requirement often results in a required sample size about 4 times larger than the sample size needed for a superiority study. So if a study is initially designed to test for superiority, but this outcome is not found, switching to an equivalence study would be inappropriate for 2 reasons. One, the acceptable difference would not have been defined in advance and sample size would be too small. Thus, the measurement matters. One of the overlooked issues that can make a clinical trial difficult to generalize. Clinical trials require determining definition of the success. These definitions should be mentioned before starting of the clinical trial. They usually involve several measurements, sometimes a clinical severity index and some form of a scale. Issues related to these measurements must be considered whether the measurements are reproducible or not. Most of the time, the data which we getting may not be reproducible in the studies if we can do the similar study again. Thus, the presented measurements published in paper translate to a meaningful improvement of real-world patients or not, whether the measurement has been validated or not. Come over to the study outcome. If we talk about the study outcome, ideally the outcome being studied should be one in which clinicians are most interested. Primary outcome should be the stronger and more meaningful than surrogate outcomes such as biomarkers level. Surrogate outcomes are based on the surrogate biomarkers which may appear to be easy, inexpensive and less invasive method, but the validity of the surrogate markers should be scrutinized very closely. Dichotomous outcomes are those in which we see that endpoints are critical and should be scrutinized carefully to ensure that they are not too lenient. Continuous outcome provides more power to detect a difference between groups. So once we do the statistical testing, the p-value has the very much importance. Statistical testing assesses the probability of getting an observed difference between the groups when there actually is not on the therapy. This difference is indicated with the p-value. The p-value is a function of sample size, the magnitude of the differences between the groups being tested and the variability of the observation. It should be noted that statistical significance does not always translate into the clinical significance. So always everything which is shining is not the goal. Every time once we get the p-value which is significant is not really translating into the clinical effectiveness. So correlation. In testing for correlation, the null hypothesis is that there is no correlation. The p-value in such tests is very sensitive to weak correlation. Even small correlations will be considered significant. Probably best to ignore the p-value for correlations and instead look at the correlation itself and its confidence, 95% confidence interval. A correlation of the 90% with a confidence interval of 85 to 95% is quite impressive. Correlation of the 23% with a confidence interval of 1 to 57% is not very impressive. A study that reports a correlation and gives a p-value but not a 95% confidence interval should be viewed with caution. Time to event analysis. These are weaker endpoints that outcomes measured at a particular time point. Statistical tests for the time to event data compare the survival rate. This approach effectively counts each subject multiple times by looking at each subject at multiple time points, thus adding to the statistical power to the test. Problem with the time to event analysis, because it can produce a significant p-value, but this value may not be reflecting a clinical meaningful difference. How are missing data addressed? Common approach for handling the missing data: non-responder imputation, last observation carried forward, and imputation. In our May measurement study, what have been published in European Society of Cardiology journal as well as in Lancet, we had the use of the imputation, in which we take the examples from the previous study, and on the basis of the results from the previous study, we have imputed the data at the place in which the data was not available. But again, it is to be considered whether this imputation is genuine or not. Come over to the results. P-value is based on the assumption that the null hypothesis is true. It's already has been discussed. The more important is to illustrate how a large sample size can make a small effect significant. These are the two curves where you can see it here. One is showing the treatment A and treatment B, another is showing the same, but inclusion population is different. This is, first one is showing the 500 every group, and the other one is showing the 50 per group. What the difference in the observation? Due to the smaller sample size, this study, which is showing the 50 patients per group, barely achieves the same p-value despite having a larger clinical significant effect. Here you can see in this study, both the graphs are very much closer to each other. So you can see that there may not be much difference in between these two treatment methods. And there could be very well differentiated method is being visible there. But because of the less number of the patient included, that really does not matter, and it makes more significance and more matters. So now come over to the other factors. What could be? Checking the figures. Many a times what the common errors we do not see about the axis manipulation. Many a times lack of a 0 point on the y-axis or a change in scale in the middle of the axis. Plots of means without an indication of variability may be more aesthetically pleasing. How big of an effect is it? To help judge the impact of a study's finding, it is worthwhile to calculate the number needed to treat. This number represents the reciprocal of the absolute risk reduction and gives the readers an understanding of how many patients a clinician would have to treat to see the desired outcome. So summarizing the talk, determining whether patients in trials are similar to the patients seen in clinical practice, it is important whenever you are addressing any clinical trial or real world study. Design aspects of the study, including randomization, blinding, should be checked for signs of the bias. Outcomes of the trials are crucial, reliable, and valuable. Not the difference between statistical significant and clinically is significant. The treatment effect can be estimated by calculating the number needed to treat, which will demonstrate whether changes in clinical practice are really worthwhile or not. I think this ends my presentation. Thank you very much for the kind listening.
Well, honors, I think such a vast subject that you have tried to cover within 20 minutes. Excellent job. But the session demands a full day at least. I think Anuj deserves the highest clap of this meeting. Thank you.
Thank you, sir. This was really very enlightening talk, and this is a very important topic for every physician and everybody. And you have covered the entire gamut of clinical research or every aspect of it very lucidly, very fluidly, and in very easy words for everyone to understand. I think this is one of the best talks that we can have in this ACP conference, and it's really, it shows the stature of the ACP governor and the amount of work that is being done. I really congratulate you and thank you, sir, for this great lecture that you have given today. Thank you very much.
Thank you.
Thank you.
I'm delighted to invite Dr. Jayant K. Panda and Dr. Divya Saxena for chairpersons for the keynote lecture. I would request Dr. Ramesh Arora as chairperson for the keynote lecture. Over to chairperson.
Welcome, sir. Good afternoon. As you watch, the good science is going on, and here in the keynote lecture, the next presentation will be by none other than Dr. Bansi Shabu. You know, Dr. Shabu, he is the physician, leader of physician in the country who has taken India to the global level, and say it diabetes, say it internal medicine, say it be any topic related, has represented the group of physicians across the globe. He'll be speaking the novel classification of type 2 diabetes and the usual style that we follow, like age-old classification of insulin dependent and non-insulin dependent, switching over to type 1 and type 2. Now we can be more rational in our approach to the classification, and Dr. Shabu will be covering that. So it's an honor presenting Dr. Bansi Shabu before you.
Thank you. Thank you, Jayant, for kind words, and thanks Jayant and Anuj and team of ACP India chapter for inviting me. What I am going to talk in next 20 minutes, I think this is very important paper. In last 20, 30 years, we know that there are few paper, historical paper like DCCT and UKPDS. Similarly, a paper had come in last 3-4 years before, which is talking about the novel classification like the reversal of diabetes. So it's very, very important paper. I'll be discussing in next 20-25 minutes. I don't have any conflict of interest for this. Let me talk about, do you think that all type 2 diabetic patients are same? And we are practicing since last 25-30 years. And we were surprising that many of our patients actually they need insulin at the time of diagnosis. Some of the patients, they were coming out with a very high sugar. Some of them were lean. Some of them were obese. So we are very sure that yes, they all are not same. So diabetes is defined by high glucose, but the cause for this hyperglycemia actually differ. Some of them have very high insulin resistance and some of them have actually insulin deficient. Type 2 diabetes is actually a diagnosis of exclusion. The type 2 diabetes increased in last 50 years. We have the data of India from 1971 when Dr. O.P. Gupta had talked that less than 1% of adult population is actually having type 2 diabetes. That was his survey was, and now we have the data of 2021. Dr. Mohan and ICMR India survey had talked about more than 15% of our adult population is actually type 1. So type 2 diabetes is a diagnosis of exclusion. It's not autoimmune. It means it could be type 2. If it is not genetic, it could be type 2, or it is not secondary diabetes, then it is type 2. So type 2 diabetes diagnostic criteria, actually you are excluding other causes of diabetes. The current classification, we all know it's a type 1, type 2, GDM and secondary diabetes. That is what World Health Organization. But can you say that all type 2 diabetes are same? Which is your 95% of the patient, actually they are not same. There is a heterogeneity in type 2 diabetes because they differ with the respect of clinical characteristics, they differ with the risk of complication, they differ in response to treatment, they differ even in BMI, and they differ even at the age of onset also. So they differ in different way, and that's how, if you want to put them, like what we are seeing them like this chocolate box, but if you put that there are some unique characteristic in all different type of patients, we can put them in a different classification, and that's what we have tried. It's not like the diabetes classification is initiated just before a few years. Long back, from if you see the Sushruta and Chakra, they had discussed that there is a insulin deficient diabetes and there is a disease of Madhumeh which happened only in Rajas, in kings. So actually in those days, he thought of there is a two types of diabetes. Then we know that diabetes has been classified like insulin deficient and insulin sensitive, insulin dependent, non-insulin dependent, young diabetes and old diabetes, autoimmune diabetes and non-autoimmune diabetes, and now we classify very clearly it's a type 1, type 2, secondary and GDM. This paper which I was talking is really a historical paper. It has changed the way we were treating type 2 diabetes, the way we were thinking that type 2 diabetes is what. This paper had come from Sweden, that novel subgroups of adult onset of diabetes and their association with outcomes. And it has really, in a press and media, it had also gone very widely that diabetes is actually 5 separate diseases. It's not a single or a one disease. This was what newspaper had put. In a Lancet, in a editorial had also talked the many phases of diabetes addressing heterogeneity of a complex disease. So it had become very, very popular all over the world. This is what in a Swedish group, they had talked about subtypes of type 2 diabetes, and they had classified actually type 2 diabetes or whatever diabetes which we are seeing is actually 5 different types. One here they talk type 1 diabetes, they called it as SAD, which is severe autoimmune positive diabetes. It is SAID, that is what severe autoimmune insulin deficiency disease, and this is a type 1 diabetes, what we call. The second is SID, that is severely insulin deficient disease. These are the persons who does not have autoimmune marker positive. Their C-peptide is not very low like type 1 diabetes, but they are insulin deficient, and that what we call is SID. The third variety is SIRD, which is severe insulin resistant diabetes. It means these have the insulin, but the insulin resistance is very, very high, and they had called it SIRD. The fourth variety is moderate onset diabetes of young. They are actually obesity induced. It is MOD. And these are the person, they develop diabetes because they have become obese. If they reduce the weight, if they go with the significant weight reduction, that is what we call is diabetes reversal. So you can definitely get the reversal in this variety of patient, and that what we call MOD. And then you have a MARD, which is moderate, or you can say mild. It is age related diabetes. Someone who is developing age because of the age, maybe at 60, maybe at 65, they develop diabetes, and we call it MARD. This is 5th variety of diabetes. The complications are also high in the persons who have SID. Like type 1 diabetes, they have more chances of developing microvascular complication because they have insulin deficiency. The people who have SIRD, it means severe insulin resistant diabetes, they also develop other than the complications like NAFLD or cardiovascular disease, but because it's a severe variety of diabetes, they also found to have more complication like insulin deficient diabetes, which is nephropathy and retinopathy. The persons with MOD or MARD, the persons with MOD are actually having more risk of developing cardiovascular disease because it is obesity induced disease. In a summary, it can be classified very clearly. Type 1 is remaining the same. We can call it SID or type 1 diabetes, but type 2 diabetes is now clear cut 4 varieties of diabetes, and you will find only 22% of your patients, they are actually obesity related diabetes, or your 1/4 of the population may be obesity related. The others have either severe insulin deficiency or severe insulin resistance, and your 39% of the patient, this is in Swedish, so we will have the Indian cluster also. Your 40% of the patient actually they have developed diabetes, which is age related diabetes. Now the point was, when this paper had come, they wanted to know whether the similar type of clustering can be done across the world or not. What about the other population? And these are some of the data which they try to do with the other population, which I'm not talking, but it is almost similar type of finding was there in different part of the Europe. So they have tried to do and clustering in the different registry which was there in the different parts of the Europe. Then they have also tried to do the replication in China and US population too. So they have done the similar type of clustering in US and Chinese population. population. So our interest is whether this similar type of clustering can be done implicated in Indian population or not. This can be applied in Indian population. There are two major papers which had happened. One is from Valjan study, which is from Ahmedabad, my center, Pune and Dibrugarh, we had tried to do, and one more which is Dr. Mohan paper, Anjana paper, which they had tried to do from the more than 50,000 of the patients from all across the country in their 54 centers they have done. And this we had tried to replicate whatever the data which Swedish people have shown, whether it has been done in India or not. This is the Indian cohort study, a type 2 diabetes, all the patients who are below the age of 45 years. This Valjan study from Ahmedabad, my center, Durvi was also associated with me, Pune and from Dibrugarh. And this paper which was published, a subgroup of patients with young onset type 2 diabetes in India reveal insulin deficiency as a major driver. And this paper which was published in Diabetologia, there were variables, but we could not get the GAD antibody for all patients. So the patients which number of people which we had taken in this more than 1200, but the variables for these, we have taken age at the time of diagnosis, BMI, fasting glucose, HbA1c, fasting C-peptide, and then calculated the HOMA2B and HOMA2IR. And the data you can say with the 1612 completed data out of 2200 patient data which we have collected, the number of participants, male, female were the same. The HbA1c was also similar, but you can see that we were having HOMA2B is almost 58% with HOMA2IR is 2.12 and 2.15, which I will compare with the Western data too. And our clustering had shown more of a SID, and that is what we had seen less of SERD, and something which is unique that we found to have more severe insulin deficiency in our patients other than that a mode. So R was very clear in compared to the Western population, either we have more of insulin deficiency or more of a obesity induced diabetes in our country. Definitely there are few who are having the age related diabetes too. If I compare the data between the Swedish group and India, the age of the onset which I had written you already, the BMI was in compared to the Western data, definitely we have low. The HbA1c is comparable. Something which was unique that we were found to have more insulin deficiency, it was 0.68 was there, but we don't have severe insulin resistance, and that I will talk about one more variety of classification which is done by Anjana and Mohan and group, where they had tried to talk about that we have more of insulin deficiency along with insulin resistance. The comparison of clustering parameter between these two populations had found to that in India we have more of obesity related and age related, and remaining are having more of a insulin deficiency rather than insulin resistance. And this was the paper in Diabetologia which was published. The pathophysiology and complication, as I told you, the SID will have more like a microvascular complication like type 1 diabetic patient. The SERD patients have more of a, again, microvascular complication along with cardiovascular disease. The patient with obesity found to have more with neuropathy. So this is something which is unique, that a person with obesity induced diabetes other than cardiovascular disease, it was the neuropathy which was more common found to be that. And a persons with age related diabetes, they definitely have, along with age, they also develop the cardiovascular disease, but other than that they may have also the complications like nephropathy too. As we did not have a GAD antibody positivity, I mean that report was not done in all 1200 patients, GAD was not done, and that may be the reason that we found to have more of SID. Probably we are missing some of the type 1, probably we are missing some of the LADA, probably we are missing some of the secondary diabetes. So the 30% or 40% which I had shown that we have more of a severe insulin deficiency, because we could diagnose only by getting their C-peptide level. But if we classify, probably maybe out of those 30%, 10% of them or 5% of them may be having insulin deficiency, and that's very important, that why you should do the C-peptide wherever you are suspecting it could be a SID or severe insulin deficiency, and wherever you find that it could be a SID, please get autoantibody also to confirm that are you dealing with a type 1 diabetes. In a simplified form, when you are seeing a patient of a type 2 diabetes who is coming to your clinic, think of severe insulin deficiency, think of obesity related, or think of age related. So if you have a young person coming to you and having all the symptoms of insulin deficiency, probably you are dealing with a SID. You have a person who is coming with a significant obesity, either it's a significant insulin resistance or obesity, which is the reason for them to develop diabetes, or someone after the age of 50, 55, 60 is coming to your clinic, it is marred for that. we have written for this modern cluster-based classification in one of the article along with Anjana. I have written an article in JAPI, that's our biggest journal of India with Association Physician of India, that we have a modern cluster-based classification. So now you are treating type 2 diabetes, it means you are treating 5 different varieties of diabetes, type 1, SID, and other than that, 3 more varieties which we have. Anjana had also done a very novel subgroup classification which was published in a BMJ Diabetes Research and Care. This was a, Anjana had done with the Indo-Swedish project only. It was an inspired study which they have done. The cluster analysis, they could do the age at the diagnosis, BMI, waist circumference, HbA1c. They have calculated 2 more things, triglyceride, HDL cholesterol. C-peptide was estimated fasting and post-meal both. Along with, that is also been done. And they have calculated HOMA-IR and HOMA-B. And the comparison they have done between the classification of Swedish group with Indian cluster, which was almost similar. They have also classified in SID, SIRD, MOD and MARD if they want to do for all their patients. But what they found very unique, that these 4 novel groups which they were having in the Swedish group, in India, actually they were having 2 unique clusters which they could find. One was IROD, which was insulin resistance and obesity induced. What they could find that in India, the obesity is not like comparable to the Western population. We were not having the BMI like 36. The highest BMI, which was the median, was around 28 to 32. So, I mean, these are having insulin resistance and obesity. So, they had put it, classified a new cluster, it is known as IROD, which is like a obesity and a SIRD, the same MOD and SIRD, which was classified in Swedish, it's combined in India, and they called it IROD, and it is 1/4 of your patient is actually obesity and they have insulin resistance, and they are the one to whom you should give them a very low calorie diet, and you can think of diabetes reversal or remission for that. The other, they had thought of combined insulin resistance along with insulin deficiency. So this is a combined insulin resistant and a deficient diabetes. This is a unique cluster which was found by this Anjana and Mohan group, that we have a patients who have insulin resistance also. That is, their HOMA-IR is high, but their HOMA-beta is low. And that is what a very uniquely clustered as a combined insulin resistant and insulin deficient. So probably they need sulfonylurea early, they need glitazone or an insulin sensitizer more, and they need the insulin also early in the course of diabetes, even they have insulin resistance very high. So they need a good amount of exercise, insulin sensitizer, and probably early use of insulin. Other than SID patient, this one more group which is CIRDD, which is combined insulin resistant and deficient diabetes. They had compared that these are the patients who have their C-peptide. You can see the cluster which I had put here, cluster 2, 1.5 in compared to that cluster 3 is having 1.2. So I mean the C-peptide is low, and the C-peptide stimulated is also in IROD was very high, 3.3, while in the combined insulin resistant and deficiency, it was comparatively less stimulated C-peptide. They have also done the same sample size with their ICMR INDAB data, which is a large study which is already been done all across the country, and where they have taken few variables because some of these blood investigations were there with them, so they could not do the C-peptide. But these, they had tried to compare that without getting C-peptide, which is very, very practical, because most of us in our clinical practice, we may not do C-peptide. So even without doing C-peptide, can we cluster these 6 variables in our day-to-day clinical practice? And still, you can do the clustering of these without getting C-peptide, and validation of this cluster in a nationally representative ICMR INDAB study, which they have done. And what they found is, they have already classified the SID, IROD, CRD and MARD even without getting the C-peptide level, and still you could classify these 4 groups, which is very common in our country. In diabetes clinic, classifying patients into subtypes of type 2 diabetes can be done with the 6 simple variables, namely age at the diagnosis, which is very important because that will also give you the young onset to the late onset of the diabetes. BMI, as I told you, the obesity is an important reason for many of them to develop diabetes. The waist circumference, which is also a central obesity, is more important for the insulin resistant. HbA1c at the time of diagnosis, and now HbA1c also give you the result. Serum triglyceride give you the very high serum triglyceride actually is an indirect sign of very high insulin resistance. So that's how you can do that serum triglyceride and HDL. Those who are insulin deficient, you will find their serum triglyceride is low, and that's a indirect way of knowing that whether you are dealing with insulin deficient or insulin resistant diabetes. The response to treatment for all these different clusters will be also different. The person with sulfonylurea will be better with the person with combined insulin resistant and combined insulin deficiency, or person with severe insulin deficiency, probably that will be better. The persons with the age related, maybe your choice of the drug, maybe the gliptin could be the first choice of the therapy, while the person with obesity, your GLP-1 and SGLT2 will be the choice of therapy. So I mean, you can decide that what variety of patient which you are seeing, and accordingly you can decide the treatment. A person with severe insulin resistant, with a liver enzyme is high, with NAFL, probably a glitazone could be the choice of therapy for these patients. And that's how the non-alcoholic fatty liver disease, the patients you treat with them a glitazone or like saroglitazar, probably a choice of therapy. That's so now a type 2 diabetic patient who is coming to your clinic, sometime it may be confused with LADA patient, sometimes it may be confused with slow growing, sometimes a type 2 diabetes, we are misdiagnosing the patient with secondary diabetes, but most of the time you can classify type 2 diabetes in these 4 varieties of diabetes, and a clustering base of classification will also give you the therapeutic benefits. The same paper, JAPI, where we have written the 5 different varieties of the clusters which we have, simultaneously it will also give an idea of precision medicine, that in future you will be precisely treating these varieties of patient. Like each and every patient you are putting them on a triple drug and a 4 drug or a 5 drug. That should not happen. You will have precise diagnosis and probably a precise medication can be given. So possible choice of anti-diabetic, which I already talked about it, and the building a precision in our day-to-day practice will be the future for a diabetic patient, and a translation to a personalized medicine will come from careful designed prospective studies, including genetic, epigenetic investigation to elucidate pathophysiological mechanism underlying the subgroup. To summarize my talk, European cluster algorithm works in an Indian type 2 diabetic patients also. Severe insulin deficient group is commonest in our country, but probably we are missing because of autoantibody is not done. Mild obese group is the most common in Swedish group, but the other second in our country also it was found to be there. Subclasses have characteristic phenotype. Association with complication has been also seen. There is an association with genetics and a step towards a personalized medicine. With this, I once again thank you, Dr. Jain, for inviting me at ACP. Thank you, Anuj, and I am inviting all of you on next week for DiaCareCon. Thank you.
Thank you, Bansi bhai. Please come here. Please come here. It's a very noble and approachable concept that we knew about insulin deficiency, we knew about age-related diabetes, we knew about the insulin resistance. But subclassifying type 2, basing on insulin deficiency, insulin resistance, both, and age-related hypoglycemia, and again, simple parameters like age, BMI, A1C, putting the easy clinical approach to them makes sense and then very well accepted across the globe. Give a big hand for this informative presentation to Bansi bhai. Before I invite our Governor sir to felicitate Bansi bhai, I request my co-chair sir to invite questions.
If there is any question, Dr. Bansi is happy to answer that. Give him to mic. It was a novel concept, but excellent presentation. Tough concept.
Thank
you.
Thank you for giving this a new area of classification. You have told actually the combined deficit and resistance. In fact, that is very much related now, proved to be highest group, subgroup who fallen victim of the nephropathy, diabetic kidney disease. So would you like to classify similarly clustering related to other complications also? I mean neuropathy or stroke or CVS, anything is related to
at present, the data is not having, the prospective study is not been done with each cluster, that whether they are developing first nephropathy and then retinopathy and then cardiovascular disease. But this is like with the highest insulin resistance found to have more with an NAFL and cardiovascular disease, while those who have more of insulin deficiency develops more of a microvascular complication. Neuropathy was more with the person with age-related diabetes also. But I'm sure in coming years, we will find that those who are classifying and doing their prospective study, maybe for 5 years, 10 years, and 15 years, how they are developing the complication, how their sugar is getting, uncontrolled over a period of time, and what medications they need, and which medication is actually effective maximum, and how much HbA1c is reduced by what particular medication. But like SEED is the one group which will be first you start with them in a sulfonylurea rather than putting them on more of an insulin sensitizer, and then they may require insulin early in the course of diabetes, while the patient with a SERD will require more of an insulin sensitizer early in the course of diabetes rather than putting them on a sulfonylurea or something like that. As you are rightly saying that in India, and this unique cluster which was found by Mohan and group, that we have many of our patients who are combinedly insulin deficient along with combined insulin resistance also. But there will be more prospective study, and we will able to have more precision medicine in coming future. That is what in my summary I had put one line that in future we will have more precision medicine on this.
Yes, Dr. J.B. Shatur.
Yeah, Dr. Sabu, excellent, thought-provoking. I just wondered, with thin diabetes and thin fat diabetics in Indians, do you think a subgroup like IROD, where we were talking about, beautifully included waist circumference, because 50% of patients of our patients are really between 20 to 22. And I think you could probably stress upon 2 points. Each clinic should have a measuring tape, a Taylor's tape in their clinic, number one. What about MRIs of visceral opacity? I mean, would you like to include that in your next part of the study? Whether, visceral opacity, do we talk more of waist circumference and less of BMI in future in Indians? I mean, what's your thought?
So we already started, talking about measuring the abdominal obesity, and abdominal girth measurement is more important. To do a MRI just to know about the visceral fat will become very costly as far as clinical practice is concerned. But definitely in a research, we do it MRI spectroscopy or to know about the visceral fat, and even DEXA also you can get it done. But primarily, if someone can do as a clinician, and which is very easy, they may just keep a measure tape and measure the abdominal girth. You may have a person with a BMI of 23 and 24, but still he is a centrally obese. And he is the one who is having insulin resistant also. And they are also one who develops the insulin deficiency too. So you have this unique group which is found more in our country, not in the Western world. That's what we had tried to replicate in India, the Swedish group data also. And then the Mohan and group, they had come out with these 2 more unique clusters found to have in India.
And in fact, in the next ACP conference, Dr. Anuj could give measuring tape
to everyone.
Doctor,
but we have, all of us.
That would be a tremendous.
Sir, before 10 years on a World Diabetes Day,
yeah,
when I was responsible for doing a national program, and USV had given with that from Diabetes India, from not RSDI, because it was actually Dr. Shokat Sadikot had done one study about the abdominal girth.
Excellent.
And it was 90 and 80 centimeter, and then across the country everyone we had given the measure test.
Excellent.
Just it was detected that it is the easiest way for person who is at the risk of developing diabetes.
Yeah.
You don't do any investigation, only one investigation, abdominal girth, and then the later paper had come. It should not be more than half of your height. So suppose I am 170 centimeter is my height, it should not be more than 85. My abdominal girth, if it is more than that, it means you are at the risk of developing all cardiovascular disease, diabetes, and all of that.
In our API in Hubli Dharwar, in most of the Karnataka, as a chairman of API Karnataka last, I made this point excellently brought. Probably we could do that in every conference. A tape could be added as a present.
Sure.
Thank you.
Thank you.
Thank you, sir, for that very informative discussion and very good message. We are waiting for the date. Like 25 years we saw by WHO, the classification became type 1, type 2, and similarly there will be a newer edition of subtypes of the type 2 by the World Authority, and then our studies will be recognized. Give a big hand for Dr. Bansi Sabo, the leader of metabolic medicine of the country, and he has given some time for the ACP. I request our Governor, sir, to felicitate Dr. Shabu. I request sir to join us.
Kindly come, sir. I invite Dr. Sabu and Dr. Mahesh. B stands for Dr. Bansi. B also stands for Big B. He is a big B of diabetes.
ये एक certificate, 12 credit hours, and the past president RSSDI is taking photograph. This should be photographed.
This should be photographed.
Thank you, sir. I am pleased to invite Dr. Sarita Behera, Dr. Saurabh Srivastava as chairpersons for international guest lecture.
हम लोग तो अपने यहाँ कीनोट लेक्चर को भी ऑनर लेक्चर
Over to chairpersons.
Hello. So after this marvelous spellbound session of Dr. Bansi Sabu, who just create a silent storm in this auditorium, and who several times who has taken this famous ICMR India study, and it is really one important study in pan-India study, and I am fortunate enough to work in this India study as an co-PI, and I was very much happy while sir was taking its name. And after this session to now, I am going to invite Dr. Jun Era for the hospital medicine in Japan. So let us now move in our psychological field to Japan to listen how the hospital medicine, how the internal treatment of critical ill patients in hospitals of Japan, it is being done from Dr. Jun Hara. Over to Dr. Jun.
And some from the lecture 2. I graduated from medical school in 2008. Now I'm department chief and program director of internal medicine of Tokyo Bay Medical Center. Japan, it's island country located in East Asia, 126 million people live in. The four seasons are quite distinct. Beautiful seasonal landscape can be seen. GDP was third among the world. Safe and clean country. Today, I'll talk about 4 topics. First, healthcare system in Japan. Second, a big issue, rapidly aging population. Third, hospital medicine in Japan. And finally, our challenge for the future. First, healthcare system in Japan. The most important things in Japanese healthcare system is universal health coverage. Social insurance covered most of the healthcare costs. Healthcare costs continue to increase despite of little economic growth. They account for 11% of GDP. That is little higher of OECD average. The number of practicing physicians per 1,000 population was 2.5. That is quite low than the OECD average. Universal health coverage lead to high equality in healthcare. Even poor people can take medical care with low cost. Private service for rich people doesn't allowed in Japan. Doctor consultation per capita was 12.6. That was about doubled from the OECD average. In the result, this is typically seen a waiting room of Japanese clinics. In Japanese clinics are usually crowded and waiting for a long time. Also, physicians work hard for a long time. This slide shows a number of board certified physicians compared to United States. Japan is blue and USA is green. In Japan, board certified general physician is quite smaller than subspecialists. In United States, general doctor is the majority. Almost all admitted patients are cared by general medicine, and the various kinds of subspecialists support generalists. On the other hand, GIM is minority department with a few doctors in urban educational hospital in Japan. Many subspecialists directly care admitted patient. Here is one case, Mr. Tanaka, 80-year-old man. He got dyspnea 3 days prior to admission. His symptoms worsened gradually, and he called emergency medical service. He had cough and sputum. He also noted pedal edema 1 day prior to admission. Past medical history is COPD, chronic heart failure, chronic kidney disease, and diabetes. He desaturated and had bilateral bleeding. This is problems of Mr. Tanaka. Problem 1, dyspnea, hypoxemia. A differential diagnosis is COPD exacerbation and decompensated heart failure. So then, who should care him? In United States, a hospitalist will care him. The number of hospitalists is growing to 50,000. They play important role in inpatient care, and most inpatients are covered by hospitalists. However, in Japan, a subspecialist will care him directly in Japan. How do you think? Is there any problem? Here is 3 major problems if subspecialists care patients directly. First, conflict in new admission. Second, focusing on their specialized area, problems will not be integrated and consultations are increased. And Third, shortage of social skills lead to healthcare system doesn't work appropriately. In admission of Mr. Tanaka, then cardiologists say he is not a cardiology patient because chest X-ray is not pulmonary edema and BNP is not so high. Pulmonologists should care him. Pulmonologists say he seemed to be heart failure because high CVP and pulmonary edema. COPD exacerbation is less likely. Would you like to care him? This is one example of conflict. If Mr. Tanaka is heart failure and cared by cardiologist, so the decompensated heart failure managed appropriately. However, other problem, COPD to be pulmonary consult, CKD nephrology consult, diabetes for endocrine consult. Ideally, general medicine work appropriately at the center of healthcare. Unfortunately, in Japan, general medicine often doesn't function. In the result, subspecialists focus on their specialized areas and other even small problems will be consulted to other department. So it lead to much more consultation and resulted in much more workload each other. Let's move on the second topic, aging. Aging is a very big issue in Japan. A quarter of people are over 65 years old. That of India is only 40%. The aging is doubled only 14 years. It resulted from low birth rate and long life expectancy. It progressing most rapidly all around the world. Aging is more serious in rural area in Japan. The red zone and orange zone is very serious in aging. In aging process, role in the society and body function will be changed. Medical problems will increase with aging, shown in this slide. Especially geriatric problems such as dementia, delirium, and chronic illness is increasing. In Japanese world, too many older patients exist, like right-side person. Here's the second case, Mrs. Suzuki, 80-year-old woman. She got dyspnea on exertion 6 months prior to admission. It was worsened gradually and influenced her ADL. She visited to clinic and referred to cardiologist. Physical exam showed Levine 3-degree murmur on LSB. Transthoracic echocardiogram revealed severe aortic stenosis. Cardiologists say she will be an indicator of, she has indication of TAVR, transcatheter aortic valve replacement. She should start workup for intervention. However, after workup, she is frail and she had multiple advanced comorbidities. Cardiologists say, unfortunately, TAVR is not indicated for you because the risk of procedure is prohibited level. What does she need next? Her prognosis will be poor. End-of-life discussions and advanced care planning are needed. We also considered how to palliate her symptoms, who will support the rest of her life, where will she give end-life care. Multidisciplinary team meeting will be desirable. Now, many older patients are like her in Japan. Physicians need to gain the skill of integration of individual medical problem and personal value from advanced care planning. They also need viewpoint of overall picture and then share the goal of care with patient. Johnson's four-box approach is usually used for difficult decision making. The Society of Hospital Medicine showed core competencies of hospitalists. 1, clinical conditions, 2, procedure, and 3, healthcare systems. In Japan, about clinical conditions, high-level internal medicine knowledge is required to integrate multiple medical problems. And then, a healthcare system is very important. It is mandatory for every physician in hyperaging era in Japan to care of the older patients. Common diseases are also common among Japan, and generalists are required. Finally, I talk about our challenge for the future. Tokyo Bay Medical Center is established in 2012, and the hospital had adopted US-style hospitals. 3 types of general medicine, GIM and ER and critical care are center of patient care. Sorry. And the first chief of each department were US-trained physicians. They taught global standard medical care. And 89 residents were graduated from our GIM program for 10 years. Movement for GIM and hospital medicine. ACP Japan chapter have over 1,200 members. Annual meeting covers various important topics of internal medicine physicians, such as mix-up, online study group, and in the clinic Japanese translation project, and clinical listening workshop by Dr. Stein. J Hospital Network is also important society, which is made in 2013. We issue our journal, Hospitals, and we held seminar biannually, total 70 times, over 200 participants. Journal Hospitals is established since 2013, and 39 books are available now. Japanese Society of Internal Medicine is quite popular society, and over 110,000 members. Current members are almost subspecialists, not GIM. Japanese Society of Hospital General Medicine focus on general hospital medicine. Member is only 80 at start, but now increased to 2,100. Still small society, but it is gradually become popular. In summary, we face serious social issue, rapidly aging. Generalist is still minority in Japan, but needed. Skills and knowledge for broad chronic condition and healthcare system are necessary to take care of this rapidly aging society. Thank you. Thank you for kindly listening.
Thank you, sir. Thank you, Dr. Jun, for the presentation. And whatever you have pointed out is the very good thing that internists are very much required to take care of holistic approach of the patient. It is not the subspecialist or super specialist who take care. So, yes, sir.
I think I congratulate Dr. June for making a very candid presentation, exposing us to the facts and the figures of Japan. One of the things I was actually noticing is that probably we seem to be suffering from the richness, whether it's a country or individuals. You know, Japan is basically a rich country, so you have finally shifted to the subspecialists, ignoring the internists. It is the same thing that happens in India too. If there is a rich person, he would straight away go to a subspecialist. If it's a middle class or poor patient, he would rather go to a general practitioner or to an internist. So that is exactly happening in your country. What happens to a rich Indian here? Just wanted to make this. Could you understand me?
I could little understand, but on the difference from the subspecialty care and the general care. In Japan, the fee of healthcare is equal if the generalist care and subspecialty care. It is equal.
If there are no more questions, so we hand over the mic to the organizer. Thank you, sir.
Thank you, Dr. Jun.
Thank you
So
very much.
here we have closed the session.
and we have chairpersons and panelists with us, and I'm going to start this particular session, and I hope that you all will participate and make the use of these 20 minutes which have been allotted to us. I know the time is very limited, but still some fruitful discussion can carry on in these 20 minutes. First of all, to make the ball rolling, I invite Professor Anuj Maheshwari, the brain behind all this activity, and Secretary General of Indian Society of Hypertension, to briefly present few highlights of the guidelines. Professor Maheshwari.
Thank you, Professor Verma. And yes, Dr. Mugunathan, please join us on the dais.
Dr. Mugunathan, sir, please join.
There we can add one more chair. In fact, Indian Society Hypertension is a society which was more than 24 years society, 23 years society, more 23-year-old society, 35. It's more than 35-year-old society, but for the first time we have come out with the own guidelines. Before that, we were all dependent upon the guideline of the International Society of Hypertension. We were dependent on the guidelines which were coming from the Western countries. Although our Indian guidelines has been issued by API in time to time, but those guidelines were not really very much backed by the data. So what actually we tried to do here, that we should compile the guidelines, we should develop the guidelines taking the International Society of Hypertension as template and add up with the Indian data. Wherever we did not find the Indian data available, we continued with the recommendations which were there with International Society of Hypertension guideline. But wherever we found the Indian data and wherever the expert opinion were different, what the guidelines were already being given the International Society of Hypertension, we tried to take a different track. And these guidelines have been prepared, kindly please show here. These guidelines have been prepared in a 1-year time. The process of making of these guidelines, developing these guidelines has started in Lucknow, where we had done the BPCon 2020, BPCon 2022, and in 2023 it has been finished. These guidelines were supposed to be revealed or released in Bangalore BPCon, but fortunately or unfortunately, whatever you say, the conference shifted again to Lucknow, so these guidelines has been released in Lucknow. It started in Lucknow and 1-year process of development finished at Lucknow, and we released these guidelines on 9th of September in our annual conference. So these are the guidelines which are called as INCH guidelines. In these guidelines, 56 experts were involved in preparing them. And those 56 experts were from whole of the country. Few of them, those who played a key role, and also the member of our executive body of the Indian Society of Hypertension are sitting on that side. Professor Kamlakar Tripathi, Professor Narsingan, and Professor Mugunathan. All the three were the key person of the Indian Society of Hypertension, those who contributed in the development of the guideline. Dr. Shashank Joshi is also outside of this hall. He also supported us as an advisor and sent me relevant documents and details time to time so that I could make them added value in those documents which were being prepared by different group of the experts. So these were the different groups which we prepared for the various experts. We have taken the segments, and each segment has been dedicated to the 4 or 5 experts, including the methodology, definition of hypertension, what international and Indian standards, what is the difference, should we follow the same standard which were followed by the international, what should be the method of measurement, monitoring, diagnosis, how to do the screening, whether we should we can follow some limited resource setting, screening and treatment of the blood pressure, how to do workup of the patient, what could be the cardiovascular risk, medical organ damage, hypertension mediated organ damage, exacerbator inducer, which were already there in guidelines which were issued by the International Society of Hypertension, but we still tried to find few of the exacerbator and inducer which were of the Indian perspective. Treatment of the hypertension, should it be different or should be same? Whether the comorbidities and complications of the hypertension, what should be more in the perspective of the Indian scenario? Specific circumstances like renal failure, like hepatic failure, and how to go with other situations which may be very much relevant for the management of the hypertension. Women, we have also took up the endocrine hypertension, and 2-3 new things we added to these guidelines. One was the obesity-induced hypertension, which was not found in previous guidelines, and pediatric and adolescent hypertension, which is coming up as a biggest problem in Indian scenario. Adolescent hypertension especially is going to be a very much fulminating thing in Indian scenario, and it is to be addressed. We thought, all experts thought that it must be addressed, so that's why we also included the adolescent hypertension. And later on, we have made a flow chart in which hypertension management at a glance has been given. So this was the method of making the guidelines through which we could come out of this make of the guideline. So as far as the brief introduction I shall be giving on the guidelines here, we are having a panel of the experts. Dr. Narsingh Verma is having some important points to be highlighted, to be asked as a question from the panelists. In between, you are supposed to ask the question to the panelists. Many of you must have received a copy of guidelines from the alembic stall. If you have received a copy of the guidelines at the alembic stall and go through of that, and you find anything which is little bit needs more explanation, you find which is not really found you as per your own judgment and current practice, whatever you are doing for the hypertension management, you can raise the question here. This session, 1 hour session, has been dedicated for the same, so that whatever the guidelines has been made by these 56 experts, 4 of them are representing here, and remaining 4 of them, those who were not the part of that, are sitting there, and they will be representing the audience who are not the part of the makers of the guideline, and they will ask the question. I have also requested, out of those 56 experts, those who are involved in the making of the hypertension guidelines, if they are there, they should remain in hall to put up their point and put up their point of view if any questions arises. So if we talk about the introduction and methodology of the hypertension, obviously 31.5 crores people in India are suffering with the hypertension. Out of that, 32.6% of the women and 38.7% of the men, and this age difference is and this gender difference is coming closer and closer very fast. And we also took the responsibility of creating a clinical guideline inspired by the International Society of Hypertension, what I already said. As far as the hypertension definition and classification is concerned, in our guidelines, in Indian perspective, we decided that blood pressure less than 130 mm of mercury systolic should be considered as the optimal blood pressure, and less than 85 diastolic should be considered as the optimal. High normal blood pressure between 130 to 139 systolic and 85 to 89 diastolic. Grade 1 hypertension should be considered 140 to 159 systolic and 90 to 99 diastolic. Grade 2 hypertension would be considered 160 and above systolic and more than 100 diastolic. Now the treatment strategy and management strategy will also change with the change of the grade of hypertension. So in the recommendations, adult more than 18 years should be screened for hypertension at every point of the contact with the medical expert or medical practitioner. Persons with high normal blood pressure or grade 1 blood pressure, grade 1 hypertension, whenever they are coming in the contact of any healthcare provider at their first office visit, they should be asked for the home blood pressure monitoring or ambulatory blood pressure monitoring after rechecking their office blood pressure 1 to 2 weeks. And once they are found to be having hypertensive on an average hypertension of those home blood pressure reading and ambulatory blood pressure reading in the category of grade 1 or grade 2 or borderline hypertension, or we can say that just high normal blood pressure, then they should be treated in a different way, and what should be the method that we shall be covering in the next few slides. So grade 1 or grade 2 hypertension should be referred to a qualified physician or should be started with a pharmacological or non-pharmacological intervention based on individual risk factor. The people, those who will be found with the systolic blood pressure more than 180 and diastolic blood pressure more than 110 should be immediately referred to a qualified physician without any delay. Section 4 says the method of blood pressure measurement and monitoring of blood pressure. Every time the blood pressure measurement should be done at least in the 3 important steps. One is wait for 5 minutes after patient's entry. It should not be measured immediately. Second, it should be measured preferably in the both arms. As of now, the recommendation of the International Society of Hypertension, many other Society of Hypertension were there for the left arm preferably, but we are coming up here with the recommendation of measuring the blood pressure in both arms. Take at least 3 readings, averaging last 2. Office blood pressure measurement should be done in the basics for the clinical diagnosis, like 3 measurements spreaded by the 1 to 2 minutes after rest of the 5 minutes. And this can be conclusive only for grade 2 and beyond. What does it mean? If anybody comes to your clinic and you found the blood pressure is 160 and 100, you check it 1 or 2 times more. If it is continues to stay in this range, there is no need to further checkup. You can start the pharmacological therapy with lifestyle modification. Later on, you can titrate back or you can reduce the medication if the patient gets good control, and you can withdraw medication also if lifestyle modification are found to be working enough. If your patient is found to be in the borderline range, means between 140/90 to 160/100, if it is in between of that, then lifestyle modification should be started immediately, but pharmacological intervention should only be thought about after asking the patient to come up with the 7 days data of the home blood pressure monitoring or ambulatory blood pressure monitoring. And if it is more than 160/100, then we can really think about starting the therapy. So section 4, which I was talking about, says that office blood pressure is required for making a diagnosis of hypertension with at least 2 separate office blood pressure measurements 3 to 4 weeks apart. Diagnosis of hypertension should be based on a office BP of more than 140/90, but this 140/90 cannot be a single reading. Office BP measurement should be performed in standardized conditions with an average of the 2 of the triplicate readings. Screening should be done using an automated electronic blood pressure instrument following a standardized blood pressure measurement procedure. BP should be measured at least 5 minutes after the patient enters in your office, and it should be measured in both arms. Section 5 says the diagnosis of the hypertension, investigation and additional examination. We should go for the medical history, what is the required all the time. Physical examination should be done. Endocrinological examination should be done. Routine clinical chemistry should be checked. One is the essential, another group is the additional. ECG and kidney ultrasound. Once we talk about the physical examination, the question arises what should be done in the physical examination. Obviously, the anthropometric, cardiovascular, respiratory, abdominal, neurological and fundus examination are the most important one. Section 5 says that targeted screening at the community level is suggested for high-risk groups like elderly more than 60 years of the age, those who are obese, those who are smoker, those with diabetes, and existing cardiovascular disease or their family is there. History and physical examination for risk factors like smoking, obesity, diet, different kind of the diet pattern, maybe the high salt diet, exercise pattern, family history of the premature cardiovascular disease, angina, heart failure, and family history of the stroke should be taken into the consideration. Presence of proteinuria doubles the risk of the morbidity and mortality for a certain blood pressure and is an independent predictor of all-cause mortality in hypertension. Section 6 is for the screening of the cardiovascular risk factors, for which we shall be recommending to go with the ECG, echocardiography for increased LV mass, even at the first timer who is coming with the hypertension, carotid ultrasound, peripheral arterial disease to be checked after ankle brachial index, and reduced kidney function and glomerular endothelial dysfunction, arterial stiffness, and brain imaging could be the suggested through further investigation. The diagnostic workup for hypertensive individuals should include an assessment of additional risk factors, especially if there is a family history of CVD. A reasonable estimation of the cardiovascular risk can be established. Emphasizing the blood pressure control, lifestyle adjustment is the most important thing. Elevated serum uric acid should be addressed with diet, urate-inducing medications, may it be the losartan, fibrates, or atorvastatin, or urate-lowering medications in symptomatic patients, those who are having the hyperuricemia, gout, with serum uric acid level more than 6 milligram per deciliter. Hypertension and coronary artery disease is also well related, so BP to be lowered more if it is more than 140/90 and treated to target less than 130/80. In elderly patient, we can keep the target 140/80. Hypertension and previous stroke, BP should be lowered if more than 140/90 and should be treated to the target less than 130/80. Similarly, the same targets may be the heart failure, where the BP to be lowered if it is more than 140/90 and treated to target less than 130/80, but more than 120/70, this is again important to be kept in mind. If we are dealing with a patient of the chronic kidney disease, BP should be lowered if it is more than 140/90 and treated to target less than 130/80. In elderly patient, we can again having a liberty for the systolic 140, hypertension and chronic obstructive pulmonary disease, it should be lowered if more than 140/90 to 130/80, and 140 could be the systolic blood pressure in elderly patient. In the patient, those who are having the hypertension mediated organ damage, like how to explore these hypertension mediated organ damage, what the hypertension mediated organ damage could be there and how can we know about them. Obviously, heart, brain, kidney, eyes and blood vessels, these are the organs which are on the risk and they should be investigated and checked if any hypertension mediated damage is occurred or not, if we are getting any patient with the hypertension. So what could be the recommendation here? Basic screening for HMOD is recommended for all hypertensive patients. Through assessment is essential for treatment decision, despite limitation in the technological provision and cost in some countries. Routine assessment may be with the serum creatinine level, eGFR, ECG, albumin creatinine ratio, routine clinical examination, as I already discussed in the previous slide, screening for the blood pressure influencing substances, lifestyle modification, enhancing hypertension management, and serial HMOD monitoring, which has been discussed on the previous slide. Let's talk about the exacerbator and inducers of the hypertension. In Indian perspective, the sodium intake is one of the important exacerbator of the hypertension. Long-term high sodium intake increases the risk of hypertension. 1 teaspoon of table salt provides 2.3 grams, while that of the rock salt provides 1.9 gram of the sodium. Alcohol and other substances are also supposed to be the inducer of hypertension. Smoking, NSAID, corticosteroid, anti-cancer therapy, calcineurin inhibitors like cyclosporin, menopausal hormone therapy and oral contraceptive pill, other drugs like antidepressants, sympathomimetic drugs, ritodrine for premature labor, bronchodilators of the beta-2 agonist class, and anti-CGRP antibodies, receptor agonist, and liquorized carbenoxolone. So these are the medications which have been identified which can be inducer of hypertension. So this is the section 9 which has been dedicated to the treatment of hypertension. We can look over the management at a glance. If a person visits to your clinic for any reason, age is more than 5 years, because we are also considering the pediatric hypertension and hypertension in the adolescent. So that's why if any patient coming to your clinic more than 5 years, having some risk factors, then you need to screen for hypertension. If there is no risk factors, then you can avoid screening of the hypertension. If a person is found to be having some risk factors, then office blood pressure measurement should be done, and if it is found out of range on multiple readings. What is the meaning of out of range? If it is 140 or 90 or more than that, then on multiple readings, then we should start and think about the treatment, labeling him the grade 1 hypertension. Now question arises, if it is less than 140 and less than 90, what to do? Till the 130 and 139 and 85 to 89 is considered as a high normal blood pressure. These patients, those who will be found in the high normal blood pressure, must be advised for the lifestyle modification therapy after office blood pressure measurement to be confirmed for 7 days by either home blood pressure monitoring or ambulatory blood pressure monitoring. There may be a category in high normal blood pressure who may be having the white coat hypertension or mass hypertension. White coat hypertension, you all know, is that once the blood pressure is found only raised when a person is in the clinic. And mass hypertension is that in clinic blood pressure remains normal, but otherwise it remains high. So both the hypertension have been found to be the equivalent in causing adverse consequences and complications as the essential hypertension. If patient is found to be with the grade 2 hypertension, then pharmacotherapy with dual drugs should be started unless indicated otherwise. Indicated otherwise means patient may not be tolerant, patient may be very sick, patient may be very frail. Then in that condition, we can start the medication with the one drug, and later on we can supplement the another drug if it is required. If the patient is having any suspicion of the end organ damage, then it's to be additional test. What has been recommended should be exposed to them, and hypertension mediated organ damage should be explored in those patients. Lifestyle intervention should be advised to all levels of the blood pressure, may it be high normal or it is associated with the end organ damage. Lifestyle intervention are considered, what you can see here, which is written. I am not going to read them. You all know about them. But once the pharmacotherapy steps are concerned, consider a monotherapy in low risk grade 1 hypertension, severely sick, frail, and the elderly patient. Simplified regimen with once daily dosing and single pill combination should be preferred. Dual drug therapy in a single pill, fixed dose combination should be preferred. Use combination therapy according to individualized patient risk factors. So that's to be considered as per your clinical acumen. You need to decide which patient requires combination therapy, which patient requires monotherapy, and added up to the another medication later on. In grade 1 hypertension, we recommend to start with the lifestyle intervention, and RAS blocker should be the first choice, followed by, if it is not working, to add up with the calcium channel blocker. If a patient is intolerant to the RAS blocker, we can start the therapy with the calcium channel blocker or thiazide. Always remember, the most important thing is control of the blood pressure, not the therapy of the blood pressure. If the blood pressure is controlled with any of the therapy, this is reducing the risk largely instead of If it is being controlled by the RAS inhibitor, then only it will be reducing the risk, and if it only be the CCB, then it will reduce the risk. Or it will be done by the diuretic, then it will be reducing the risk. It has also been found in the evidences that after the 115 and 80 and 75 of the blood pressure, people starts having the end organ risk in Indian population. So that's why that should also be considered. Lower the better, therapy should be there. But there are certain conditions where we should not prefer to go less than 120/70 or less than 110/70. Grade 2 hypertension, we can start with the dual therapy, and grade 3 hypertension, the combination therapy is the rule to start with. And if there is an HMOD, means hypertension mediator organ damage, you need to choose the therapy as per the whatever the organ damage is there. Combination should be chosen as per the patient's risk factor. Dual therapy or triple therapy, it would be decided depending upon the risk factors involved there. Further combinations as per the protocol for resistant hypertension management can be chosen. So this is already I have discussed here. Combination therapy has also been I have discussed in that slide. Now the section 10 says the comorbidities and complications of the hypertension and their management. Cardiovascular disorders, coronary artery disease, heart failure, atrial fibrillation, valvular heart disease. These are the 4 cardiovascular disorders has been identified as a comorbidities and complications of the hypertension whenever we try to manage it, and many times if we don't manage the hypertension, then these consequences can occur, including the cerebrovascular disorder in the form of the stroke, kidney disorder, diabetes, obesity, cancer, and there are certain other comorbidities which has also been identified and required their management while treating the hypertension, like psoriatic arthritis, glaucoma in hypertension, and hypertension oncology. So there are certain recommendations in the stroke management. A blood pressure 140/90 is advised in individuals with hemorrhagic stroke and within 6 hours of the onset of symptoms to prevent hemorrhage expansion. And systolic blood pressure of more than 220 mm of mercury may be carefully decreased with intravenous treatment to 180 mm of mercury in patient with hemorrhagic stroke and in more than 6 hours after the beginning of symptoms. Slow and moderate blood pressure reductions are superior to aggressive blood pressure reductions to 140/90 if systolic blood pressure is 220 or less than that. Patients with acute ischemic stroke who are eligible for mechanical thrombectomy or intravenous thrombolysis should have their blood pressure carefully decreased and kept at or below 180/105 mm of mercury for the first 24 hours following the intervention. Clinical judgment should be used when considering pharmacological therapy to lower blood pressure by 15% during the first 24 hours following surgery in patients who are not candidates for IVT or MT and have a BP of more than 220 or 120 mm of mercury. In acute ischemic stroke patient, it is not advised to reduce BP with antihypertensive medication regularly if BP is less than 185 and 105 diastolic during the first 3 days. Patients who have elevated BP and are otherwise eligible for treatment with IV alteplase should have their blood pressure carefully lowered so that their systolic blood pressure is less than 185 and their diastolic BP is less than 110 before IV fibrinolytic therapy is initiated. Alteplase is the most preferred one. In patients for whom mechanical thrombectomy is planned and who have not received IV fibrinolytic therapy, it is reasonable to maintain blood pressure less than 185 and 110 before the procedure. The special circumstances. There are the recommendations related to the resistant hypertension. Blood pressure remains more than 140/90 despite taking 3 medications with distinct mechanism, including diuretic, should be considered as a resistant hypertension. Increased cardiovascular risk and overall mortality is the impact of the resistant hypertension, and usually it is seen in Indian population 10%. Secondary hypertension is prevalence in India around 4 to 5%. Diagnosis is based on clinical and biochemical features. screening for secondary causes important in specific cases, like if it is occurring early onset, young hypertensive, adolescent hypertension, and pediatric cases of the hypertension. Hypertension crisis is 0.5 to 2% in India. Common causes are non-compliance of the treatment. Secondary causes of secondary hypertension may be the reason. Antihypertensive drugs withdrawal is very common reason most of the time. Diagnostic workup includes various tests and imaging. Hypertension in asthma and COPD, it occurs with hypertension, affects the lung function. Key factors may be the systemic steroid, beta agonist, and stress. Lifestyle adjustment crucial for management. Hypertension in elderly, hypertension in acute stroke, hypertension in diabetes, especially in the setting of the cardiac autonomic neuropathy and orthostatic hypotension, is important to consider. Hypertension and human immunodeficiency virus means HIV disease, hypertension with coronavirus 19, hypertension, collagen vascular disease, sickle cell anemia, psychiatric disorder. These all special circumstances has been covered in our guidelines, in which we have discussed the management of hypertension in all these circumstances. Hypertension in women, the recommendations has been issued in the form that screening the premenopausal woman for secondary hypertension to identify underlying causes. Monitor oral contraceptives in women, those who are using them and found with high blood pressure. Manage pregnancy hypertension. Initiate or intensify drug therapy if systolic blood pressure exceeds 140 or diastolic blood pressure exceeds 90 during pregnancy. Blood pressure goals should be 140 and 90 in cases of the pre-existing hypertension during pregnancy. Always remember, during pregnancy, much lowering of the blood pressure is not really recommended. Caution in lowering blood pressure. Avoid aggressive diastolic blood pressure lowering. Do not lower it below 80 mm during pregnancy. Safe medications. Avoid ACE inhibitors, ARBs, and direct renin inhibitors during pregnancy. Opt for safe alternative. Aspirin for preeclampsia. Administer 100 to 150 mg of the aspirin between weeks 11 and 35 of gestation for preeclampsia prevention in high or moderate risk pregnancy. Endocrine hypertension. Consider screening for the endocrine hypertension in new onset or uncontrolled hypertension, especially in young hypertensive, resistant hypertensive, or drug-induced hypertension. Abrupt onset of the hypertension in family history of the early onset is there. Onset of the hypertension in coming up less than 30 years of the age, and suddenly we see that exacerbation of the previously controlled hypertension. Disproportionate target organ damage for the degree of hypertension also becomes one reason for exploring endocrine hypertension. Accelerated or malignant hypertension, onset of diastolic hypertension in older adults more than 65 years of the age, unprovoked or excessive hypokalemia. So these are the detailed recommendations of the endocrine hypertension, in which they say that initial screening for the endocrine hypertension should encompass a comprehensive evaluation of the patient medical history. A thorough physical examination focusing on clinical indicator and basic blood pressure blood biochemistry. Subsequent investigation should be aimed at diagnosing endocrine hypertension, including additional biochemistry, imaging studies, and other relevant tests. And all adults with persistent hypertension exhibit indications of a particular type of endocrine-related hypertension. During screening, could be prudent to consider referring them to a specialist physician well versed in managing that specific for hypertension. Obesity and hypertension. BMI could be one guide. For normal BMI 18 to 22.9, overweight 23 to 24.9, and obesity more than 25. WHO says in Asian population this cutoff should be different. Underweight should be considered less than 18.5. Normal between 18.5 to 22.9, and overweight 23 to 24.9, pre-obese 25 to 29.9, and obese more than 30 should be considered. Waist circumference, waist hip ratio, body fat percentage, these all could be the parameter of the measurement of the obesity, and patient education, lifestyle, and dietary modification should be started even when the patient is in normal blood pressure or in high normal blood pressure. Pharmacotherapy for the weight loss is an indication if the patient is having hypertension with obesity. Many a times weight loss also becomes a therapy for the hypertension management. If a patient loses the weight, his blood pressure gets under control. Recommendations may be, it is advisable to prioritize the weight reduction as a means to lower blood pressure and enhance cardiovascular results. Technology recommendation. Using digital devices for the blood pressure measurements is encouraged. We recommend regular usage of the electronic health records as they facilitate quick retrieval of patient records and augment the efficacy of existing treatment. And Government of India is also very soon coming up with a mandatory electronic health record with all of us. Better we can start before that. Artificial intelligence and technology innovations will continue to develop at rapid pace. We will bring out regular updates with recommendations of that. Pediatric and adolescent hypertension has also been discussed in detail. I'm not going into the detail. You can go through this because I want that some discussion should also be held here. So I am not taking up into the details these recommendations. But blood pressure levels should be evaluated in children from 3 years old, and hypertension diagnosis should be confirmed through multiple measurements using a manual auscultatory device. Next, for INCH, Indian Society of Hypertension, INCH is used as an abbreviation for the Indian Society of Hypertension. It takes the lead in supporting India-centric evidence generation, and this is the edition 1. We must all strive to update the guidelines with new evidence every year. And I really request all of you to continue doing the studies, continue collection the data wherever Indian data is lacking, so that in coming years we could be more richer in those data and our guidelines could be more supported by the data. Thank you very much.
Thank you, Dr. Anuj, for concluding the guidelines, because the mammoth guidelines cannot be concluded in 20-30 minutes, but we have done a marvelous job. Please join. And so to start the discussion, first of all, if you have any question from audience, they will be preferred, because you will be using these guidelines, and these guidelines will be refined by your experience and your evidences. Yes, Dr. Supratik Bhattacharya. Please give him mic, organizers.
So first of all, congratulations to the entire team for such an excellent and comprehensive guideline that we have for the first time. I just wanted to understand some practical difficulties that we face on a day-to-day basis regarding the cuff size. So do you have any recommendations regarding the cuff size, A? And second is regarding the ambulatory blood pressure monitoring, when and for who?
Should I answer? Yeah. We have in our guideline detail about the cuff size. 4 cuff size have been divided and they have been given. And also there is some guidelines for the ABPM use and home monitoring and office. Everything has been covered in detail guideline, you can see there.
A very practical question. We have seen many times that patient BP remains 130/80. Whenever he is excited, BP goes up. Whenever in the hospital, BP goes up, he's in the office goes up. But at home, we do ambulatory, it is always normal. How to treat that patient? Because he's working at least 16 hours a day, 8 to 10, 12 hours a day. BP remains high. He's sleeping, BP is normal.
Dr. Narsingan, you can answer.
Yeah.
Oh, that shows that the patient has got an increased sympathetic drive. As Indians, I think we have an increased pulse rate in the evening. Increased blood pressure rise had been appreciated by one study called India Heart Study, which was conducted in our country. It has shown an increase in the systolic blood pressure in the evening time, particularly for Indian population. Taking that into consideration, probably an increased sympathetic drive plays an important role, where the office blood pressure is on the higher side, home blood pressure is normal, ambulatory blood pressure is normal, there is no HMOD. I think we can probably review the patient every 3 months or 6 months according to.
This fits in with what is called as weight coat hypertension. When you see in the clinic, the blood pressure is more. At home, it is. So this is like weight coat hypertension. It's better to do home blood pressure monitoring for you can observe really whether at the home the blood pressure is normal. And as Narsingan said, look for HMOD, and if he can afford, do on 24 hours ambulatory blood pressure monitoring, so that full day, you can know what is his blood pressure variability and things like that.
In ambulatory monitoring, if there is no night dip in the pulse rate and blood pressure, suppose patient see whatever time he sleeps is there, but in the midnight sometime there is no dip, that means this patient definitely needs treatment. If there is no night dip in the pulse rate and blood pressure, then of course we can give beta blockers or whatever. But this is one very important thing.
If someone is having stage 2 hypertension, but there is no evidence of hypertension mediated organ damage, are you going to straight start the drug, or should we still wait for another visit or confirmation by measurement of home blood pressure measuring? Per your guideline, what I learned is it is not written there. And my personal opinion is we come across many patients and we hastily examine the patients, and many times stage 2 hypertension also we detect. And we should not start unless we confirm it by another measurement in another visit, unless there is evidence of hypertension mediated organ damage. This is my personal opinion, number one. And so far as the treatment of stage 1 hypertension is concerned, it is not only the absolute amount of blood pressure is important, but also the accumulated risk. What amount of risk he has? Well, supposing somebody has coronary artery disease already, is also having heart failure. Even if he is a patient of class 1 hypertension, I think we should start at the same time lifestyle measure along with drug, without giving him an opportunity to wait for more time. This is what is your take on it, sir?
In most of the guidelines, sir, it is already recommended by the International Society of Hypertension and also European Society of Hypertension that if the blood pressure is in range of stage 2, need not to confirm it by home monitoring, you have to start treatment straight away. But if the blood pressure is in range of stage 1, then please go for the home monitoring and confirm it whether patient is having hypertension or it was just episodic hypertension. So we have stick to that because we don't have much Indian data regarding this, that stage 2 hypertension. Target organ damage is very true what you are saying, but most of the time it is difficult to find out target organ damage without investigating, and without only clinical examination will not show sometime target organ damage. And blood pressure, if it is in range of stage 2, I think it is better to start treatment. Home monitoring. But does that hold for all conditions? As it is also for as Tara was saying, that in high risk group this is not required, but it is only for general population. Everybody should not be subjected to that. That is why it is written there, because the guidelines are for physicians.
Stage 1 and 2 certainly requires intervention, and the previous session I had one paper I presented over there. There are evidences, international publication. The Indian publication we do not have, but there are international publications which have insisted that transition from stage 1 to stage 2, you must screen the target organ meticulously. And if the person has microalbuminuria, it always correlates with the deterioration over the years. So that's important issue to screening. Target organ damage is important to screen. And associated factors, if patient have a risk like obesity, like diabetes, then intervention should always be there. It would reduce onward deterioration of the renal function. What happens in kidney, and that's what kidney is an important issue. If the patient has initial stage 1 and is diabetic, then he has a hyperfiltration. So serum creatinine is not an indicator, good indicator. maybe either increased, maybe normal. But microalbuminuria is important because it's happening at the tubular level, and that would give the health of the endothelium as well as the tubular health. So there you need to do intervention.
Any other question from the house? Because this is more important. Our guidelines in your hands, and this is edition 1. We will follow more editions. Dr. Virmani, please, sir. Previously it was there, but most of the international guidelines have removed that. The traditional teaching was that in our time when we were in MBBS, it was taught that age, 100 plus age. That thing is now not seen in most of the international guidelines, and we do not have evidence for that.
Whatever your age is, if systolic blood pressure becomes more than 149, 150 onward, it should be referred.
Treated.
Because it has direct correlation with the mortality. So that it is issue. But this guidelines gives you enormous opportunity to look at your own data. And if you look all the stages of the recommendation, there are ample chances to work on it. And we must collect our data. That's what the Professor Maheshwari was telling. Each of us must add on something because there are many dark areas and absolutely there are no publication. We do not have Indian publication on resistant hypertension. We do not have publication on accelerated hypertension and its complication. We have very scarce data on the pregnancy-induced hypertension. We have only hardly 1 or 2 drugs at our disposal. So these are the dark area where each of us should contribute, and we would recommend to have a registry into with the society, whether International Hypertension does or ACP does, and each of us should, through electronic device, we have probably our International Society has a data to pull. We should feed it. This has been our observation, and even simple observation may not be very supported by electronic gazette, but simple observation will be helping a lot in collecting the data. So probably one of the issue was we do have some here, either chances for modification with the next society when we meet or next meeting. We would request all of you to bring your suggestion, improvement, recommendation, and support it by evidence. If we have any publication from this country, it would always be wise to include that. But if we have publication from neighboring countries, Southeast Asian countries, or Indian, those who are living in the Southeast Asian countries or even abroad, they would be of immense help to all of us.
As sir is saying, we are open for your comments, and with evidence, whatever you suggest, definitely in second edition that will be included. This gives the idea that you start some research in that. Yeah.
Sir, thank you. It was such a nice talk that we are going through. I just wanted to know your precious comments on what is the difference between these guidelines and the International Society guidelines as well as the European guidelines as per the in view of Indian population.
If you go and see both guidelines, you will find a lot of difference. We have used the skeleton of International Society of Hypertension and European Society of Hypertension. The skeleton looks same, but the contents are different. Whenever we have been able to search and find out the Indian evidence, we have incorporated it. But if the evidence is not there, then we have to follow the international guidelines. That is the case. That is why we are stressing again and again, this is edition 1, and we are waiting for your follow-up and your research, your guidance, and then we have the second edition that may have more Indian data. But skeleton is same. Everything is not same. It is not copied version. It is not copied version.
Exactly. Can I?
Yeah.
Yes, can I think he asked one pertinent question, how it is differing from that of the other guidelines published internationally.
Yes.
I think many of you in the audience would have read the JNC 7th guidelines. We still quote it for some purposes. You can remember that they introduced the terminology called pre-hypertension. 120 to 139 systolic, 80 to 89 diastolic was considered as a pre-hypertension. This terminology was completely removed by ACC-AHA, which had been given an authorization by the NCEP guideline developers that you should come out not by JNC 7 or 8. 8 is no more available now. So you come out with the good guidelines. These people, they divided 120 to 139, 80 to 89 as a pre-hypertension into two categories. One is elevated blood pressure, the other one is a stage 1 hypertension. Stage 1 hypertension, that is 140/90. So we are not actually accepting the same classification or categorization. That's number one. European Society of Hypertension still holds good the same old statement which was published in 2018. It is also now applicable even 2023. What they did now, they have divided into 3 stages. One stage, there is no cardiovascular disease, there is no CKD, there is no diabetes, blood pressure is elevated. So that is stage 1. Number 2, there is evidence of cardiovascular disease, plus there is evidence for CKD up to stage 3. Then there is also a problem of diabetes stage, that is called categorization of stage 2. Stage 3, 4 and 5 CKD plus established coronary artery disease. These are the stages which they have introduced recently in 2023 guidelines. That's about the classification. But still they hold optimal, normal, high normal, stage 1, stage 2, stage 3. That is European Society. Even I cannot remember, and nobody can remember these figures. Very, very difficult. So we wanted to simplify it with the consensus statement which we got it from various experts, 57 experts or so. All of them had put their heads together what to give as guidelines from Indian Society of Hypertension. There's a consensus guideline. Please remember that. Not based on huge body of evidence. We have some evidence, picked it up, then compared it with the evidence available throughout the globe and the recommendations given by various organizations. Then we came out with this sort of recommendation. In fact, if you look at the definition, almost looks like that of International Society of Hypertension Guidelines 2020, where we have set 130/85. That is optimal. After that only we are classifying. That's the classification. That's the difference between these two. And in addition, I think one more classification what had been introduced by European Society is that if you have eGFR less than 30 and more than 30. If you have more than 30, ACI or ERB plus CCP or diuretic, first step, combination pill. The second one, the 2 drugs. Third, 3 drugs. Patient is not improving, but eGFR is more than 30. You can always use spironolactone. If the patient has got a eGFR less than 30, you can use chlorthalidone, thiazide diuretic, or thiazide-like diuretic over and above loop diuretic in those patients. That's an extra recommendation given by ESC, ESS guidelines. Did I make it clear for you? Thank you.
Yeah, please.
Which device is best for measuring BP? Mercury, non-mercury, or digital?
In our guideline, we have some words regarding that. The auscultatory method versus the automated method, we have commented on that. And even if you want to use auscultatory method, LED one is better, not the mercury, because mercury legally are not allowed. So we cannot say use mercury. Mercury may be gold standard, but at present, legally not allowed. So if you are interested to do it auscultatory, go for LED one. That one has been written.
Digital is not accurate. Defense.
Pardon?
Digital measurement is not accurate. Digital. Electronic, yeah.
Digital.
Yeah. Not accurate.
Automated.
Automatic
same.
is accurate or not accurate?
Manual versus automated.
So manual is good or automatic is good? Which one is good?
Validation is a must for all.
Validation is must.
Is a must.
Validated equipment is must. First thing is validated equipment, whether you are using automated or manual.
Kindly log in stride.bp. Stride.bp. If you can log into that particular internet, you will get all sorts of information, how to maintain the blood pressure apparatus, what are required for semi-automated, what are required for automated blood pressure measurement, how often you should do it.
Thank you, sir.
Sir, any comment on cough-free blood pressure measurement?
Yeah,
No.
it has some comment that is still, it is not validated. So, time may come. It is under investigatory phase. So we cannot say it is good for diagnosis. No.
I think we can just change the brain imaging
Proceeded.
Actually, these are the investigations. Guidelines is not only for the limited resource. Guidelines are the overall guide. But investigation should be done, but not necessarily if you find that at the ECG level your problem is resolved, don't do anything. Many times it is also seen. Now, young hypertension, name hypertension, those who are coming to our clinics at 140/90 blood pressure, they are also having the diastolic failure, left ventricular hypertrophy, and left ventricular failure. Many times it is not giving any symptom to them, and they are not having any complaint. People are running with a 180, 160, 100 blood pressure with diastolic failure, but not having any symptom, not complaining of any. This can only be diagnosed if you keep the echo as a first investigation. If a person is coming for the hypertension with the first diagnosis of the hypertension, that is the take in.
It depends on the availability of resources, because in Japan, what they are doing, even in the first time high BP, they subject it for the MRI and they are detecting lacunar infarcts. So it depends. Before we move further, sir, your comment.
Excuse me, sir.
Two panelists have not commented. Their comments are required.
I am going outside my subject. Pregnancy and hypertension are 3 recommendations. Number 1 says, use as a first line. There is a spelling mistake, find. Use as first, find, I don't know, it's a first line. Second, I will say, don't use in first trimester. I cannot be used in second and third trimester. Recommendations, no, don't use it in pregnancy. They are all contradicting, I think. It's an absolute contradiction in pregnancy. These 2 recommendations has to be removed from the guidelines, I believe.
Can you clarify it? Actually,
First line, everybody will start using in pregnancy. And second, I will say, don't use in second and third trimester. Number 1, first. Pregnancy and bilateral relatory services, they are absolute contraindications. First one.
Dr. Verma, can you read out?
Sir is asking about hypertension in pregnancy.
Yes.
And in classification, ACE inhibitors and ARB use as first line. It is written.
Sure. We agree.
And then caution, be mindful of possibility of first dose of hypotension.
Exactly. We Dr. Raut, we have taken that into account. Myself, Dr. Narasimhan and Dr. Muruganathan, we are going to modify some of the areas, and that's accepted. Yes.
It is an appeal to Dr. Anuj as well as Nursing Verma and the entire team who are actually getting involved in this sort of consensus guidelines. I would request all of you can post this information on our website. There is an Indian Society of Hypertension website where you can always post your comments on particular paragraph or whatever you would like to give a comment or criticism. Even criticism, we invite criticism. Not that we are actually adamant in giving all sorts of information. You need to criticize. Let us invite criticism from all of you and then try to refine as much as possible. Sure. Do you agree, Dr. Anuj?
Yes, sir.
Yes. What do you say, sir?
Yes, correct.
Then in resistant hypertension, another new category has come out, refractory hypertension, where 4 drugs are used, blood pressure is not controlled. One of them is MRI receptor antagonist. That we can add, I think. Refractory hypertension after resistant hypertension.
You
you can, it's very close to it.
Yeah, so he's asking there is another subset like refractory hypertension where you can use 4 drugs, one is the MRA, but still it is not controlled with resistant hypertension.
The MRA is the fourth drug which should be used for patients with resistant hypertension and in patients with the diabetes, with the CKD. Instead of using the so-called spironolactone or eplerenone, probably you can use finerenone because we have an evidence now to show benefit in cardiovascular outcome as well as a CKD outcome. I think that will be the better choice in those group of people.
Though nursing says finerenone, but it does not come out in the guidelines, in any guidelines. But finerenone is better because it's a non-steroidal mineralocorticoid antagonist. And even if the potassium is more than 4.5, between 4.5 to 5, spironolactone cannot be used, whereas finerenone can be tried. And even in the late stage kidney disease also, the EGFR is less than 30, we can try, but not less than 20. So finerenone is coming in the market, and finerenone and SGLT combination also comes in the market for resistant hypertension. But it is only off-label now, but it's not come in the, even the company doesn't promote this.
Our scientific chairman has reminded me that time has up. So the last comment by sir. Our
Excuse me, sir.
panelists have not commented.
Yes, I have a comment on table 2. There is a row 2, echocardiography increase LV mass. And in the second column, I think there are printing mistakes because the message is not very clear. The echocardiography criteria are not very clearly written. This should be revised.
We are taking note of it.
Yeah.
Echocardiography criteria are not very clearly written.
Yes, yes.
We will go through it. Try to.
Radiographic criteria. Is it the end diastolic volume? Is it the ejection fraction? Is it so? All here next time it would be elaborated. I think it's in the text it has been elaborated, but could do it also here.
It will be corrected if possible. So I think we were allotted 1 hour and 1 hour has passed. So it is a very enormous task, will not be completed in 1 hour. So please go through it. Keep on putting your comments to us. We will definitely consider them. Thank you. Thank you very much. All panelists, all chairpersons, everybody, all the physicians, they definitely contribute for that. Thank you. Thank you very much. Yeah. Scientific chairman will announce.
I think the experts here on that side and this side of the table, and also on that side who are involved in these guidelines, they deserve a standing ovation for the first ever guidelines from the Indian Society of Hypertension. Thank you. Now we'll proceed for the next session, which is a very prestigious session. It's a master's talk by none other than Dr. V. Mohan. Can I invite the chairpersons, Dr. Surinder Swai, Dr. Monogenic Behra, and Dr. R.K. Nayak. Dr. Surinder Swai, Dr. Monogenic Behra, and Dr. R.K. Nayak to kindly chair the session. Sir.
Very good evening to all of you. This is my proud privilege to share the session, share the stage with the masters of the masters, the legend, and mentors of many of us sitting here, Dr. V. Mohan sir. So this is the time to call upon sir for his words of wisdom, his deliberation. I would request chairpersons to please, sir, call upon the sir for his deliberation.
Thank you. Today is an auspicious day to invite Professor B. Mohan, the Dawn of diabetic field, and he's a master of masters. Now he will tell about the monogenic diabetes, what's new. And monogenic diabetes, you know, it is 2.5% of diabetic population, and the examples are monogenic. These Modi varieties, and neonatal diabetes, and so on. And Professor Mohan will deliberate this marvelous lecture now.
We have a,
Thanks, Professor Mohan.
We have a simple process of felicitation. I request our governor, Dr. Maheshwari, and our scientific chair, Dr. Birmani, to felicitate Dr. Mohan before the master talk. Actually, we are honored. The 8th ACP India is honored by presence of Professor B. Mohan, who is at present the best researcher of the world. If you see his publication, his achievement, he is followed not only in India, all across the globe for his work. So, congratulations. Give a big hand to Professor Mohan.
First, Dr. Mohan has been the first MACP of our country practically. Technically, it was the second one, but practically he was the first, because first one who was there, he was joint nationality of the Indian and Pakistan. So, from the J&K part, which is occupied by the Pakistan.
Good afternoon, ladies and gentlemen. Thank you, chairpersons, for the kind words, and big thank you to Professor Anuj Maheshwari, Professor Jayant Panda, Professor Anil Virmani, and the organizing committee for a brilliant ACP India 2023 meeting. From the attendance here in the full hall, one can judge the popularity of this meeting. The scientific standard is very high. We just heard the Indian guidelines for hypertension being released, and it's hats off to you for putting together such great work. Wish you continued success in the years to come, because India should become the leader of the world in medicine. And we are already there, and I think we just need to take it a couple of notches higher by producing Indian data and very good RCTs, which can easily be done with the kind of talent that we have in this room. On that note, let me move on to my topic, monogenic diabetes, what is new? I've been talking about monogenic diabetes for quite some time, but in the last 6 months or year, we have some new data to share with you, and I thought I can talk about this topic because it's something which people don't know much about, and it needs some amount of sophisticated research work to go into that, to go into the depths of it, and we have been one of the privileged centers recognized by ICMR. And that's my disclosure slide, that none of these, I have no conflict of interest. Almost all the funding here is by the Indian Council of Medical Research. We are an ICMR Advanced Center. Now, before I go any further, I think I must acknowledge this young group of scientists at our center. The picture there is actually in our research center, and if any of you have not visited our research center in Siruseri, I would invite you to visit our research center. It's a 40,000 square feet facility in the outskirts of Chennai, only for diabetes research. There's no patient care at all there. And it's very, very high level of research. And this one department alone, headed by Dr. Radha Venkateshan, whom you can see in the center there, wearing the sari, she and a team alone have produced 150 publications just on genomics of diabetes. And 16 PhDs have already completed on this topic alone. They've already got PhD, and another 4 or 5 are now working on it. So we'll have about 20 PhDs produced from that one department. So that's the kind of work that they do, which I'm going to present here. So starting with what is monogenic diabetes? The name is quite clear, isn't it? It's monogenic. So there's only one gene which causes this disease. So what is the difference between this and type 1 and type 2 diabetes? In type 1 and type 2 diabetes, there are more than 450 genes which have been associated with type 2 diabetes. And none of them are causal. They're only an association. With type 1 diabetes, again, there are at least about 40, 50 genes which have been associated. But again, they're not causal. They're just associated. If you have this, you're more likely to have. In this case, there's only one gene, and that gene is causing the disease. So you're actually saying, it's like, if you get COVID, test positive, it is COVID. It's not an association with COVID. It's COVID because you're proving it. So like that, you're proving it here. That's the beauty of monogenic forms of diabetes. I'm not saying that it's the commonest form of diabetes, but just because something is not common, you can't brush it under the carpet and say, we are not interested in it. And I'll show you why. Well, let's start with, I'm not going to talk about all the monogenic forms of diabetes. There are so many of them that we have discovered. Some of them are novel. I'll just give you a highlight from a clinician's perspective of just a few types of monogenic diabetes, which I think you should know about. The first one you should know about is neonatal diabetes. Now, why you should know about this? Because this diabetes is diagnosed typically before 6 months of age. That means a newborn child. Even on the day of birth, the child can have it. More typically by the first month, second month, third month. Very rare after 6 months. We have seen up to 11 months, never after 1 year. So if the child comes, and somebody says, test my child for neonatal diabetes, child got diabetes when it's 2 years old, waste of time, don't do it. You won't find neonatal diabetes. But if it is before 1 year of age, and you don't test for neonatal diabetes, I think you're doing that child a big disfavor. And I'll show you why. Because perhaps a child doesn't even need insulin. And you're going to diagnose type 1 diabetes and tell the parents that the child needs insulin lifelong, 4 times a day, throughout life, and the child doesn't even need insulin. In fact, it'll do much better without insulin, as I'll show you. There are 2 types. One is a transient variety. That doesn't come much to us because it's diagnosed around 4 months, 6 months, and by the 9th month or 8th month, it's gone. So by the time they find out where to go and all, the disease is gone. It doesn't usually affect the child. At that time, they may need little insulin, but then they are through. What comes to us is the permanent neonatal diabetes. A child is diagnosed, told that they have to take insulin throughout, and then for a second opinion, they usually land up there. And that's when we tell them, hey, this may not even be type 1 diabetes. We'll have a look at it. And even within the permanent neonatal diabetes, there are at least 6 or 7 genes which cause it, of which 50% is due to 2 mutations, the KCNJ11 and the ABCC8. And these are the ones which will respond to sulfonylurea. So you may ask another question, why should we do genetic testing? Any child below 6 months, stop insulin and just give sulfonylurea. The child will die if it doesn't have any of these 2 mutations. So without this, you cannot just do it. It's not that, oh, anybody below 6 months, give tablets. No, you can't do that. You can't experiment with children. So it's a simple genetic test. In 2 weeks, you'll get the results, and then that child's future is decided. Nothing like a case report to illustrate this point. This girl, this female child actually came to me about 9 years ago now, 3 months old. 3 months she was diagnosed to have diabetes at Calcutta, started on insulin immediately. She was taking 14 units of insulin. Imagine a 3-month-old baby, this small, taking 14 units of insulin, 4 injections a day. That's a very high dose for that child. And the sugars remain between 300 and 400. They didn't know what to do, so they landed up at our center. Now, the first thing we said was, we have to do genetic study. This is below 6 months of age. It qualifies. Any guideline now, American Diabetes Association guideline, IDF guideline, anyone says any child below 6 months, straight away genetic testing. There's no question about that, okay? So we said we have to send the child for sample for genetic testing. True enough, we found the KCNJ11 mutation. Very easy to diagnose this. Once you have a setup and once you have the bioinformatics in place, it's very easy for us to tell you which type it is. Now, what did we do? We started the child on glibenclamide. Why glibenclamide? Because most of the monogenic diabetes studies have been done on glibenclamide. Glycoside, we are doing a trial now in Modi. Some of you may be involved in it, and we'll tell you whether glycoside also works. It probably works because there's a study from Exeter many years ago in the Lancet where glycoside also worked. Any sulfonylurea actually should work. Now, this is what happened. Now, we slowly increased the dose of the sulfonylurea, shown in green there, and then the dose of the insulin came down. What happened to the glucose levels? Now, look at the glucose levels when the insulin was given in blue, just below that red. All that is when the insulin was given. As the insulin dose came down and the sulfonylurea dose went up, the blood glucoses came down and stayed normal. 9 years later, the child has not had a single dose of insulin till today, not one. So the child is still on sulfonylurea. If the child has not come to us, the child will be still taking 4 times insulin per day, and the sugar control would have been terrible, okay, as you can see. So she was able to completely stop insulin. This, of course, made at that time big news. And the reason we went to the press is because we wanted people to know that there could be many such children. We don't know how many such children. In fact, if I were to take a guess, we are probably only diagnosing 20% of neonatal diabetes in this country. 80% are still undiagnosed. That's the reason why I choose to speak at such meetings to tell you about it. The first report was some 30, 40 cases many years ago in clinical genetics. And the point that we were showing there is that if you look at the right-hand side, this doesn't come up well in the projection. If you look at the HbA1c levels before sulfonylurea was started, it was 14, 16, 10, 11, and so on. After the sulfonylurea started, A1Cs are 7, 5.9, 7, 6, 6, and so on for these children. So clearly insulin not working, and sulfonylurea is working. And the fasting glucose levels also, you can see, much better after the sulfonylurea treatment. This was 2013, 10 years ago. Subsequently, now we have a huge series now. Now this, we have gone a step further. ICMR insists that every child who is referred to us, even if they're not taking treatment with us, we have to get the data. So if some of you have referred patients to us or given the samples, don't worry if we call you back and ask you, what happened to the child, what happened to the child, what, because ICMR is saying, it's your duty, you're an ICMR center, you must get the data on every child and what happened. This is just to show you that even if they have the KCNJ11 mutation, based on the type of mutation that you have, the blood glucose can vary from 250 as shown down to 1100 as shown there. So depending on which type of mutation you have within the KCNJ11, the severity can completely vary. But they all respond to sulfonylureas, as you can see. Even the one with 1100 responds to sulfonylureas. Here's another one, ABCC8. Again, the 4-year follow-up. Again, you can see a huge range in the starting glucose levels. That red dot means when they came to us, and before that they were on insulin, that was the sugar levels. And you can see how it has come down. Now, what if they have the same mutation within the same gene? They respond exactly in the same way. Now, here are 5 different patients who have the same mutation, and they're responding in exactly the same way. So this is, to me, this is precision diabetes at its best. It can't get better than this. You're saying not only which gene, but which mutation And you're saying how they will respond if they have that mutation. I would put it to you that in no other form of diabetes you can do that. You can't do it in type 1. You can't do it in type 2. You can't do it in GDM. You can't do it in any other form of diabetes. This is the only form of diabetes where you can predict exactly what's happening. And when you have a large enough series and put it together, you can say Indian children with this particular thing will respond in that way. And we're actually making a dictionary of this, the whole thing. Let me now move on to the opposite condition. Okay? Neonatal diabetes is really the what do you want to say, the poster child of neonatal diabetes. And that's what we all hope to get. In fact, Professor Raghupati, whom some of you may know, retired professor of pediatrics from CMC, who's now in Bangalore, he says, every time I send you a blood sample, every week he'll send me a blood sample for testing. He'll say, every time I send you a blood sample, I pray and say, I hope he finds a mutation. And then I send it to you. Because many we are not able to find the mutation, which means now we have to take our research to the next level, come back to that. But the opposite condition called congenital hyperinsulinism is a nightmare. Okay? Now this presents with hypoglycemia. The day of birth, you will think, oh, mother was treated with insulin, mother may not even be diabetic. So then the child gets hypo, they give some glucose, and they think it goes away. It doesn't go away. And the child develops fits. 1 week later, 2 weeks later, blood sugars are 20, 15, 18, unmeasurable sometimes, you know, and we just don't know what to do. Now, this is called congenital hyperinsulinemia, CHI. Interestingly enough, it's the same genes which produce this, just like the neonatal diabetes, except that one is a gain of function mutation, the other is a loss of function mutation. So you can get exact opposite results. Now, based on our experience with CHI, we now classify them into diazoxide responsive and diazoxide unresponsive. Diazoxide responsive, thank God if the child has it. You just give the drug diazoxide and the sugar will come up. If they are diazoxide unresponsive, it becomes very difficult. You can try octreotide, you can try all kinds of things. Sometimes it just doesn't work and they might have to go for subtotal pancreatectomy. 10 years ago, every child with CHI went for subtotal pancreatectomy because they didn't know. Today, hardly any child goes for subtotal pancreatectomy because you can even say which child will respond to which drug. Now, here is a series of 62 cases of diazoxide responsive and 188 cases of diazoxide unresponsive CHI. So these are large numbers, one of the largest series in the world now. And we are still growing. Every week we get a new case referred from all the medical colleges in India are now referring these cases to us from the pediatrics unit, including AIMS, PGI Chandigarh, and many other institutes. So you can see that there are some differences between the two. The birth weight is slightly lower in the diazoxide responsive group and so on. Now, if they have this particular type of mutation and you start treating them, you can see the opposite happening. In neonatal diabetes, we found the sugars coming down. Here we're finding sugars going up now because you're treating them and the effect is being corrected and you can see the blood sugars becoming normal. And here is another example of an ABCC8 gene mutation. As I told you, it's only the gain of function and loss of function mutation. There are different types of mutations producing different responses, but they all kind of respond. We have done a lot of work on congenital hyperinsulinism for shortage of time. I'm not going to go into that. You can look up some of our publications. Now let me move to MODY, maturity onset diabetes of the young, where again I have some new data to show you. Now MODY, when the genetics of MODY was known, I started working on MODY just after it was discovered. It was first described in 1975 when I was doing my final year. And at that time itself, I told my father we had to start working on this. And between 1984 to 83 to 85, 86, I published a series of papers in diabetes care on MODY. Today, I know that they are not MODY at all because there's no genetic study described of MODY. The first gene for MODY was described only in 1992. And so many of those that I described are actually type 2 diabetes, not MODY at all. Once MODY was diagnosed, 14 different subforms of MODY or subtypes of MODY were described. Later, the ones shown in red, 7, 9, and 11, have now been dropped. You should not diagnose 7, 9, and 11. These are very recent things which our lab learned from the real experts from Exeter, Dr. Andrew Hattersley, and others. So what we did was we wrote a paper on what we call as now to diagnose MODY, it is not sufficient if you just find a mutation. It's not sufficient at all. You now have to use criteria called as the NOMAD criteria and the ACMG, American College of Medical Genetics criteria. Very, very strict criteria. To do the test, it takes 2 weeks. To do the interpretation, it takes another 2 weeks because it is that rigorous. And we have developed the expertise now to do that. What happens is even among the MODYs whom we had diagnosed, neonatal and CHI are different. But in the case of MODY, many of them are really not MODY at all. They're just having some mutation which doesn't really work. It's just you and I may have that same mutation and may not have it. Today, based on this, we have, I think in the previous slide we have, that we have now identified 3 types of MODY which we should be looking for. MODY 3, which is the commonest form, not only in India but all over the world. MODY 1 and MODY 12, which is the ABCC8 MODY, about which nothing much is known. Today we have described its clinical features. So these 3 forms of MODY are what we call as actionable MODY. The other MODYs, like MODY 2 or MODY 5 and so on, even if you find it, it's of academic interest, but you're not going to change the treatment. They may need insulin, MODY 2 doesn't need treatment, so that's not going to be useful. In our initial studies, we reported on each of these MODYs separately. For example, MODY 3, we've described, and this you have the typical 3-generation transmission. They have a low renal threshold. They respond to sulfonylureas. The HDL cholesterol is actually high, and that's how you distinguish it from type 2 diabetes. These people, they have a progressive form of diabetes, and if MODY 3 you don't treat, they will develop kidney disease, eye complication, neuropathy, all the complications they can develop. Then we had a series of MODY 1, less common. Macrosomia occurs in the affected fetuses. They are slightly older age group. HDL levels are low in MODY 3 in MODY 1 as compared to MODY 3, but otherwise they respond to sulfonylureas just like MODY 3. This is the second most common form of MODY in India. Now we looked at these actionable forms of MODY, MODY 3, MODY 1, MODY 12, and compared them with type 1 and type 2 diabetes, a very recent publication in April 2023. What we did was, we took our entire records, 5,25,000 patients in our electronic records, and then we identified those who had the Tattersall-Fayens criteria. Then we did the genetic testing for MODY, and then we identified those who had MODY, then classified them into actionable MODY, the MODY 3, 1, and 12, and the non-actionable MODY is MODY 2 and MODY 5. These actionable MODY we took together and compared them with our type 1 and type 2 diabetes. We matched them for duration, and you can see that if anything, the retinopathy, the nephropathy are actually more in the MODY compared to type 1 and type 2. And you may ask, why is it more? That's because they're wrongly treated. They're treated with metformin when they should have been treated with sulfonylurea. And that's the clinical implication of diagnosing MODY. Otherwise, you'll treat everybody with metformin, and then they don't respond, you'll add SGLT2, or you'll add something else. These patients have to be treated with sulfonylurea. And if you don't treat them with sulfonylurea, they are not going to do well. Now you may say, why bother about MODY? Why don't you just treat them like type 2 diabetes? Are you making too much of fuss with all this? Why don't you just simplify it and say, start everybody with metformin? Well, it's been attempted, and that's why we learn from our mistakes. Here is a report from Andrew Hattersley. He had a patient, and this is long ago, 2005. He had a patient whom he had not done the genetic testing, and he was treating them very beautifully controlled A1C. Patient was on sulfonylurea when the guidelines came that everybody should treat with metformin. So what he did was, why am I giving sulfonylurea? So he stopped the sulfonylurea, started metformin, A1C went up to 10%. Then he said, oh, probably this is MODY. Then he went and did the genetic testing, found it's MODY, switched back to sulfonylurea, and the A1C is down to 5.56. So it is not so simple that you just treat everyone in the same way, give everyone metformin, give everyone something. Some level of precision medicine, we have to start thinking. I'm not saying that everybody has to do genetic testing, but think of that some people who are not responding, ask yourself, is this really type 2 or am I dealing with something else? Now that brings me to the next question. So there is actionable MODY in a clinic. Now, when we have such a large number of patients, we see on an average between our 50 centers, between 1,000 to 1,200 patients a day. Now, when we see such large numbers of patients, how do we identify those who even come to our centers, how to look for genetic testing for MODY? It's expensive. Even if the patient doesn't pay, we have to pay. Somebody has to pay. It's not free. So how do we do that? So for that, what we did was, very recently we published this in Scientific Reports, where we did a series of screening, and we said, which clinical parameter will help us to narrow it down and say that these are the people who should go for MODY genetic testing. And of course, what we did for that was, we took 34 of those who were confirmed by NOMAD testing and ACMG criteria to have MODY, and then took 1,000 of the type 1s and 1,600 of the type 2s, and said, now let's see, what was MODYs, that's all we have. In the true MODYs are not that common. So we said, let's compare this group and say, clinically, what are the factors which will distinguish MODY from type 1 and type 2? Does age at onset help us? Now, the green is type 2, and the other two are type 1 and MODY. Well, they are crossing each other, so it's not useful. What about BMI? BMI is somewhat useful because the type 1s are leaner, so you can see that there is some separation occurring. The red is the MODY, and the green is type 2. So there is a slight separation, but there's so much of overlap that you can't do it. Next one, HbA1c, useless. All are crossing over each other, so it's not helping you. HDL cholesterol, to some extent you can make out, but again, I told you in MODY 1, the HDL can be low, so you can't make out. Then we come to C-peptide. Fasting C-peptide and stimulated C-peptide are tests which we routinely do in our clinic, and recently we're having a big argument, Banshi will know, in the T1, D1 group, whether we should do C-peptide, and somebody is saying you shouldn't do C-peptide, you're unnecessarily doing C-peptide. I say, I beg to disagree, because I have to progress in my science. And if I have to progress in my science, I will do C-peptide. Whether the patient pays for it or not is a different question, but I have to do it. Nobody can question me and say, why are you doing C-peptide? I do C-peptide because I like to do C-peptide. And that has helped me to, in this particular case, to make a diagnosis of MODY. So if you look at stimulated C-peptide, the blue dotted one that you're seeing is type 1. 1,000 cases. It's not a small number, okay? So the type 1s are completely going off. And then only the MODY starts, and then only the type 2 diabetes comes. So by using stimulated C-peptide, what is stimulated C-peptide? Just have breakfast, 90 minutes later, take a sample. How much does this cost? 300, 400 rupees. I don't think it's costing 10,000 bucks or 50,000 bucks. So it's a very simple test. When a cardiologist can say, go and do a CT angiogram and come, and go and do angiogram and come, you can't do 300 rupees, 400 rupees test. Who tells you not to do? Please do it. If you're going to change that patient's life, don't hesitate to do a test which is going to help you. You're not doing that to make money. You're making it to change that patient's life. Never hesitate to do a test if it's going to help your patient. And never do a test to make money. These two principles you have in mind, you can't go wrong. Okay? So here is the sensitivity and specificity. BMI, specificity, sensitivity, not very good. HbA1c, 60, 70%, not very good. When you come to fasting C-peptide, not bad. Sensitivity is about 84%, specificity is 96%. Look at stimulated C-peptide. The specificity is 100%. If you get within that narrow range, and we have said what that narrow range is, we have published it, it has to be MODY. It can, type 2s don't go so low, type 1 don't go so high. You're clearly separating it out. And even with the sensitivity, picking up of the cases also is close to 97%. So here is a simple test. It took me 40 years of work to get to this. 40 years I've been working on MODY. At the end of 40 years, I can tell you, now I know the test which can distinguish MODY from type 1 and type 2 diabetes. So the non-actionable MODY, we have done some work on that. We have published something on type 2. MODY 2 is interesting because once you diagnose MODY 2, you can stop all treatment. They don't need any treatment. No sulfonylurea, no metformin, nothing, unless they get pregnant. Only during pregnancy, they'll need insulin or whatever else you want to give. So it's a very simple form of MODY. MODY 5 is important because they have other abnormalities. They'll have genitourinary abnormalities. You'll find one kidney missing, agenesis of the kidney, horseshoe kidney, uterus will be missing, or something else will be there. So with these kind of abnormalities, MODY 5 presents. They need not even have diabetes. They can just have that abnormality. And if they have diabetes, they need not respond to sulfonylurea. So it's interesting, but it's not an actionable MODY. Where are we with our 30 years of work on monogenic diabetes? This slide just summarizes my future next 20 years, what I'm planning to do. We have 1,334 patients of monogenic diabetes or CHI, of which only 28% we are able to actually find a pathogenic variant. In that 28%, I can say, yes, this is exactly it. In the middle, 14% have what is called as a variant of unknown significance. We have found a variant, but it's not described in the literature. We don't know what to do with it. So what do we do with it? We have set up a functional genomics lab where we are trying to see whether that variant is really important or not. We have what is called as a patch clamp technique. So with that, we're able to do that. So those kind of studies are going on. Now, if we find, and some of them, we've just published a report saying that we have now shown some of those viewers are actually pathogenic. We've just published that about 10 days ago. So that then goes into the actionable group. Some will find they are not, they are benign, and therefore don't even report them. We don't report them, by the way. If you send for genetic testing and if you have said no MODY is there, maybe some of them have VUS, but we're not supposed to report on it. Because then everybody will say it's MODY and it may not be MODY at all, maybe type 1 diabetes or something. Then we have the last one, 58%, where we still don't know what to do. There's no genetic thing found at all. But the child has got it at 2 months of age. It can't be type 1 diabetes. All the antibodies are negative. So we have to now do what is called as either the exome sequencing or the whole genome sequencing and try to find new types which have never been described in the world. And that's very, very expensive to do, crores of rupees. I don't know, looking for some funding to do that, but that will lead to gene discovery. If you're able to do that, then India can teach the world many things. To me, it will be like Chandrayaan landing on the south pole of the moon. And that's what I'm hoping to do, and hoping to come back and present to you in a couple of years' time. Now, for all this, we need national data. And so many years ago, we set up this monogenic diabetes registry. I'm happy to tell you that from virtually, see if your city is not there. If your city is not there, please put the dot there and see that you get the samples. You may ask me, how much do you charge? I'll do it free of cost for you. Don't worry about the cost. I'll bear the cost, okay? If you find any child with either neonatal diabetes or congenital hyperinsulinism, you just send it. I'll do it free of cost without 1 rupee being charged, okay? We'll even arrange for you to send it and pick it up and so on. MODY, if you think that it is worth, and I know that there's a large list of collaborators, I'll just show you, but I'm happy to tell you that we are fast becoming the largest monogenic diabetes center in the world. Right now, we are number 2 position. We were like 20th position some time ago. We rapidly climbed up. Very recently, we have overtaken the Chicago center, and now we are number 2 position after Andrew Hattersley's group, after the Exeter group. And very soon, I want India to be number 1 in monogenic diabetes in the world. Here are a list of some of the doctors who have been referring. Some of you will find your name there. And that's another list, and that's another list of people who are actively sending samples to us. I wish the rest of you are also find your name there. So to conclude, ladies and gentlemen, all children with diabetes diagnosed before 1 year of age must undergo genetic testing. If you find neonatal diabetes ABCC8 or KCNJ mutation, you can treat them with sulfonylurea. This is nothing short of a miracle as far as I am concerned. CHI is also being recognized. It's not so easy as neonatal. I always regret when I get a case of CHI. Stimulated C-peptide seems to be the best test to screen, to send which patients to send for action. I'm not saying you should do it, but then we will be able to kind of narrow down who will have a positive result if you do that. And this can help to stop insulin and transfer them to sulfonylurea. And I would say that this is one of the best things in my 50 years of experience of treating diabetes. This gives me the greatest satisfaction. And with that, I thank you.
I request all of you to give a standing ovation to Professor Mohan.
Thank
Please
you.
sit down. Please sit down. SAB experience. We had a baby at the beginning. I took this story to Dr. Mohan. He told me to contact Radha Venkateshan, and I'm proudly a part of that publication with the DMDSC center. And all the samples that we have sent, a test genetic analysis costs more than 10,000 rupees. But DMDSC is very kind enough to take the test free of cost of our patients that we refer. So I acknowledge that, give a big hand for this good work. And when I saw the picture that before the MDRF Research Center, which I have visited personally, the team, I felt like the ISRO team of Chandrayaan standing there, and I'm sure this epoch-making project will be world #1 very soon. If Dr. Mohan will take a few questions.
I can take. And
any-
I know
any
Dr.
one,
Banshi
two
is here and many others who sent
Yeah.
so many samples for testing. And he has also had positive tests, positive cases.
over to
I don't know
chairperson.
whether Dr. Suresh Kumar and Dr. Chandani are in the audience now.
No, they have
So
not.
they
you.
send maximum number of cases. In fact, Suresh Kumar has picked up, I think, 6 or 7 cases of MID, which he maternally inherited diabetes from one city, from Calicut. And both of them are from Calicut, Dr. Chandani and I think large number of cases come from there. So any questions?
Chairperson, sir.
Thank you, Professor Mohan, for your outstanding contribution to the field of diabetes and also the excellent presentation and eye-opener to everybody. Thank you again for your contribution for last 50 years in the field of diabetes. And you are a miracle person in the field of diabetes. I acknowledge and everybody acknowledge in India. Thank you very much for your contribution and long life, cherishing long life, Dr. Mohan.
Thank you, sir. Thank you very much.
Thank you. Thank you, sir, for such a masterly deliberation. And thank you, chairpersons, for concluding the session in time. Thank you so much.
Better thing. Like,
After such a wonderful original research, now we'll hear the incretin story from Dr. Manoj Chawla from Mumbai. I would like to invite the chairpersons, Dr. Sudhanshu Sethi, Dr. S.S. Panda, and Dr. Sanjay Singla. And panelists, Dr. Alok Kanungo and Dr. Sambit Das. Dr. Sambit Das, please come. Moderator, Dr. Jayan Panda and Dr. Divya Saxena.
Shall I invite.
So, good afternoon, friends. Welcome to another interesting session, and it's a incretin story where Dr. Sudhanshu Sethi and Dr. Sanjay Singla are chairing, and we have Dr. Manoj Chawla as the speaker, and Divya and me are moderating, and we have an excellent panelist, Dr. Alok Kanungo and Dr. Sambit Das. So, let me tell you the structure of the session, this half-an-hour session. This is an incretin story, and then the topic is clearing the mist of myths, the oral GLP-1 receptor agonist. And you know, the oral GLP-1 receptor agonist, the semaglutide, has created a wave across the world in the treatment armamentarium, not only in diabetes, in obesity and these metabolic challenges. So this attempt of this incretin story is to clear up all your doubts. Keep your question ready. After Manoj's presentation, we'll have a question answer session to the panelists, and finally your question before we take a call to close this session. Over to Dr. Manoj Chawla.
Thank you, Dr. Panda, and the ACP organizers, Dr. Virmani, Dr. Anuj, for having me here. The topic that I'm going to speak on over the next 15 minutes or so is clearing the mist of myths. On the way, the drive from the airport here, it was very misty, raining, beautiful. I don't intend to clear that mist at all, but it's the mist about myths. This is a contracted talk, and that's my financial disclosure. The agenda is going to take you through the background of GLP-1s, getting into oral semaglutide, a little deep dive into what exactly is this molecule, busting the myths around oral sema, and then summarizing the presentation. Now, the fact remains that despite multiple options over the years of all these drugs which have come into the market in our armamentarium, the fact remains that people with diabetes predominantly are not achieving control. You barely have control in 1/4 of the patients, with 3/4 struggling in spite of all the advances in oral and injectable therapies. Diabetes management still remains a challenge. It remains the 9th major cause of death globally. 50% patients with type 2 diabetes present with microvascular complications, telling us that we are not screening early enough. 27% present with macrovascular complications, and 25% of patients of diabetes land up with diabetic kidney disease. GLP-1 receptor agonists, I think the concept is now getting more and more established. We've been using this, hearing this for the last decade and longer, and they've now become very, very important drugs because we realize that they do target multiple pathophysiological defects. So almost 6 of the ominous octet GLP-1s have direct or indirect action at the different mechanism of action. So let's move ahead and understand a little better on the next generation innovation, the magic pill, the development of oral semaglutide. Well, semaglutide is a human GLP-1 analog, the most effective GLP-1 receptor agonist tested to date. It has a long half-life of almost a week, and that along with the pill called SNAC or the molecule called SNAC, which is actually an absorption enhancer, is a research miracle in itself. This promotes the semaglutide absorption across the gastric epithelium, enhancing the oral bioavailability. For the longest time, it's been a challenge of how to have oral ingestion of peptides, how to make sure that there is bioavailability of oral peptides, and this SNAC as an absorption enhancer has done the job along with oral semaglutide. So the oral semaglutide preparation is a daily GLP-1 receptor agonist co-formulated with 300 milligram of SNAC. Let me take you through the developmental program. Well, it had a very robust phase 3 developmental program, the Pioneer series. And in terms of its efficacy, what we saw with oral semaglutide is whether used as monotherapy versus empagliflozin versus sitagliptin versus another GLP-1 liraglutide or along with insulin, you saw significant A1C reduction, fair to say an average A1C reduction at 1.5%. But every time you see efficacy data for any drug, it's important to note the baseline A1C. And which is where when we look at the data for oral semaglutide in patients who had a high baseline HbA1c of more than 9%, that's where you start seeing how efficacious this drug is. So if the baseline A1c was more than 9, the average reduction in A1c was much better to the tune of 2.6%. So higher the baseline, higher the reduction, telling us about the actual efficacy of this group of drug. It has also shown clinically significant weight loss across the Pioneer program. You look at again different studies as monotherapy against other commonly used drugs like empagliflozin, sitagliptin or other GLP-1s. You're looking at an average weight reduction between 4 to 6 kgs, and which gives us fair to say that you can expect up to 5 kilogram as average reduction. Of course, in the panel discussion, we'll talk about stories of patients who've done far better in terms of weight loss. So it does address the multiple risk factors. Oral semaglutide on an average can bring down the A1C by 1.5%, a weight reduction of about 5 kilograms, systolic blood pressure reduction of up to 5 millimeters of mercury, improvements in the lipid profile, and reduction in waist circumference as well. So let's bust some of the myths around oral semaglutide, because though physicians across the globe and the country have been made aware and listening to conversations on oral semaglutide and GLP-1 receptor therapy, there still remains certain apprehensions in the mind of physicians. Let's see what we can clear up, especially with oral semaglutide. So is the dosing too complex for this oral semaglutide? Some physicians feel, are there too many instructions to be given? Will my patient follow it? Is this all too cumbersome? Well, not really. So oral semaglutide is available in 3 dosages, 3, 7 and 14 milligram. Ideally, you start with 3 milligram and escalate the dose at the end of 4 weeks or 30 days, because you'll have strip of 10 tablets. You start with 3 milligram. It's 3 milligram is more of a dose which is going to be for getting used to the patient, in the sense the patient gets used to this drug more to avoid the adverse effects. The actual efficacy you'll start seeing when you move up to 7 milligram, and the best results would be with 14 milligram. So at the end of each 30 days, you escalate the dose up. What's important is for every drug, just the way you would have done for SGLT2 inhibitors, pre-warn the patient about the possibility of a genitourinary infection so that they take extra care for hygiene and use certain local antifungals and so on. Here as well, it's important that we preempt the patient and tell them that there is a fair chance of nausea, acidity and occasional vomiting, especially in the initial titration days. And hence, if this happens, use of simple means, proton pump inhibitors, antacids, so on, will bring this trouble down. When the patient is pre-warned about it, they do not react so adversely. They kind of expected that this may happen, and in case if that happens, they do not discontinue the drug, or they are prepared for it better and they are able to overcome that initial phase of nausea and vomiting. So dosing is simple like any other drug. You need to start slow and then up titrate. Of course, the way to have this drug is first thing in the morning, and which is what we'll elaborate on how it is done. Is the daily dosing condition challenging to patients? Well, aren't our patients used to the daily dosing? Most of our patients would in fact prefer the daily method rather than taking it once in a while, because it's so much more difficult to remember and they lose the rhythm. How do you really take it? Well, wake up fasting and take your semaglutide tablet with up to half a glass of water, so not more than 100 to 120. A simple instruction is 2 to 3 sips of water. wait for at least 30 minutes before eating, drinking, or taking any other oral medication. And that's important. When we've now been using it for a year and a half, you still come across some patients who were started and not given instructions, who come and tell us that they've been taking it wrongly, they've not been waiting, they're crushing the drug, they're doing multiple different things, which is absolutely wrong and will hamper the absorption. So take it first thing in the morning, 2 to 3 sips of water, wait for half an hour before drinking or eating or taking any other medication. And after 30 minutes, you're good to go with your normal routine. What may affect its absorption? Well, if you've eaten food within those 6 hours of taking the drug, it may impair the absorption. If you're increasing your water volume, you're having it 1.5 glass of water. Some patients will say in the morning, I feel extremely thirsty. Well, if you want this drug to work, you have to stick to 2-3 sips and no more water for half an hour. Otherwise, it will impair it. And again, if within half an hour you're eating or drinking something, it will impair the absorption. Simple instructions, and you tell it to your patients. Trust me, they follow it when they know the benefit of this drug. So advise their patient that if they miss a dose that day, there's no point in taking it just before lunch or after their breakfast. It won't help. They can just take the dose next morning in the right manner. So the daily dosing is simple. Wake up, take your oral sema, carry on with your regular morning routine, and be mindful not to consume any food or water or drug for the next 30 minutes. There are certain thoughts that is the injectable semaglutide really better, and you see some grey market existing even in India today for the injectable semaglutide, because some people perceive it's really far better or much better. But when you see the data, the exposure response relationship is similar for both these drugs, be it the injectable or the oral. And when you compare, there is really no difference in terms of the dosing or the Cmax for the drug and the HbA1c reduction, which is the efficacy. So that's largely a myth. Well, maybe on the weight front, there may be a slight more benefit with the injectable, but in terms of A1C reduction, there is really no difference between these two drugs. So when you ask your patients and have a conversation, what do they prefer? Do our patients prefer vial and syringe? Well, if that's the case, we would have insulinized our patients much better and much earlier. Then do they prefer once daily pen injections? Well, better than vials. Would they prefer once weekly injections, pen devices? Definitely, that's going to be better than the daily ones or multiple times daily. So when it's injectable, they would prefer it as infrequent as possible. But when it comes to a choice between injectable and oral, I think it's hardly it's a no-brainer. It's no robotic science that your patients will say, any day give me an oral medication as compared to an injectable drug. Patients with diabetes type 2 have a preference towards a daily oral rather than a weekly injection, and there are multiple surveys done amongst patients and primary care physicians and healthcare practitioners, including cardiologists, which have found that there is largely a preference for oral medication as compared to injectable. What about the efficacy of oral sema? Is it different in the Asian population as compared to our Western counterparts? So this is data looking at different races from the Pioneer program. This is a sub-analysis of the data. You're looking at how the whites responded, how the black Americans or African Americans responded, how did the Asians respond. And you'll be able to notice across the different Pioneer programs a slightly better reduction in A1C amongst the Asian patients. So you look at change from baseline in A1C by race, and you will find better response across the Asian race in all the Pioneer programs, whether used as monotherapy or compared to different drugs. What about weight loss with oral semaglutide? Well, let's again bust some myths, as that's what we're doing this afternoon. Central action of GLP-1 receptor agonist is what is responsible for the weight loss. Well, it happens predominantly through appetite regulation. GLP-1 directly and indirectly activates the hypothalamus, the arcuate nucleus section of the hypothalamus in the hindbrain, which is involved in appetite regulation. GLP-1 will reduce the energy intake, will reduce the appetite, the food cravings that the patient has, and then indirectly cause the weight loss. So for your patients who complain, who may not even be overweight or obese, but who complain of feeling excessively hungry and snacking and eating, these are type 2 patients, there can't be a better therapy for them than GLP-1 receptor agonists. So GLP-1s will stimulate the propiomelaanocortin receptors, the CART receptors, which is again your cocaine and amphetamine related transcript receptors, and through that pathway it will decrease the hunger, decrease the energy intake, decrease the food cravings, almost similar to what happens with cocaine addicts in terms of food craving going down, though it's not an addictive drug. GLP will also inhibit the neuropeptide Y and the agryl receptor peptides, which will actually improve the satiety. So through these both mechanisms, one which is decreasing hunger, decreasing energy intake, and on the other hand through neuropeptide Y increasing the satiety, that's how it brings about reduced energy intake and weight reduction. There is a threefold greater loss of mean fat over lean body observed with semaglutide. The worry is when you're losing weight, is it muscle loss? But clearly again evidence and data showing that it's more fat loss as compared to any kind of muscle loss. So you look at the data, body weight coming down. On the right side you'll see the data for body composition. So as compared to the lean muscle mass, it's predominantly the fat mass which your patient is losing on oral semaglutide and GLP-1s. Greater loss of fat over lean body mass with oral semaglutide. Again, comparison of the same aspects. Less appetite and food cravings, better control of eating, lower relative preference for fatty and energy dense foods. And that's another thing that happens with oral semaglutide. Your patients will say that if they eat a fried meal, they have very fatty fried food, then the nausea actually increases. So one of the means of letting them know about how to reduce the side effect is avoiding large meals, avoiding fatty meals, avoiding oily meals. This brings down their nausea, and of course the evidence about reduction in fat mass. What about the effect of other medications? Will that be altered by oral semaglutide? No clinically significant effect on other drugs, and you see most of the drugs used, be it your ACE inhibitors, warfarin, digoxin, diuretics, and levothyroxine. There is no major difference in their absorption, though some differences have been seen and which can actually be used to our advantage. You look at the data for levothyroxine co-administered, and that's very often the question, right? Because that's the drug you're asking your patients to take in the morning. Well, today we ask our patients to take their oral semaglutide, wait for half an hour, then take their levothyroxine, wait for half an hour and start. But honestly, if your patient actually took this within 20-25 minutes of that, is it going to make a huge difference to the oral semaglutide absorption? Probably no. But the levothyroxine absorption will actually be higher. So be on the watch out, because you may have to reduce the dose of levothyroxine in your hypothyroid patients. Even though you give them instructions to keep the gap, sometimes they may not keep that clear half an hour gap or longer, and it will actually increase the absorption by almost 33%. So levothyroxine, well, both should be taken under fasting conditions, and as I said, the right way is your Rybelsus first, and after half an hour your levothyroxine. What are the key considerations for patients taking oral sema in addition to other medications? So the exposure of commonly administered drugs is not affected to any relevant degree. No clinically relevant differences in exposure of oral with the proton pump inhibitors, which very often will be used, though not within half an hour, but later, to avoid the nausea and vomiting. Warfarin is not affected the exposure. However, frequent INR monitoring still continues to be advised to your patients who are on warfarin. And in terms of thyroid, as I said, you will do regular monitoring of thyroid parameters and may require down escalation of the levothyroxine dose in some patients. Is there any dosing alterations when your patients have comorbid conditions? Well, not really. It's elderly patients. This drug is safe as long as they can afford it. Your patients with hepatic and renal impairment, no dose reduction to be done for oral semaglutide. Those patients who have upper GI tract disease, this is not a contraindication. So those who have just their upper GI symptoms, your oral semaglutide will not bother them. Of course, patients with lower GI, you may think twice about for this drug in those specific patients. What about concerns on retinopathy? For quite some time with GLP-1s, we've been worried, is there an increase in retinopathy? And then we again look at the data for retinopathy across the Pioneer program. No increased risk of retinopathy seen across the developmental program of Pioneer, or for that matter, their cardiovascular outcome trials like the Pioneer 6 as well. What does the ADA say on the standard care of diabetic retinopathy? It's a known fact that you should screen your patients with diabetes for retinopathy regularly. Every time you're going to be intensifying your therapy, trying to get your patients to target, keep a watch and screen for retinopathy, because we know intensifying therapy and improving the metabolic control can worsen pre-existing retinopathy, and hence the need to watch there. Any association between GLP-1 drug usage and retinopathy has largely been put on this improvement in metabolic profile, though I must say we don't have the final word there. But when it comes to the data from oral sema, no real association seen. So let me summarize, chairpersons and panelists, that oral sema is the first world peptide pill that has efficacy significantly better than many active competitors. Oral sema is an effective option for type 2 diabetes management along with its benefits on weight loss. It acts through the central nervous pathways, providing a significant and sustained weight loss. It has shown to reduce weight by up to 5 kg, A1C by 1.5, higher baseline A1C, 2.6% A1C reduction, and waist circumference reduction up to 5 centimeter. And oral semaglutide is easy to titrate and can be used in all stages of CKD and hepatic failure. With that, I thank you so much for having me here and hand it back to our moderators and panelists.
Thank you, Dr. Manoj, for the wonderful deliberation and excellent information regarding oral semaglutide. It is really a promising drug recently made available in the whole armamentarium of type 2 diabetes treatment, and making it really a promising drug for helping the people who are obese and who want to lose their weight. So, sir, Dr. Alok Kanungo is our esteemed panelist. My first question to you is, sir, what are the potential benefits of weight loss in people with type 2 diabetes? As we know, it is one of the risk factor for type 2 diabetes.
Thank you, ma'am. Previously we had the idea that only obese people get diabetes. But now in India, lean people also get diabetes. But when a diabetic becomes obese, his cardiovascular problems increase, all organs are affected, drug requirement increases, his joint problem increases, there is more of osteoarthritis and other problems, and many such complications do occur, and thyroid becomes another problem for that patient. When you reduce weight, maybe by diet or by exercise or by drugs, then there is a potential benefit of vascular risk, and all those things that I told are reduced after there is a substantial weight loss. Weight loss can be gradual or weight loss can be rapid. Gradual weight loss is good for health, whereas rapid weight loss leads to so many complications also. Question of weight loss discussion came to the forefront after oral semaglutide was available. Clinicians started getting wonderful results when they started giving semaglutide, oral semaglutide for diabetes management. But my first patient, a 70-year-old man, retired Chief Justice of a High Court, whom I gave the medicine, he went on losing weight up to 22 kgs in 6 months' time. And a point came when he was behind me that when do you stop this medicine and how low I can go. Then I reduced from 14 to 7. He was stabilized, gained 3 kgs, and now he's perfect man. All his dresses fit him, and his parameters, all biochemical parameters are normal. I have given semaglutide to more than 200 people. 3 have discontinued because of financial thing, and 1 for intolerance due to gastric intolerance. But rest are all receiving the semaglutide and getting wonderful result. They have a new lease of life, as if they are facing the life differently. They are able to dress well and they are feeling good. That sense of well-being is very much if you lose weight. And the taboo that you are obese goes away. So weight loss not only gives physical benefits, it gives mental, social, psychological benefits to a patient. Thank you, ma'am.
Thank you, Dr. Kanungo. 40 years back, Dr. Kanungo started working in the field of diabetes when many people didn't thought that this can be a global challenge. So rightly he has told as many weapons in the hand of diabetes consultant will be there That way, patient can be benefited. My question is to Dr. Shambit Das, who is a professor head of endocrinology at KIMS and a very senior endocrinologist. How does the modern anti-diabetic agents like oral semaglutide impact your treatment decision?
So first of all, thank you, sir. So oral semaglutide has definitely come up as a very ideal anti-diabetic agent. Why I say so? Because Dr. Manoj has already told that for an ideal anti-diabetic, we want a drug to be efficacious in HbA1c reduction. It should be beneficial to the weight, at least it should be reducing a weight. It should not produce hypoglycemia, and it should have some added advantages in terms of reduction of the CVRS, in terms of reduction of BP, cholesterol, and uric acid also. So in that term, definitely GLP-1 receptor comes very high up in all the anti-diabetic medications. And since it is available orally, still it is more compliance oriented, so it is definitely a good drug. In clinical practice, definitely it has changed the scenario we treat a patient with diabetes, because if we follow the current guidelines, say the RSSDA or the ADA or any other guidelines, we definitely see that maybe after metformin, if ASCVD is there or predominant, definitely GLP-1 receptor agonist, especially semaglutide, is effective. If ASCVD risk factors are there, then again it is one of the first choice of therapy. Heart failure and CKD also, it is almost an alternative to SGLT2 inhibitor. And in all that spectrum, like if you see the weight, if you reduce the hypoglycemia, if you want to control the glycemia, then definitely it should come as one of the first or second line of therapy with metformin. So I think with the introduction of this class of molecule, it has changed the paradigm shift in how we manage a patient with diabetes.
Thank you, Dr. Das. I just want to ask one question to Dr. Manoj, that how much weight loss is there with 3 milligram and 7 milligram? Is it really significant, or higher doses are required for the weight loss? And we know that obesity is also a risk factor for cardiometabolic complications in a type 2 diabetic patients. So how does oral semaglutide fit into the treatment paradigm in these patients who are at high risk of cardiometabolic diseases?
Thank you. So to your first question, in terms of how much weight loss will you achieve by different dosages, as I said, 3 milligram is not an extremely effective dose. 3 milligram is a dose which is more of a startup dose, though I must say, of all the several patients that I have used in over the years, I've had one patient who's come back and told me that I couldn't tolerate 7, but I was doing extremely well with 3 milligram. So that's just one patient I've had who's insisted that, and it was not about affordability, it was not about tolerance, but somehow she felt that 3 is what is suiting her. So that's been just one case. But otherwise, it's going to be 7 and 14. The weight loss is pretty much variable. I'm sure all of us look into our database. I've had patients who've done 15 kgs starting at close to 9,500 and have done 15 kgs on oral semaglutide and maintaining that. And then you've had some patients who've barely done 2 to 3 kgs on that. So it's like how Dr. Mohan spoke about precision medicine. I think somewhere ahead we will probably have to find means of being able to predict and say, you know, what are the factors which will have better response to GLP-1 in our patients. Today it's more generalized, we use it, some patients respond, some don't respond to that extent. So variable, but you can, the data showed 5 kg, but I can say in real world, and a lot of real world data is now getting published, anywhere between 5 to 15 kgs over a period of time. In terms of cardiometabolic risk reduction, the class in itself, GLP-1, has proven through its various cardiovascular outcome trials, whether we look at the data from LEADER-6, the first one which actually showed that, and then of course various other ones, Harmony and other GLP-1 trials have shown improvement. Though I must say that the cardiovascular outcome trial for oral semaglutide, which was the Pioneer-6 program, showed non-inferiority but did not show superiority in cardiovascular risk reduction. But which is why we have another cardiovascular outcome trial. So the company has so much faith in the drug. SUSTAIN-6 for injectable semaglutide showed cardiovascular risk reduction. Pioneer-6 did not, and which is why the other second cardiovascular outcome trial called the SOUL study is ongoing, Some of us here are part of that study, the global cardiovascular outcome trial, but it will take another year and a half for us to get the results, to have the final answer of oral semaglutide and the cardiovascular risk reduction. Similarly, you have the renal population and renal risk reduction, the flow study for oral semaglutide. So it's fair to say that as a class, we expect cardiometabolic risk reduction with GLP-1s, but we really need to look at the evidence for each specific molecule. And for oral sema, fair to say that it's non-inferior, but in terms of superiority, the data is round the corner.
Manoj rightly explained. Before I go back to Dr. Kanungo, I think our scientific chair wants to put an issue.
Just a question to Manoj. I mean, you have just discussed this very point that I was thinking on. But what do you think could be the reasons that we saw positive CV benefit with injectable semaglutide, but not with oral?
So, sir, I think it's a $1 million question, but very often, if you see the cardiovascular outcome trials, and we've seen the results differ across whether it's GLP-1s or SGLT2, it largely depends on the population included in the study. So you've seen differences in results depending on what is the population which is for primary prevention, what is the population. So statistical significance is missed by certain points. It's a matter of few events. So if in your selection of patients, you had an X kind of patients who were more primary prevention rather than secondary prevention, then the chances of the results being different may be the difference between statistically significant and non-statistically significant. So if you see the baseline population between Sustain 6 and Pioneer 6, it's not exactly the same. So which is where you will also wonder that for dapagliflozin, in the DECLARE, you did not get any statistical significance, right? But then you look at the data for DAPA-HF, DAPA-CKD and the studies later on, you see CV death and other reduction, MACE reduction, you're getting statistical significance. So it's all about, I think today, what the FDA did not do earlier was pre-specifying the kind of population you can include. They gave a very broader outline that high-risk population, cardiac risk is what you can include. And which is where what led to the disparity between different results in different molecules across the CVOT program, which as you are aware has now been stopped. And currently you do not require CVOTs. What the current FDA mandate is in the phase 3 developmental program itself, you will do trials including studies with patients above a certain age with a certain cardiac and vascular risk as part of the phase 3 program. So you do not require a separate cardiovascular outcome trial. But my thinking is the difference is related to the patient population at screening which were included and which is where the company has the faith in doing another cardiovascular outcome trial. And we know it takes huge amount of money to do a cardiovascular outcome trial. So they have to have some faith that this drug may show different benefits when you change the criteria of inclusion.
And that's true. Patient selection is very important. But you know, if you look at the various GLP-1 RS CVOTs, there is a subtle difference that you note. The positive CV benefit is seen with long-acting GLP-1 RS, not with short-acting. The benefit is much more with long-acting as compared to short-acting. Now the question is, if that difference we are seeing with the injectable, could there be some difference because of oral and injection that we are not getting the same benefit?
I don't think so, sir. And honestly, liraglutide is not a long-acting. I mean, in those days when they did not have a long-acting, they used to call liraglutide as a longer-acting because the comparator was exenatide. But liraglutide is a once daily.
But it's 24 hours. It is still longer than exenatide. Exenatide did not show that.
So you look at oral semaglutide, the actual half-life is the same. It's just that the oral absorption is such. So this is the first oral GLP-1, so we really can't say that.
Yeah, I think I also, yes, sir. So I also support what Dr. Manoj has told, because this Sustain 6 and Pioneer 6, they are not similar type of study, and Pioneer 6 was not intended to prove the superiority of this oral semaglutide. It just wanted to show the non-inferiority. So probably the event rates were less, and probably that will be proven exactly with the SOUL trial.
Semaglutide is basically a glucagon-like structure. Is it true? The
this semaglutide is a glucagon-like structure.
It's a GLP-1, sir.
Yes, it is a glucagon-like structure.
Sir, it's a GLP-1 agonist.
Means this is a glucagon-like structure. GLP-1 stands for glucagon-like structure.
A glucagon-like peptide.
Yes.
GLP.
So it is a peptide like glucagon. Yes. But pancreatic glucagon does the work, it does the opposite. Why?
Extremely important question, and what you said and your thought process is right, and I'll repeat for the benefit of everyone. What Dr. Tripathi is saying that this is a glucagon-like peptide, GLP. And glucagon, we know that does the exact opposite action in terms of opposing insulin. It's a great thought, and this is where we are learning new things every day. One of the newer therapies in diabetes moving ahead is actually glucagon agonists. You're getting triple peptides, which is GLP, GIP, and glucagon. And you're also looking at data which was presented at the ADA recently, which is of glucagon agonists. And it's a whole circle that we are going through. So actually what we thought that glucagon may oppose the action of insulin, but in a certain dosage and beyond, it's showing evidence of benefits in type 2 patients. And you're absolutely right that one of the bases of GLP could be the fact that it has similarity to glucagon, and that's the basis of further research. So very good question, and
My point is, sir, this is a glucagon-like structure or not?
Sir, Dr. Chawla and Dr. Das are there. So we'll take it up. Scientific chair is standing right behind. So quickly we'll wind up. We have a few questions which we had designed to the panel, and then I request Professor Tripathi to just after the session get this cleared. I request the panelists to make it very quick this round. Direct question to Alok Kanungo: how do you approach your patients with diabetes who need weight loss? Quick answer.
If diet control, exercise fails, and metformin doesn't give much benefit, and glucose control requires further addition, recently I am trying semaglutide. But before that, diet control, exercise, and strict diet control, sometimes intermittent fasting, all those things were helping, but most important is exercise. Anybody who is not doing exercise, his muscle mass goes down and he suffers. So exercise is the primary, then these drugs and oral semaglutide has a place.
Thank you, sir. So with this, hand over to chairpersons to take the audience question and wind up the session.
Thank you, sir. The only crux is that we should spend at least 5 minutes with the patient whom we are prescribing this drug. We should allay the anxiety of the patient, because a number of patients are having anxiety in terms of how to take it and how to manage it. Thank you so much.
Thank you, chairpersons. Thank you, panelists. Thank you, Manoj, for a wonderful talk.
I request all to come to the memento.
I have an announcement to make that the biostatistics and ECG workshop will be held in Dr. B.P. Tripathi Hall. Next, we have another very important master's talk from none other than Dr. Shashank Joshi, another legendary diabetologist from Mumbai. And to chair his session, I'd like to invite Dr. Indra Patnaik, Dr. Santosh Kumar Swai, and Dr. Pranabandhu Sahu. Dr. Santosh Kumar Swai, yeah, and Dr. Pranabandhu Sahu. Is Dr. Sahu there?
I request the chairperson to start the sessions and invite the speaker.
Good evening. The next session is on diabetes and immune inflammatory disorder, what is new, by Dr. Shashank Joshi.
In the physician world of India, we have Professor Shashank Joshi. Right from his student days, he has excelled academically, and the whole career he has devoted thinking much ahead of his generation and putting Indian thoughts and Indian research at the global level. We want to felicitate him before he starts his presentation, and his differential thinking and achievement has encouraged each and every physicians of the country, and we take the pride of his presence in the 8th IIM ACP Bhubaneswar. I request our scientific chair and Anuj here. Somebody to call Dr. Maheshwari, please. So please give a big hand. I have seen in the conferences. I have seen in the conferences where Professor Shashank speaks, the audience remains full. पीछे में खड़े रहते हैं लोग, and that is just to listen what he speaks. So give a big hand. And then, so I request the chair. Ma'am has already invited, and the
I'm
stage
really
is yours, sir.
privileged. I'm privileged to be a chairperson where Dr. Joshi is the speaker.
So thank you so much, Dr. Maheshwari, Dr. Virmani, Dr. Panda, everybody. Many times I committed to Anuj and I could never make it. I always used to send it virtually. So this time I said we'll do it physically. And I'm happy that he allowed me to talk on a topic of diabetes as an immune inflammatory disease. So we are moving gears actually from obesity, weight loss, and the incretin axis into inflammation as a target organ for treatment. In both type 1 and type 2 diabetes. Because we know that type 1 diabetes has a lot of autoimmunity, and the autoimmunity has targets now. And clearly that is very well recognized. In fact, there are treatment options available in type 1 diabetes space today, where if you pick up an early stage of type 1 diabetes, you can actually intervene disease and keep that person insulin free. But in the type 2 space, there has been a lot of old work. You know that sulfonylureas were discovered by accidents. When sulfonylamides were being given to soldiers of World War, and they used to get hypoglycemia. And even when salicylates were given to soldiers for pain in World War II, there were hypoglycemias which were seen. So clearly when we look at health, age and obesity, clearly we recognize even in type 2 diabetes, if the metabolic milieu and immune homeostasis is disturbed, you will get clearly a immune inflammatory syndrome which causes all the complications. So the directionality of complications of type 2 diabetes are linked to the degree of inflammation. And that's linked to adipocytes. The reason we need to lose weight is because we know that adipocytes have some types of adipokines which are healthy and also make some anti-inflammatory cytokines. And the adipocytes have tissue-resident lymphocytes like CD4, Th117, CD8, which clearly do a physiological crosstalk with the T regulatory cells and balance the adipocytes and the beta cells. And clearly that maintains the milieu. Unfortunately, when there is excess or enlarged adipocyte, the crosstalk which is physiological becomes pathological. The number or function of the T regulatory cells gets down-regulated. The anti-inflammatory cytokines go down. You get a lot of unbalanced level of adipocytokines, a lot of leptin which goes out, and the beta cells of the pancreas actually go into a cryptic self-antigenic source of autoapoptosis. And clearly we get a lot of inflammation, and this inflammation leads to disease. So the earliest data which came out between normoglycemia pre-diabetes, normoglycemia diabetes on inflammation and immune biomarkers has been quite old. And if you look at a meta-analysis of that, whether it's WBC count, granulocytes, lymphocytes, monocytes, platelets, CRP, IL-1, IL-18, neoptorin, albumin, fibrinogen, all of them are abnormal. Why should we know about inflammation, and can we target it today? And can it make a difference? The reason we need to target inflammation today is because the complications of diabetes are linked to RAGE, which is the ligand receptor for advanced glycation end products axis. And that can trigger signaling events which are associated with diabetes and its complications, neurological disorders, cancer, inflammation, and other disease. As people will live longer with diabetes because we give them antiplatelet drugs, we give them statins, we give them ACE or ARBs, they will die of neurological disorders, cancer, or other inflammatory diseases. But one thing is clear cut. Every type 2 diabetic we treat, some of them get nephropathy in 1 year, some in 5 years, some in 10 years, some never get it. And clearly we recognize that the studies of diabetic kidney disease show that there is a clear interaction between the age, which is advanced glycation end products, RAGE, which is the receptor for advanced glycation end products, on the glomerular foot cells. And that increases the expression of acetylheparinase, which degrades the acetylheparin sulfate at the glomerular basement membrane. And when the glomerular basement membrane is disrupted, the filtration barrier is activated by NF-kappa beta signaling pathway, and you get a very rapid deterioration of kidney function. We also have very good data that HMB1 interacts with the toll-like receptor 4 and again generates a very, very strong inflammatory response on the retinal vascular barrier. Some people get, even at pre-diabetes, a bad retina and advanced retinal disease. Some people at pre-diabetes get advanced kidney disease. And the reason for that is linked to how is the immune inflammatory pathway activated. So remember, in the etiology of type 2 diabetes, it's always a stage of chronic low-grade inflammation. And we never take that into account. In fact, if you look at the heterogeneity of various diabetes endotypes, because today we are in an era of personalized medicine and precision medicine, immune etiology is important. But whatever we see today in medicine, there is a constant state due to stress, a low-grade chronic systemic inflammation. And clearly we know whether it's social factors, psychological factors, environmental factors, or biological factors, there is a continuous state of a sterile chronic inflammatory response. And that leads to a 2 to 3-fold increase in the inflammatory mediators and innate arm of the immune system. So clearly between classical inflammation and low-grade systemic inflammation, we have a lot of systemic insulin-dependent tissues, macrophages, T lymphocytes, dyslipidemia, atherogenesis, and hypertension. And clearly we recognize that the causes of this low-grade chronic systemic inflammation are linked to gut microbiome, improper diet, loneliness, isolation and chronic stress, disturbed sleep, the various endocrine disrupting chemicals and environmental disrupting chemicals which we get, sedentary habit, obesity and chronic infections. And all of that will trigger a systemic chronic low-grade inflammation which will lead not only to metabolic syndrome, MAFLD, type 2 diabetes, cardiovascular disease, cancer and depression, but a spate of autoimmune diseases, neurodegenerative diseases, sarcopenia and osteopenia, and immune senescence. So the link between inflammation and type 2 diabetes is extremely clear cut, and disruption of insulin signaling is very well known. And therefore there is a whole new concept now in modern biology of meta-inflammation. Whether it is the adipocyte or the skeletal muscle, the liver or the beta cells. Clearly it is a state of meta-inflammation. With the insulin resistance, there is a clear state of meta-inflammation, and clearly the adipose tissue dysfunction affects every organ. At the pancreas, we clearly recognize that there is a fatty pancreas. There is a lipid accumulation in the pancreatic beta cells. And we know that remission of diabetes is possible if you do reversal of fatty liver and fatty pancreas. In the brain, due to dysregulated adipose tissue dysfunction, the satiety signals are disrupted, and you keep on eating and you get a craving habit, particularly nocturnal craving habit, which is on the rise. Clearly, we recognize that obesity reduces the ability of thermogenesis. You suddenly feel cold, even if the AC is not working. It means that you have very poor thermogenic fact, because that's all mitochondrial dependent. Obesity clearly disrupts gut microbiota. It clearly impacts fatty liver, and now we know the word fatty liver has been replaced and it is called as metabolic associated fatty liver disease or steatohepatitis. And even in the muscle, you get a lipid accumulation. So clearly we recognize that at a molecular level, you get a lot of lipo and glucotoxic state, and all this will lead to beta cell dysfunction. And all you need to do is eat less, reduce the intrapancreatic fat. You need to target inflammation. One of the best drugs to target inflammation is pioglitazone or glitazones in general. And we have recognized it long time back, but they have been abused. But you know that we are insulin resistant. And therefore, glitazones still form an important armamentarium in our type 2 diabetes continuum, because they fundamentally modulate insulin resistance through the inflammatory pathway. Beyond that, the new age GLP-1 agents, which we just had a discussion, whether it's injectable or oral, they reduce the oxidative stress, again working through the mitochondrial dysfunction pathways. We also know the endoplasmic reticulum stress, whether it's metformin, whether it's GLP-1 analogs, whether it's pioglitazone, or the new ER chaperones which are being now developed, or whether it is the auto death of the cells or impaired autophagy with GLP-1 analogs. All these pathways, whether it's dysfunction, whether it's apoptosis, whether it's dedifferentiation, are impacted. And clearly we recognize the role of inflammation here. Even in macrovascular complications, the pro-inflammatory and pro-atherogenic mediators are very well recognized, whether it's atherosclerotic plaque, whether it is a skeletal muscle or renal damage. And therefore, whether it's glucose or lipids, whether it's hypoxia or rage, whether it's oxidative stress, there is a cascade of inflammatory signaling pathways, local activation of pro-inflammatory cytokines, and you get development of microvascular disease. And that's why we have different clusters now. You know that Scandinavians described the cluster. You had a very elegant talk by Dr. Mohan, who has also described in a group that we now see type 2 diabetes is very heterogeneous. And the Scandinavians described it as severe autoimmune diabetes, SIAD, SIDD as severe insulin deficient diabetes, MOD as mild obesity related diabetes, MARD as mild age related diabetes, and these are the different clusters. In India, we get two novel clusters. IROD, which is insulin resistant obese diabetes, almost 1/4, and around 1/10 get CIRDD, which is combined insulin resistant and deficient diabetes. And both these clusters have a link with retinopathy and kidney disease, because we probably have more inflammation. We do have a lot of severe insulin deficient diabetes, which probably is early onset and needs insulin. And we also have a large proportion of 1/3 patients with mild age related diabetes. But our phenotype is very, very classical. We are lower age of onset for type 2 diabetes, lower threshold for BMI, lower insulin levels with high insulin resistance, very rapid decline of beta cell function, low adiponectin, a lot of disturbed dysbiosis, a typical dyslipidemia, predominantly low HDL, 70%, and then of course a little bit of high trig and high small dense LDL, low B12 and D3, low muscle mass, lot of inflammatory markers, a lot of abdominal fat, and MAFLD and low birth weight. So all this forms the phenotype. And if you look at the hazard ratio in the Indian population, clearly you can see the risk in two subtypes of the clusters, IROD and CIRDD, is very high for diabetic kidney disease. If you walk into any dialysis unit, if you walk into any renal transplant unit, more than half of the people are having diabetes today. And that's because we have a vulnerability, and those vulnerabilities are driven by inflammation. So clearly we can see that it is the type 2 diabetes associated dysregulation of immune system which upregulates HSCRP, IL-6 and the ENRAGE, and the downregulation of leukocytes and CD4 which clearly make the switch. Whether it is SIRD or MOD or MARD, clearly the inflammatory endotypes are linked to the inflammation. A large EU supported project called Intercept type 2 diabetes stratified type 2 diabetes patients based on circulating frequency of leukocytes and monocyte subtypes. In fact, monocytes, simple CBC monocytes are abnormally elevated in 10 to 20% of global type 2 diabetic population. And they have linked that based on a European cohort in the Intercept type 2 diabetes study to genes related to dysimmunity and complications like MAC3 kinase, NLRC3, IFNGR1 and PPAR gamma. Clearly now we are getting simple insights from simple things which can make relevance. We also know that the main immune cell type for metabolic organs are macrophages, the scavengers, whether it is the adipose tissue, the liver, the pancreatic islets. Macrophage represents the main immune cell type for every metabolic organs. And when we see type 2 diabetes with increased expression of genes functionally related to inflammatory responses and cytokine-cytokine interactions, we clearly see IL-1 beta, TNF signaling pathways which are disrupted. You know, the anti-TNF was discovered by an Indian who is based out of UK. He's a rheumatologist from UK. He's more than 80 years old and his name is Dr. Maini, and he's from Ludhiana originally. He's in fact nominated for this year's Nobel Prize, and clearly this is a pathway which can actually be blocked. If the inflammatory features are detectable in the pre-diabetic stage, the beta cell dysfunction can be disrupted. And the islet inflammation can be pharmacologically treated at a pre-diabetes stage because before irreversible beta cell damage occurs. And therefore the net number of macrophages in the islets compared to healthy individuals decide how rapidly the beta cell will deteriorate. So clearly we can recognize in personalized window now, because we are moving into personalized window, we can actually have circulating biomarkers. If you have monocytes in the blood, a heterogeneity which can come up, metabolic tissue macrophage activation, clearly we can recognize that some people with type 2 diabetes are immune predisposed. Some people will get beta cell or islet cell failure. So we can clearly recognize that the cytotoxic T cell expression on the type 2 diabetic islets can be recognized. And you can look at the cytotoxic processes which contribute to beta cell death. So clearly we see that a large proportion of type 2 diabetic patients, the immune profile will give us whose beta cell will deteriorate, whose won't. And this is a approach to novel personalized medicine. Also, there is very good data now to suggest that there is a link between white adipose tissue, macrophages and type 2 diabetes. As we put on weight, and data from obese rats have shown that the pro-inflammatory state, TNF alpha, is a target. And it will have a role in obesity and type 2 diabetes. And as I told you, the circulating monocytes in the metabolic tissue and macrophages therefore can be used as surrogates when somebody gets type 2 diabetes onset. And you can actually decide who will switch and who will not switch. For example, we know sedentary habit, unhealthy diet, overweight are modifiable risk factors. Genes, ethnicity, aging are not modifiable. But the inflammation is now under scrutiny, whether it's type 1 diabetes or type 2 diabetes. And targeting inflammation can actually prevent and control disease and its complications. And we can actually target them. Here you can see a schematic representation of Raj ligand axis, and each of these last ligands can be blocked. At each strategy, we have very novel immune drugs which can block, and we'll look into data. So the data between inflammation and diabetes is clear cut. I don't need to talk about that, CRP, adiponectin, WBC count, and clearly you can see the odds ratio in meta-analysis. High CRP, high TNF alpha, high IL-6 and low adiponectin. So that is very well documented. And we know CRP is an independent predictor for heart disease from Scotland, and that was very well documented. High WBC count is associated with worsening of insulin sensitivity and develops and predicts clearly. So if your WBC baseline count is more than 6,900, from this large study, they showed it's an independent risk marker with a hazard ratio of 1.52 to actually look at whether your insulin sensitivity deteriorate or not. So simple basic indicators of inflammation can actually indicate how badly metabolic disturbance will ensue and what would be the hazard rates for diabetes and its progression. And even the DPP program showed us very clearly. And the link between TNF alpha expression and neutralizing that on insulin sensitivity is also very well known. So this whole meta-inflammation concept, even in the Indian population has been replicated, whether it's HSCRP, IL-6, and there's very, very good data to suggest now. There's international evidence for the last 2 decades to suggest that type 2 diabetes is an inflammatory disease leading to insulin resistance and beta cell dysfunction. And clearly intervening these pathways, can it be a way to treat diabetes? Well, can we use IL-1 blocker monoclonal antibody like anacarna? Can we use simple blockers like salicylates, etanercept, infliximab, the tocilizumab, the canakinumab? Can we use methotrexate to actually reduce some of these pathways and treat diabetes? And data has not been great. Tinsal was a study which was done with salicylate, and Alison Goldfein, she did this study. She's at Harvard. She's an endocrinologist. She's the daughter of Eugene Brunwald. You know that he's now 100 years old. He's a cardiologist. And she did this study which was published in Annals almost a decade back. And clearly you can see if you give salicylate, the WBC count comes down, the adiponectin levels go up, and the A1C is impacted. So clearly the Tinsal study showed that if you give simple salicylate, which is the equivalent of acetyl salicylic acid, it improves glucose and decreases inflammatory mediators. However, the cardiorenal signals and the outcome is not positive. Similarly, in metabolic syndrome, if etanercept 550 milligram twice weekly was given for 3 months, A1C mildly reduced. But the TNF alpha blockade failed to demonstrate beneficial effects on glucose metabolism and insulin sensitivity. And there was a small risk of myocardial infarction. So again, that got abandoned. The IL-1 blocker, anacarna, was also used in a double-blind placebo-controlled study with type 2 diabetes. Randomly giving 100 milligram anacarna subcutaneously daily versus placebo. A1C did come down, but the cost and daily injections did not merit it. And canakinumab, again, the CV events came down by 15%, but the drop of A1C was only 0.1%. So the results have been very, very poor. Methotrexate also was tried because they felt it's a good agent. A lot of rheumatologists use it. So this was a large trial which was published by Paul Ridker in New England Journal of Medicine in 2018 November, just before COVID. And in more than 4,786 patients with previous MA or multivessel coronary artery disease with type 2 diabetes, low dose methotrexate 15 to 20 milligram weekly versus standard care, they looked at the MACE. Unfortunately, the methotrexate did not result in lowering of IL-1, IL-6 and CRP, and the final endpoint was not significant, it was neutral. So obviously, the inflammatory pathway, though looks very attractive, a broader targeting was required. And probably the too selective targeting was not meeting the goal. This is the conclusion which came out. From India, we had a compound which has been approved by DCGI for diabetes mellitus called hydroxychloroquine. It got very popular during COVID time also. You know, it was first approved in 1955 to treat RA and lupus by US FDA. And You can clearly see that it was approved by DCGI in 2014 for diabetes mellitus, because probably it inhibits insulin degradation, reduces inflammation, improves insulin sensitivity, beta cell preservation. If a patient is contraindicated for a glitazone, a hydroxychloroquine is excellent sensitizer reducing inflammation, and you can still use it. I use it as a reserve drug. It's there in our RSSDI and ESI guidelines, but clearly we can use it as an option available. But today, as I told you, we are into cluster medicine, and every cluster needs a different drug. For example, in the autoimmune cluster, it's insulin. In the cluster 2 or SIDD, it could still be insulin or something else like a bigonide. But as the clusters move into the MAFLD space, MOD space, SIRD space, the SGLT2 inhibitors, glitazone, GLP-1s come up in the pecking order. And probably inflammation does have a role in the immune modulation of diabetic complications. Because we know complications are mediated and need validation by clinical trials. And complications occur due to glucose, due to fat, due to hypoxia, and clearly the pathways of retinopathy are well established. It's IL-1, IL-6, NLRP3. The metabolic liver disease pathways are TNF-alpha, NLRP3, IL-1, IL-6. Similarly is for insulin resistance and beta cell defects. IL-6 is for neuropathy, IL-1 is for nephropathy, IL-1 and NLRP is for heart failure. So for each pathway, the immune biomarker is different. So obviously when we are looking at a simple approach to inflammation and diabetes, there is a heterogeneity within diabetes, and look for monocytes and macrophages, because they are the ones who are likely to deteriorate. Look at immune system more critically, and look at the B and T cell alterations and who is vulnerable to get a beta cell loss or a insulin resistance. But food is equally important. As I conclude, food is equally important. And there's a lot of evidence based on anti-inflammatory diets now. Whether it is tomatoes are popular for different reasons now, political reasons, but there's a lot of science around tomatoes and lycopenes, fruits and nuts, different types of oils, leafy greens, fatty fish, and all the inflammatory foods which we consume, whether it's fried foods, the sodas, the refined carbs, the lads, the processed foods, including the foods which we will eat in this hotel, are all inflammatory foods. And it's very, very recognized that we need to eat better. It's also important to recognize that a lot of inflammation is mediated through frying in India, and therefore we need to cook in less oil. Don't reheat the oil. Use blends or rotate oils. And balance sat fat, PUFA and MUFA, all of them. We don't have an ideal olive oil here. Okay, but we need to have a blend of rice bran. And you need to use less than half kg per person per month in the edible oil. So clearly we know type 2 diabetes is rising in India. Whatever we are doing, we are still, despite of all these advances of modern medications, affordable, accessible drugs, we still see an explosion happening, and we still see a burden of complications, mainly mediated through inflammation. And there is abundant clinical evidence to suggest that this inflammation, though it's low grade, has an impact on obesity, metabolic syndrome, beta cell dysfunction, insulin resistance, and complications. So finally, of course, I always talk my mantra, whatever is the topic given to me, is that we need to be lifestyle gurus. We should not leave it to non-medical people to propagate lifestyle messages, because we have a larger evidence-based impact on that. So we need to eat slowly, we need to eat less, we need to be mindful of inflammation in the diet which we eat, we need to eat on time, we definitely need to do physical activity, do some yoga, sleep and smile, and we also need to do half an hour of digital detox before going to sleep and after getting up from sleep. And health is not just about good health and good outcomes, it's about less inflammation and happiness. Thank you for a patient hearing.
Thank you, Dr. Joshi, for your lucid talk. Diabetes, as we learn, is no longer a metabolic disorder. It is a immune inflammatory disorder, as you have explained so clearly. And the medications also immune related and inflammation related. Thank you so much, and the house is open.
Sir, during COVID, we saw lots of patients with shooting diabetes without any prior history, without any family history. So, is that due to the immunoinflammation?
Sorry?
Lots of COVID patients suffered diabetes, high shooting diabetes. So is it due to that immunoinflammation?
So there's good data to suggest that COVID virus itself is beta cell tropic. So people with COVID who never had any history of family history of diabetes and no history of diabetes in the past got diabetes and got stuck with insulin. Another group of patients got diabetes during COVID. They had pre-diabetes before COVID and they got unmasked during COVID. People who got severe COVID or critical COVID and got into the hospitals and got steroids or immune modulating drugs, they probably had worsening of their diabetes after COVID, and that worsening continued afterwards. So before COVID, if you see the mortality of diabetes and number of people dying with COVID, due to diabetes worldwide was 4 million people. And afterwards, from 2019 to 2021, when IDF came out with their atlas, the mortality in diabetes has gone up to 6.8. So clearly we see that COVID was a disruptor for care. COVID was probably a cause, and in people who were pre-diabetic or predisposed to diabetes, it was probably a further mediator to make things worse.
There were some subset of patients, those were cured of diabetes in some patients after COVID.
That I'm not aware of any publication in that direction. But probably what could have happened is if people have got better, they were probably the scared types or the paranoid types who became physically very active and did the right thing. See, there was a scare that if you have hypertension or diabetes, you are a vulnerable group during COVID and you are the ones who are likely to die. So people who suddenly went on a recoil mode and probably looked after themselves better may have done a little better. So those may be that cohort which you are talking about, but that's anecdotal. There's no published observation to suggest. In fact, all the published observations do indicate that there are 5 subtypes of COVID related diabetes, including a state like a flat blush diabetes where beta cells are also damaged.
Thank you, sir.
Is there any molecule in pipeline, anti-inflammatory molecule in pipeline for prevention of type 1 or type 2 diabetes?
So really from a inflammatory standpoint or meta-inflammatory standpoint, there is no molecule in the pipeline. But we can use a lot of molecules where inflammation probably is a pathway to explain things. So glitazones in the tripod, where troglitazone before it got banned, had best response in the diabetes prevention program. For example, metformin reduced diabetes by 1/3, lifestyle by 2/3, and the glitazone by almost 80%. So if you use probably a glitazone in pre-diabetes with a SGLT2 inhibitor and do a trial, both of them reduce inflammation, modulate the weight, maybe we'll have better outcomes. So we don't know. We need to do structured data and publish that.
Thank you, sir. Thank you so much. It has always been an enlightening talk by Dr. Shashank Joshi.
Before we start the next session, we would like to felicitate Dr. Nasengan. Please come on the stage. Thank you. He's there.
After this wonderful session, we come to the next master's talk by none other than Dr. Muruganathan, past governor of ACP India chapter. And to chair the session, I would like to invite Dr. Kabir Purohit, Dr. Saraswata Mishra, and Dr. Siva Prasad Dalai. Dr. Saraswata Mishra. Dr. Shrikant Dhar. Dr. Shambhu Datta. Dr. Shrikant Dhar is there. And Shambhu Datta. Dr. Shambhu Datta, please. Yeah, okay. Dr. Satish Kumar.
A very good evening to all of you. I welcome all of you in this session, and it's my privilege and pleasure to invite Dr. Muruganathan sir to deliver this lecture on lesson learned from COVID, the way forward. Dr. Muruganathan sir needs no introduction, and as everybody knows him, we are pleased to have you sir here, and please come on the stage and to share your thoughts with us and enlighten us with your thoughts. Thank you, sir.
Thank you, chairpersons. At the outset, I thank my brother Anuj, the scientific chairman Virmani and Narsingh Verma, that after the 3 or 4 master talks on diabetes, now we change the gear to come to COVID. I don't know why Virmani has taken me into COVID talk, but anyway, I always like to talk something different every time. My outline of the talk is going to be very simple. What are the lessons we learned? Public health, and then medical lessons, and then greater life lessons. The current scenario with new variants coming up, the way forward, of course, if time permits, something about long COVID and post-COVID, and further vaccinations. All of you know COVID-19, caused by the novel virus, has unprecedented global repercussions. It emerged in late 2019 and quickly spread worldwide, challenging the healthcare systems, economies, and daily life. You don't know who you are until you have faced real adversity. Don Gatsby. In this audience, how many of you have not got COVID? Only 2, 3, yes. So all of us got COVID. So we have learned a lot of lessons in personal life also. This is a great opportunity to learn some important lessons. Broadly speaking, we can learn a balance between independence and interdependence. That is there are many times when we need to take responsibility for our own well-being, and other times when we need to turn to others for help. When we depend on them and don't fully realize it, we can learn some lessons about life in general. There are some subjects we try to avoid thinking about, such as our own mortality and that of our loved ones. This pandemic is forcing us to confront these issues head-on. Looking at them in a different way may bring us some peace and acceptance. The public health lessons, importance of preparedness. The COVID-19 pandemic has underscored the critical need for robust preparedness plans at the national and global levels. Preparedness involves stockpiling essential medical supplies, developing response strategies, and investing healthcare infrastructure. Very important, resilience of healthcare system. The pandemic revealed vulnerabilities in healthcare systems worldwide. To build resilience, we must invest in healthcare workforce training and expand hospital capacity and improve supply chain management. And digital transformation. The pandemic accelerated the adoption of digital technologies. Telemedicine, remote work, e-learning become essential tools for maintaining essential service. Social and economic impact. The pandemic exposed deep-seated social and economical disparities. Vulnerable populations were disproportionately affected and highlighting the need for social safety nets. Coming to the healthcare resilience, of course, overwhelming healthcare system. Healthcare systems were overwhelmed, leading to shortage of hospital beds, ventilators, personal protective equipment, PPEs. The strain on healthcare workers was immense. And building resilience, to prepare the future health crisis, we must invest in healthcare infrastructure. This includes expanding hospital capacity, training and retaining healthcare professionals, and improving supply chain resilience. Lessons from vaccine development. Rapid vaccine development showcased the potential of scientific collaboration and innovation. In fact, never in the history we made a vaccine against COVID with such a short time. The mRNA vaccine technology demonstrated its effectiveness and versatility. And digital transformation, rapid adoption of digital technologies. Lockdowns and social distancing measures led to the rapid adoption of digital technology. In fact, we in the ACP India chapter was the first to start the digital. I started WhatsApp CME when we didn't have any Zoom. The first WhatsApp CME in India was started by ACP India chapter against the COVID and teaching about COVID. Telemedicine allowed patients to access healthcare remotely. Remote work became the norm of many industries, reduced the need for physical office space. E-learning platforms enable students to continue their education. In fact, everyone now starts using digital. Even now, online is a part of education now. And benefits and challenges, remote work and digital transformation, work from home is always now liked by so many lady workers who can do work at home. Challenges include cyber security, concerns and the need to address work-life balance issue. Of course, social economic impact, the economic consequences, pandemic resulted in job losses, business closure, all the 5-star, every hotels have a problem. Vulnerable workers in sectors like hospitality, retail were hit hardest. The pandemic exposed existing social disparities. Minority communities were disproportionately affected. The need for social safety nets, the importance of social safety nets, including unemployment. Governments implement economic stimulus package to mitigate the economic fallout. This is very important. Many times we say equity and equality. We think both equity and equality is same. No. You can see the picture, what is equality and what is equity. So we have to have both equity and equality and same chance to be healthy for everyone. So medical lessons learned is evidence-based medicine keeps changing as the time and disease evolves. By controlling comorbidities, like you heard Dr. Sashank was talking, when you have hypertension or diabetes or obesity, if you control hypertension or diabetes, the mortality in COVID was reduced. And there were a lot of discussions happening about whether to continue ACE inhibitor when you have hypertension with COVID with hypertension. And many people like nursing and all, we are talking everywhere, you should continue ACE inhibitor. Same way in diabetes also, whether to change or not to change. There's a lot of discussions. Then a pregnancy, whether to have vaccine. So many discussions were there. So we learned that, we should continue the same drugs irrespective of whether you're COVID or no COVID. And ACE inhibitor does not alter the prognosis. Trust and sharing their knowledge is the key. All the COVID articles were free and had open access. In fact, ACP headquarters periodically was giving ACP free articles, free webinars, podcasts, etc. And everywhere, everybody was talking more about COVID. And in fact, some of the WhatsApp messages are not correct. Myths and misconceptions were spread. Complete lockdown alone won't contain a pandemic. So these are some of the important things you should do as doctors and as people. We must do health education, how to prevent COVID, how to prevent infection, and health insurance. Many of us do not have insurance, and then you must insist that they should have health insurance. Especially when you go abroad, you should have at least those 20 days or 14 days health insurance that will cover if suppose you fall sick in the other country. Self-service is not selfish. We were talking about, you have to take self-care. Self-care is not selfish. You should always have balancing the family and profession. And Anuj Maheshwari was one of the well-being champion. Burnout issues were more in the doctors. So we developed, especially ACP, have well-being champions, and how to avoid burnout, how to balance family and profession was the main lesson. Safety in all aspects, including finance. You see, as doctors, as industrialists, as a worker, when you lose the job or when you have less rotation, all of us should know how to have safety in finance, in health, overall comprehensive safety. So safety is the key whenever there is a pandemic, whenever there is a disaster. We should not overuse anything. We learned that. Be it oxygen or steroids. Side effects are even more difficult to treat. You know about mucormycosis, pulmonary thromboembolism, then multiple inflammatory syndrome in adults, multiple inflammatory syndrome in children, and long COVID. Rapid development of vaccines and its equitable distribution through formation of collaborations like COVAX is very important. You know how to distribute vaccines, because sometimes you get vaccines, sometimes in the hospital you don't have. So vaccine distribution is very important. We are very happy and proud. From India, we exported vaccine to many countries. The greater life lessons. Now I come to the life lessons. This is also very important. Lesson 1, family is important. Family matters. Lesson 2, medical breakthroughs. Self-care matters. I told you self-service is not selfish. Be financially prepared. Age is just a number. Getting online for good. Working anywhere. Restoring trust. Gathering carefully. Because in those days, the marriages were happening only 30, 40 people. It was good for many families, because middle class families enjoy those period, because they did not spend much. Now in our place, Tirupur and Coimbatore, they spend exhaustively. Everybody is spending so much. In COVID time, only less crowd. The parents were very happy, especially the bride's father, because they have to spend less only. So gathering carefully, isolations, health toll, getting outside, wealth disparities, preparing for the future. Whenever you are in a bed, when you have COVID, you think about future, what to do for your children, what to do for our own selves. So that was another lesson we learned. And telemedicine. Now telemedicine, even the NMC has given a guidelines for telemedicine. Lot of us are doing telemedicine. And then cities are changing. Because of the COVID, there are a lot of changes in many cities. So another few lessons, life lessons, is how to enjoy life without spending lots of money. So you can spend your life happily when there is a lockdown. People started learning new language, started learning online course, started learning some new music, painting, writing. So they know how to enjoy in the house without going out. The second lesson is how to live on a smaller budget. Save money is food. See, whenever you have options, you go out and eat. But during the COVID times, nobody went out. They cooked at home. They saved the money by simple repairs also. They don't call the repairers. They do the electrical repair, everything. And YouTube has tutorials just about anything you can think of. And many people learn to cook, also bake. Because cooking is a skill everyone should have. Otherwise, you are completely dependent on someone else for your survival. Even Divya did not know cooking, but during the COVID time, she started learning cooking. And everybody learned cooking and baking. And being with ourselves, if you have to stay at home during the pandemic, you have to spend a lot more time by yourself. So mindfulness and meditation can help you significantly in this area. So mindfulness is a word which was all the time in the TV, everywhere. And mindfulness and being with ourselves was the lesson learned during COVID. I request Virmani to come and sit, because he is the one who gave me the challenge of learning lessons. I was telling so many lessons, but you were there outside taking tea, but it doesn't matter. Now at least you sit with us and give your comments. Relationship, how to get along better. the pandemic has forced to spend a lot more time with our loved ones. We did not go out, so we'll have to spend more time. You know, for example, Narasimhan doesn't sit with his daughter and grandchildren. Because of the COVID, he did not go out, so he spent more time with the loved ones, understood them. They had dinner together, breakfast together. So this is the time they developed a good relationship. You know your loved ones well enough to know what they like. You know, sometimes his anniversary, he's there somewhere in Lucknow. They did not celebrate the anniversary. But during COVID time, he was forcibly there. So relationship, how to get along better, that was the lesson also we learned during COVID. How to handle a crisis, being a part of the solution. Of course, pandemic, COVID-19 pandemic is a crisis like most of us have never seen before. So we were not sure how to react. In order to deal with crisis effectively, you need to understand the best you can and then determine what measures to take to deal with it as well as possible. Practicing love and compassion. This COVID has really helped us to practice compassion and love. We know the fear of death and sufferings of everybody, and we had opportunity to learn many good things during the COVID, especially compassion. And interconnectedness. You see, you cannot be without anybody. Just for example, you think you go to grocery shop, you buy something. Those grocery was made by whom? Who agriculturists, the marketing, things like that. So interconnectedness also we learned. And what is really important in life, we realized during COVID, being mindful of our health. We learned how to take care of our health. And then how to remain peaceful during difficult times. When you have stress and strain, we learned how we can remain calm and how to deal with loss. You know, so many people lost their loved ones, father, mother, even husband, they lost, or wife, they lost, son, they lost. So they know how to deal with loss. One of the things that brings me comfort when we lose loved ones is that they are at peace when they pass on. This is what the self-explanation. Then effects on children. What was the effect? Increased home cooking, increased consumption of sweets. They did a European survey. They found out a lot of obesity in children. They found out during COVID, they were consuming more chocolates, more pastries, more cakes. So increased consumption of sweets, obesity was there. They have a decreased playtime of physical activity. They could not go out, and then decreased playtime. Increased rate of childhood obesity, less interaction, and increased screen time. They were watching television all the time and watching computers. Language development delays. And then misinformation is the enemy of pandemic. There were a lot of misinformations in the COVID times. Why COVID vaccines cannot contain a tracking microscope, microchip, or make you magnetic. So many things, even in the abroad. I recently spoke to one of my friends in US, Orlando. Even his nurse did not take COVID. We are thinking that it will have complication. Then government of US sent a circular that everybody should take, and then they give a reason. Because of the religious reason, we are not taking vaccine. They accepted the explanation. So many misconceptions, misinformation is the enemy of pandemic, and that is a lesson we learned. So we must, as doctors, must propagate what is good for the health. Again, what a variant, lot of variants have come. It's nice, the pandemic is all behind now, we can get together again. You can see the step-by-step Alpha, Delta, Omicron, BA1, BA2, BA4, BQ, BQ1, XSB, XBB. Latest one is XBB 1.5. And in current scenario, new COVID variant is better at escaping immunity. And there was a lessons from various BPC news. COVID vaccines at care homes as BA2.86 variant spreading. And in the European CBDC, there was a new virus called Iris EG5. That is the currently spreading in UK. And they say it has different spike protein, it is immune evasive, increased transmissibility, mostly uncomplicated URTI, severe infection only in immunocompromised patient. The current vaccine strains may not protect against this variant. And long COVID or post-COVID, I've heard about it. What is long COVID? Long COVID is broadly defined as signs and symptoms and conditions that continue or develop after initial COVID-19 or SARS-CoV infection. The signs, symptoms, and conditions are present 4 weeks more after the initial phase of infection, It may be involving multi-systemic and may present with a relapsing remitting pattern and progression or worsening over time, with the possibility of severe life-threatening events, even months or years after infection. So now this is 1 in 5 was the old report. Now they say 13 to 15% of the people are having long COVID or post-COVID. As you see, it can involve neurological, kidney, musculoskeletal. Many people developed avascular necrosis. They have to go hip replacement. They had, as somebody said, they didn't have diabetes, they had diabetes. They have so many respiratory conditions, blood clots. All these things are due to long COVID or post-COVID. So post-COVID estimates was 65 million people worldwide and 15 to 20% of the long COVID symptoms. But many people with long COVID symptoms have limitations, but most are not significant. So synonyms of long COVID, they say long COVID, post-COVID, and the terminology are varying. And long COVID is not one condition. And these are the various things in how acute COVID and then post-COVID. It can be fatigue, dyspnea, then palpitation, thromboembolism, chronic kidney disease after week 12, hair loss. Many people had a hair loss, one of my doctor's wife completely hair lost after the COVID. So many things are happening after the post-COVID. And a word about the treatment. The Paxlovid is not there in India. We still use remdesivir. They were using beptilovimab, then also the monolovipir. So these are the drugs they tried. And recently in 2023 June, ACP has come out with this paper called Clinical Guidelines. I think those of you are interested to know about it, you can go to ACP website and you can download. They say practice point 1, practice point 2. They say to consider the Paxlovid, do not use ivermectin, do not use sotorolumab. So these are the guidelines from ACP in June 2023. And this is the chart algorithm. If you download it, you will see what is the best drug, how it proves. And there are evidence does not support use of SARS-CoV Omicron variant. Though we use it, these are the recommendations from ACP. And then cold vaccines, how many, what CDC says. Received previous mRNA dose, need 1 or 2 doses of updated vaccine. And then the WHO recommendation, take whatever vaccine is made available to you. So that was the WHO vaccine. The breaking news is CDC recommended updated vaccine. It's called updated vaccine. It's a monovalent vaccine. On September 13th, 2023, it was released by CDC that you should take updated vaccine. They don't call it as 4th vaccine or 5th vaccine. It's called updated vaccine. It's a monovalent vaccine. It's an mRNA vaccine. So I was talking to Elise Choya. You saw, she told yesterday that she had the vaccine. And I talked to Vidya Sundaresan, who was the speaker. She also had the vaccine. So we, myself and Anuj are going to US in October. She said she will arrange updated vaccine for both of us. It costs something like $90. But still, they say it's very good, safe. So updated vaccine is the recommendation by the CDC. So if somebody is going to US or UK, try this updated vaccine if you are interested to protect. It's a 4th vaccine or it's called updated vaccine. Very safe and lot of things. You see, CDC recommended everyone 6 months and older get an updated COVID-19 vaccine to protect against the potentially serious outcomes of COVID illness this fall and winter. Updated COVID-19 vaccines from Pfizer, BioNTech and Moderna will be available later this week. So it's going to come all over the world, and this is called updated vaccine. So one lesson we learned is still COVID is there, so updated vaccine can be useful. And now the way forward. See, strengthening the global health structure is the way forward. The pandemic demonstrated a need for stronger international cooperation. Initiatives like COVAX aim to establish equitable vaccine distribution, promoting remote work and digital inclusion, reducing social and economic disparities. Policies should prioritize accessible healthcare and quality education for all. Social safety nets and affordable housing programs can help bridge disparities. In fact, we from India exported many such vaccines to many countries, and we were pioneer and also role model in vaccination. So governments and business should invest in digital infrastructure. Remote work is possible. Now every company has got work at home. And then global cooperation, strengthening global health infrastructure. International collaboration is crucial for pandemic preparedness. Sharing research, resource, and expertise can lead to faster response. Equitable vaccine distribution, I already told you. Research and development from vaccine development should inform future research also. And then promoting remote work, the digital divide. The digital divide remains a significant barrier to digital inclusion. Governments and organizations must work to expand broadband accessible to underserved communities. There are a lot of benefits from remote work. You see, many people who has got your son and daughter working in US, they have come to India for 3 months, 6 months. They are able to work from home and they allow with us. And in fact, many of our family members are happy because they can come home and they can do work. So remote work can reduce commuting times, congestion, and environmental pollution. These are the good points. Employers should continue to offer flexible work arrangements. So these are the lessons we learned in the working with the remoting places and digital inclusion. And reducing social and economic disparities. I already told you equity and equality. Universal healthcare access is crucial for everyone. Policies should focus on reducing healthcare costs and improving accessibility. For everyone in US, the vaccine is free. And quality education for all. Education reforms should prioritize equal access to quality education, online education resource, and then robust social safety nets, including unemployment benefits and affordable housing, especially in places where migrant workers are there. They don't have home, so they did not have food. So people were given food also, and then supported, the industries have supported them. They have given the health insurance coverage. So equity and then equality was taken care of by the government as well as private industries. So that's the lesson we learned. In case of any emergency or any problem, they should have insurance coverage, and the companies pay insurance, and they also make sure they get their food. The way forward continues. Number one, need for pandemic preparedness. Everywhere, we must be prepared. If it is Jamshedpur also, something happens, Nipah virus has come. So if you have preparedness in Kerala, they do a lot of good things in Kerala. Unfortunately, only Kerala gets, such things, and they know how to control. So pandemic preparedness is important. Need to upscale public health and epidemiology to track infection threats. Development of guidelines. Today we had a guidelines of hypertension guidelines based on current data and making it a living document. This has to be evidence driven and avoid misadventures like HCQs. Should be followed by rapid training of healthcare personnel and audits to confirm compliance. So if you develop a guideline, you must make sure it is also trained and given enough education. And development of systems to promote multi-center trial and early access to therapy, especially those in development as part of unexpanded use of authorization. Central command to ensure judicious use of resource and manpower. Upscaling technology to meet challenges like drug development and diagnosis. You have to develop a lot of new drugs because every day the virus is evolving, changing. So we must also cope up with the virus because virus transforms and mutates so fast. We must also have the technology to change the drug as and when the mutation occurs. And then use mask when and wherever appropriate. In fact, I see in a flight, at least 10% of the people still wear mask. The Indigo announces that you should wear mask. But now we don't wear mask. Actually by wearing mask, there is a carbon dioxide toxicity and things like that is propagated more than the use of mask. Joint efforts to update vaccines, including the latest strains like influenza vaccines every 6 months. You should make a culture or habit that they should promote vaccination. And many of us, though we know healthcare workers, we don't take influenza vaccine every year. We are supposed to take. And it's going to be like this for like influenza every year, the strain will change. The vaccine also you have to change. So as a healthcare worker, every year you should take influenza vaccines. Something like that may happen in COVID also. Setting up of long COVID clinics for long-term follow-up. Many people, they should have, I heard from Jayant Panda in this college, Jayant Panda started a long COVID clinic. So all patients, COVID patients, they go to long COVID clinic or post-COVID clinic where multi-speciality people are there. They analyze and they treat and advise. So what are the responsibility of the healthcare worker? Above all, we must empathize, honor your community, pursue your passion, expect the unexpected, persist, persevere, prevail. You are living to serve, live to serve, passion to serve. You lead by example. You see, when you take the vaccine, tell them, and then be a lifelong learner. Every day, new things are coming. You should be a lifelong learner. Forge partnerships. Revere the truth. Always, there are a lot of myths and misconceptions. You should appear in television. You should write in the paper what is important. Then, as Anthony S. Fauci, who says, it ain't over till it is over. But it's never over. See, COVID is, or anything, it's never over because emerging and re-emerging infectious disease are always there. So, it's still not over. And Anthony says, it's time to move forward from COVID, though we have a lot of problems. And key takeaways, you summarize the essential lessons learned from COVID, highlight the potential for positive change in healthcare, technology and social policies, and pathway forward, empathize the importance of applying these lessons to create a more resilient and equitable future. Thank you for your featuring. I think I completed on time. So, Virmani, I think you should be happy that actually, I saw lessons learned. Everybody seeing so many other medical lessons. I thought personal lessons, physical lessons also important. Yes, I've touched that also. So thank you very much. And if there's any question, I'll be happy to answer. Otherwise, yeah. Also yours, no?
Thank you, sir, for the lucid presentation. I think he has given in a concise for social and medical aspect both, and his experience as well. Thank you, sir, again. But one question only, whether the new updated vaccine has any immune escape for the Aries or the XBB variety. Any data, sir?
No, as I said, it was announced in CDC on September 13th, and this vaccine is a booster vaccine. It can cover all the virus. So this was introduced only last week, and no data has come. But the idea is a monovalent antibody vaccine, and it's useful, no side effects, and it's good for all the strain. This is what they told me. I have to go through again. And we are going to have the injection probably October when we go. I think we'll have that vaccine also. No side effects. And they are very sure it's good. And for 6-month children also, it is used.
Sir, one more question. Sir, actually long-term COVID have a lot of sequelae. What are the effect on fertility of the patient?
No, as I said, it can involve any system. It can be neurology, it can be cardiology, it can be throat. As I said, I've got so many patients who developed avascular necrosis of the hip bone and they had hip replacement. We don't know why. And there are so many complications happening. So anybody who has got problems after 4 months, then if they have problem, to think about long COVID or post-COVID. I said, some people have lost hairs suddenly. And surprisingly, somebody asked a question, after COVID, diabetes is cured. I don't know. This is a good thing to know. But after COVID, so many good things happen in the family. The family get together and family unity is better. And there was a statistics. What is the divorce rate after COVID? In India, divorce rate has come down, but in other countries, divorce rate went up. So many lessons we learned. Thanks.
Thank you so much, sir.
Yeah.
I request Dr. Murugathan to facilitate our chairperson. Please.
It is my pleasure to invite chairpersons for our next session, Misfortune of Aging, Dr. D.N. Maharana, Dr. P.K. Rathore, Dr. Sridhar Panda, Dr. S.K. Sonkar. Dr. Ajay Kumar Verma. Over to chairpersons.
Yeah, thank you for giving us the opportunity. So may I please invite Dr. V. Chandrasekhar for his topic on challenges in examination of elderly. Dr. V. Chandrasekhar.
Laptop is best. This one. This is
Shall I go? So good evening all. At the outset, thank slides. So at the outset, I thank Dr. Anuj Maheshwari, Dr. Muruganathan, Dr. Viramani sir, and all those giving me this opportunity. So after the legends talk, now we are changing the focus for elderly geriatrics. So I am talking on the challenges in the examination of elderly. So whenever we call it as an examination, physical examination, it is apt for the theme of this year conference and art and science of medicine. So we are progressing science-wise, but art is taking a back step. So that we have to restore. So whenever care of elderly comes, it is not the same as pediatrics. Geriatrics need to progress further, and Jericon is also going to happen in this weekend at Delhi. And elderly care is fulfillment of the special needs requirement unique to senior citizens, and it all should be done with respect, engage and enjoy. So aging refers to inevitable, irreversible decline in the organ function without any injury, illness, environmental risk. So initially there will be only the first manifestations of reduced capacity, functional capacity. But here in the functional capacity, cardiovascular system, renal system and central nervous system are the most vulnerable in elderly. These are called the weakest links. So because of these weakest links, there are so many geriatric specific complications put together as geriatric syndromes. So this will have some impact whenever you want to see geriatric patient. So because a delirium may complicate pneumonia and urinary tract infections. You can't understand which is causing which. And falls may cause dizziness, syncope, or urinary incontinence. Weight loss that often accompanying in minor illness with the older adults. Sometimes it may not be significant also. So aging organs are also more prone for susceptible to injuries. So like that intracranial hemorrhages is more common. So life expectancy in men is additional 17 years at the 65 and 10 years at the 75. So in the women, it is 20 years at 65 and 13 years at 75. Overall, women live 5 years longer than men in US and 7 years longer in worldwide. And India, I think it is 10 years. So the difference of survival have changed little despite changes in the lifestyle of the women also. increased smoking, increased alcohol, increased stress, all these things into the latest century. So here, whenever we want to examine the geriatric patients, you need to understand what are the physiological changes which are normal. So, but there is a big list is there. So I will skip for want of time, and I'll summarize what are the physiological changes. So we know that decline in all 5 senses: vision, hearing, touch, taste, and smell. So this will have its own impact on the multiple systems. There is a lower muscle mass, sarcopenia, bone density, osteoporosis, and ligament elasticity, which all may contribute for the falls. And there is some amount of the atherosclerosis and arteriosclerosis, which may cause the pseudohypertension. So there is increased risk of comorbid conditions, because we know that higher incidence of cancers happens, greater likelihood of the chronic diseases, and there is a cognitive changes also. With these age-related changes, we have to examine older patients. So, evaluation of the older adults is always challenging. Usually, it differs from the standard medical evaluation. For older patients, history taking and physical examination may have to be done at different times, and physical examination may require 2 sessions and more. So, older adults are different, often complicated with healthcare problems. One is multiple disorders and polypharmacy. And early detection of the problems are delayed. If the early detection is there, you can intervene early so that the improvement in the quality of life will be there. So particularly the frail and chronically ill are evaluating best by what is called as a comprehensive geriatric assessment, and comprehensive geriatric assessment will have so many domains like daily functional abilities, instruments of daily functional living, and assisted devices, and caregiver, drugs, what they are taking, nutritional status, and cognition status affect advance this thing, and substance use and abuse, caregiver use and abuse, and gait and balance disorders, sensory functions. So there is a list is there, big list. So that is a mandatory for comprehensive geriatric care. So coming to the components, so multiple disorders. On average, older patients have 6 diagnosable disorders at the same time. So a disorder in one organ can weaken other system, and multiple disorders complicate diagnosis and treatment, and sometimes it is magnified by the social disadvantage that may lead to isolation, and that may lead to the poverty, because the patients outlive their resources and supportive peers are less, and functional and financial problems will occur because of the multiple disorders. And the patient who have the multiple disorders and treatments has to be integrated very well, so which cannot be possible if you have a prudence in examining the elderly patients. And in the elderly, what happens, there are many missed diagnoses and many delayed diagnoses. So disorders that common among the older adults are frequently missed. Early diagnosis of frequently depends on the clinician's familiarity of that patient's behavior, history beforehand, and you have to know the mental status examination before, otherwise you have every chance of missing the early diagnosis. And first signs of the physical disorder are not physical, so they are behavioral and mental and emotional symptoms will be prevailing. So polypharmacy is the principal drug safety issue in elderly. So polypharmacy is defined in number of ways: too many medications, more than 5 or 6, are inappropriate medications and bad combinations. So a person over 65 are usually taking 6 to 8 medications, and if the multiple consultants are there, 6 or 7 consultants will write 6 or 7 types of B complexes. So that itself will be adding. So because of this, there are so many adverse events, over the 7 lakh emergencies because of this polypharmacy happening every year, out of which 1,20,000 will be hospitalizations. And So there is a solution for polypharmacy, what is called as the brown bag events. So bring all the medications which are used in the brown bag and take a list of medications, and the pharmacist will look out, are there any concerns with side effects or not. Then the prescribing doctors will have a medication review, so that it helps a lot. So there are 3 Ds which are very common: delirium, dementia, and all those things. Delirium is a transient acute confusion. Sometimes it is very difficult to diagnose because there are 3 important contributing factors for the delirium. One is infection, another is trauma, and medications. Until unless you carefully see, the infection cannot be found out, a trivial trauma is ignored, and these medications, which are drug-drug interactions, are all problems. So always keep on these 3 factors to diagnose the delirium. So dementia is the second of 3D. So dementia is the insidious memory loss, intellectual impairment, and loss of emotional control and problem-solving ability. So one common thing, Alzheimer's disease, so there is a disruption of the speech and difficulty in finding the words. That is the only symptom, difficulty in finding the words. Otherwise, so all other mental functions will be normal, including the orientation. Orientation will be never changing in the elderly. So the dementia is a very great problem. 5 million people are currently living with, and 50,000 deaths are attributed to this dementia. So because of this reason, any physical examination in the elderly must a mini mental status examination should be done first. And the depression part is there. So until unless you diagnose the depression in the elderly patients, so very difficult to bring out the symptoms and signs. So it is 1 in 5, and 80% of all the depression is completely treatable. So one of the top 10 causes of death in elderly people. So significant risk factors for the developing depression is chronic illness and chronic pain. So the poor diet and poor absorption of the vitamins is also one reason, and there may be some emotional liability will be there, loss of spouse, friends, and peers. So depression, geriatric depression scale is there. You can keep on dashboard so that you should not miss these 3 Ds. Otherwise, your subsequent examination will be a big mess. So common comorbidities will be there: heart disease, stroke, heart attacks. The women don't always follow the rules, because here they will present in atypical presentations. Uncommon symptoms, uncommon findings of the common diseases. So the musculoskeletal pain may be having a complications, arthritic changes, spinal arthrosis, osteoporosis, and it could be a metastasis. So you cannot take musculoskeletal pain as this one. So history taking, more time is needed, because so there are sensory deficits, there is underreporting symptoms, because the patient himself is telling that it may be because of my age, and unusual manifestations of diseases. Because of these 3 reasons, the patient may not be giving the proper history. So functional decline is also only the manifestation of the underlying disease. So the cardiac reserve is come down, so his memory is come down. That may be the only disease. So here, so coming to the functional so the basic activities of daily living, ADLs and instrumental ADLs, must be assessed. Even without, there is no diagnosis of the disease is there. So there may be the problems of difficulty in recalling. There is a fear of hospitalization and age-related disorders, as I enumerated, the depression, discomfort because of the disorder, and impaired cognition. So a clinician knowledge of the older patient's everyday concerns is the primary backdrop, so that you can succeeding in geriatric physical examination. Mini mental status examination done early in the interview, and routine screening of the physical and psychological factor should be done. Last but not least, and it should be encouraged that the patient alone should be interviewed, because so many personal matters cannot be revealed unless some other mental status problems are there. So last but not least, there is a drug abuse. So alcoholic abuse may be there, and there may be a patient abuse by the caregiver also. So these are to be Well, caregiver problems are like if you see the frequent bruising, grip bruises, bruises at the genitalia, peculiar burns, unexplained fearfulness about the caregiver, so maybe all indicate the patient abuse. Coming to the physical examination, patient will be easily fatigued, so that you need to require additional time, and you have to conduct in a two sessions. So examination table should be appropriate. Frail patient must not be left alone on the table, and protective padding and bedside rails should be appropriated. And observing the patients and their movements about their personal hygiene is a important role in comprehensive examination. General appearance of the patients, like whether comfortable, restless, because these verbal, non-verbal clues can give you about whether patient is having depression. In the depression, lowered voice, subdued enthusiasm, even tears will tell you. Physical, mental health, if you ask directly, you may not get. Ask about the sleep and appetite, and weight gain or weight loss. Any change in the fit of the cloths or dentures will give you this thing. So the vital signs, taking the weight also should concentrate on the grab bras are there or not. And height should be recorded annually, because osteoporosis is the one important reason height will be lost. And temperature should be recorded, but absence of fever does not exclude infection. And BP may be overestimated in elderly people because of arteriosclerosis. So there is so much of pseudo hypertension. So, and orthostatic hypertension must be excluded by measuring supine and standing. And mini-mental status I have told you, but orientation may be normal in many patients with dementia also. Only abnormalities may be there in the consciousness, judgment, calculation, speech and language, but orientation will be lost. Nutritional status is also very important. Aging can alter the height, and weight changes can reflect the alteration in the nutrition and fluid balance and both. But BMI is useful in elderly patients, but it underestimates the obesity. So waist circumference and waist hip ratio is the best to assess the nutritional status. So you have to head to toe examination you have to do, but these I skip for want of time. So many things are there. So the digital rectal examination, fecal occult blood, anorectal area, in the reproductive system as to prostatic gland. So all these things, bimanual pelvic examination. So musculoskeletal system is very important, and feet examination is important. Coming to the neurological system, cranial nerves, because many special senses are there. So motor function is very, very important, because unless the muscle strength is there, it is very difficult. So, but muscle strength, weakness in the weakness in symmetric, then only it is very important. And the weakness which is causing the functional disability, so that is very important. You have to pick up, and then it is treatable by resistance training. Muscle tone is also sometimes increased normally also. So sarcopenia is a common age-related problem. So in the hand muscles, weak extensors. So if you touch back of head, so all these so many tests are there. So coordination, gait, and is very important for the fall risk assessment. Reduced movements in some joints will be there. Slight changes in the walking posture. People with gait velocity reduction 1 meter per second is directly related to the mortality increase. So reflexes, there may be some changes, some causes of gait dysfunction, and again coming back to the principles of elderly care with respect, engage and enjoy. And here the effect of aging must be taken into account during the diagnosis, examination and treatment of the older patients. A clinician should not mistake a pure aging for the disease. Like a slow information retrieval is not dementia. And clinicians should not mistake a disease for pure aging. So a debilitating arthritis, tremor or dementia to the old age also. Clinicians should not ignore the increased risk of the adverse drug effects. So always consider whether any polypharmacy is there. should not forget that older adults often have the multiple underlying problems. So one diagnosis doesn't complete the examination. So clinicians should alert for diseases and problems that are more common in elderly adults like diastolic heart failure, Alzheimer's, incontinence, atrial fibrillation. And one more important point I want to emphasize is ageism is different because aging is different. Ageism refers to the prejudice against the people of elderly age. Healthcare providers, we clinicians, should not affect the bias by not offering the treatment, because sometimes we misdiagnose this could be a part of your aging. That should not be. So, older adult, but based simply on their age rather than other factors such as life expectancy, quality of life, and patient preference. So, here, if you are not missing the aging and normal problems, and not having prejudice for the age and their normal age problems, should not be. So thank you very much for your patient hearing. So elderly people are our asset. Love them, care them, help them live their lives with dignity. Thank you very much. And soon we are going to celebrate International Day for Elderly, 1st October. Thank you very much, sir.
Thank you, sir. So in elderly, it is like children, okay? You have to be very careful, but some relevant examination should be done, because some important things like prostate and patient doesn't remember also his history also. So some relevant examination for the sake of the audience. What a relevant examination should do means 1, 2, 3, 4, 5. This should be done.
Agreed, sir. So, but usually when we want to examine like other normal adult, so because of these particular problems, we need to change our routine way of this thing, and definitely chair raising test, and they're putting their hands behind it, and the mobility around the joints, and whether these orthostatic hypotension, there are special tests are there, but in the exclusive list I have mentioned but not told. So I can give the slides, and it is mentioned in many of the manuals, sir.
Thank you. Next speaker.
Thank you, sir. Thank you very much.
I would like to invite Dr. Vinod Mittal to deliver his talk on managing older people with frailty and multimorbidity.
Very good evening. I convey my thanks to Dr. Anil Virmani, Dr. Anuj Maheshwari, and Dr. Jayant Panda, and the entire organizing team of ACP Internal Medicine 2023 conference. It's my proud privilege to be here, and I would be sharing my knowledge on basically managing elderly with frailty and multimorbidities. It's not moving. Can you make it full screen? Yeah. Okay, so, the screen was not moving. So I would be basically, discussing managing elderly and with frailty and multi-morbidities. Now, the definition of frailty is basically, it's a multi-dimensional geriatric disorder, which is not only physical. We think it is only physical. It is physical, physiological, and cognitive reserve decreases with aging. So all three systems have to be declining, leading to increased vulnerability to adverse health outcomes. So the risk of adverse health diseases increase, and the outcome also goes down. And sarcopenia is the hallmark, which is, basically the muscle mass and strength as well as function goes down with aging. And this is, there's not enough, muscles are not strong enough to strain pressure or for strenuous efforts. And there is inability to cope up with everyday stressor, ultimately leading to functional disability. So basically, we have to understand this, that it is not just one problem, it is a multi-dimensional problem, and it has to be tackled at all levels, the physical, physiological, and cognitive. Now, other important point is that global prevalence is going up. Since the aging population worldwide is going up because of newer innovations and better medical treatment, so 10% of people more than 65 years have frailty worldwide as per NHS data, and people who are more than 85, it's around 25 to 50%. So this is quite significant, and India also we can see the graph is it's going up. So more and more number of people are having now frailty. Now basically here also we can see pre-frailty is a condition like pre-diabetes, and we can reverse, we can make the person normal. So this is a stage where we have to, intervene and take proper measures so that, patient does not progress to frailty, which is around 24.7%. So pre-frailty is 62.7%, quite significant. The problem is we never diagnose, and we diagnose only when patient is having a clear-cut frailty and when it is kind of, a non-reversible or a permanent damage. And we can do only a supportive management at that point of time. Overall, the risk factors are aging is just one, but lifestyle, environment, and diseases. If a person has multi-morbidities, CKD, CVD, heart failure, then definitely there would be more frailty. And then if we see this, basically, as we grow old, the muscle mass goes down, the fat mass increases in general, and there is also inflammatory system becomes active, and that is why with aging we also develop diabetes. So we have to address this inflammatory component also as we grow old. And the signs are basically weakness, weight loss, unexplained weight loss, exhaustion, low activity, and slow performance. And ultimately this leads to falls, disability, dependency, surgical risk, and death. So this is basically, a vicious cycle where basically, we can see that metabolic syndrome, we know there is an inflammation, there's insulin resistance, there's a chronic inflammation, underlying disease like CVD, hypertension, chronic diabetes, as well as heart failure. Ultimately, this all leads to cachexia, sarcopenia, and similarly decreased activity, environmental factor, decreased protein intake also lead to weight loss, and ultimately this leads to sarcopenia, frailty, and decrease in strength and speed. Now we can see there's a vicious cycle again, inflammation on one side, oxidative stress, and aging. All this lead to, there is a multi-organ dysfunction with aging. It's not only the muscle strength which is going down. Inflammation leads to inflammation in the cardiovascular system, in the endocrine system, as well as in the skeletal muscles and respiratory system. So ultimately there's a multi-system dysfunction. This point has to be understood well
it is not just one system, it is a multi-system problem, and we have to address all the systems. Now, this is the beginning. Patient is very fit, then patient is well, patient is managing well, and then patient becomes vulnerable. We can see with the stick, but patient is doing normal activities, and slowly this goes on increasing, and we can see moderately, mildly, moderate, severe, very severe, and patient becomes almost, bedridden or handicapped, and, it becomes really, a burden of not only for the patient, for the family, and it is totally a, terminally ill, a patient, and patient is totally dependent on other people. So overall, there are different clinical, basically frailty scores. Many scores are available, and they are well validated, frequently used scoring system, which depends on basically the activities of daily living, and mainly, 4 or 5 questions are there, like do you need help in doing, routine work, in, passing motion and having food, walking, going outside, how many times you go outside, and depending on that, you make a scoring system. Now, if the scoring system is, we can see here, like depending on this system, like 7 to 8 is severely frail patient, while 1 to 3 is mild. So once we make a diagnosis, whether it is pre-frailty or it is mild, we can take proper precautions, intervention, and we can make these people totally reversible condition, like reversibility of diabetes and hypertension, we call it. So it is not totally reversible, but at least we can make them self-dependent and do independent activities. Now, as per International Association of Nutrition and Aging, there are 5 components of frailty. One is a slow gait. The second is a weak grip. So this slow gait is 4-meter walk test. The second is weak grip. That is, basically, as a resistance done with a dynamometer. Low levels of physical activity, which is generally self-reported. Fatigue is again self-reported. Unintentional weight loss more than 5%. So these 5 components have to be there generally when we diagnose patient is having frailty. Now, even there is an electronic frailty index, which is basically, again to identify biological, psychosocial, and social deficit. So again, when we treat these people, we have to take all these into account, the psychological aspect as well as the social aspect. And 7 is a severely frail, which is, when patient is totally dependent on personal care, and 8 is severely frail, very severe, when this patient is approaching end of life. So this is important to basically always use a scoring system depending on some symptoms and signs. Then we can have other, is a 5 illness frailty index, which depends on 5 different diseases like COPD, pneumonia, CHF, and then, functional status, hypertension, and diabetes. So this is another, illness frailty index. Now, these are different other basically frailty scales. We don't use them, all of them, but they're all depend on basically physical activity, mobility, energy, cognition, disability, medication, health, nutrition, strength, comorbidities, then incontinence or continence, weight loss. So basically, whenever patient has frailty, it starts with robustness when you are normal, then there's a pre-frailty, and ultimately there's a total disability, functional disability, and up to this level, it is reversible, while beyond this, it becomes irreversible. So intrinsic capacity is the most important thing to be judged, and initially this resilience is there. Patient, our own body reacts, and we try to achieve normalcy, but when disease progresses, patient becomes frail and vulnerable. So the different stages, as I told you, mild when it is isolated organ, maybe only muscles, maybe only one cardiovascular system, and slowly multiple organs, like we can see here, kidneys, heart, brain, vessels, muscles, all the systems are involved, and patient becomes totally bedridden. So that's how the disease progresses, robustness to pre-frailty to frailty and to disability. Now, this is multi-morbidity basically in India. Almost 32.1% of older people have multi-morbidities. In Kerala, the prevalence is highest, around 60%, and it's more in women. And the conditions generally are hypertension, arthritis, thyroid diseases, CVD, heart failure. So overall, we can see these are all multi-morbid conditions which patient can have. So disability, frailty, and multi-morbidity, there is again an overlap, and patient becomes, ultimately they are bedridden. So what I want to convey, that we have to tackle all separately and simultaneously. At the same time, it's not only that you are only focusing on sarcopenia, no. So on arthritis, on COPD, heart function, heart failure, everything has to be tackled at the same time. Now, meta-analysis has shown of 48 studies, including 80,000 participants, that 7 of 10 patients who are frail have multi-morbidity. Multi-morbidity is very common in frail patients, and we have to basically, do intervention at a stage of pre-frailty. This is algorithm for find out sarcopenia, which is a totally a different topic itself. But in short, one is measuring the gait speed, more than 8 meters per second or less than 8 meters per second, then hand grip, normal or this thing, and then sarcopenia. So that's how these are the basic thing. But there are many tests. So that's a separate entity altogether. So overall, sarcopenia on one hand, frailty on other hand, and this is an overlap. So overall aging, inadequate intake of proteins, low physical activity, endocrine disorders, immunosense, chronic kidney disease, comorbid conditions, they all occurring together. Polypharmacy. Now, patient is frail, multi-morbid conditions, but at the same time, patient is also having multiple medications. And there, sorry, and there are side effects of these medications. So, one end we need medications to be given, other end we want to stop medications. So we have to be very, very careful which medication is actually required and which one is not required. So this is basically for diabetes. Now there is a mitochondrial dysfunction, there is a sarcopenic obesity, hormonal dysfunction, inflammation, oxidative stress. In diabetes also, it is not only diabetes, it is obesity, nutrition, inactivity, and hyper and hypoglycemia, cognitive impairment. Now patients with heart failure who have multiple, frailty also, 25% of these patients are more susceptible to fall and cognitive impairment because of decreased cerebral perfusion. So, frailty is a powerful marker of poor outcome in heart failure patients. Heart failure patient as such, the outcome is very poor, but if patient is old and frail, the outcome is very, very poor. So management has to be individualized and tailored, and we have to include 4 different aspects. One is physical, psychological, cognitive, and social. So it is not only physical aspect which you are considering, it is psychological also, cognitive and social. So multi-pronged support has to be there. So there is a primary prevention to maintain the robust state, otherwise from pre-frail to at least back to normal, and then tertiary prevention. When everything happens, you are giving only supportive management. Now, as per ESC heart failure guidelines, supervised exercise-based cardiac rehabilitation program in patients who are frail with multiple comorbidities is advisable. Then intense exercise therapy is a must. Exercise training is very, very important. So we, every time, but despite of saying it is very difficult to follow exercise for lifelong. Now, what kind of exercise? It has been seen intensive exercise, intensive resistance training is very important, which is very difficult in old people, but it has been seen, we can see physically disabled, frailty, pre-frail, robust. Now we can see the effect of whenever we are, there's always an increase, like exercise, resistance exercise goes down. In patients who are robust, they can do more, while patients who are frail, they can do less. There are many clinical studies which have seen the effect of physical exercise in older people with frailty. Diet and nutrition. So this is another important aspect that we have to be, kind of looking for vitamin D supplementation, then folate supplementation, iron replacement. Generally, these are neglected, aspects. And we can see there are studies of these vitamins and nutritional supplements in elderly population, and RCTs are also there. So vitamin D especially, and then, creatine, DHEA, omega-3 fatty acid, and then, walking, cobblestone walking and resistance training are very, very important. So the takeaway messages are very clear that frailty is quite common. It is a multi-dimensional geriatric syndrome characterized by not only physical, but also physiological and cognitive reserve. All three, they go down. And this increases the vulnerability of that person for adverse health outcomes. Prevalence is nearly 10%, more than 65 years, and it is 25 to 40% in more than 85 years. Routine and meaningful assessment of elderly people is very, very important, especially the assessment of multimorbid conditions, because, and then multimorbidity leads to polypharmacy, more adverse outcomes, more adverse effects of these medications. So we have to be very careful here. Enhancing intrinsic capacity is important through various strategies like physical exercise, nutritional supplements. So we have to have a multi-pronged support system and interventions to prevent frailty with multimorbid conditions. And more intensive resistance training is important. And overall patient-centered personalized intervention is important, like we do for hypertension and diabetes. And we should include not only physical, but also psychological, cognitive, and social aspects. So with this, I conclude my talk and I convey my thanks to all of you.
Sir, I have one query. In one of the score you mentioned in your talk, COPD and pneumonia have been taken. I want to know what is your take on other chronic respiratory diseases and this frailty and multimorbidity.
Actually, this was only
like
to mention.
Interstitial lung disease and tuberculosis.
This was only to mention too, but any chronic condition, whether it is involving the lungs or cardiac or diabetes or any other organ like kidney, which is remaining for a lifelong, is very, very serious. So generally in pulmonary, if we talk COPD is again, asthma is again a lifelong thing, and pneumonia sometimes they leave a post-pneumonic fibrosis. Otherwise, like tuberculosis and others are totally curable. So, but anything which leaves a scar, which leaves some kind of deficiency, gets included, because that will decrease VQ mismatch, decrease oxygenation, and obviously more oxidative stress.
What about, sir, the GI symptoms also, like the poor appetite, poor intake, all these things are there, because we think about cardio, renal or brain, but this GI symptoms is also
So-
very, very important.
Yes, you're absolutely right. So overall, if we see, elderly people have less intake, total appetite is less, so diet is also. So we should increase protein intake. Keeping in view, obviously, the renal functions, but overall protein intake is very, very low, and sometimes in these people, we have to give a supplementation. We have a lot of supplements, good supplements, which have whey protein and other good proteins that should be given, along with exercises. Both are important. But definitely, if somebody has got stage 4 or 5 CKD, then you have to restrict. Otherwise, you can give normal and you can supplement. Okay, thank you.
Thank you, sir. Good afternoon to all. Our session is the misfortune of aging. Now the topic is how to fight sarcopenia while being older. The topic will be presented by Dr. Anil Kumar Birmani. Number 2. Slide show कर दीजिए. Number stick. इसमें नहीं. Yeah. Honorable chairpersons and good evening, friends. My topic is on sarcopenia and how do we tackle while we get older. Of course, there is a lot of overlap between what he said, but I am going to go more into specifics of sarcopenia. After hearing Dr. Sathu's talk today on exercise, I realized I am a potential candidate. We all know that sarcopenia is a progressive and generalized loss of skeletal muscle mass and strength, and this is correlated with physical disability, poor quality of life, and death. It was way back in 1989 when Rosenberg proposed this name, sarcopenia, from the two Greek words, sarx meaning flesh and penia meaning loss, so loss of flesh. Although primarily a disease of the elderly, it may be associated with conditions not exclusively seen in older patients. We all know that we start losing muscle mass right by the age of 45 or even less, but after crossing 50, the loss of leg muscles is almost 1 to 2% per year. Loss of strength is 1.5 to 5% per year, and that has been reported. It has also been called skeletal muscle insufficiency or failure. Now, we just had a talk on frailty by Dr. Vinod Mittal. The phenotype of frailty that was described basically by Fried and co-workers has a lot of overlap with sarcopenia. There is low grip strength, slow gait speed in both. The weight loss criteria is also important in both. Treatment like physical exercise, optimal protein intake, vitamin D is same for both. But then what is the difference between sarcopenia and frailty? Frailty is a geriatric syndrome, whereas sarcopenia is a disease. Whereas sarcopenia contributes to frailty, the latter represents a very broader concept. So it is important to realize that here we are dealing with a disease and not with the normal aging process, which basically gives us an idea as something we can prevent. We cannot prevent aging, but we can prevent sarcopenia. That is important message that I want to give you. The European Working Group on Sarcopenia in older people have put 3 criteria. There should be low skeletal muscle mass, low muscle strength like hand grip, and low muscle performance like walking speed or muscle power. If it is characterized by only low muscle mass without any impact on strength or performance, it is called pre-sarcopenia. In the revised guidelines, it was said that strength is better than mass in predicting adverse outcomes. So the latest criteria operational guidelines says, criteria 1, there should be low muscle strength, that is possible sarcopenia, low muscle quantity or quality, you confirm the diagnosis, and low physical performance leads to severe sarcopenia. The International Working Group added one more thing in that it may be associated with muscle mass alone or in conjunction with increased fat mass. And that came to the term sarcopenic obesity. The prevalence is almost 5 to 13% in 60 to 70 years, 11 to 50% in more than 80 years. And sarcopenic obesity basically means there is a reduced lean body mass in the context of increased adiposity. Obesity itself exacerbates sarcopenia, increases the infiltration of fat into the muscles, lowers physical function, and increases risk of mortality. If you look at aging, sarcopenia, obesity, there is a very strong connection. As far as the muscle mass is concerned, the decrease in physical activity and increase in the lipotoxicity and dysfunctional adipose tissue, oxidative stress in obesity. And that is what leads to sarcopenic obesity, insulin resistance, mitochondrial dysfunction, inflammation or inflammaging, adipose tissue dysfunction, and low quality of muscle. Gut dysbiosis has been considered to be one of the contributing factors. Sarcopenic obesity has been associated with cardiometabolic disease, liver disease, arthritis, mental health, as well as pulmonary disease. So it is encompassing a lot. It may be primary if it is age-related, or it may be secondary due to vascular, hormones, neuronal, weight loss, or pro-inflammatory cytokines. If you do a biopsy, there is reduction in size and number of myofibers, especially type 2 fibers, inter and intramuscular fat infiltration, known as myosteatosis, decreased number of type 2 fiber satellite cells, and altered mitochondrial integrity in the myocytes. Now, we must differentiate between acute and chronic sarcopenia. Acute is less than 6 months and is related to an acute illness or injury. Chronic is more than 6 months, associated with chronic and progressive conditions that increase the risk of mortality. So basically, the difference is that you must assess the patient periodically to see whether he is progressing or improving. Differential diagnosis from malnutrition, cachexia, and frailty, consequences of sarcopenia, physical disability, poor endurance, falls, frailty, hospitalizations, morbidity, poor quality of life, and ultimately mortality. How do you find? There are a lot of clinical tools, and I'll just go to some of the important ones. The first is SARC-F questionnaire. That is a very important questionnaire. 5 domain symptoms, looking at the strength, whether it's grip strength, chair strength test, ambulation, walking independence, rising from a chair, stair climbing, and history of falls. And you score this 2 points for each. And these are the questions that are often asked. How much difficulty do you have in lifting and carrying, say, around 10 pounds? How much difficulty you have walking across a room? How much difficulty do you have transferring from a chair to bed? How much difficulty do you find climbing a flight of 10 stairs? And how many times have you fallen in the last year? And this questionnaire gives you an idea whether the patient is having sarcopenia or not. Assessment, skeletal muscle grip strength by the JAMAR dynamometer. You can measure it has been validated and widely used. And the cutoff criteria is 27 kg for men and 16 kg for women. This is the chair skeletal muscle chair stand-up test for skeletal muscle strength. Basically, it's a proxy of strength of the quadriceps muscles. Measure the amount of time needed for a patient to rise 5 times from a seated position with hands like this without touching the chair. And it can be timed, that is different thing. And it requires both strength and endurance. So it is qualified as a convenient measure of strength. And the criteria is that sarcopenia cutoff point is more than 15 seconds for 5 rises. If you take more than 15 seconds for 5 rises, you are probably having sarcopenia. Skeletal muscle mass can be measured. The appendicular skeletal muscle mass can be measured by dual energy X-ray absorptiometry. Whole body skeletal mass by bioelectrical impedance analysis. Lumbar muscle by CT or MRI, and the cutoff criteria are for the appendicular less than 20 kg for men and less than 15 kg for women. Calf circumference. Calf circumference is very important. It predicts the performance and survival in older people. The cutoff is 31 centimeters. So anything who has got a calf circumference of less than 31 centimeters needs a treatment. Physical performance. This is objectively depending on the locomotion, multi-dimensional concept involving a battery of tests. Gauge speed, cutoff speed should be less than 0.8 meters per second is indicator of severe sarcopenia. Then there is a short physical performance battery test. I won't go into the details. There is time test equal to 20 seconds and 400-meter walk test where patient is asked to complete 20 laps of 20 minutes each as fast as possible. And that has to be done within 6 minutes. So this is the algorithm. Use the SARC-F questionnaire. If it is positive, look at the muscle strength, grip strength, and chair stand test. If it is low, probable sarcopenia, then look, confirm by muscle quantity or quality. You can go through those tests that I just mentioned. If it is sarcopenia is confirmed, then go for the severity. Look for severity by looking at the physical performance of the various tests that I mentioned. How do we treat? There are 3 pillars. Exercise is the most important. Progressive resistance training exercise. Multi-component functional exercise is recommended, like balance exercise, resistance training, gait training. This is a very important part of the treatment. The second is diet and nutrition, basically high protein diet with all the essential amino acids, possibly vitamin D, but again, no randomized controlled trials. Exercise still remains the most important. It promotes healthy aging of skeletal muscles, as you can see in this particular slide. And this was a network meta-analysis of all the interventions used in the treatment of sarcopenia, and it was seen that resistance exercise has more advantage in improving muscle mass, strength, and physical functional performance with a better curative effect. So the underlying message is that exercise is the most important thing. There are novel therapeutic strategies, drugs, myostatin inhibitors, which basically enhance skeletal muscle growth and improve physical function. And this is one molecule, epicatectin, and this has been published recently only on 18th of September this year in the Diabetes and Metabolic, and it has shown good evidence of preventing or treating sarcopenia. There are others, all in the trial phase, so I will not go into the details. But there is one drug, bimagrumab, and this is an activin type 2 receptor monoclonal antibody, basically used in diabetes, but also in sarcopenic diabetes, because it has got double action. On the muscle, it increases mass and volume. On fat, it decreases mass, increased brown adipose tissue, thermogenesis, mitochondrial and oxidative metabolism activation. And this is the first anti-obesity molecule that preferentially improves body composition via muscle mass gain as well as providing loss of adipose tissue. So both, you are getting loss of adipose tissue as well as gain of muscle mass. Now this is what is normally happening, the lower curve that you see here, the threshold of physical performance. So what do we have to aim? It starts from early life, adult life, and older life. We have to aim to get the upper curve. And how do we get the upper curve? Prevent or delay sarcopenia by maximizing muscle in the young and young adulthood, maintain muscle in the middle age, and minimize loss in the older age. And how do you do it? The difference is between non-exercisers and exercisers. And Dr. Satur will be very happy to see that I have again emphasized what he was trying to say, that exercise is the most important thing. Thank you. 13 minutes. Next.
Thank you, sir.
13. Even next, 12. Can I go?
Thank you, sir.
Thank you. Yes, sir.
So now we invite Dr. Vasant Kumar for his topic, Young Boy with Severe Hypertension.
Actually, it's a welcome change, you know. We have been hearing about old people,
Yes,
old people from young
Yeah,
people.
yeah.
Sorry.
No problem. We have switched from elderly to younger population now.
So that's a change now. You're going to, I don't know, Dr. Veermani decided to give me this topic on hypertension because he must be thinking that this guy is going all around and speaking only on diabetes everywhere. So he has given me a challenge to speak on. नहीं, वसंत कुमार कहाँ है देखो, अशोक कुमार है यार. It's not that. कहाँ है, इसमें नहीं है, वहाँ देखो, नाम नहीं है ना, इधर है देखो, इधर आ गया नाम. That's what I'm telling you, no. Sorry for the delay. It's further reducing my time to speak to you guys. So sometimes I wonder the challenge is more for the people who listen or people who speak. I think definitely the challenge is more for the people who listen. But most of us are speakers as well as listeners, fortunately or unfortunately. So the topic is here, severe hypertension in young. Oh, this is interesting because all the while we talk about hypertension. Even just a couple of hours back, we have released guidelines for management of hypertension, Indian guidelines. So we must also understand there is an entity called young hypertension, which has become important. We have been looking at it for the last few years. There are many analyses that are done. And one of the analyses showed that 30% of hypertension among younger adults was due to secondary causes. We all know that. When somebody presents himself with hypertension at a young age, we must understand what is that young age. We are talking about adolescents and below 40. So young hypertension, it can be defined as hypertension occurring in people for less than 40 years of age. And almost 1/3 of the young hypertension is caused by some underlying secondary cause I just mentioned to you, because that's important. Finally, that's how we differentiate. We handle them separately, how you compare to those who have hypertension, the middle-aged or older people. So secondary hypertension can be cured when compared with essential hypertension. That is something we must understand, because you will always find the reason for secondary hypertension, whether it is renal, renovascular or endocrinal. So you may have a solution for it, which is good actually if it can happen in younger people, so that they don't hook on to antihypertensives forever. So it is certainly an overlooked problem in young adults. I'm sure all of you understand. Most of the young people come to us. How often are we checking their blood pressure? So young individuals have an unrecognized hypertension issue. All of us have to realize this point. And the research indicated hypertensive young people had high rate of, most of these young fellows, they smoke, they have other addictions, apart from also having comorbid conditions like dyslipidemia. Even diabetes is becoming more common amongst the younger people. So in any case, when you deal with a young guy with hypertension, you need to certainly look for secondary causes, and so that you will be able to handle them better. So it is especially important for young people, important in young people where the sustained duration of high BP on organs such as brain and kidney may produce irreversible changes, because you are looking at somebody's active life for another 40, 50 years. Furthermore, we have to also look at the identification and treatment of secondary hypertension, especially those who are below the age of 40, as I mentioned to you. So we need to investigate them. And in fact, it is advocated across America, Europe, and British guidelines for the identification of secondary causes whenever you are dealing with young hypertensive. We also look at, we've been talking about severe hypertension. So what is severe hypertension? It could be anything above 180 systolic and 110 diastolic. Even one of them has that kind of a figure. So you need to consider it as severe. And sudden deterioration in blood pressure control non-dipping status on ambulatory blood pressure monitoring, or the presence of hypertension-mediated organ damage are important features that you may find amongst these young guys. So you need to clinically evaluate the young hypertensive patients, which should include, as usual, the family history, the medical history, and see also what kind of addictions these people have, and the dietary habits, their stress levels, and so many things. Physical examination, of course, is even more important than compared to the older people, because you are looking at every aspect and look at the clinically evaluate the organ damage or comorbid condition these people may have. So hypertension is often thought of as a disease of old people or middle-aged people. We know that. But in US, 22.4% of the people aged between 18 and less than 40 are estimated to have blood pressure more than 130/80. So this could be, you could rather call it a pre-hypertension. They are looking at preventing hypertension in younger people. So essential hypertension still remains the common cause of hypertension even in young onset hypertension. We understand, because finally you may find secondary causes about 30%. Rest of them still have hypertension of unknown etiology, which we call essential hypertension. So in addition to these risk factors, there were additional important risk variables, such as, especially in India, we have illiteracy, we have ignorance, disregard for our own health, especially amongst the youngsters, especially those who live in semi-urban rural areas. I already told they have succumbed to the Western culture and addictions like alcohol. All these are reality, and most of us who are practicing in the suburban rural areas, even urban areas, you see this happening. Most of these youngsters are used to many kinds of habits and addictions. So hypertension certainly makes things much worse for these people. So this is just one of the categories that they have shown as the blood pressure amongst the people who are less than adolescents, those who are beyond adolescent age and beyond 39. This is a slight change in the staging compared to the adults. So what is, we always talk about hypertensive emergency, but what is hypertensive urgency? Severe hypertension, we can call it as hypertensive crisis. This is a term that traditionally includes both hypertensive urgency as well as hypertensive emergencies. Hypertensive urgency is defined as severe blood pressure elevation without progressive target organ damage, whereas hypertensive emergency is something where apart from severe BP elevation, there is also impending or progressive target organ damage, which can be heart, brain, or kidney, as all of you know. So basically, an extreme elevation of blood pressure should prompt the initiation of the treatment and also close monitoring, which is very important, especially you're dealing with young people here. Dropping the blood pressure too quickly raises the risk of introducing autoregulatory responses in key circulatory beds in the brain, heart, and kidneys. So this is a similar situation. We are always conventionally taught, when somebody comes with severe hypertension in a stroke, non-hemorrhagic stroke, don't reduce the blood pressure precipitously. So the same thing holds good when you are dealing with a very severe hypertension in young people. So you need to look at it critically. We always talk about ambulatory blood pressure monitoring, which has its own role. We know about it in every situation where you talk about hypertension. You talk about AB, PM, which is obviously has more importance when you're dealing with very young guys, because you will see so many things, how the blood pressure is dying, whether they have dipping, what's happening rest of the time. But how often can we do it is a question mark. Every time what we learn, what we talk, are we able to practice when we go back home is a question that we as internists should realize and put it into practice as far as possible. Hypertension due to renal causes can be categorized as resulting from, it can be renovascular or renal parenchymal. Because dealing with young people, you are looking at both the aspects. Renovascular causes, as you know, can be a renal stenosis, renal artery stenosis, or even atherosclerotic disease or fibromuscular dysplasia of the arteries supplying to the kidney, that is the renal arteries. And renal parenchymal diseases can be acute or chronic glomerular disease or chronic tubulointerstitial disease, as you know, many of them, they can be drug-induced, chronic pyelonephritis, and even diabetic nephropathy amongst the young people. All of them can lead to secondary hypertension. Based on these etiologies, the baseline investigations for renovascular causes we need to do, apart from doing creatinine and urine exam and ultrasound. Sometimes we need to subject these people to the renal angiogram, where you need to exclude serious renal causes. There are also cardiac causes that can cause hypertension amongst the young people, especially the serious. One of them, commonest, is the coarctation of aorta, which is a congenital disease, not very uncommon. And we have many endocrinal conditions which can cause hypertension, especially amongst the young people. So we need to look at them very seriously and exclude them. And some of the neurological causes also can be the reason for elevated hypertension in these patients. I'm not going into the details because where is our scientific chair? He has warned me that I should finish in 10 minutes. So most common causes of secondary hypertension by age, or depending on the age, you can always decide what kind of things, whether they are renal. Most of them are renal causes or endocrinal causes that you need to exclude in most of the people. I'm sorry, this is a little overcrowded slide, but you can actually see how you differentiate a child, young adult, middle-aged, and older person when you're dealing with them. How do you deal with them in terms of medication and advice to these patients? Hypertension care cascade pathway among adolescents and young adults. This is what it is. This is one of the Indian studies where they have screened almost thousands of patients and found out 14% of the common population below 40 have hypertension. This is one of the Indian studies. So it's quite remarkable that you're looking at 15% of the young people having some kind of hypertension. So I think that gives us more responsibility for all the interns to look at this, prevent it perhaps, and treat properly. We also know there are different types of hypertension that we can see. So it's finally what I thought the message would be, it's important to check everyone's blood pressure, irrespective of the age. Which some of us, we don't realize, even I was not realizing it until I went through this. So whether they are young or asymptomatic, we need to check the blood pressure, whether you or your nurse. Only then we will be able to detect hypertension in young people. And once you detect, monitoring is more often is important, and counseling the lifestyle change is very, very important. And I already said many of them have risky behavioral pattern. We need to change them, and we need to use different strategies to counsel them before you start them on a proper antihypertensive therapy, which may not really vary from what you otherwise treat older people, except that we all know that we don't give beta blocker as the first line of antihypertensive unless there is a compelling reason for you to do that, is it not? So finally, stress on the proper medication is important, and telling them they need to take the medication. Many of the young people refuse to take the medication because why should I take it at this young age? They have all kinds of ideas that they'll get hooked on to it, but it's not true. So we need to spend another couple of minutes, explain them the importance of controlling their blood pressure to live longer and also have some good quality of life. Thank you so much for giving me this opportunity and giving me a chance to speak on a different topic. Thank you.
Thank you, sir. So, in young hypertensive patients who come with hypertension, what are the things special examination will be doing? What are the special examinations will bring for young patients with hypertension?
The sir was asking about what special examinations would you do. So that means physical examination are important. You are looking at so many things, whether somebody has any endocrinal causes or some other thing, but investigations are even more important apart from the physical examination, looking at the renal, cardiac, endocrine causes. So we need to very seriously look at, because we are talking about severe hypertension. I agree with you, sir. We need to really look at the physical examination, also for all the investigations which I mentioned, in fact. Can I get
Thank you, sir. We will close the session then. Sir has one question.
Chairpersons. I would like to thank the chairpersons for this session, and we'll be closing this session. I would request our esteemed chairperson and our speaker of this excellent session for the felicitation on downstage. It has been an excellent session on geriatric medicine, and I think we had excellent speakers for the session. I'd like to thank one and all. Now, moving forward, we have had a wonderful session for the last 2 days, and I should thank to all the delegates sitting here for making it a grand success. Now we are on the last leg of day 2, and I think we have studied lots of scientific medicine. Let's move on to some different topics, and for which I would request my chairperson, Colonel S.K. Singh. Sir, if you are in the audience, please come on the stage, come on the dais. Dr. Jyoti R. Parida, sir, are you there? Dr. Jyoti, I would request J.K. Sharma sir to please come on the dais and grace us being a chairperson for this excellent and most awaiting session of the evening. A different topic, a mind-body medicine, and I hope we'll have a great session. I would request our chair to introduce our speaker. Sir doesn't need any introduction, but still, as the decorum, sir, I would request you to start the session.
Thank you. Thank you very much, Dr. Anuba. I think if I have to introduce Dr. A.K. Das, then everybody in the hall should quit practicing medicine. He does not require any introduction globally. And the topic, sir, please start your deliberation. Mind-body medicine, a consciousness approach for clinical cases. Very important topic for today's day-to-day practice, not only for the patients, for we all physicians also. Sir, please.
Yes. Esteemed chairpersons, esteemed chairpersons and my dear colleagues, they wanted to speak about Medica because people liked it and it was a good digression. Today I'm going to speak to something not exactly materia non-medica, but this has a lot of scientific inputs. But this is the future towards which possibly we are moving. Dear friends, we are the largest democracy. I'm not speaking politically. We have reached the south pole of the moon. Economy, sports, whatever China does doesn't matter. We are close to 100, definitely give a big round of applause. Close to 100 medals we'll get in the, we have got position in the Olympics we never had. I don't know, we are fast in many ways. But in one way, India is showing the direction to the world is to be in the leader in the ways of spirits. I'm not talking about other spirit. I'm talking about the spiritual path which India leads. It has been said that India is a country which is helper of everybody, but leader in the area of spiritual medicine, spiritual science, spiritual advancement. So I thought it will be appropriate to speak about something which is materia non-medica, at the same time extremely useful, and I'm sure that there'll be something coming out of this talk. When I talk about the mind-body medicine, we abbreviate it as MBM, and I don't know anything about other subjects, so I'll be alluding to diabetes and other endocrine diseases in between. But that is just for the sake of proxy. Dear friends, I have a big agenda, but I assure you, I have left 18.5 minutes. I will not go beyond it, maybe before that. Now we'll discuss today, does mind interact with the body, or what are the pathways? The brain as an endocrine organ, hypothalamus as the master regulator of hormones, and the autonomic nervous system on which many things depend, hormone imbalance, autonomic imbalance as the unifying concept of many diseases, including diabetes, including heart attack, including sexual disorders, many disorders, and also the kingpin for stress. Why do we discuss MBM in endocrinology? And what is meant by positive psychology? And whether this positive psychology has an impact on the health, impact the way we practice medicine. I'll show you that. Some evidences from studies. You know, I basically started my career. I won't say the year, you'll know my age, sir. I started my career in Jipmer, and the Jipmer has the icon. And sir, our icon says, Peta Kurat. We are from I'm from Pondicherry. It used to be a French colony, so it says in French, truth cures, faith cures. So we'll just discuss. It is from the government of India, Jipmer monograph, and we'll see some thoughts for the future. Dear friend, first thing, what we want to see the disease a man has, or the man who has the disease. I'll repeat again. It is very important, it is very gratifying to note that it was told by Hippocrates when he said, I would rather know the person who has the disease than the disease which has affected the man. All that it means that health behavior of any human being is basically driven by the mind. It is mind driven. I'm driving home the point why mind-body medicine is important. It is mind driven. Now, what are the pathways of mind? How does it interact with the body? Dear friends, I have brought only three examples, three known examples, but there are many known examples. But beyond that, myriads of unknown mechanisms which the youngsters like Rishi, my friend, and others will unravel in the coming times. Now, let us talk about the first one, the classic mind-body connections. Number one, the hunger drive. NPY, you know the hormone to it, ghrelin and leptin. Sex drive, DHEA, testosterone, estrogen. Parenting, oxytocin, which is love, and the maternal care, maternal hormone. So this is one of the examples of the mind-body connections. And you know, it is also, can you make it a little bigger, this one? So I had shown here how the various things we do in life are also connected to the brain. We'll come back in a minute. Dear friends, it is also very gratifying to note that diseases and our emotions are connected. You may not believe, we say this cock and bull story, but they're very well connected. I'll give the example of tension headache. The genius, like our previous past president of RSSDI, the current president of the Odisha API, they're in front of me. These are the people who do not have their health and hearty, but the big people have migraine. You know the migraine history, how it affects the big people. The chronic back pain, the fibromyalgia, it is entirely in the mind, the connections with the mind. Now, it has been also said that anger leads to blood pressure, which is high, heart disease, the resentment. When somebody resentment, one gets autoimmune disease. I'll show some cartoons in favor of that. Do you know that the thyrotoxicosis, Rishi is here, many endocrinologists are here, starts with a sudden sadness. Am I correct? Loss in a family member, loss of a near and dear one, it starts. And asthma has been told as a Bishada disease, Bishada rog. Bishad stands in Sanskrit for something unhappy, something you are not, or something you're trying to cure absolutely forcibly. Somebody had some skin allergy. He burnt it to say it will disappear. He developed asthma. This is not only one example, there are plenty of examples, so they're connected. Now, anxiety is the realm of multiple disease. We have here irritable bowel syndrome, MBP. MBP, what do we give? We give them beta blocker. Why do we give beta blockers? Because it's a disease centered on anxiety. And of course, the heart palpitation, etc., etc. Dear friends, now I'll just give some example from the area of diabetes and thyroid. I just told you that 30% of the diabetics have depression. 40% thyroid disorders come with psychiatric manifestations. Thyrotoxicosis originates possibly from a type of stress. We call it acute stress. Psychiatric manifestation has a very important cause and effect relationship with obesity. I'll come to PNI, but these PNI alterations manifest with autonomic dysfunction and many psychosomatic disorders, palpitation, breathlessness, fatigue, and of course, needless to mention, stress is one of the very important in our area of endocrine disorders. Now, if you look what is PNEI, the Psycho Neuro Immune Endocrine Association, this is a great thing in the area of mind-body medicine called MBM and consciousness approach to medicine. I have taken it from NIH. This photograph taken from NIH. I'll give the NIH definition also, why they are accepted mind-body medicine. Now, in the brain, we have hypothalamus giving rise to CRH, pituitary gland giving ACTH, and we have adrenal gland which gives rise to cortisol. Now, this simple diagram shows why stress and the stress hormones are of paramount importance in all the diseases. Now, this is the NIH described. I'm not talking to you. Every slide I'm showing you has some scientific background, good scientific background and evidence. So this is from the NIH listed the positive psychology techniques which help in the mind-body medicine practice. We call it mind-body integration. Number one, controlled breathing exercises. We have meditation. Even not meditation, mindfulness. Deep sense of relaxation. Just ask the patient to lie on a bed, and even it can be a cot bed without a mattress that we all afford. It can be single cot. Let him imagine that he's sleeping on water, sleeping on a lotus flower, lotus bed, whatever. A sense of well-being, that is very important. And you know, it is also said that few postures can give you something very new, like forward bends can trigger the relaxation signal in the brain and activate logical brain at the same time. Now, there is also some movements which can suppress emotions from the brain. It has been also said yogic practices balances our emotions, free ourselves from anguish and loneliness, and yoga is also a tool for healing trauma. Dear friends, I am giving you some examples again from the NIH and other experts from mind-body medicine. You will just see here how neurology is influenced by this yogic or whatever say postures, meditation, etc., etc. Look at this. The body postures intended to increase flexibility, intended to increase balance and strength, increases awareness in the body about the nervous focus, and it is centered around the central axis of the body between the spine and the organs. By easing the body into several postures, our logical brain becomes stronger, which disactivates the sympathetic nervous system. You know, parasympathetic nervous system is very good. We know that, sympathetic is also good, but parasympathetic relaxes us. Am I correct? So parasympathetic relaxes us. So this makes the, and related bodily functions. When the stress response is turned off, our parasympathetic nervous system signal is turned on, and this signal, parasympathetic signal, relaxes the body. So like that, so many things, say neuroplasticity of our brain and the nervous system has been described as a power to rewire our body. So dear friends, I just want to bring to you, I will not give many examples, that there are literature and there are evidences that we have today that the postures, the meditation, the traditional mind-body medicine system is very beneficial. Now let us look at the metabolic and endocrine disease. Now, substantially, the positions increases flexibility, yogic positions and blood and oxygen supply after regular classes of yoga, regardless of whether doing aerobic or anaerobic exercises. Mind and thoughts alters the chemical structure of the brain, And this can also promote a sense of well-being. It increases the level of the brain chemicals like GABA, serotonin, I think just now, serotonin and the dopamine, we are called happy chemicals. Happy chemicals, we discussed the happy chemical in a minute, which are responsible for the feeling of relaxation and contentment. This response helps to regulate cortisol and other stress hormones to a certain extent. I've just given 8 examples from my areas, how the hormones control, and the examples are limitless. Oxytocin is the hormone of love and well-being. Serotonin, happiness and bliss. Look at this, bliss. And endorphin, of course you know, don't have to describe it. Cortisol, definitely anti-inflammatory. You heard the talk by Dr. Shashank, my student. You know, Shashank wonderfully said how diabetes and many diseases today inflammation. Not only diabetes, Canto study showed the heart attacks, the acute myocardial infarction in Canto study, they gave methotrexate and showed benefit. So many of the diseases today are inflammatory. And adrenaline for the vitality, the fight, flight and fright, DHEAs for the orgasm. You know, I hope the Nova people are not here. You know, I have one objection regarding the GLP-1 RA oral. Sir, it takes away your hunger. We have a hedonic pleasure of taking food. I'm looking forward to a good dinner at the end of this evening. There's a hedonic pleasure. It takes away that pleasure. How in life we survive for power, for wealth, for sex, for food. This is a known fact. We can't deny. We are not sannyasis like Binod Mittal. So we are the ordinary human beings. So we survive for this. So this pleasure taken away. So I prescribe rebellious. But this is the thing, we have to find a molecule which does not take away the hedonic pleasure. Am I correct, madam? Hedonic pleasure is a pleasure which you have to enjoy. So DHEAs for the orgasm, testosterone for the libido, melatonin for the sleep, and we know today melatonin is used for the sleep, is a molecule available in the market. Dear friends, I have only one slide on immunology. Now, cells of our body react to whatever mind says, but I must say you that autoimmune diseases, sir, I don't have enough evidence. I said some known evidence, some unknown evidence, but I can give you we have a society called Mind Body Medicine. We have a lady president, we have a lady secretary. I also in that committee, and we are all out there. We have made a compilation. We call it a compendium of MBM, compendium Mind Body Medicine. I'll pass on to anybody who is interested, soft copy. It says that negativity brings down your immune system. It is believed all autoimmune disease, say for fibromyalgia, for any autoimmune disease starts with a negativity. Therefore, we advocate to be compulsive optimist and to have positive psychology. Dear friends, the power of the amazing brain, I know details of it, but this is a very important sentence. Every bodily disease has a brain or mind behind it. I strongly believe every bodily disease has a brain or a mind behind it. Diabetes is a neuroendocrine and inflammatory disease. I have shown the nervous system, how it impacts the diabetes, from the picker diabetes, which was produced by the puncturing the fourth ventricle of the brain, to the other systems. Nervous system has a great impact. You know, the inflammation has everywhere. Pulmonary disease, Alzheimer's, arthritis. I will not describe to diabetes, cardiovascular disease, cancer, inflammation. And if you look at the internal high-risk fat, which is also highly metabolically active, is also dependent upon the mind-body system. You can control a lot of diseases by taking care of this. Now, the powerful ways in which emotional, mental, social, spiritual factors affect diabetes, its occurrence and control, and also affect diabetic health in the diseases. Now, I have given you towards the end, I've got only another 5-6 minutes talk. Now, mind-body medicine encompasses a wide range of practices and therapies, designed to facilitate mind's capacity to affect health. The NIH definition, mind-body medicine is not a astrology science. It is best, astrology also a science. It is based on evidence. It is a participatory and it's a self-care approach. It combines the power of traditional knowledge of yoga and meditation with modern psychology and modern medicine and has applicability across healthcare system from prevention to rehabilitation and improving outcomes and quality of life. It is affordable, scalable by all of us, and is also centers around health promotion, which is very important for our country today. Now, we have MBM applied. I'm telling on the areas that I work, but in every system, epidemiological connections of mind to many endocrine diseases, lab association with poor glycemia, clinical experience, lot of diabetes subjects need psychiatric consultation. I will not go to this, but I have just tried to say here that in spite of strict diet, exercise and medication, many people have sugars high. In spite of knowing that diabetes is a killer, many people have no compliance. Chronic pain in spite of having sugar and everything under control. Sleep disturbances. No weight loss in spite of medications for weight loss. And depression very common. So you see, we do not move our patients the way we want. Now, you know, the adherence to protocol, test, adherence to diet, adherence to exercise, stress of work, psychological work. I mean, all these are embedded in the various diseases. And of course, the thyroid I spoke about. Now, mind and thyroid, there are many other things like depressive eating behaviors, crying spells, temper tantrums, emotional sensitivity, chronic fatigue and pain, IBS, arthritis, fertility issues in women who are anxious, fear of lifelong disease and therapy, inability to handle pressure and stress. I have taken it from my senior colleague and teacher, Kochupile. Kochupile gave me this slide. He said, these are the issues which plague thyroid. He was one of the best thyroidologists of the country, Dr. N. Kochupile, sir, of AIMS fame. So he gave that to me. So obesity. I mean, what a type of mind they have. They have inferiority complex, they have peer pressure, they have eating pressure, unable to lose weight in spite of best trials, stress, and etc., etc. So therefore, mind has a great impact. Now, I'll just come back to the, how do we implement the mind-body medicine in our practice? I'll just take another 2 minutes on the diabetes practice. Mind-body medicine focuses on the communication between the mind and the body and the ways we can emotional, mental, social taken care of. The sex-driven metabolism, the mechanisms can be altered in diabetes. Living with diabetes is a stressful experience. Now, with mind-body medicine, we have seen this stress can be diminished. Now, we can modify the stress response. A lot of trials have shown that meditation, yoga can bring down the blood glucose, can be helpful in the complications. The reduction of the H1C has been shown. And also, people believe that those who integrate mind-body medicine, they give a holistic diabetes care, because diabetes is not only high sugar levels. Now, the nature of evidence is very high. I will not details of it. This you may ask me, how do I speak about it? I am not authorized to speak on this topic. I do not know anything about the chakras and all that, but I can tell you what is important. That yoga is a form of mind-body experience, and it has great influence on the endocrine system, and they possibly works to some centers of the body which are occult, but I do not have evidence for it, so I'll keep quiet on this. Now, before I close, I'll tell you that we have coined some things like, we talk up to the glycemic happiness. We talk euthymia in diabetes. We recognize diabetic stress. We establish in diabetes who have diabetic distress to eustress. We have a concept of my clinic, my gym. Professor Rishi's clinic runs from early morning to late night, but his clinic must be having a gym behind, which madam will equip with proper food and equipments. So my gym, my clinic, my gym is a concept. Biopsychosocial and of course spiritual aspects. I have seen these dialogues on the doctors who practice, they're DM doctors. I'll tell you one, Vaishali Deshmukh. You know Vaishali Deshmukh. Her clinic reads, do not eat for living. You eat for living, eat for living, do not live for eating. Physical inactivity is the basis of all NCDs. She first started that sitting for half an hour is 3 cigarettes. Compassion fatigue is there, but there is also consultation fatigue. Doctors who take care of it. There must be river rooms breaking into silent rooms. These are very important. Now, before I close, there are 3 quotes which I myself heard while I was taking care of the changing diabetes in children. Abdul Kalam one day asked me in a meeting, diabetes disease is syndrome of mind and body and soul. Diabetes needs an integrated approach, was told to me by A.B. Bajpayee when I was installed as the API president in Delhi. JK was there. In the Bigyan Bhavan, he told me diabetes is a disease of mind-body medicine. Not only, so he says we need integrated approach. We must try the common soil hypothesis, we strive for it. Dear friends, I'll stop it here, but I'll just end with last part, sir. These are the things we have put in the RSSDI ASI clinical practice guideline. Breeze Makkar and Rakesh Shah, they cannot be wrong. They are our presidents, sir. Colonel, sir, they are our presidents, Breeze Makkar and Rakesh Shah. They put this in our RSDI ESI guideline. This also has a role in the diabetes therapy. Of course, diabetes care. I just go to the last part to say that, in the infectious disease, we had a healthcare approach for illness repair. NCD era, we want to establish wellness. Today, in the area of growing mind-body medicine, we were looking well-being, growth, and also the healing touch. I'll end with the healing touch. It is believed that the disease is because of some falsehood, whether false food, wrong diet, wrong habit, whatever. So this, to keep it all right, what we need, knowledge, but we also need love. Knowledge give you capacity to restore health in the patient, but your love for the patient connects you, and both together, knowledge and love cure the disease. Thank you very much. So I'll end by saying, truth cures and faith cures. And you can contact me to become it's free membership of our society, and we have presence from United States to Kanyakumari. Thank you very much.
Thank you, Das sir, for this excellent masterly talk. It is always pleasure to listen you. Just one question. Basically, for the young physicians, for the MDs in different medical colleges, how you are going to make this as a practical, innovative approach? How should we go about this?
Yes, sir. Yes, sir. It's very important, sir. I mean, I saw somewhere in one of the health minister's office, medicine started as a nobility. Then it became a practice, then it became a trade, then it became a trade and commerce, then it became a stock exchange. So, Dr. Saab, these are not true. Medicine is, we don't do that. People made us do that. We basically, doctors, have a different dimension. I'm not telling superior dimension. We do care for the body, but we care most for the mind, for the vital, and for the spirit. Thank you, sir.
Thank you, sir.
Thank you.
I think this was the theme, the art and science of medicine. And sir, you truly did the honor, and really the mind plays the games. Sir, I would request you to, for the felicitation.
Good. Mind-body medicine is something we feel value addition.
Before I forget, sir, we have a society also in Kotak Medical College, which I started. I started my career, not tell you the year again, and I was the chair. Now, today chair is, yesterday I saw him with the governor of Orissa, receiving him, and he spoke about similar subject yesterday in that meeting, where governor was the Ganesh Lal, our honorable governor was there.
If we want to benefit our patients, we have to go beyond the medicines.
Yeah.
Because the treatment doesn't start with tablets only or surgery only.
Yeah.
That is the concept Professor Das has opened
Sir,
before you.
I mean, doctor has to be a yogi. Mahatma Gandhi did not tell the child, mother brought the child taking too much of sugar. Mother said, ask the child to stop sugar. Mahatma Gandhi did not say anything, come back after 1 month. After 1 month, he came back, and Mahatma Gandhi told the child, stop sugar. And he stopped sugar. Mother asked the Gandhiji, why do you took 1 month to tell him? He said, I was also taking lot of sugar. That. So doctor has to be, a doctor is something different, has to be a yogi. And your foundation, our foundation is in that.
Learning science is fine, but going beyond science is what is need of the time. So we have to expand ourselves to the holistic need of the patient, and after the medications regarding lifestyle, regarding mind, body, and regarding the holistic approach to the patient makes all of us a complete doctor. Professor Das has opened the avenue. give a big hand to him.
Thank you.
And we are proud that he is here.
Thank you.
The whole country respects, and he is the son of the soil, a alumni of ACP Medical College, and we are very happy that he has spent his valuable time
Oh,
this
no,
afternoon
I'm
with
delighted.
us.
Homecoming, sir.
Yeah, give a
Homecoming.
big hand, and I request J.K. Sharma sir, our Vice President ACP, to felicitate sir with a Uttariya and the memento.
Oh, beautiful. Punarak. Thank you, sir.
And I request sir to felicitate our chairpersons with a
pleasure.
small memento.
Sure. Colonel Sahab, Colonel S.K. Singh Sahab, thank you, sir. Thank you. We know each other for a long time. But Colonel is a Colonel. Full. Student, but full Colonel today, sir. Professor J.K. Sharma, my friend for a long time, a philosopher and guide. Thank you, sir. Thank you. Jyoti is the son of my teacher, Professor R.K. Parida, who taught me medicine. Hats off. Perfect gentleman, and he was my examiner also. And I must tell you that. Thank you. Thank you.
So let us move ahead.
Thank you, madam.
With this wonderful session, we move forward to the yet another exciting session, love, lust and hormones. I think we are moving beyond medicine, and that is what is the need of the hour. For this session, I would request Dr. Shrikant Dhar, sir, if he's around. Dr. Pradeep Behra, sir, please grace the dais. And I would request you to invite our esteemed speaker for today's evening. And I would request you all to please make it an interactive session and do ask questions. That is what keeps a child within or a student within active. So I would request our chairperson to start the session.
Good evening, one and all. So almost we are heading towards the end of the presentations of this today, and after a so much interesting presentation of mind body medicine, we have to follow with another topic, love, lust and hormones. So I request Dr. Rishi Shukla to the dais for the presentation. Sir.
The topic, love, lust and hormones, fit to all generations, old, present and future. And Dr. Rishi Shukla has chosen such a beautiful topic, and you'll see the content. The last presentation of the day will refresh all of you. Stage is yours,
Actually,
sir.
my talk is focused the person of your age exactly, so you'll be the most beneficiary. Thank you, everyone. Thank you, ACP. Thank you, Dr. Anuj, Dr. Jayant, and Dr. Virmani for the invite. And a double thanks to Dr. Anuj because today we visited Puri also. And I'm blessed to hear lecture of Professor Das. It was amazing. It was actually, I was lost and I forgot that I have to speak for this topic. There is some overlap of hormones. I believe you'll relish it. What am I going to discuss today evening is what is definition of love, how it manifests, and neurohormonal systems. There will be some common overlap, and finally the clinical applications. Dr. Jain Panda was saying that he should cover all age groups. I will do, don't worry. Now listen carefully these sentences. Why people lose appetite and sleep in love? Why people kill in love and suicide in love? Why a very ordinary person becomes extraordinary? Why people stop loving after some time? Down regulation. I mean, it happens. अब तो हमको चाहते ही नहीं है. What happens when people visit Bangkok and Amsterdam? I tried to have answered this. And what is one night stand? Finally, what is love with sex? Love without sex, unconditional love. Professor Das was hinting towards that, and loving the core. These shadows of love are many to infinite. If you look at the novels, movies, I think more than 80% of movies have some amount of love, and every time a different dimension of love is discussed. Am I right, friends? I think every time a different dimension is discussed. What is definition of love? As I told in the beginning, by poets, philosophers, lovers, people from the society, and finally the neuroendocrine definition. I write poetry, so this is the poetry I try to pen down and try to imbibe each line. प्यार क्या है? न तुम जानो न हम, बस जो एहसासों में आ गया, फिर रूह में समा गया, बस यही प्यार. Thank you. तालियां और बजा. Finally, neuroendocrine definition of love. Love is an emergent property of cocktail of it is cocktail of neuropeptides and neurohormones, the game of brain and different endocrine systems. A quick question. How many of you had love marriages? Raise hands. Only one. This is modern India. Some people are raising hands like this. Look at the romantic love, because you can this is the picture of our days. Dr. Jayant was saying, Amitabh Bachchan and Rekha, Kabhi Kabhi. And what is romance? And what happens in that? It is cross-cultural, universal. Having two individuals with distinct physiological, psychological, the individuals are very different backgrounds, different countries, different societies, different economic backgrounds, but the core thing is love. So love has no language. Sometimes you feel it. How it is initiated? Individual starts regarding other individual as a very special and unique, followed by focused attention and increased intensity. It starts minimizing his or her faults. Nahi, koi baat nahi. This is all right. People behave like this with their girlfriend, or even the girls behave with boy. Because this is not a gender specific, but dominantly from initiated by men, but it can happen to any gender. He starts minimizing his or her fault, increase ecstasy when things go well, and despair when not going well, anxiety when separation. वो मिलो ना तुमसे हम घबराए, मिले तो आग चुराए. Has taken place. There is emotional dependence, empathy. People sacrifice. I can do anything for you. Obsessive thinking. Continuously keep thinking about your girl or boyfriend. Even if you don't want, you want to do some other things, but that thought comes into your mind. There are a lot of movies into this theme. And then comes the physical relationship component. There is a sexual desire, intense sexual possessiveness, mate guarding. However, emotional union appears to supersede craving for sex. I'll come. But love is not, look, if you look at the nature, what nature wants, why nature has created love, and what we human beings have done. It's not a primary in emotion, but a motivation system. Nature created love so that you're motivated, do sex, produce, you create offsprings, but not. It is fundamental human mating drive. However, love appears to be a stronger than sex drive. This is a very important, I made it green. Because now the other sentence, if you see it carefully, people who are rejected by sexual initiation, if a lady refuses to have sex, nothing happens. But those who are failed in love, they can do anything. They fall, they suicide, they are totally into very depressive to agitated zones. So the love is a stronger component than the sex. Now coming to the hormones, Professor Das has shown it is interplay and cocktails of many hormones, starting from cortisols to epinephrine to norepinephrine, dopamine, serotonin, oxytocin, vasopressin, endocannabinoids, endorphins, endogenous opioids, testosterone, estrogen, even in prolactin in a normal person. Normal males also prolactin plays a role. I'll discuss very shortly about one by one about each hormone. What is dopamine? It is secreted by adrenal gland and some amount from the hypothalamus. It brings excitement and ecstasy. It plays a central role to the maintenance of love as it involves a reward process. Dopaminergic pathways appear to be more specific for partner preferences. Main function of dopamine include reward and motivation. When you think of a boy or a girl, something happens. Dopamine also makes us blind in love, since rewarding by dopamine lowers emotional. This is again a very important touching. Dopamine also makes us blind in love. So sometimes people take very untoward decision when they are very intensely into love. I mean, our own mythology, Raja Darshat has given throne to his younger son. He fell in love of Queen Kaikeyi. So again, I mean, that point of time he was in intense love and his brain probably stopped functioning. And what is observed that when these things happen, there is a reduction of blood flow in prefrontal cortex. Oxytocin is another hormone. It is basically a milk during pregnancy it is, but in normal relationship it plays a very important role. Involved from a start, process of falling in love to subsequent outcomes in offsprings. After initial cortisol surge, oxytocin increases to cope with stress of isolation by triggering pair and social bonding and relationship. It also ensures basically the trust, loyalty, devotion. This is all care, looking very soothingly to your partner is all part of oxytocin. Together with vasopressin, prolactin and endogenous opioids, oxytocin reduces. So what it does, all these hormones, prolactin, endogenous opioids, they reduce the hypothalamic pituitary axis. Again, sir was talking about HP axis. So there is a little bit inhibition. So cortisol, epinephrine, norepinephrine goes down. You feel good. And this is the way it happens. Serotonin, a bliss, hormone of bliss. It's a mood changer. It brings mental calmness, something that individuals who have just made you feel good with. And mind you, in this whole entire gamut of love, sometimes serotonin goes up and sometimes it goes down. I'll be sharing. So it has a bi-dimensional management. Now coming to the gonadal hormones. A small piece of intricately knit puzzle that forms complex phenomenon of love. Coming to the sex hormones, because sex it plays a role. It plays a role from the day of conception, development of neural system, deciding of gender, may mediate both genetic and environmental influences. Increasing in levels of testosterone and estrogen is an important component of sexual activity. So whenever the physical sex is there is a small surge of testosterone and estrogen. And testosterone, in fact, plays a very dominant role to have surge in both the genders, not only in male, both the genders. But rise in both sex hormones promote dopamine release and vice versa. Whenever there is rise of testosterone, there is a rise of dopamine. But when there is dating, the romantic part, the things are different. The testosterone increases in females, but testosterone reduces in males. So females are little more excited, more aggressive, but males are little down. So there is a different way of testosterone behavior in different modes of love. Finally, there are three things that happen in love. One is lust, other is attraction, and third is attachment. Lust, I think, very clear-cut thing. You've seen a person, it can happen to any way. Male to female dominantly, but female to male also. You want to have a relationship, there is a surge of testosterone, there is a little increase in estrogen. Operating mode is a midbrain. Everything happens in midbrain. Attraction, you've seen, and something happens. Little bit of dopamine, little bit of excitement in terms of epinephrine, norepinephrine. Again, in a part of brain, and ventral regimental area and nucleus accumulates. And attachment is a very different thing. So it is dominantly played by oxytocin, vasopressin, prolactin, a bit of dopamine. If you look this picture carefully, whenever a girl looks at a boy or a boy looks at the girl, something happens. And this gives stress. It works. No, it will not, I think. Whenever a girl looks something, there is a stress. And that gives you palpitation. And there is a difference of stress, what Professor Das was talking in day-to-day versus stress in love. The routine stress is stress. I have to go to exam, something is happening, whether I'll be doing good or not, I tend to forget the answers, even if I know it. This happens. But when there is love, there is excitement, but at the same time, there is release of oxytocin, there is a release of serotonin, and what it does, they again, if you look at the dotted line, they suppress the hypothalamic pituitary axis. So there is reduction in epinephrine, norepinephrine, all the stress hormones. So when you fall in love, there is little excitement, but something happens, and that excitement goes down, and you have a release of certain other hormones. What is Lavaria? There was a song, Sardi Khansi na malaria hua, humko to yaro Lavaria hua. I can't sing because then you'll all be run away. This is the early, those who had romance, those who had love marriages, meeting with boyfriend, girlfriend, this had to happen. They had sleeplessness, loss of appetite, increased tension, increased heart rate, trembling, and many more things. All manifestation of adrenergic discharge. This is all called Lavaria. Actions of norepinephrine characterizes the earlier phase of human love. Out of world feeling is brought by endorphins, which is released by anterior pituitary and hypothalamus, and release of pleasure molecules like dopamine, endocannabinoids, endorphins with endogenous morphine. They act together to create this stage. And it is supplemented by vasopressin, oxytocin, and stress hormones. So there is a love, you are feeling good, very good, out of the world. Abbas, this moment should be stand still. This type of thing starts happening. And I use the word, if you look at bottom line, food with a spice. And then a small surge of epinephrine and norepinephrine comes. They'll be successful or not, or will be successful. So these things keep on happening in love. Out of world feeling, this is a wonderful feeling. I mean, post-marriage also it is possible, but premarital it is more dominantly seen. Now the question is, love and sexual activity, same or different? Basically, the sex is a reward system. It is associated with increase in testosterone and estrogen, I shared with you, which promote dopamine release, oxytocin release, prolactin release, but have different pathways for love and sex. Sex drive is often expressed over a range of individuals. I mean, again, read it carefully. Sex drive is often I mean, you can have sex for with more than one person. But love is often focused to one. So there is a difference in love and sex. There is overlap also. If you have questions, because I think we'll have time, you can comment questions and we can share. Whenever there is a excitement, there is increase in testosterone, which stimulates receptors in hypothalamus, and what this receptors do, they reduce serotonin. Not so peaceful. So they make you more aggressive. So this is the bimodal functioning of serotonin in love. On one hand, it increases calmness, peacefulness, blissfulness. On the other hand, this. And there is arginine vasopressin. It also gives some amount of aggressiveness. So, which is a very different pathway when people are excited. The endocrine manifestations are very different. What is one night stand versus long-lasting love? I think I shared with you the interplay of different hormones. Because one night stands dominantly is played by testosterone drive, a bit of estradiol, very small amount of dopamine, and rest of the hormones, the oxytocin, the arginine vasopressin, the prolactin, these hormones probably don't play much role, because it is one night, it is done, and that's all. They have gone their way. Monogamous versus promiscuous behavior. Monogamy, sex facilitates the arginine vasopressin, dopamine, generating feel of love and attachment. In promiscuous behavior, attraction is there, but no, the pleasure effect is, I'll not say no, but the pleasure effect is lesser, very less. In nutshell, if there is a pure lust, there is testosterone, estrogen, a little dopamine, attraction, dopamine, norepinephrine, serotonin, attachment, oxytocin, and vasopressin. Endorphins may play additional role. Now I'll be sharing the clinical implications. What happens when girls and boy meet? What happens when they date? What happens when they marry? What happens when they attain a middle age? Where is Dr. Jayan Panda? He's, I think, middle age or a young person. I'll call him young. What happens when we age? There's been a lot of topics on sarcopenia and elderly people. What is elderly love? And what is brother and sister's love? A very important, very interesting thing that I think it is for both the genders. Males are excited looking or even thought of females, but females do not. Whenever a female goes, males usually tend to look like this. Dear friends, am I right or wrong? Say yes. कोई भी लेडी जाती है तो धीरे से देख लेते हो ना, सच बोलिए. But females are not. Why? There is scientific reason and rationale for this. In functional imaging, men show more activity in region posterior dorsal insula and regions associated with visual. So the visual stimuli part is more conditioned, more stimulated in men versus in women. Look at what happens in women. Women tend to show more activity in regions associated with attention, memory, and emotion. If you care of lady, the excitement part is more. What happens in middle-aged love? Middle-aged love, what happens? The attraction part is dominant. So dopamine, norepinephrine, serotonin, all these hormones are there with a small surge of testosterone. So basically, middle-aged love is a different love. There is another love known as platonic love. People have relationship but no physical love, no physical component. So they have lot of dopamine, lot of serotonin, oxytocin, vasopressin, prolactin, a small amount of endocannabinoids. Siblings love is purely on dopamine, oxytocin, and vasopressin. Different hormones have, because testosterone, estrogens are not there. And what are the therapeutic implications? I mean, you can create this type of love out of world. Is it possible or not? Because the complexity, the amount, the surges, it is not possible to create. So this is the question that often asked. So again, you have to condition yourself, do the love where it is done. The therapeutic implications are obviously the hormone replacement therapy for premature ovarian failures, or as we want, and the interplay of all these hormones is so complex that we cannot create love or ecstasy by giving these molecules. Because I think I've been doing a very regular patient education program for last 28 years, every fourth Sunday. So this is my entire team. This is my entire clinic team, because everybody has been helping me, and whatever I am because of all of them. With the friend in blue, look, Sangeeta is my wife sitting here, and I'm for journeys uncontrolled.
Thank you for the lovely presentation. Everybody has lost in love. I think the podium is open and we can invite one or two questions. Thank you.
As I promised, I finished in 5-7 minutes earlier.
Dr. Rishi, it was so fascinating. I'm sure it could not have been so fascinating, but for it has come out from your own practical experience of so many hormonal surges at different levels. So it is fascinating.
Thank you, sir. Thank you for the good words. Yes, sir.
Kushwant Singh, who fell in love or whatever lust, even after 90, made a bold statement in front of his own girlfriends that they can never in red capitals, a platonic relationship between man and a woman, unless driven by negative circumstances. So, I mean, what's your opinion on, even I strongly believe that in my own, not that sort of an experience, but in clinical experience, I also firmly believe there can never be a platonic relation between man and a woman. Your comments, sir?
I think answer was partly given by Professor Das. I'll be discussing. I partly agree to what you said. And that's why if we go back 20 years from now, there used to be hardly any gap between engagement and marriage, and they were not allowed to meet frequently, because if something happens and then finally boy dislikes, and so this is the fear. But if you look at the hormonal interplay, if the interplay of oxytocin, interplay of arginine vasopressin, interplay of prolactin is very, very dominant, the excitement part is very less. And sometimes, I mean, if you share your own experience, sometimes you would like to sit with someone, and it is irrespective of gender. I can sit for 1 hour with my younger sister Anubha. She will hug me and I'll hug her, and both of us will fall in love. So, I mean, again, an interplay of hormone, how you actually, mind is, I'll answer how much mind you motivate on that side. All is the game of mind. And the way you motivate your mind, the outcome comes. If you motivate on platonic love, no, I don't want to have any relation, then it will be, but I love him or her. It will move into different directions. And I've seen in my personal experience, I've seen many couple, 3-4 couples, they have very nice relationship, they go together, but there is no physical link. They love, they care. One's husband is cares, others wives, others, but no physical component. No, they had ample, they go there and have a cup of tea without the spouse. So again, I'm trying to answer socially, experience-wise as well as endocrine-wise. The dominance of which component?
Social innovation is going to also play, but still the mind is the seat of all.
All is the game of mind. And any other questions, comments?
Thank you, sir, for the nice presentation. Only one question from my side, sir. The whole slide is in a red background. So whether this color, red color, is to do with any like a love and lust?
No, I could not. I'm not able to hear. Keep mic off. You tell me.
The whole slides were on red background. So whether this color
Whole sides were actually the person who looks after my and my wife's work. She did a wonderful job. She made it like that. So it was her hard work. So credit goes to my secretary who does it. So she did it, but it was liked by us. So I think you liked it. And
Sir, last question from this end, sir.
Yes.
Whether you want to rise in love or fall in love? What according to? Rise in love or fall in love?
No, you want my comment?
Your answer to that.
I want.
You want to fall in love or rise in love?
Everybody wants to fall in love. As simple. Because if Dr. Anuj permits, next time I will speak love and beyond. So it will go different dimensions.
We did the obesity conference and we kept a theme, let us gain by losing weight and gaining by health. So here the theme will be, let us rise by falling. Let us fall in love, then start rising.
Start rising. Thank you so much.
Yeah. Give a big hand. Give a big hand for a beautiful session.
Thank you so
Closing
much.
session. Hand over to Ankita. So, mementos.
I would like to thank our chairperson and our speaker for a wonderful session. And I think everything is of the mind, whether it is anger, whether it is love or the lust. The anterior pituitary has to be blamed, or किसी को blame नहीं करेंगे. So I would request our chairperson and Dr. Panda sir to felicitate our speaker. And here we close our scientific session for today. Hope and to see you tomorrow early in the morning for the last day of the session.
So with this beautiful lecture of love, lust and hormone, and then prior to that, the mind-body medicine by Professor Dash, today's program comes to an end. And then very soon we are starting our award session. So I request our Governor Sir and the team ACP India chapter. We have our Vice President, we have our council members, we have advisors. I think the sessions are not over in that hall. Last session is going on. Okay. Virtual. Then we can prepare the hall and over to the Master of Ceremony, the anchor of the award ceremony, Ankita. I invite our Governor Sir and the whole ACP team. Yeah.
Thank you, sir. Steve Jobs once said, the only way to do great work is to love what you do. And this is visible that we love what we do. So moving forward with the felicitations ceremony, the most awaited part, and the unique thing that is happening And we'll be starting shortly with the felicitation.
सब तो स्टैंडिंग हुआ ना, चेयर तो नहीं। वाले नहीं है। आप भी रहोगे और वो भी रहेंगे। तो what will you do? क्या हमारा सीक्वेंस क्या रहेगा? पहले रिसर्च इनिशिएटिव होगा, फिर उसके बाद एप्लीकेशन। ठीक, 4 ही लोगों का तो 3 ही लोगों का तो ऊपर जाएगा। हमारा कोई और वायरल डेंगू वो था वायरल डेंगू। तो स्टार्ट जो है क्या है नहीं, क्वेश्चन वांट्स टू कलेक्ट कोई दिक्कत नहीं, करा देंगे। नहीं बुलाना देवाशीष, शंकर सेन अपने आप आएगा। हम तो देवाशीष को वो कर रहे हैं ना, तो शंकर सेन विल कलेक्ट इन द, so he will come on his own, na?
The medical field is a demanding one, often requiring long hours, relentless dedication, and the ability to make critical decisions under immense pressure. The individuals we are honoring today have not only met these challenges head on, but have also excelled in their respective fields, setting benchmarks for excellence and innovation. So, as soon as the session gets over, we'll be starting. In the words of Calvin Coolidge, I quote, "No person was ever honored for what he received. Honor has been the reward for what he gave," I unquote. Distinguished guests, esteemed colleagues, and fellow healthcare enthusiasts, today we gather here to felicitate a group of individuals who have dedicated their lives to a noble cause, the well-being of humanity. We are here to honor and recognize the medical practitioners whose unwavering commitment, expertise, and compassion have not only saved lives, but have also touched countless hearts. In a world where health is paramount, these individuals have stood out as beacons of hope and healing. They are not just doctors, they are healers, caregivers, and pillars of strength. Through their exceptional skills and dedication, they have made a profound impact on the lives of their patients and the communities they serve. With these lines, I invite Dr. Anuj Maheshwari, Governor ACP India, on stage. Please give him a big round of applause for the untiring efforts the team has made for organizing such a wonderful conference. Thank you, sir. I invite Dr. Anil K. Virmani, sir, the scientific chairperson, on the stage. Welcome with a round of applause. Thank you so much. Dr. Jayant Panda, the organizing chairperson. Welcome, sir. I invite Dr. Divya Saxena on stage and Dr. Swati Srivastav on stage, please. Now, first we will have this award for ACP India Research Initiative. The significant contribution in ACP India Research Initiative. I, with profound gratitude, invite Dr. Mohsin Aslam from Hyderabad for the award. Welcome, sir. Mohsin Aslam, the Research Initiative. Oh, okay.
Dear friends, in last 1.5 year, our organization ACP India chapter has started 3-4 very unique projects which were called as research initiative of the ACP India chapter. And these research initiatives are reaching to its conclusion, and these are presented here in this conference as a research initiative or research showcase of ACP India chapter. Because of all these people, those who have participated in those research initiatives, we thought that we should involve them in presentation of those research initiatives in our annual meeting. So that's why the people, those who have contributed maximum in those research projects, they have been given the responsibility of presentation of those projects in our program, and their presentation has occurred yesterday. The 4 important projects were anemia in physician's clinic, and that project has been done by a good number of the clinicians across the country, but the maximum number of the contributions has been done in that project by Dr. Mohsin Aslam. So he has been given the opportunity to present that paper yesterday in our Congress in William Osler Hall. And now this is the time to felicitate him for his wonderful contribution. Over to Aslam, our organizing chairman. Shall we? Yeah, we can do both. Thank you. Congratulations and keep doing the same in future also. Yeah, FACP. Now, I will invite the another very important and very ambitious project of the ACP India chapter. That was the subclinical hypothyroidism in diabetes, in the patients of the diabetes. And that project has been monitored and supervised by Dr. Swati Srivastava, who is standing beside me. And the maximum number of the contribution in this project has come from Dr. Dinesh Kumar, and would like to have his presence here. Yesterday he has presented the data of this project. लोग पहले से लाके खड़ा कर एक आए तो दूसरा आके खड़ा हो जाए वहां पे
A big round of applause for this wonderful achievement.
The third very important project was of the EVO India project, and EVO India project was supported by the LCAM, and evogliptin has been, and we have collected data of the evogliptin, a very new DPP4 inhibitors which have been used in India from across the country, and the maximum contribution came from a wonderful clinician of the country, Dr. Vinayak Hiremat. If he is here, please join here us on the dais. Vinayak has presented the data yesterday in our Congress. Vinayak, you are here. I think he is not here. No problem. हो गया हाँ आएंगे तो फिर दोबारा दे देंगे. We can give them later on. The fourth one was the Red IR project. For that, we have already congratulated and felicitated Dr. Brijmohan Makkar yesterday because he had to leave. So this is the activity of the research initiative, research showcase of ACP India chapter, which was the most ambitious one. Now I shall be inviting the ACP members, those who are being elevated as fellow FACP to their as their suffix, and they will be awarded with this wonderful honorific FACP in annual conference of ACP India chapter Boston. But before going to the Boston, our chapter wants to felicitate him for their wonderful achievement. So I will invite them on the dais, taking one by one their name. Dr. Vineet Behera. Dr. Vineet Behera. If you are here, please join us on the dais. Not here, no problem. Dr. Prahlad Chawla. Dr. Prahlad Chawla. I think he is also not there. Dr. Ashish Srivastav. Please, big round of applause for these who have earned the FACP. And FACP is being honored by our ACP, global ACP from the headquarters. It is not a award of the India chapter.
Your dedication, hard work, and passion have led you to this well-deserved achievement. Congratulations, sir.
Congratulations.
With your permission, I invite Dr. Anupam De. Dr. Anupam De, please come up on stage, and a big round of applause for Dr. Anupam De. I have this. Dream big and dare to fail. These are the words from Norman Vaughan. And a big round of applause and a big congratulations to you, sir, for this wonderful achievement. I now invite Dr. Atanu Kundu. Please join us on stage. Do we have sir here? Okay. Okay. It's Dr. Atanu Kundu. Okay. Dr. Anirban Ghosh. Dr. Balamurgan Subia. Dr. Balamurgan Subia. Dr. Gururaj K. Kulkarni. Dr. Manoj Kumar Srivastav. Dr. Harsh Vardhan. Dr. Munna Lal Patel. Dr. Rajiv Srivastav. Okay. Dr. Please. Dr. Rajiv Srivastav. Dr. Rajiv Srivastav. Next, I invite Dr. Sashti Narayan Chakrabarti.
Dr. Chakravarti,
Yeah, he's
please
here.
join us.
A big round of applause for sir, please. Please keep the applause going. This is kind of a motivation that we have. Thank you. May this accomplishment be the beginning of a new success in your life. Congratulations, sir. And the next recipient is Dr. Arvind Kumar. Dr. Arvind Kumar is there. Please join your hands and applaud him for his great achievement. Dr.
Request our audiences to clap more. Dr. Arvind Kumar.
The future belongs to those who believe in the beauty of their dreams. And those who have believed in their dreams are standing here with us. Big round of applause. The next recipient is Dr. Debasis Chakrabarti. Dr. Debasis Chakrabarti. Okay. I invite Dr. Amitesh Kumar Chatterjee. Dr. Amitesh Kumar Chatterjee. Welcome, sir. Please clap. It's a motivation, as I said. Thank you. Your success is a testament to your unwavering commitment and hard work. Congratulations, sir. The next recipient is Dr. Arvind Gupta. Dr. Arvind Gupta. Okay. And I invite Dr. C.H. Vasant Kumar. Dr. C.H. Vasant Kumar, a big round of applause for sir. Every great achievement begins with a dream. Your dedication has turned that dream into reality. Many congratulations, sir.
Dr. Vasant Kumar has been awarded invited fellowship by ACP. Sir, काम में लगाने दो. Sir has got an invited fellowship.
Yeah, yeah. उनको पहले बुलाना था. Invited जो है, available होते हैं, नहीं बोल दिए ना. They announced. That's enough. I know.
Let's capture this memorable moment so that we can cherish it for life. Thank you. Next is Dr. Shambhu Datta. Dr. Shambhu Datta? Yes, he is there. Welcome, sir.
Dr. Mugnathan is doing that job. Dr. Shambhu Datta.
We have Dr. Manoj Kumar Srivastav here. Many congratulations, sir. And moving forward, we have Dr. Manoj Kumar Srivastav. A big round of applause for this victory. I call upon once more those who have not been here. Maybe if somebody is present, please join us on stage. Dr. Vineet Bahera. Dr. Vineet Bahera. Dr. Prahlad Chawla. Dr. Atanu Kundu. Okay. Dr. Anirban Ghosh. He couldn't come for taking an award now. Moving to the other awards, we have Early Career Physician Award, and for this, I invite Dr. Nidhi Kaili. Dr. Nidhi Kaili, please come up on stage. Please welcome her.
Please have a big round of applause, all the award winners. And early career physicians are those who are in their early days of the starting their career after passing out of their last examination. As per the ACP definition, it comes to the 16 years after the passing out of the last examination is considered as the early career physician. Dr. Nidhi Kaili, who is the professor at Rishikesh AIMS, she has been awarded with this award. Congratulations.
Dr. Malay Parekh, congratulations for the early
मुझे
career
लगता है
physician
ये
award.
काम तो मुझे ही करना चाहिए.
Dr. Malay, please come on the stage. And a very big congratulations for receiving an early career physician award.
I invite Dr. Robin George for this award, that is Early Career Physician Award. Many congratulations, sir.
Malay Parekh is another early career physician who is being awarded by the ACP India chapter.
Special thanks to my mentor, Dr. Bansi Sabu, sir.
Bansi Sabu is here.
Yes. Special thanks to my mentor, Dr. Bansi.
बंसी भाई आ जाओ जरा डायस पे आ जाओ जल्दी से. ना अर्ली कैरियर फिजिशियन ये है तो आप थोड़े हो, आपको एडवांस कैरियर में बुलाते हैं.
And this moment calls for a round of applause. Thank you, gentlemen and ladies.
Good, very good. Congratulations. Oh,
We have Dr. Robin George. I welcome you on stage, sir, for this Early Career Physician Award. Thank you.
congratulations.
Amit Dey. Not here, but he also has received an early career. Moving on to our next award.
And that is for Rising Star Early Career Physician Award. And I delightfully invite Dr. Abhijit